You are live now, ma'am.
Right. Good morning, everyone. I welcome you all to the first session of day 2 of AIOS-YOSI Forum 2022. We've got a lineup of amazing sessions today, and I hope you all enjoy them as much as we enjoyed putting it all together. So the first session is beginning right now. It is about the extraordinary resident. What will make a resident stand out in his residency, which will set the tone for his or her future career in ophthalmology. So we have a host of great speakers who have put in their thoughts to uh, formulate talks and topics about amazing issues that residents face. And it is a very diverse program, and we are really looking forward to what each of you has to say. Our first speaker is Dr. Rajat Srivastava. Dr. Rajat is associate professor in KGMU Lucknow. He has done his post-graduation from RP Center AIMS, and currently he's in charge of the glaucoma subspecialty in KGMU Lucknow. He is actively involved in teaching and research activities related to glaucoma at the state and national level. His topic is knowing the residency program, the expected and unexpected. We're looking forward to hearing from Dr. Rajat. Please share your screen.
Thank you. A very good morning to all of you, and nice to see you all on a Sunday morning. At the outset, I would like to thank the All India Ophthalmology Society and also the Young Ophthalmology Society of India to have given me this opportunity, this platform to connect with you all today. So residency training, the residency program becomes a very crucial part of our professional lives. In fact, it is the first time when we are getting initiated to the nitty-gritties of our subspecialty. And what I have realized is, unfortunately, at that point of time, when we are getting exposed to the maze of residency, we are not truly aware of what exactly we are supposed to do in it or what do we expect out of the residency program. So the entire purpose of this program is to familiarize you with the terrain of the residency program so that we can all achieve the desired outcomes. So let's begin with the very beginning. Now, all of us would be very familiar with the happy memories which we have, all the congratulatory messages they start pouring in once we clear our entrance examination. And it's just all lovely at that point of time. And the moment you join your residency program and you see all those experienced, accomplished surgeons working around you, you feel awesome because you know that in a period of time, maybe after the end of your residency, you might be in their shoes. And soon you start believing that your dreams are shifting into realities. And suddenly you find that the sky is bright, the horizons are absolutely clear, and you love it. It's just a matter of 3 more years. Fast forward 3 more years. Now, this is what I am afraid of. It's a thing which we often come across. People land up at a situation after completing their residency where they were not supposed to be in the first place. There are times when you really don't know how do you land it over there. This is not the train you actually boarded for. The destination is very different to what your ticket was for. And this is concerning. It is almost like swallowing a bitter pill of disillusion. So what I've seen that this kind of a situation, I thought could have been unique to some individual, but no, I think a lot of us do have some issues once we finish our residency. Because what we realize at the end of residency is that the residency just happened to us. We didn't do the residency. And this concern has also been raised a lot by our past researchers, our seniors who have tried to voice their concern, who have tried to put in their efforts to show what are the deficiencies in our residency program and what steps should be taken in order to provide a wholesome experience to the entire residency program in the country. The National Medical Council, erstwhile known as the Indian Medical Council of India, has has actually put in a lot of hard work. They have actually brainstormed with our with this revised curriculum for the residency program, and they have actually posted a document like this online. The thing is that not long time ago, I was aware that such a document actually exists, which is kind of a blueprint to the entire residency program. And maybe had I been aware of such a program initially, or the residents were aware of it initially, then things could have been a little better. And so the objective of today's talk is that I'll be taking up clues from these documents, the link to which I have mentioned at the end of my presentation. And I would highlight some of the important aspects of a residency program with the hope that this would help not only the students, but also the teachers in enhancing the experience of residency program. So let's see what are the salient features of a residency program. The first thing which I would like to put across to our residents is residency program is unlike anything we have experienced in the past. It's not like the kind of teaching which we have been exposed to in a school and colleges, which are primarily teacher-oriented. Residency program is a situation where you don't have teachers or you are not students. You have facilitators and you have learners. So both of you are at similar plane, and it's a mutual learning experience. The facilitator is going to facilitate your learning process, but that learning process has to be initiated by the learner itself. Unlike the previous exposures which we have, wherein the teacher gives you an absolute truth and you can fly and you can just blindly follow. That's not how the residency program will actually work. हमारे यहाँ तो lectures ही नहीं होते हैं, कोई हमें पढ़ाता ही नहीं है. We keep complaining for those things, but we have to understand that we are in a different environment altogether, and that is not actually expected out of it. It is an adult learning program wherein the objectives are based around the learner. You are the one who would be actually initiating the process, and your teachers, your facilitator would be the one who would be facilitating this. So it's a continuous learning process, and herein you will learn with experiences. So that is the first point which we need to understand about our residency program. It's not like the ones which we have seen in our schools and colleges. The next and another most important point which we need to understand is what is the goal of this residency program. See, nobody prepares somebody to be a Sachin Tendulkar. Okay, you don't expect that you train and you are as good as what Sachin Tendulkar was at 200 matches. But what we definitely aim is what he was at the time of his debut. And similarly, when it comes to a residency program, we don't aim to produce masterful surgeons or clinicians. Definitely not. But what do we aim for? We aim to produce a good specialist who has a sound knowledge of subject and who can provide to the needs of the community while working within the frameworks of his professional ethics. Now, that is what we want. We want a person, a resident trained, to be a blend of a good clinician. He should be a teacher and should also have some teaching experience, some teaching qualities as well. So you see, the residency program is actually kind of a matchstick. It is something which will flame the process of scientific curiosity, the process of continuous learning, and the ability to adopt to the best practices over time when you deal with patients. So that is what we want to impart in a person. We want him to get the foundation strong enough and as robust that he is well exposed to the understanding of the subject, and then he can apply those, build on those foundation, and then maybe build a structure the way he wants. Okay, so if you understand that you are not going to be an accomplished person at the end of residency, that is something which will happen over a period of time. If you have that thing in your mind, you can focus on what you are supposed to. So we know what is the goal of our residency program, but then how do we achieve such a goal? And a lot of work has been done there as well. It is a well-known fact that our residency program is a competency-based program. And what do we mean by competencies? There are small little skills, small little things which we need to learn over a period of residency. And if you end up learning each of the competency, you would end up being a well-trained postgraduate, whether it is in ophthalmology or elsewhere. So you'll be surprised to know that a lot of work has been done to actually make large number of competencies out of the ophthalmology curriculum. So in our residency program, which we have, the documents actually outlines all competencies. All you need to do is make sure that you end up initiating the learning process in each one of them and learn it over a period of time. This applies both for the facilitator as well as for the learner. The facilitators need to see whether the competencies mentioned in here are being picked up by the learners, and learners need to put in efforts to get those competencies. So there can be a direct communication between the learners and the facilitators, and both of them can actually monitor the progress. And if you can find any deficiencies in the process, you can put in timely intervention to enhance the learning process. So competency, knowing about the competency is equally important because it becomes a self-directed learning in the long run. And because it is a self-directed learning, it becomes even more important for the learners to know what exactly they're supposed to do. So I would actually, I'll share the link for these documents. I would really urge all our residents and even the teachers to please go through that draft so that you will know about the competencies which we are talking about. And in addition to all the competencies which a person is supposed to learn, it also gives a broad outline of the syllabus and the teaching learning methods, and also how we are going to assess these competencies in these students. So we have a very well made residency program, provided we get aware about what we are supposed to do. Both the facilitators and the learners, if they're aware of, they can reach the desired outcomes. So that is what we expect of the program. But expecting is not enough. We have, if you're given something, you want a whole of it. There will be hurdles, no doubt about it. We are living in a diverse population. There will be problem in actually implementing the program as it is. There will be some challenges, some of them unexpected. We complain of infrastructure, the faculty motivation, patients, opportunities, and so many things. We always find that, greener pastures elsewhere. But believe me, barring a few institutes of national importance, more or less the institutes are of similar types. So you can't just continue whining for things which are not there. If you're aware of what you are supposed to learn, what you need to grab out of the residency program, you can make a change for yourself. You can find a way. Where there's a will, you can make a way, and you can actually overcome all these hurdles. Many times we don't even realize how these hurdles are because we don't know what we are actually looking out for. We just believe that, okay, they come in, like we say, residency just happened to us. So you have to overcome these unexpected things that will happen, but that should not deter you from getting the best out of the residency. So what I would like to say is how your residency program will actually depend upon the choices you make during your residency. And what kind of choices you ultimately make depends upon the level of your understanding and awareness of the program is about. So I hope that by sensitizing you to a document like this, which is existing online, that our programs had certain objectives, certain ways to achieve it. If you have that awareness, I'm sure you will make a right choices to get it through. You have to understand that it is always going to be a self-directed learning process. So more input you put in, the better output it is going to be. Don't expect just help to come from anywhere, even because if you don't go for it, you won't get it.
Is
yes,
frozen,
yeah, I'll just close it in a moment, but just 2 minutes. So last thing which I want to say is that in this era of globalization, communication, and socialization, you can actually resort to online teachings, to USC platforms, to AIOS platform, to YouTube's, where you can actually learn the competencies which you find are deficient. You need to collaborate to take the best out of other institutes. And remember that all it takes is a little bit of exploration and discovery, by which you can upgrade the experience of your residency program and make it a happy residency. So best wishes and thank you. This was just to sensitize you with what you can expect. These are the links to the documents, and if there are any further queries, I would be happy to answer them at the end. Thank you so much.
Thank you, Dr. Rajat, for that lovely presentation. And in fact, I would say looking at residency programs in a very different way. I think this is something that you probably have realized as a faculty once you've gone into that situation. As a resident, for us, it's just what gets passed on from, seniors. I think most of the times we are just looking at them for our inputs and all. But formal documents like this definitely, can be a strong guideline for that process.
Yes, sir. I mean, you know what you're supposed to do, so it becomes easier for you to do it.
Right. And I think, as you also mentioned that, so there are certain institutions where you possibly are able to fulfill all of these parameters. In some places, you'll have to struggle a bit. But I think on the whole, if we look at it in an open way and if we look at it, I mean, it's a broad kind of, as you said, the broad objectives of the process,
Yes.
I suppose that can be fulfilled in, I think, any of the programs, and that I think
Yes.
it is ensured by the authorities.
Yes.
So an interesting question to you now, basically,
Yes,
is,
sir.
so what, in your residency program, what was the one unexpected thing that happened that you realized that you probably hadn't thought of?
The unexpected thing which I realized was that I always thought that, okay, I'll tell you one thing very honestly. In RP Center, we follow certain protocols. We know, okay, if we just follow it, things will happen that way and the patient is going to be benefited. And we keep on doing it so many times that it just becomes a spinal reflex. For instance, if we are managing corneal ulcer, we know that you have to scrape, you have to do this, and you have to look out for that thing. Many times you don't have any sound knowledge about this is what you were supposed to do. And it just happens to you. And it dawns you at the end of the residency, okay, why you did a particular kind of thing, or whether what things were missed out on. So if you have an idea about what you are supposed to do, see, people don't read initially that much. People are not aware of, we keep coming, I have been coming to you asking, okay, which book should I refer to? Main yahan se padhun ki wahan se padhun. But the fact is very simple. You have to just pick up any book and start reading it. It is not that you have to read from the bosses to be a boss. You have to read from somewhere and build upon it to become a boss in a period of time. Then since I was in an institute where everything was already well taken care of, so the chances of me coming across something which are unexpected are less. But let's talk of an institute where not everything you are exposed to. Suppose if there is a person who is there in an institute which has absolutely no infrastructure for, say, LASIK or for the recent advancement, then what will that person do? He will just continue seeing what is happening in this his setup. For instance, in a setup in Uttar Pradesh, you will see that somebody is just performing SICS routine day in and day out, and that is the only thing that person is doing. So what goes in the mind of the resident is, this is perhaps the only thing which I'm supposed to learn, because there's nobody to guide you. And then once you finish your residency and you move out, you realize, okay, there were a lot of things else to which we had to read and to learn, but we didn't know that we are supposed to. And when you realize it, when you go in a conference and you see your colleague is doing something of which you had absolutely no idea about it. So when you're getting to a residency program and you realize, okay, at the end of my residency program, it is not just that I need to be a surgeon who would be performing cataract surgery. I need to be good at indirect ophthalmoscopy. I need to know how to do a 90-day examination. And if you are aware of such a thing, at least you will make an effort. You'll ask your teacher. The teacher would assist you in doing it. And even if you find that there are deficiencies at your place, you will look for the solutions elsewhere. You can't just find a solution without knowing a problem. So the unexpected issue here is that many times we just don't know what the problem is. We realize all these problems at the end of residency when we ask, "Mujhe kya dobara comprehensive fellowship karni chahiye?" So that, imagine somebody going for a comprehensive fellowship at the end of 3 years of residency. Is it justified by any means of imagination? I'm totally against such a thing that, okay, you have invested 3 years of your life for doing a thing and then you're planning for a comprehensive. It is a complete failure for all of us as teachers and as a system altogether. And that is what struck me. Okay, let us make the student realize, okay, this is what you are entitled for. This is what we are doing for you. This is what you're supposed to learn. And if we cannot fulfill it for you, it won't come otherwise. It wouldn't come. Because unexpected has that after expected. You don't know what the expected part is altogether. So you just accept everything, whatever comes along. And that is where I want to go in, that if a child is going for any residency program, he should be aware of what the outcome which we are wanting him to be. And if that outcome is clear, there'll be less of unexpected things. For instance, one very simple thing, for psychomotor, for skills, it is mandatory that the institutes should have a skill lab. If the students are aware of it, that they need to practice, if they cannot practice on patients, they need to have skill lab, wouldn't they ask for it?
So yeah, I think
it will just go unknown. And I have realized students not knowing, having absolutely no idea about what they are going to do in the residency program. आप उनको जो बता दीजिए वो कर ले. And that is why we are landing into such problems. So we have to talk about अरे तुम senior residency कर लो, तुम fellowship कर लो, तुम ये कर लो.
Something like this should come in the beginning as an orientation of the residency, as a as a mandatory thing to
yeah,
tell
it
them.
should, and that is what my plan is. That we should take our orientation right at the beginning of our residency, explain them what our objectives are, and then initiate the process. And it will not only help you overcome your deficiencies as an institute, but will also help the student also to look out for alternatives. Rather, at the end of the surgery, at the end of the okay, I think we'll so the schedule thing is. I'll be happy to answer all the queries at the end as
well. No,
Dr.
yes.
Just share those documents with me. I'll share with it amongst our groups as well. Thank you.
Yeah,
thank you for your talk.
I'll just mail it to you.
Thank you for your talk. Indeed, an excellent talk.
Thank you.
And something that I think all of us have got sensitized to. So, Apurva, next you'd like to call?
Yes. So thank you. For the next talk, I invite Dr. Prithvi Chandrakant. He'll be talking about frugal ophthalmic imaging techniques for residents. I think it's the need of the hour because of the gross imbalance in availability of infrastructure. So I invite Dr. Prithvi.
Good morning, everybody. I'll be talking about innovative residents. The video is going to be split into two parts. One is the first part will cover all the needs, what a resident, how a resident should innovate. And the second is innovations which I've done and which could help all the residents. And first of all, I would like to thank YOSI and All India Ophthalmic Society for giving this opportunity to talk. I'll be playing a video right now. Hope it's visible.
The innovative resident. There are three terms that sound similar but are very different from each other: discover, invent, and innovate. While discover means to obtain sight or knowledge of something for the first time, invent means to produce for the first time through the use of imagination or ingenious thinking and experiment. Innovate means to make changes in something established, especially by introducing new methods, ideas, or products. So, what is innovation? It is an idea that has been transformed into practical reality or a process to bring new ideas, new methods, or new products to an organization. Let's take an age-old example. If not for innovation, we would be exchanging monetary medium via barter system. In ophthalmology, let's take a few basic examples. Diagnostic innovations in the field of refraction led to the introduction of smartphone refractometers from the plane mirror retinoscope. The evolution of cataract extraction from couching to femtosecond laser due to the innovation in the surgical techniques. Now the question is, why do we need innovation? Innovation is important to us and the entire society as it can be time-saving, provide ease, better quality, affordable, accessible, and improved version altogether. The important questions to the smallest of the idea would be, will it make a positive difference? The main aim of innovation is to solve a real problem or an unmet need for the development and benefit of the society. How can we innovate? It is by a thorough understanding through direct observation of what people want and need in their lives and what they like or dislike about the way particular products are made. All we need is to find a problem statement with an inquisitive mind and work on it further. So now, where to find the problem? We can find problems everywhere around us, but it is important to address the right problem. which can benefit both the doctor and the patient. The problem should address a large audience and should solve real problems. As a resident, when we start fresh, our inquisitive minds can search many such problem statements easily in our daily life, work which seems to be often ignored by others who have made peace at these common problems around. Don't look for a great idea, look for a good problem. When should you innovate? There is no particular date or time to innovate. One doesn't need any extra time to search a new problem and find a solution to it. It's a part of our daily life, and just by focusing on the real problems, you can innovate the simplest of solutions. So let's stop giving excuses to ourselves and be in constant search or thought of it. Because these problems are right in front of us, we just need to fill the gaps of the jigsaw puzzle. Now for the main question, who can innovate? The answer is anyone and everyone. We are all different in our own way, have our own different creativity or art of doing things. We all have certain unknown qualities which we need to find out. Every person will have a different approach to a certain problem, and that's where all of us can innovate in their own possible way. People who want to innovate need to make it their priority. It should be a skill combined with a will. Few important lessons that I have learned during my journey of innovation. First is to be yourself. Second, stay away from negative people who would always laugh at your ideas. Be surrounded by positive people who are going to lift you higher. Mentoring is important. It could be anybody, like it could be your parents who will support you, your friends who will push you for doing new things, or your teachers who can guide you with their expertise. So always think positive, stay away from negativity because they will always hold you back. Talking about my journey into innovation, I was always passionate about photography and was that inquisitive kid since childhood who would just want to create something useful from waste products which would be lying unused. I loved to create something new and show it to my friends when I was in school. Then I met my mentor, my friend John Sir, during my post-graduation, who saw that I was just focusing on my career and not doing things which I was really passionate about. He suggested me to introduce my photography skills into ophthalmology and create something which would make me enjoy my work even more. This led to my 3 innovations which were all related to photography and smartphones. Those are trash to treasure red cam, anti-segment photography with intraocular lens, and IOL scope.
All these instruments were then published in the Indian Journal of Ophthalmology in the section of innovation, which would help others make it and use it for ophthalmic imaging. My first innovation was trash to treasure red cam. 20 cm sanitizer bottle was cut in the bottom to fit the 20D lens and the smartphone attached to the mouth of the bottle, and you could take fundus photos once you turn on the flashlight. We used the trash to treasure red cam to see if it was efficient enough to see for diabetic retinopathy screening. These were the images taken. The upper half was from the tabletop fundus camera and the lower half was from the trash to treasure red cam. It was found to be comparable. The second innovation was anti-segment photography with the intraocular lens. Here we take a chart paper, we cut it into 10 cm into 1.5 cm length and breadth, make a fold in the center, stick a double-sided tape at one end of the folded paper. Once that is done, we use a puncher to make a hole at one end of the paper. Once the hole is done, we remove the double-ended tape, an intraocular lens of the desired power stuck to the double-sided tape. The chart paper is folded back to sandwich it in between. Your ASPE is ready. The ASPE is then taken and aligned in front of the smartphone camera. This helps the camera of the phone to be used as a macro lens. On it on video mode, flashlight is on to take photos. And here are few photos taken from the ASPE. The outreach program called the Aroma, Arvind Rural Outreach Using Mobile Application, was initiated during the COVID pandemic which use macro lens attached to smartphone for ophthalmic screening via local volunteers who would then share the images to the clinicians at the main center. ASPI, in collaboration with Johns Hopkins University, developed a concise smartphone device which is now being used in the Aruma project for telescreen. My third innovation on ophthalmic imaging was the AIOS-YOSI. It is very similar to ASPI, but here, instead of one intraocular lens, we use 4 intraocular lens of 30 diopter power. As you see, we need to glue all the 4 intraocular lens haptics using Fevicol liquid adhesive. Once that is done, the AIOS-scope is ready to be aligned on the phone. Keeping the slide on the torch, you can take photos of any microorganism. Here are a few photos of fungus taken from the AIOS-scope. We went on to use it during a live surgery. This is a video showing FES being conducted on a patient suspected of mucormycosis, and we diagnosed it intraoperatively right at the operating room. This comes to the next innovation, that is SLIM, slit lamp based intraocular lens microscope. It is a very simple attachment of AIOS-scope to the slit lamp. As you can see, the mobile adapter is fixed to the slit lamp. Once the adapter is fixed to the slit lamp, we use the AIOS-scope to take photos and videos of microorganisms at the OPD. Simple innovations are those which gives you the best results, and that is what is a great innovation. If it is a really good idea, you should patent it, or if it's not patentable, it should at least be published in a reputed journal. I would like to conclude by saying that innovations are the brick laid by each one of us to lay a foundation that will turn into a beautiful monument in the future. Thank you.
Fantastic talk, Dr. Prithvi. It was very, very cool actually using 430 diopter lenses. That IOL scope was like ultra cool thing to do. Very inspiring. And congratulations, hearty congratulations. It was quite thrilling to see your video. Although I really think that the first what is innovation could have been avoided, and we would like to see more of your innovations. So yeah, anybody has anything to say?
So I think that's quite a. I mean, I think the whole idea, the thought from having the idea to executing it to probably patenting it, and you've gone ahead with that process as well.
Yes, sir. We have. I've tried patenting, and also if not patentable, then I've always published it in IGO innovation section, because that has very good reach to Indian residents and all over the world actually, and getting it targeted to all ophthalmologists. And all my ophthalmic innovations are mostly frugal, which anybody can do it. You just need some 5 to 10 minutes. You can just make it by yourself, and then you can use it in OPD, and it's very easy to do it and execute it.
Right. So could you briefly describe that process of how do you go about trying to patent it if you have patented something? I mean, just briefly describe that for all of us.
Like I said, all my products are such that it is do-it-yourself concept. So anybody can just do it in their house. So basically, patenting actually requires 2 things. One is if you want a name as you have a patented material in your name, so just for fame kind of thing. The second thing is if you want to make it into a proper business model, or you wanted to make a product which is readily available for people. So those are the 2 main things which I feel you require to patent. So if you require to patent, you have a lot of people. There is a website in which you can actually go. All India, the Indian government has made a website available where you can submit all the papers required for the product, and then you can get it patented. Or even there are the attorneys who can help you with it. So 2-3 things that we need to be clear, that is whether you wanted to make it into a business model and make a monetary outcome out of it. So if that is a thing, then you'll have to go for patenting. If not, then it takes a lot of energy and money actually. And the other thing is, I wanted to make it more available for people. So the best thing was to publish it and make it available for other people to use it. So I didn't have much, I felt it wouldn't be much of a patentable product. So I had to publish it. That would actually help all the people use it in a much broader way.
True. I think so. I'd also done a couple of patents for some softwares and all, and I think there is a whole process. And I just want you shared it quite rightly for all the people. Even if you've got something that tomorrow should not get exploited by somebody else, then also the patent helps. And getting a provisional patent is not very expensive. You can at least start with that, and then obviously you can go for a permanent patent. And in your own country is good enough to do. But indeed interesting. And was there any, so before you reached your final product, how many tries did you have to make? How many times did you have to attempt it before you could finally say that, oh, now it works?
Yeah, each product actually had, kind of 1 to 6 months of work behind it. So first initially it would be an idea, theoretical idea. Then we'll have to go by, trying trial and error method, and then going by its optics, the physics involved in it, and slowly come to a better product of its own. And then even now I keep, exploring new grounds. Like the ASPI product we have used it for gonioscopy right now. So it's under the patency and publication process right now. So we are exploring new grounds with all these instruments which we have made. Recently, we even made instruments which could record retinoscopic reflexes, which has never been tried before. We really don't have any instrument which would actually record the retinoscopy reflex. So there are a few other innovations coming up, and we keep exploring new things each time. So it's always a learning process.
Wonderful. So let's, I think, move on to the next talk now. And we have Dr. Megha will be talking about how to ace theory exams. Again, something which is probably very important. So over to you.
Right. So Dr. Megha has really aced all her exams in her life. I think she's got gold medal for her MS exam, gold medal for her DNB exam. She's been the winner of Erudio quiz, and she's been given grants to attend conferences in Singapore. I think we have a stellar person here who's going to tell us exactly how to ace the theory exams. So over to you, Dr. Megha. All the best.
Thank you so much, ma'am. Thank you for the kind introduction. I'll just share my slide.
And requesting all the speakers to just stick to time. We are behind schedule already. Thank you.
Yeah, sure, sir. Are my slides visible?
Yeah, please go ahead.
Yeah. So how to ace the theory exams is probably $1 million question that we all want to know during our residency. So first year, right, as we have joined, we all have questions like, should I buy all the books, or should I read standard books or exam oriented right from beginning? Or should I read for knowledge or for exams? Should I read every day, or should I start reading articles right from now on? So in the first year, what are the basic books which I feel you have to buy are the Parsons Diseases of the Eye, which is at least the symptomatology in the first few chapters are really good in this. Kansky's Clinical Ophthalmology, and the UG A.K. Khurana book which you have, it's better you just go through it once. And the Anatomy and Physiology of Eye by A.K. Khurana, these basic sciences books are also necessary. This doesn't mean that you need to stick on to these only books, and don't get discouraged when you start reading bigger books like Albert Jacobi and people tell you not to read such books. It's always good you read from standard books as well. So always patient is your first teacher. So more the number of patients you see, the more you learn. So never don't start cribbing about going to the OPD and seeing patients. Try to do a complete workup of all the patients, at least when the time permits. And once you do the workup, discuss it with your seniors as to how the patient has presented and what are the treatment modalities you can do for that patient. and then go back and read the theory of that the same day, so that that particular case is etched in your mind. Come back the next day and start teaching your juniors. The more you teach, more and more you learn. So not only your juniors, if you have undergraduates and paramedicals, don't hesitate to take classes for them as well. For refraction, in places where most of us have optometrists now, we all lag behind this great skill. So at least in the mornings when the patient load is less, better go and start practicing your refraction. For refraction, the theory part, I feel the Duke Elder Practice of Refraction is really good book, wherein you can see the even refractive errors have been described in a story-like format. But of course, it would be difficult to write for exams from this book. So for that, the Elkington is a good book. So with the various materials, start collecting them right from the first year, various notes and PPTs and articles like the DOS articles and review articles are really great materials, which so that in the last moment, you don't have to sit and search for which kind of material you need to know. Start collecting them right from first year. Nowadays, there are various online resources available, like since most of the webinars are occurring online, and YouTube channels like iFocus Online are really good sources. Other than that, you have the ONE network, ICO e-learning, iWiki, the Orbis cyber site. These are also great resources. Always be proactive in your classes. Come prepared for the class. I know it would be difficult for most of the classes, but at least the important topics, and then ask doubts in class. And if the seniors or professors have asked you some questions, go back and find answers for that. Don't just leave it off there, and then the topic is always forgotten. The place where I did my post-graduation, we used to have a whiteboard wherein all the questions which were unanswered were written on that whiteboard. And the next class would start only after those questions had to be, it had to be answered, only then the class would start. Attend various quizzes which are available. Attend conferences. You'll have a visual memory when you attend conference, so that some few rare topics you may be able to gain through that. Try to present papers and posters as well. So you're already in your second year and you've crossed your first year, but this would be ideal time to read various reference books like Shields or Becker-Schaeffer's, Krashmer, Collins, and the NEMA. And for DNB students, the clinical trials is a short question. So it would be good if you have a handbook of clinical trials as well. So preparing notes from these reference books, it would be difficult to go back in during your exams and read the whole thing. So it's always better you make up notes like this. And at the beginning of the notes, you can have an index so that at the last moment, you can just go and flip to the page you want to, the topic you want to. To the specialty postings, plan priorly by talking to fellows and seniors and present cases, especially those which are frequently kept for exams. Investigations and interpretation of reports and OT observations. So plan priorly by talking to the fellows or the senior residents in that particular. There are many institutes which have annual exams or the formative assessment tests for the FAT exams in the DNB institutes. Take these exams seriously, and you can also attempt for FIC or FRCS by your second year, the first part in your second year. So those of you who are already in your third year and haven't done any of these or haven't found time to do most of the things which I just told, thesis takes up a major chunk of your time in third year. So start planning and fill up your master chat right from first year, so that most of the time, it won't take most time in your third year. Then prepare question banks if you don't already have one. Make the question bank topic wise and mark the number of times the particular question has been asked. So suppose this terms conad, it's been asked 5 to 6 times. So you'll know which topic you need to concentrate on during your exams. And also you can make a short note behind it as to from where you have read that particular topic. There are various websites like the eofta.com or DNB websites or your particular university websites wherein you can ask if you can find the question papers. Preparing for the exams as such, there is no single golden book. There are multiple books. Each one of you might find one particular book as more interesting. Anything like Kansky, Datta, Zia Chaudhary, or Payman. You can make one of these books as your base books. Like if you're not that great in making notes like I am, you can just stick on notes from various other topics and put it on various other books and stick it onto your base book. Suppose you find a particular topic is better in some other book rather than the base book which you have kept, make that particular book as your base book and add topics onto it, and just make a note in your question bank as to where you have read that topic from. So other than that, you can make various stories and mnemonics. What I used to do is make them and stick it on the wall, especially those volatile topics, so that every day morning when I just go through them, it will stay in your mind. One more important thing is practice diagrams. If not all of us are very artistic. So basic things like eyelid surgeries, the orbit, retina anatomy, ray diagrams, Sturm's conoid, visual pathway. So these things, at least among these, at least one or two is a short in any of your theory exams. So make sure at least the common ones you practice. Group discussions are also really helpful for you to remember later on. Then revision is the key, as you all know. So coming to the day, it has come, it's a theory exam. So stay calm, carry all your stationaries like pens, color pencils, stencils, bangles, and 1 rupee coin to make those smaller circles. Try to write down as many as possible point wise and classify properly if you have classifications in that particular answer. Have flowcharts and tables rather than writing paragraphs together, underline, and diagrams. You need not be really beautiful diagrams, but then make correct markings, and preferably with pencil and not pen, and follow the color coding for the corneal and the retinal diagrams. So this is an example of one of my residents. You can see it's actually supposed to be a ray diagram, but it's all wavy, and even this diagram, it's going right from somewhere to somewhere. We have no idea what that person is trying to show. So for ray diagrams, always use scale and pencil, and for you to be correct in that, you'll have to practice earlier. So this is one more example. You can see that there is some small circle and large circle, whether the resident is trying to show 2 right eyes or 2 left eyes, no idea. So simple thing like using a bangle to draw the circle would have made it look much better.
Ma'am is on इसमें अभी जो है इसमें है मैम. Ma'am has logged in.
Sorry.
Please mute yourself.
तो मैं एक बार इनको मैं ये वाला फोटो मैंने जो अभी पॉइंट नोट डाउन किए, तो या मैं आपको ये फोटो भेज दूं, आप उनको मैम से भेज दोगे?
Mr. Sharik.
So you just say to ma'am.
Sharik, just mute yourself, please.
Sharik, please mute yourself.
आपको वो pointers भेज दीजिए. So she is just prepared कि हम.
Megha, continue.
Yeah. So just by using a bangle to draw the fundus the diagram would have looked much better. So try to draw as many diagrams as possible. That doesn't mean you sit and draw a pig and a tapeworm and even the digestive tract is drawn and blood vessel and even colored it. But ultimately, she's not drawn the diagram of the fundus in the toxoplasma question. So that doesn't mean you sit and waste time for all these things as well. So usually there are various patterns, but the usual pattern is of 8 questions with 180 marks. The key is time management and attempt all the questions. That's the most important thing. So you, by the first star, complete the long essays. There's a 20-mark questions, which is completed. And the rest don't exceed about 16 to 18 minutes. And if you feel the particular topic you want to write more, leave a page or 2 empty so that if you have time later on, you can come back and fill it up. So make a basic format for most questions. Like for a disease, you can make it like incidence, etiopathogenesis, then classification, then the clinical features, management in form of investigations, medical and surgical, and differential diagnosis. Like there's some format you can, so that in the exam you don't have to think what I have to write next. So everything said and done, theory exams, so how much ever the best you write, the marks usually hover around the same marks. So it's always in order to reach that notch and get the gold medal, it is better you have to focus on the practical exam more. So 2 main books which I would suggest are FAQs and ophthalmology clinics for postgraduates. But then class notes are most important, I feel. Whenever you're attending any of the classes, write down whatever the professors or the seniors are asking, because whatever they're going to ask you in the class is the same thing what they're going to ask you in the exams as well. So ophthalmology is a lifelong learning. So exam is just one point wherein it probably to get your degree, but you'll have to learn lifelong. So for all the residents who are listening, yeah, you're welcome. And thank you to AIOS-YOSI for this great opportunity. Thank you.
Thanks so much, Dr. Megha. That was a wonderful talk, very comprehensive. I hope everyone goes to the YouTube video and watches it multiple times to get, inspired by you. So
Thank
our
you.
next topic is by Ajinkya Deshmukh, a very good friend of mine. Is he here? Yeah.
Yes, Dr.
Ajinkya
Apurva.
is going to talk about a squint case not being the end of the world when you get it in practical exams. I think squint is something everybody is afraid of. So Ajinkya is residency. He finished from Prabha Eye Clinic. He did his long-term fellowship in peds, ophthalm and strabismus from LV Prasad. And he's back in his alma mater as a consultant in pediatric ophthalmology. Go ahead, Ajinkya.
Thank you so much, Dr. Apurva. Thank you, AIOS and YOSI, for this wonderful opportunity. So I'll directly go to the topic. Bob Dylan said, doesn't expecting the unexpected make the unexpected expected? So quite a confusing quote, but it is very relevant. So we usually hear this, yaar mujhe exam mein squint case to nahi aana chahiye. But no, mind you, the first and foremost step, expect the squint case in your practicals. I tell by my example, my experience. We were 4 people who were appearing for practical exams together, and 2 of us got either short or long case in squint. So yes, there is fairly 50% of the chance that you will get a squint case in your practical exams. So yes. So now you expect the squint case. How to prepare? So Benjamin Franklin said, by failing to prepare, you are preparing to fail. So now you know that you can get the squint case in exam. Now you have to prepare for it. Where does the preparation start? So the preparation starts right in the clinic, right during your clinical posting in the department of squint. The preparation for this squint case in exam start. Now I understand not all the institutes and hospitals have a dedicated squint department, but you must have an ophthalmologist who is dealing with such pediatric and squint cases. So whenever you are posted with them, or make sure that you get some time, dedicated time, like during your residency, to be around squint cases, so that you know the basics of squint, you know the basics of assessment of the squint case. So that once you start doing it, once you have seen it, then you know how to prepare for it. So long as I know what's expected of me, I can manage. So now if you have a case in exam, what are the points? What are the things you must know? Now, first and foremost, throughout the residency, don't neglect squint. You should know the squint. Everyone reads, everyone sees cornea, everyone sees retina, so everyone knows it. So unless you make an attempt to see a squint case and understand it, you will not get it. So know all the terms in squint thoroughly. You should know exo, iso, hypo, hyper, tropia, phoria, dissociated deviation. Be thorough with it. You should know how to assess for abnormal head posture. You should just not miss it. That is the first thing you observe in your patient when the patient is sitting right next to you in the examination chair. The most important test in squint assessment is extraocular motility assessment. It does not require any fancy instruments or anything. It just requires one near target, and you can assess the motility, and it can lead to the diagnosis of most of the cases. Then you should know how to look for Hirschberg corneal reflex and how to interpret it. Then again, the very important test is cover and cover and alternate cover test. How many times you read it in book, you know it, you understand it. But unless you do it on a patient, unless you get an occluder of yourself, put it over the eye, look for the motility of the eye under the cover, the other eye. So make a habit, do it yourself. Unless you do it, unless you see it, unless you keep doing it, it will not come in exam. Be habitual of doing cover and cover test. And last is prism alternate cover test. Not all people would have access to prisms, but at least know how to use prisms. What are different types of prisms? What are base in prisms? What are base out prisms? How to hold the prism? How to stack the prism? How not to stack the prisms? At least know the basics, so that even if in the exam you might not have the prism box, but at least if the examiner asks you how would you put a prism in this case to assess, to measure the deviation, you should know. There should be no confusion in the exam. You should know it beforehand. So these are some few must know things. Now, again, like any other topic, there are few cold cases, few hot cases. We never expect any hot case in exams. Hot case means any acute case or any child who is very small and will be uncooperative for examinations. So we can, like, when we are thinking about the practical exams now, we can forget about these cases and focus on cold cases. What are the cold cases? So in comitant squint, accommodative esotropia, intermittent exotropia, sensory or constant exotropia. These are the comitant squint cases which you can expect. Other than that, in concomitant squint, you can expect nerve palsies. Ischemic nerve palsies are seen very often in all the OPDs daily. In each hospital, in each OPD, there will be at least one case. So on the day of exam, they would definitely have one case presenting to their OPD, if not prior. So you can definitely expect ischemic isolated cranial nerve palsy, and there also can be a case of Duane retraction syndrome. So just in brief, very brief about all these cold cases, what are the must know or good to know things when you need to pass the exam? So when there is a child, 2 to 5 or 8 years of age who is wearing the, hyperopic glasses, you don't know what is the case, just take out the glasses. It is likely to be a case of accommodative esotropia. So you should know the types of esotropia. You should know how to what is refractive accommodative, what is partially accommodative esotropia. You should know what is high AC by ratio. Then always remember to measure the squint in these cases with and without glasses. And then in brief, you should know about the management. Intermittent exotropia, you should know the types and classifications, different classifications. For that, you need to measure the deviation for distance and near both. You should know how to assess the control. What are the different types to assess the control? What is home control? What is clinic control? So you know already, you have read these things for theory, but while examining the patient, ask these things to the patient. Do these things yourself. Check for the control. Once you do it, you know it, and then you can keep doing it. And in brief, you can know the management options. Then third, cranial nerve palsy, the eye is down and out. There is a ptosis. The case is clear. There is third nerve palsy. Then you should, for all cranial nerve palsies, like for all cranial nerve related cases, you should know the course of these cranial nerves, 3, 4, 6. The course should be on tip of your tongue. Then you should try, and depending on the location and the lesion or the symptoms and signs, you should try at least to localize the possible lesion, the location of the possible lesion. Then you should see and not miss if it is pupil involving or pupil sparing. Why it is important, that you should know. If it is painful or painless, it is complete or partial. These are all must know things. Then know what all are the indications for any cranial nerve palsies for that matter. What are the indications to neuroimage? What are the different fascicular syndromes one can encounter? And again, the management options in brief. And always remember, for any cranial nerve palsy, always check for all the cranial nerves. It does not take more than 5 minutes. If it is a habit to you, it will be just done in 5 minutes. But always check for all the cranial nerves, or at least mention. Then fourth, cranial nerve palsy. The patient complains of vertical diplopia, is coming with AHP. So this concomitant vertical diplopia will probably be your exam case. Even if you have this case or not, be sure that at least 50% of you would be asked about PAS 3-step test, either in a theory or practicals. Somewhere you will be answerable to what is this PAS 3-step test. Then assess the AHP, know how to differentiate between bilateral versus unilateral, course, localization, and management options. 6, nerve palsy, again, you should know the course, you should know the localization, know what is pseudolocalizing sign, look for other neurological signs, ask for other neurological symptoms. Again, there are different fascicular syndromes associated with 6, nerve palsy, so ask for related signs. And again, you should know the management options in brief. Whenever there is a DRS case, first thing, you should identify that it is a DRS case. The patient with AHP, with globe retraction, with overshoot and the exotropia or esotropia. So first and foremost is identify, diagnose, type of DRS. Is it exotropic, esotropic, type 1, type 2, type 3? Then what is the mechanism of overshoot? What is the mechanism of globe retraction? These are the basic things one should know. And then if you know the management, that is like a brownie point, and you will definitely score great. Now, few points about OSCE. In an OSCE pattern, you can definitely expect diplopia chart, Hess chart, Worth 4 dot test, Maddox rod, double Maddox rod, and synaptophore. So these are the things, tuck, tuck, tuck. It should come in your to-do or checklist before your OSCE exam. Then you should know different kinds of chart. They can show you the chart, and just you should know what is this type of chart, what is the principle behind using this chart. So these are different pediatric vision assessment charts. And in spotters, again, you can have a DRS case, a Brown syndrome case, MED case, or a case of leukocoria, and they would probably ask you for the differential diagnosis. These are the few I could think of, but again, there are always many things, but at least these things are like very often seen, and so you are probably most likely to get this. So take-home tips are: be familiar and used to examining a case of a squint, know the basics, know the theory, don't forget the theory, go methodical. The most important thing which examiner looks for you in an exam is how you approach the case. They don't expect you to manage that case or diagnose that case correctly. But what is your approach? Did you ask the history properly? Did you look for the HP? Did you check the extraocular motility? So have a set pro forma. And if you are lucky, so imagine that you are lucky if you get a squint case, because examiner think that it is hard for you, but now you are prepared, and so you will nail it. And so there is a low threshold for obtaining passing marks when you get a squint case. And make sure that you get few brownie points by knowing in detail about each of these things. Thank you so much. I hope डर के आगे जीत है.
Excellent talk, Dr. Ajinkya. Thank you so much for making it easy for everyone to understand. And I'm sure nobody will be scared of a squint case after watching your talk. So our next speaker is Dr. Aditya Anand.
Yes, ma'am. Can you listen me?
Yeah, I can hear you. We can see you. Please share your screen.
Yeah.
He's going to talk to us about how to deal with work, relationships, and academics during your residency. I think a very pertinent topic. Go ahead.
Is the screen visible, ma'am?
Yes.
Okay. Good morning, everyone. My topic, I would like to discuss about how to balance work, relationships, and academics during your residency. So first of all, it's a very casual and very important topic. And I myself, I did my diploma from RIO Vinto, and currently I'm a secondary TNB resident at Arvind Eye Hospital, Pondicherry. And I would like to thank Apurva ma'am and Dikvijay sir and our entire AIOS and YOSI to give me the opportunity to talk today. First of all, I'd like to say that this life is all about balance. So we need a balanced journey to sail through the challenges of era, which changes from time to time. So as a resident, there are a lot of things which we face, and I myself, I am a resident, so I know what are the common problems which my colleagues and which my other friends are facing. So
it's not running in a presentation mode. Could you run it in the slideshow mode?
Yes, sir.
Showing as a slide navigation mode.
So the slides are changed.
So this was an issue yesterday also. I think you can go ahead like this only. It's fine.
Oh.
Okay, then proceed. It's showing a slideshow on your slide, then that's fine. Just proceed. Maybe some issue. Yeah.
Okay, sir. So first of all, there are three things which our resident, any resident actually should balance, and currently, and it's always a problem, like to balance how the work pressure in the institute and the relationships and the academics. So many of the residents face this usual problem during their residency. So one by one, we will just like to pick up the the balancing sectors. So first of all, I'd like to talk about the work So basically, I am just dealing with each and every point one by one. So according to me and most of the people during the residency, we have to be very dedicated and honest towards our work. And we should not consider it a pressure, because so many residents, they tell me, or many of my friends also, they tell that it's a work pressure and we don't enjoy it. So like, first of all, we should enjoy our field, enjoy our work, and then we can really we can really face the pressure during the work which we face. And there is always a complaint about the seniors and juniors, like they're not what you call they're not working in symbiosis. In many of the institutes, the so many seniors and even the juniors are not very friendly. So first of all, if this is the situation, they have to sort it out together, or there has to be an atmosphere which has to be created, which is useful for entire batch or the entire postgraduates. So there should be a need of a proper channel and understanding between every one of us. And so many residents, they complain about the work given to them. They tell that they're mostly given the clerical work or the written work or something like that. They are like devoid of being given a surgical chance or something. So if this is the situation, first of all, every work is important. First year, second year, and third year, everything is divided according to the it's a tradition. Like, see, everything we have to learn. But even the clerical work is most important. How to write the sheets, OPD sheets, how to record, how to see the patient and recording. Everything is important. And then gradually, the residents are given a chance to move on the surgical side. So, but so many residents, they just want to neglect this and only crave about or mainly complain about the work given to them. So everything has to be learned, whether it's a recording, clinical work also, or your even the seeing the patient also, and the surgical part also. So gradually you will move on to that. So this is how we should actually carry, or we have to create a work atmosphere so that it is good for entire institute. So now, how to next come on to the relationship. So now what happens, this is a very important, but so many residents face it. So, but the thing is, but majority of people think that it's too complex. So the thing is, it's all in our mind. So we have to first of all, relationships doesn't mean that you have to be it's with everyone. It's with family also, friends also, and even your close colleague also, and if you are married, even with your spouse also. So now, this is the majority of people think that it's a too complex topic, but it's actually not. It's how we take it. So now here what happens is, now even your relationship with anyone during your residency, so and it should not, first of all, it should not affect your academics. That should be the most important. So we should always decide in which category it lies, if it is a fragile relationship or casual, or if it's a very serious or toxic. So we have to divert our our goal according to that. Because see, if the relationship is carrying you away from the academics, so always choose academics first. So this is everyone says that, and we should also follow this. So if given a choice, we have to prioritize our career first. So this is how we should, like, it's a very serious thing. So we should maintain relationships along with the academics. So many residents face it. So now, how do relationships come and go? Is it so? But that is a very casual talk. So we should not put this into the like how we channelize our growth. So the thing is that if it is important for your growth, if your partner is good, then very well ahead. Go according to we can actually mutual, we can study and they can grow together. So it is not a very big thing. So come on to the academics. So people say that academics is a way to attract people. So, but according to me, first of all, that is always there. If you are good, then people will always ask you, they always praise you. But for ourselves also, it gives the essence of life. So first, it is always required to keep ourselves busy in a very good academic atmosphere, and we should always dedicate our time to study various these topics and to keep ourselves busy. So this is what is very important. So now how to study, like my previous speakers have told everything, all the materials which is needed to excel in details. So but people think like own study and combined study, it all depends on them. So nowadays there are a lot of materials available all over. So people can study, like even the self-study can also like lead, they can excel with that, and combined study with discussion is anyways fruitful. So and more important is good academics, and moreover a balanced academic along with your work. It makes you more confident in any stuff, like how you even to deal with your professors, even to deal with your friends. It will show that confidence in your face and in your work also. So I would like to highlight some of the important things. With these points, I have actually asked so many residents, and then I have put it in a one very in a point wise. So people like who are in the residency, like me, so they have to, like, they can follow these things. So first of all, the self-discipline is the most important. Self-discipline means like how you prioritize your work and your academics, and even if anyone is in relationship, so they have to prioritize everything and they have to balance everything, and that too in a very disciplined mode. So first of all, in this thing we have to stop procrastination, and we have to involve ourselves in a fruitful thing. Okay, and later this is exam time schedule, means the study schedule which people make near to their exam. So that is also very, very important. We have to jot down the points and we have to make it. And moreover, only exam time schedule is not very important. We have to be like into the study throughout the year. That is, we call it a whole year series along with your work. So it's most important that after duty hours, how to spend the time. Most of the residents, okay, almost like more than 50% of the residents, they become so tired after duty. So they can't even study, they can't even like watch anything. I mean, obviously the duty is so hectic, so if people can't do that. But in this issue, we have to make ourselves very focused, and we have to create a plan. In a week, at least something, or some days, we have to give to our self-study, or it's a or discussion with our colleagues, so that along with the work, we can study also. So even if a resident can't study daily after duty hours, so he can actually spend it for 2-3 days or for 3-4 days in a week. He can make a schedule and do according to that. And most important, we have to keep ourselves involved in all the research activities and attend as like entire whatever conferences and other activities also. And already discussed with the other speakers that we have to keep, like, it's better to keep involved in publishing and to read various topics. So, and most like this we have to avoid take any kind of nicotine, liquor, or watching explicit material. See, this is very common thing. So because any kind of thing which divert our mind, so we should avoid that. In fact, even we should avoid the negative people who do not focus on our growth, and who actually are jealous and try to divert us. So these are the things which we should actually see that and judge, and according to that we should act. So what are the priority we should keep as a resident? So the thing is, we have to clarify our goals, what you want to achieve, and along with the study and all, there should be little time we should give to our exercise or practice yoga or any kind of meditation. And whenever we feel like depressed or something like that, we should watch motivational stuff whenever we need. And obviously we should not wait for that time. We should avoid procrastination. Whatever we want to do, we should do right ahead, whether it is related to whatever kind, like even our
Yeah,
work.
Aditya, you need to wrap up, please. We have two more talks.
And we should be always joyful. And that's why, and that will lead to our all-round growth. So thank you.
Thank you, Aditya. That was superb. It was very refreshing to see a resident having such, mature and concise and quite succinct thoughts about such complex and broad topics. Thank you. Thank you for your talk.
Thank you, ma'am.
So next we have Dr. Pranesh Balasubramaniam. He needs no introduction. He is very active young ophthalmology teacher. He's a fellow in Arvind Eye Hospital, Coimbatore. And he is an online teacher with a very robust YouTube channel with thousands of views. And he's deeply passionate about ophthalmic pedagogy and medical education. Go for it, Pranesh.
Thank you so much, ma'am, for the opportunity. Hope my slide is visible.
Yes, go ahead.
Right. So the topic is scientific proven strategies to create a successful resident surgeon. So you might wonder, this topic is an outlier. In a session which is intended for extraordinary residents, here I am putting the teachers or trainers as the primary audience. But when you know how to train one, you know how to be one. As I always maintain that by teaching, you can become a better learner. And this talk is relevant for residents as much as it's intended for the trainers or the surgeon teachers. So sit back, relax, and enjoy, dear trainees and trainers. For the ease of understanding, I've divided this talk into 3 subdivisions. So what are the principles we need to have in mind before even we venture into training a young surgeon? And what you should have in mind while we train them surgery, and how to take it further. So 3 levels will take it. Before even we start to train a young surgeon, it is important to know that we are teaching, we are training not adolescents, not children, but adults. That's why it is not pedagogy, it is andragogy, which is very different from teaching an adolescent or a teenager. In adult learning, it is important to know these assumptions, of which the most important and more pertinent to us as trainers is that experience. Adults learn based on their previous experience, and it's very important when we train a fellow, a secondary DNB resident, a foreign graduate. If they have learned a faulty practice, it is very difficult to make them unlearn and make them relearn the right one. That is something which a trainer should have in mind. So residents learn the steps correctly. Secondly, the adults learn what is important for them, what is relevant for them. They don't care about some theory, some kind of irrelevant content. If you can appeal to their interests, you can teach them, you can train them well. And not only they learn differently, not only they are different from the pediatric age group or from the adolescent age group, but they learn different in different ways. Not all prefer watching videos. We all tell about, let's train them by watching videos, but not everybody prefers watching videos. Some wants to get their hands dirty. Some want to read books. Some want to teach and discuss. Some want to journal. I'm one of those rare species who love auditory learning. So what I do is I kind of make a running commentary on my surgery. Okay. And I record it on my phone. It's right there even on my phone. So I will say, Pranesh, now we have sit down and now we are focusing on the microscope. The focus is clear on the conjunctival vessels. Take your scissors, make a nick, peritomy. So I give a running commentary, like an audio version, and I listen to that every night before I operate. And it works. It really works. So find what the resident prefers to learn. They may have multiple ways of learning. And this auditory worked for me. It's like a hypnosis tape. I think you might all remember Chandler embracing his femininity after listening to a hypnotic tape. So something like that, maybe you can wake up as a master surgeon. So know what learning style is predominant in your student, and the resident also should know what he or she learns the best way. But no matter how different we learn, we all come together in this very important Maslow's hierarchy of needs. See, the concept is that only when my physiological needs are fulfilled, only when my thirst is quenched, only when my hunger is satiated, only when I am employed, when I feel secure, when I feel trusted by my friends and family, only when I get the respect and confidence from my peers and from my friends, only then I perform better. Now, this might look like a deep philosophy, but it is important to know what is running behind my trainee, what is running behind my student's mind before they come for training for surgery. As a trainer, it is very important to know that. Fulfill these needs first, or at least ask them whether these needs are being fulfilled before you take them, before we push them towards a challenge. So now our trainee has its, the idli and vada. Now he is very satiated, very satisfied, well hydrated. Now sitting for surgery, what to have in mind? The trainee and trainers operate not just on a patient, but we operate in two different zones, the learning zone and the performance zone. Please watch the TED Talk on these two zones. Brilliant talk you should watch as a teacher. The learning zone is where there is a comfort zone, where you have a cushion, maybe in a wet lab, maybe the simulation models, or operating on a patient under extreme supervision. So the more time the student is going to spend on the learning zone, the better he becomes at the performance zone, where the stakes are very, very high. So the whole idea is the more they sweat on the ground, the less they'll bleed on the battlefield. So the lessons learned in the learning zone has to be applied in the performance zone, and it doesn't end there. In the performance zone, when you're operating in a very high volume setup like Aravind, when you're operating under intense pressure, note what you're doing, record your surgeries, take it back, reflect, practice what you have done, and go back again to the cycle of learning zone. It's like a vicious, constant cycle of improvement is what makes a resident a better surgeon. And as a teacher, as a trainer, it is important to facilitate the reflection part of it. And speaking of reflection, moving on to the last part, what to do after the training. The most important element is getting a good feedback. Feedback is very, very important, not just for the students, but for the teachers as well. So how I give feedback, I follow always this rule of this Pendleton's rules of giving effective feedback. It works very well every time for me. So first, I'm sitting with the resident has done his or her surgery. He's asking me, so what did it went? I'll first ask them, what you felt went well. I will ask them. They will tell me. Only then I will tell them what went well. Then I will ask them what went wrong. And only then I will tell them what went wrong. Now this ask, tell approach works beautifully, and it kind of reduces the intensity and makes the feedback far more palatable for the students. So what I do is, whenever I train my residents, I ask them to perform this reflective learning. It's kind of, again, it's like a deep philosophy, like a Stoic philosophy, journaling. It's one of the best researched methods on improving any skill for that matter. So here is my resident who has done her reflective writing on a patient. She has done her beautifully. And she's even mentioned or journaled about her mindset, the emotions she had before she entered to the OT, and then the various steps she performed, what went right, what went wrong. When it comes to what went wrong, I always tell them to maintain these four things. First, the errors they did and how these errors became a complication like PCR. How this error could have been managed and how this complication was managed. So these four things should be written on any error or any negative steps being done. So one well-researched document on how to perform surgeries or how to assess a resident surgery is Oscar rubric. This rubric was built by Dr. Carl Golnick, a great teacher, and he has done rubrics. He has devised these to-do lists or these assessment checklists for almost any skill, for any surgery. You have for phaco, you have for trab, you have for pediatric surgeries. You can find it online for free. It is a blessing for trainers. And I'm quoting what Dr. Rajat sir told in the very first talk. When we know what we are supposed to do, life becomes a lot more easier. I think we have come to a full circle right now. And you even have an app for Oscar rubric. You can type in ICO Oscar on Play Store or App Store. You can download them for free.
You have 1 minute remaining, sir.
Yes. So what you've tried to do here is to introduce proven principles of effective teaching and imparting those principles into our daily surgical practice. There is a way to do Rexes. There is a way to do trench. If there's a way to do trench, there is a way to teach how to do trench. So let's teach surgery scientifically. Let's all teach to reach. Thank you, Yosi, for the opportunity.
Superb, Pranesh. It's always a pleasure to hear you talk, and it was 10 minutes well spent. We really learned a lot from you. I think I'll give you my feedback and my appreciation for you on personal messaging as well. So I look forward to learning more. So next we have Dr. Anujit Paul. He's a resident in Pondicherry. He's going to tell us about avenues and perspectives of a resident after two cruel COVID waves. He's got a lot of publications, I believe, on the same subject. It's very nice to have you, and you have so much clarity even as a resident. So go ahead, Anuji.
Thank you so much, ma'am, and thank you AIOS and YOSI for the platform. So the session was about the extraordinary resident, but the two cruel waves of COVID affected most of my residency and most of the residency of a lot of people. And these are my perspectives and the perspective of any resident going forward after two waves and how they can make the most of residency, as well as how not all is lost. There is something to salvage from both the waves of COVID as well. So sometimes the goals of a resident are not exactly clear, but I went on to the NMC guidelines, and these are the quote unquote statements mentioned by the NMC as what a resident should ultimately achieve after 3 years. They are the following. A resident must be well versed in clinical and investigative modalities. He must have individually performed as well as managed complications of lid surgeries and other superficial surgeries. He must be competent in cataract surgeries, and he must have a desirable knowledge to perform intraocular surgeries other than cataract, like retina as well as glaucoma surgery. Now, turning back the clock, we all know that the COVID wave has now loomed upon us for about 2 years. There was one wave in 2020, followed by a second wave in 2021. The second wave sort of waned in September 2021, and there was a small third wave as well as COVID variants in 2022. So we are looking at a period of almost 2 years of residency training loss. Having said that, there are some perspectives of a resident going forward, and for the purpose of making it a slightly more simple, I will be dividing it into a clinical and surgical, an academic, a research, and a psychosocial perspective. So patient care during the entire COVID-19 pandemic dipped immensely, both for clinics, OPD, specialty clinics, as well as surgeries. A retrospective study that was done between the periods of 2020, comparing it between the periods of 2019, actually showed a reduction of 97% of OPD outflow, as well as emergency services decreased by 35%. Coming to the surgical aspect of it, we all know for a resident to hone their skills, ultimately it is the state-sponsored camps that they get cases from. The DBCS or the NPCB target for every year is about 66 lakhs. And though the data for 2020 and 2021 is not out yet, you can see that the 2019, 2018, and 2017 data is more or less meeting with the target. It is well assured that the 2020 and the 2021 data will be much less, which means that residents have got a really lack of surgical skills going forward. In fact, Dr. Akshay Nair et al. Conducted an online survey where he saw that residents are deeply impacted by the decreased surgical training as high as 80.7%. So these are some photos of what I was doing during my residency instead of being in the OPD or as well as the OT room. These are photos of lid suturing done by PPE. The photos are they're not purposely hazy. In fact, they are hazy because this is the exact view that you get while you're screening a patient. This is some photos from the second wave of COVID when we had to screen for CRAO in cases of mucormycosis. In fact, the photo on the right has been published in IGO as well, which I will come to a little later. These are some more photos of where I was in my second year of residency instead of the ophthalmic clinics. The photo on the right is someone exclaiming at the admission of one more patient into the COVID wards in the middle of the night. So there's been a lot that has been lost in 2 years, but it's not fully lost. In fact, there have been some mitigative measures as well. Two of the primary mitigative measures that maybe can be taken forward is wet lab training, as well as the changing paradigm of resident teaching. Wet labs have a huge advantage because they help you hone your skills and also protect patient safety. There have been a lot of innovations in the wet lab as well in this regard. The changing paradigm of OSCE teaching has actually allowed consultants, professors to vary their teaching among residents. For example, you are only stuck with a couple of cases which you end up knowing the night before your final exams. But OSCE goes for a more compound, a more comprehensive knowledge taken from the resident. Having said that, we come to an academic perspective where academic classes or patient exposure or bedside teaching or clinical teaching has been extremely hampered, but there has been an exponential rise of online classes, which has actually augmented postgraduate teaching. So the photo on the right shows me actually eating an apple and attending an Arvind seminar, which I believe would be impossible in a real life scenario. So as the photo states, you can eliminate the cost of travel, you can eliminate the time and place, and actually cater your learning and taper your learning to your convenience, which is actually an advantage for residents in going into this these couple of 2 years. Additionally, it's difficult for residents to attend every single conference, but from the comfort of their home and almost every conference going virtual for the past 2 years, this has been made quite easy. So this is me attending an AIOS-YOSI panel 2 years back. As you can see, the who's who of ophthalmology is on this screen. And without the COVID-19 pandemic, I don't feel I would have stood a chance to share screen with them. This is from 2021's AIOS-YOSI Forum. Another chance which I only got because of probably the COVID-19 pandemic and physical needs curtailed. Then we come to a research perspective. So a new disease obviously breeds scope for new research. In fact, Dr. Bharat Gundani sir wrote an article in the IGO mentioning how there was a rising trend of COVID-19 related articles as well. However, with this positive note, there has been a problem with dissertations because students and postgraduates are missing to meet their sample size for correction, as well as core fields of ophthalmology taking the sidelines. Research in the core fields of ophthalmology not done now might not seem like a big deal, but maybe 5 or 10 years from now will have an effect. In fact, through this COVID-19 pandemic, I myself got to test myself in the field of research. These are 2 articles that I published. We noted a case of bilateral retroorbital optic neuritis in a COVID-19 patient, as well as give my take on making the most of wet lab resources with a single microscope as well as single wet lab setup. Last but not least, we come to the psychosocial impact of COVID. So Dr. Khanna et al. Conducted a study in 2020 to assess the mental health among the residents and trainees during COVID-19 and found that there was 32% of them had some degree of depression. This is primarily attributed to the fear of a longer training period after residency because of inadequate exposure. Frontline work being not the domain of expertise for ophthalmology residents, us not being familiar with management of COVID patients. The fear of contracting the disease itself, it still looms quite high, as well as family constraints and financial constraints going forward. So 2 years have been lost. There's been a loss of clinical as well as surgical skill. There has been a boom of academics, but the loss of wet lab teaching. There has been a boom in research, but a stark effect on thesis completion as well as core fields of ophthalmology. Plus, there's always a looming threat of COVID. This has affected us for 2 years, but then there are some valuable additions that we can take forward. Firstly, the impact of COVID has affected all residents in the same way.
You have 1 minute remaining, sir.
Okay. It has opened new avenues for research. Online platforms eliminate the need for time and location, as well as eliminate resident-specific teaching. And finally, there are wet labs and simulators, which previously would play a second fiddle to patient care, are now taking primary importance. So there are some takeaways that we can go forward and make the most of what has been lost over the past 2 years. Thank you very much for your attention.
Thank you, Anujit, I think, for that lovely presentation, and indeed something that was a unique situation, and the best use you can make of it. So if we can just get all the speakers to switch on their videos, and we don't have too much time for discussion. Actually, we have to hand it over to the next session, but we can take a quick snapshot. So all the speakers, are you there? Megha, yes. Admin, can you take a screenshot?
I am taking one.
You're taking, okay.
Yeah, 1 second. Yeah. Done.
Wonderful session, I think, everyone. And amazing, a lot of insights, very nice talks. And I'm glad we started with this session right in the morning. So I think Apurva, over for you to continue the proceedings. And
Yes.
Next.
Thank you, Digvijay sir, and thank you all the speakers for amazing talks. I really enjoyed the session. Thank you for making it so worthwhile. So let's have the next session now. Karan and Divakant are here. They're going to take over from here. Thank you, guys. Thank you.
Thank you, Purva. It really was a fantastic session, and everybody brought out wonderful talks. So our next session is continuing with the flow, and the credit actually goes to Apurva, and I think we should say this multiple times, for which, because she's the one who has designed and planned the entire program, our academic in charge. So the next session is the peers interactive. Get all your burning questions on fellowship answered by YOS. So this will be moderated by myself and Devakant. Devakant, are you there?
Yes, I'm there. So
Yeah.
let's, without wasting any further time, I hope all the panelists are here: Dr. Niluparna, Dr. Aparna, Dr. Siddharth, Dr. Aditi, Dr. Raman, and Dr. Harika. And may I invite Dr. Bhavya to start sharing his screen. And just before the session, I was discussing with Dr. Karan. So we realized that the best person to introduce oneself is yourself. So please give a very small one-line introduction before you start your talk. Please, Dr. Bhavya, over to you.
Thank you so much, Dr. Devakant sir, for bringing this around. My name is Dr. Bhavya. I am a consultant with AIOS-YOSI Hospitals. I've been an alumni of Sri Shankaradeva Netralaya, and here I am. So is my screen and voice, everything legible around?
Yeah.
Yes, Bhavya, but you have to share your screen. Yeah, enter slideshow mode. Yeah.
Yeah, I'm good.
Yeah. Yes, please go ahead.
And Dr.
Okay, so
Bhavya
good
is the only stand-up comedian who is also an ophthalmologist, or the other way around.
Yeah.
So, yeah. So go ahead, Dr. Bhavya. Yeah.
Thank you so much. Good morning.
So, Bhavya, we should expect a bit of comedy in the middle as well.
Absolutely, it's just coming. The very fact that we are talking about phacoemulsification in the morning, whether to go for fellowship or trust, is biggest form of humor. So good morning. As we start the topic, it's a burning one. It's a phacoemulsification perplexities, fellowships versus trust hospitals. I'm going to dive into the different paradigms, the different dimensions that as a resident, as a fresher, and as an ophthal himself, all of us, we have faced it and proceeded with that. So there are no financial disclosures. It's just a story of struggle for the most perplexities, which is, I don't know how to do a phaco. That is what the 10 minutes are going to be all about. So the confusion, whether to take up a fellowship or whether to go to a trust hospital, the eternal confusion between both of them. So we bring our hero back to this new juncture called phacoemulsification. And I fondly call this hero as Motioman, who's the cataract learner, the phaco man, and let him reintroduce himself to the new challenges which he's going to face ahead. So the spectrum of questions: why, what, how, where. As soon as you are a first year resident, the word phaco becomes a part and parcel of your thoughts. Why? Come on, because it is the cataract. Statistically speaking, cataract is the world's leading cause of blindness, said by WHO, and learning cataract is the most important surgery in ophthalmology, referred by who's who of ophthalmology. What makes this perplexity so important? Because it is my story, because it is your story, because it is our story, and it is every single ophthal's story. All of us are aware of the fact that this meme is very self-explanatory. Instead of first year resident, I could apply all the residents. Instead of diverging towards the steps of cataract surgery, a resident is busy doing his ward work in most of the institutes that we see. So let's actually throw some light to why do we really need a phaco fellowship or a trust hospital as a stepping stone to our careers. Statements that all of us hear during the residency, which are not so pro cataract learning. My next turn comes too late. Patient's BP miraculously shoots up to 200 by 120 because he has forgotten to take medications on the same day. Your turn gets cancelled and the seniors do their cases. And a very sad story. I don't like going to the wet lab. I've been fondly quoting this, that wet labs are like dinosaurs. All of them have heard about it. They knew that they exist, but nobody has ever seen them. So all in all, residency at a number of places is holistically a bad destination of doing cataract surgery, and hence the common dictum, bahar nikal kar kar lenge. Now, the struggles post-residency. Deciding a fellowship with a burning introspection, if they give a cataract training along. I've seen the most focused and the most elite and the most intelligent residents turning into fellows, going for fellowships other than phaco-refractive, still asking if they're going to get some phaco exposure in their residency. Evolution to phaco-emulsification from SICS, because yes, that's a very important step. And of course, the economic aspect, because the moment you are an MS, the moment you are a DNB, the moment you are a DOMS, the economic aspect starts shooting in. The second question, where would you learn phaco-emulsification? This is a very nice triangle of learning curve, which I call the triangle of freshers, which I have developed. It shows surgical exposure, good pay, and comfort zone at 3 different points. If you see any setup where a fresher is working, if you see any setup where a fresher is serving or learning, only 2 out of these 3 will happen. You go to an elite center, you do your SR-ship, you'll have a decent pay, you'll be in your comfort zone, but there won't be a surgical exposure. You go to a very peripheral center where there is too much amount of surgical exposure, they'll pay you good, but it will be out of your comfort zone. At the same time, if you go for a city which is high volume and it is in your comfort zone also, of course, they won't pay you good. So out of these 3, only 2 will be sufficed at one point of time. And that's the biggest confusion that a fresher faces. So the road called trust hospitals suddenly popped up, and it's not new. It has been there since the previous generation of ophthalmologists. These trust hospitals, they function under the umbrella where you can actually do numbers. They could be a solo practice, they could be a clustered practice. A trust hospital where basically they are doing charity cases, and the ophthal side of the story is you go there to do numbers, you go there to learn, and you go there to polish your skills. The first perplexity is the first phaco surgery, because you have studied residency and then suddenly you start learning or you start having to do phaco. The pros, you're a consultant there, it's independent, it relatively has more numbers, they pay good. Patient expectation is low, there is no fixed timeline, like you are not bonded for a year or 2 if you're not into a bonded with that particular trust, as I call it. You have an independent decision making, and of course, it's a professional growth. You start serving that trust. If it is somewhere around your area of settlement, you start building up your name and your patient pool. The cons, the independence becomes aloneness. Like I might get personal at this moment of time because I come from Gujarat, and we usually have solo trusts, and practicing alone does become an issue because probably you don't have anybody to handle your complications or to teach you at the point where you get stuck up. OPD surgical imbalance because you're the one who's seeing OPD, you're the one who's operating. Low salaries eventually, because if you feel that the trust hospitals are paying good, I'm sorry, we are mistaken. Low patient expectation induces recklessness, which is a very derogatory or which is a very detrimental term for learners like us. Surgical misadventures, complication rates, because they shoot up when you're working alone or when you are at a place where you relatively are there to learn. Tunnel vision towards cataracts. You start focusing your career, or you start focusing your learning more only towards cataract. And of course, detachment from the academic world because you get into the number game. The second umbrella, the phaco fellowships. They could be short term, they could be long term. And they could be with refractive surgery, as most of the institutes are providing. The major perplexity is there, which is hands-on and numbers, because they say that they don't give so optimum numbers as compared to your own a trust learning curve or a short-term fellowship, which is paid in nature. The pros being, yes, of course, you learn under an expert guidance. They give a step-by-step approach. There is an academic touch. There is a quality and a corporate exposure. There is a fixed timeline, that it's a 1.5 years course or it's a 2 months short-term paid FACO fellowship. So you know that you're going to get a finite number of cases. So this is how you're supposed to learn. Of course, you get a wet lab training exposure, and you get exposed to the most fancy machines and the different dynamics of the FACO emulsification under expert guidance. Of course, you get a refractive exposure. Of course, you get to see complicated cataracts and how do the people manage, which probably being in an independent trust setup, you would not have ventured to do that. And of course, it is patient satisfaction oriented. The cons, majorly based on the teaching surgeon, which is very subjective in nature. Paid short-term fellowships, of course, you call it paid, right? So stepping out of your MS and having to pay to learn something is not everybody's cup of tea. It's a long-term course. It's skewed at the ends. In the starting, you learn less, and in the last 6 months, it picks up pace, or you get major chunk of your hands-on in the last 6 months. They're relatively less number. The independent exposure to complications is curbed because obviously you have somebody above you. And of course, geographical disparity, like somebody living in the northernmost.
1 minute remaining, sir.
Would have to travel. Oh my God. So what do? You start with SICS, and there are 2 types. I would have to skip fast. So things to consider, you inquire proper numbers, you go for bonded, non-bonded, you go for complication management. And these are the things that you consider. Look for an institute that teaches you A to Z of pharmacodynamics, because to draw is a skill, to paint is an art. And of course, time and space are relative. So be wise in choosing the institute. SRship bonded avenues are also considered. Go to the institute where they meticulously teach and you are allowed to be verbal about your insecurities, be it a running rhexis or a hydrodissection. And a setup with a posterior segment is always beneficial on a lateral thought. And finally, how? Because, well, the entire EOC exists to guide. It allows you networking. How do you decide these institutes? You have a list of institutes which are there at these particular junctures. And my story specifically, insignificant but yet worth sharing. DOMS from a government institute, a paid short-term fellowship, a trust hospital exposure, and finally secondary DNB from Sri Shankaradeva Netralaya. And as a coincidence and as a pleasure, I have somebody I consider my guru, Dronacharya, Dr. Nilutparna Devri ma'am, who is a trainee, who is a panelist and who was taking care of all the trainees. I specifically remember the meticulousness that after trust hospital exposure, I came down to Shankaradeva, and this is how it gets instilled. And currently, finally, I'm a phaco-refractive surgeon at AIOS-YOSI Hospital. So this was the entire scenario: exposure optimum, complications plenty, and learned infinite. So seen all the worlds possible, and that's how landed up deciding that this could be a nice way to do that. Probably you could start with a fellowship under a training or under a trained setup, and then you could go to a place where you're relatively doing numbers. So that would be an ideal thing to do. And finally, be aware of 2 optimistic people. One over optimistic who says that.
So your time is up.
Can I take 30 seconds? Yeah, the last controversial food that I would leave the young ophthalmologist is: do we really need a fellowship for cataract? Can the residency programs become self-sufficient? And are we genuinely lost in the number game? So I guess that's the take-home messages. Don't take home messages, take home optimism, take home some beautiful bonds, take home the stories, and take back home a part of you that's lost in the rat race. So that's it from my side. Dr. Bhavya Gokani signing off. Thank you so much, EOC and AIOS, for having me here. Thank you so much.
Thank you so much, Dr. Bhavya. Dr. Nilutparna, you're there, right? So a wonderful talk, Bhavya, and you have pointed out some very pertinent points. And you have also mentioned that Dr. Nilutparna is your Dronacharya. So we'll ask her for her comments. So Dr. Nilutparna, it's difficult for us. It is difficult for us at YOSI to really, control how the residency programs function in our country. But if somebody comes to you post residency for cataract training, so what are your top pointers for that person so that that process can be expedited? Because from a very practical perspective, cataract is indeed, fortunately, unfortunately, the bread and butter in the market today, right? If we see from a very financial and economic perspective. So your pointers on that, please.
Yeah, I have a few pointers in that. First and foremost, thank you so much for including me in this session. And second, Dr. Bhavya Gokani, thank you for considering me your Dronacharya. I think I have been harsh on you a lot of times. But thank you so much. The pointers that I would like to say, as he has mentioned in the slides also, first and foremost, the resident who has come to us for learning, sometimes they come from the same locality or sometimes they come from outside. So the best thing is to first adapt to the environment, and then get a idea about the institute, what you are supposed to get. As a teacher, I feel that we should be more comfortable with the students when they come. We should be more welcoming. That gives a comfort zone for the students. Now, second point is how to go ahead with the surgical aspect. So in order to go ahead with the surgical aspect, I would definitely say that you should be very observant in what you are watching. One. Second, you should be like a sponge to take in whatever you are getting. Do not compare with others, how much they are doing, what they are doing, because every individual has his own set of skills to learn. And it's not that everyone learns from one single case. Some takes 10 cases, some takes one case. So I feel that it is really important that you have a conceptual learning both for as you have for academics. You should also have a you should have a conceptual learning for your surgical skills as well. So that is my take on that.
Excellent points. I would, this question, I would also like to take it up with Dr. Aman, because I remember us discussing this point before he was about to go for his fellowship. Aman is an excellent, by the way, a phaco and a retina surgeon. And just quick 30 seconds, Aman, on what would be your take on it?
Yeah, before when I finished my residency, I hardly did any cataract surgery. So this was a big question in front of me also, to decide whether to go to a trust hospital or to do a fellowship. So I had a lot of discussion with Karan regarding this. So now at the end of, after completing my fellowship and a very good presentation by Dr. Bhavya, he has put all the points forward. So when you do a join a trust hospital, the basic problem is that when you land into trouble, there is nobody to stabilize you or nobody to handle your complications. So if you end up doing complication in 5 or 6 cases, it kinds of demotivates you and you tend to fall back and there is nobody to hold you there. So my opinion would be, like, first you go for a good phaco fellowship or any paid fellowship or a long-term fellowship, depending on the options you get. And if you want to join a trust hospital, yes, you can join after your fellowship at trust hospital so that you can just polish your skills before going into a corporate or a private practice. So that will be my opinion on this.
But Dr. Aman, it's not really fair, grabbing best of both the worlds, retina and cataract. But that's fine. We'll live with that. Dr. Karan, let's start the next one.
Excellent talk. Over to Dr. Ajinkya, who will be speaking on, is pediatric ophthalmology a good career choice?
Thank you, Dr. Karan. So I'm Ajinkya. I'm practicing pediatric ophthalmologist and strabismologist, and with special interest in community ophthalmology and research. So coming to the question of my topic, I would answer in one word first. Yes, it is a very good career choice and a very promising one. Why? Let's see. So children are 1/3 of our population and all of our future. And so is the magnitude of this problem. Even in India, there are more than 410 million children who are less than 16 years of age. And the prevalence of childhood blindness is 5 times as that of it's seen in developed world. Overall, 60 to 70% of the childhood blindness is either avoidable or treatable, and rest 30% requires low vision and rehabilitation care. So you understand what is the magnitude of a pediatric eye care problem in our country. As per WHO, one children's eye care center is required for every 10 million population, where at least one specialty trained or specialty oriented ophthalmologist should be available. And now this warrants immediate doubling of the number of dedicated children's eye care units across India. So this is the first point, the magnitude of problem and the requirement. There is a huge gap. Now, what is our patient base? So we deal with this huge patient base, right from the preterm newborn to the newborn, infant, toddler, preschool children, school going children, and adolescent. All these different age group patients present with varied spectrum of eye related problems. Additional to this, we also deal with adult squint patients. So we have a huge patient base and a lot to work and lot to do in this field of pediatric ophthalmology and strabismus. Now, you know, monopoly is the condition of every successful business. So how do we have the monopoly? Many comprehensive care providers do not feel comfortable managing pediatric patients. And we manage various ocular issues, right? From the eyelid to the anterior segment to the optic nerve to the posterior segment. I would go even behind to the cortex in cases of cortical visual impairment or cerebral visual impairment. And we manage these patients with rare and complex disorder, and we get to work as a team with other pediatric subspecialties. And we are a hot commodity. There are very low numbers of pediatric ophthalmologists, and this allows us for ability to find work in an otherwise saturated job market. I'm not sure about the increased power of negotiation though, but yes, few say it is true. The most important thing which we usually talk these days and people are getting aware not only in medical field but otherwise also, so this work-life balance is very important. So how do we have it? How do we achieve it? So being in pediatric ophthalmology, there are relatively low after hours and on-call responsibilities compared to the emergent retinal detachments and entrapped orbital flow fractures. There are relatively few amblyopia and strabismus related emergencies. So we pediatric ophthalmologists, we enjoy a good work-life balance. Now, strong relationships. Many pediatric ophthalmology issues such as amblyopia, strabismus, glaucoma, ptosis, ROP, these all problems, they have long-lasting impact on the eyes and the visual system, and it requires continued follow-up. So if you are someone who likes to build the relationships with your patients and watch them grow and improve, mind you, this field is for you. Again, there is a lot to do in public health and international work. One can find funding opportunities for community outreach program, both locally and abroad, where there is significant need for pediatric ophthalmology care providers. Now, what is QALY? We have all learned in the preventive and social medicine. It is quality adjusted life years. So the vision that you save in a child in childhood will serve your patients their whole lives. So you operate one adult cataract and you gain 20 years of vision on an average. You operate one infantile cataract, you gain 80 years of vision. Again, if you treat an amblyopia, you see the amblyopia being treated, the vision getting better with each visit. This dramatic improvement in vision will assure you that these patients will get to keep this vision for their adult lives. And mind you, the satisfaction that gives you by preventing or gaining these light years in these terms is really very satisfying. And taking care of children is fun. You get to play the games, use toys, you stay young at heart. I remember most of my YouTube playlist now consists of 5 Little Monkeys jumping on the bed or Baba Black Sheep, and I really enjoy it. And kids in OPD, when you see them, at least in each OPD, you will have that one cute kid which will enlighten your day, and you will be free from all the tensions and relief and all the worries which you are facing throughout the day. And they will do the funniest things, and you will always have the stories to tell and share with your friends and colleagues. So I will leave you with this thought that the idea is to die young as late as possible, and being in the field of pediatric ophthalmology will ensure you to get closer to this idea. Thank you so much for the opportunity.
Thank you, Ajinkya, for that wonderful talk. So we have a pediatric ophthalmologist here amongst us, that is Dr. ND ma'am.
Hi, ma'am.
Yeah. Ajinkya, it's great to see you after.
Great to see you, ma'am.
Yeah, after 2 years, I guess. Yeah.
After physical AIOS.
Yeah.
Yes.
It's a great talk. Yeah.
Dr. Nilparna.
Yeah.
So I just wanted to say that Dr. Ajinkya has made a very good pitch for pediatric ophthalmology. So he has pointed out all the good things about pedia, and I work with a pediatric ophthalmologist in my current practice, and I can vouch that all of them are true. But we would like you to focus on some of the challenges that a pediatric ophthalmologist might face, right?
Yes, definitely. See, basically, to even take up pediatric ophthalmology as a fellowship subject is that you must like children and you should have a lot of patience for these children. So that is the basic idea about this fellowship. Because if you think that it's just like any other surgical procedures or surgical fellowships, it's not like that. It's not like that. You have, as Ajinkya has pointed out, it is about dealing not only with the children, you have to deal with the parents as well. And you have to be very, very educative about your management protocol. You need to educate even the parents what you are going to do and how you are going to set your follow-ups with the children. So I feel the most difficult times that the fellows face is that they feel that bhaiya mere se to bacha sambhala nahi jayega. That is the most important thing that they say when they first come to us. And if you ask any resident or any resident to say, do you want to take a pediatric ophthalmology? Says, no ma'am, we just can't do that, because they feel that it is difficult to handle the children. So that is why I am saying that the most important criteria is that you have to like the children and you have to dedicate yourself towards the childcare services. That is most important. And it really takes up a long time for you, the counseling part, the training part. So patience is the most important factor here. So these two aspects I'll definitely say.
Yes, indeed. Thank you, Dr. Nilparna. And thank you, Dr. Ajinkya, for a great talk.
I would like to add one more thing. I think Ajinkya, he has presented a good paper in the morning. Squint is something that students are scared of. So don't get scared of strabismus. That is actually fun. No, Karan, don't raise your hand. Your wife is in pediatrics. Thank you.
Thank you.
Ma'am, the best thing that I got is my wife is pediatric ophthalmologist. So I don't have to actually worry about squint. Otherwise, squint was to be.
This is what I'm saying, the attitude. You have to change the attitude to get into pediatric ophthalmology.
That's why he is not into pediatric ophthalmology. Now, Karan, let's move ahead.
Let's move forward. Yes. The next talk is by Dr. Shishir Varghese on the reviews of surgical retina fellowship. What you expect from one. Dr. Shishir, can you please share your screen?
Yeah, sure.
Yeah.
Dr. Shishir, I would request you to keep it brief so that we can have more time to discuss with you and the other panelists.
Thank you. Sure, definitely. Yeah, can you see the first slide?
Yeah.
Yeah, perfect.
Perfect.
Yeah. Okay. So thank you, Yosi, for giving me this opportunity. You all want me to talk on retina, something which takes more than 2 years to complete in 10 minutes. But okay, so here we go. It's not moving forward. Yeah. So before you start the fellowship, you should decide why you really want to do a fellowship and talk to somebody. You know, there are a lot of pros and cons of a retina practice. So the pros are you have your mind challenged. You can be a savior for the anterior segment complications. You will be recognized in your community. You know, you'll be popular among the local ophthalmologist community. And also, if you are a posterior segment, why not get married to somebody who has anterior segment? But there are a lot of cons also. You see that all cases, like other subjects too, retina, all cases are different. And there is an effort required to learn and practice. A lot of effort is required actually to gain clinical as well as surgical skills. And there's a steep learning curve. Monetary gains are not so much for the amount of effort you put in. And even if you gain something, the profit margin is quite minimal, not like how you have in cataract surgeries. And it requires a long-term fellowship because we don't believe that you can do a full retina surgery in 3 months or 6 months. It's not possible. And obviously, after fellowship also of 2 years, it requires a guidance. So I have asked this to a lot of our fellows, why retina? You know, like, why have you chosen retina? So no retina surgeon in my home city. That was one answer. My spouse is practicing anterior segment. Never had the opportunity of learning retina during PG. I want to do a short-term retina because I can manage my own nucleus drops. So I like the surgical aspect. It's very challenging. It's a very fascinating, intriguing subject. In my hospital, the retina department was very chilled out, very cool people. So I want to take up retina. It has more scope. I was inspired by a mentor who was in retina. And some even answered that I found other subspecialties more difficult. So my reason was obviously intriguing, yes, but the main reason was without knowing retina, you won't know the cause for decreased vision in a patient. And it's also, you'll be confident and do a complete ocular examination when a patient presents to the OPD. So the first question you ask before you join is, like I said before, time. Are you willing to put in time? So most surgical retina fellowships are 2 years, but that's actually not enough. And vitreoretinal surgery is a steep learning curve, like I said before.
Dr. Bhavya, can you please mute yourself? Dr. Bhavya, can you please mute yourself? Yeah. I would request people who are not speaking to actually mute yourself so that the speaker's flow doesn't get disturbed. Over to you, Dr. Burgess. Sorry for the interruptions.
Yeah. So before you join you think of taking up retina fellowship, you do a self-analysis. You know, after I finish my post-graduation in ophthalmology, yes, I surely want to do retina. But am I familiar with good anterior segment examination and surgical techniques? Do I have enough hands-on in managing anterior segment? If I do, yes, you should your retina fellowship will be a relative ease. It's not easy, but it will be a relatively easy. If no, then your struggle is increased as the first few months or first even half a year or more than that will go in just managing anterior segment, because you'll be struggling to do AC paracentesis, holding the globe, difficult in managing the microscope. Simple procedures will make it even more difficult. So better to get a hands-on comprehensive training, like at least for 6 months or 1 year before you actually think of joining retina fellowship. Have a good anterior segment management training. So then you come to choosing an institute. So that has a lot of factors which you decide when you choose an institute. If you go to vrsi.in or even the AIOS website, there are a lot of retina fellowships centers which are described there. So it depends on observation. So first of all, you can go there for an observation. You talk to any ex-fellows or seniors from the institute, see how much hands-on you get. You tell them about how much you're experienced. Your decision can also be based on the city and also on the surgical chances which the institute provides. Also, you have a option between a private going for a corporate institute or versus a tertiary eye care center where the numbers will obviously be more. And you can have a structure and go for an institute which has a structured training. You'll be here and then after a week, you'll be posted somewhere else, something like that, a structured training. You are going to get your numbers like that. And then obviously some of them will have a waiting period. They'll ask, and in that time, you can probably, brush up on your anterior segment more. And you can also choose institutes with a bond versus, no bond. That's also influencing factor. And obviously short-term versus long-term. So short-term, I really don't believe in. Retina is always a long-term fellowship. So you are a new VR fellow in the department. So what you can expect? So you can expect to see a lot of patients, obviously, in the OPD, and there'll be a lot of variation of normals. So you will get access to diverse cases, different presentations of a disease, access to imaging, and also you'll get classes and teaching by the seniors. Now, what is expected of you? You are supposed to learn, perform, and show indirect ophthalmoscopy as a beginner. Charting of retinal detachments, obviously. Ask questions, any doubts you have to ask. And if you see something interesting, you have to read upon it on the same day. So all this goes into gaining a clinical skill. So the depressor and the indirect ophthalmoscopy and your 90D will be part and parcel of your life. You'll be going through the OPD, seeing the retinal diseases or fundus examination, doing indirect, learning about FFA, interpreting FFA angiograms, doing B scans on patients, doing as well as interpreting OCTs. And also you'll be doing indirect lasers as well as lasers on slit lamp assisted lasers. So all this forms part of your OP workup as well as OP procedures. So charting of RD is very, very important. When you are as an initial fellow, you'll be taught how to chart. The problem nowadays is most of the system has become EMR. So you really, the practice of charting is actually lost, as now most of the things are on the EMR. But charting, if you do it, it's really good. And then it forms a basis of, you'll be perfect in your anatomy and you'll be perfect in your examination, and you'll be confident as a surgeon if you are doing your charting. So, and also in the OP, you'll be posted in different subspecialties. Now retina has multiple subspecialties. You can choose, you can be posted in uveitis. You will have be learning stuff with a mentor for macular diseases. Even pediatric retina and intraocular tumors are a different subspecialty now. And Arvind is offering a 1-year pediatric retina fellowship, separate after you finish your 2 years of VR fellowship. So you will be you'll be screening for ROP. Then also you'll be doing access to ROP laser. So all this forms part of your basic OP training and procedures. So it's an ever winding road. So once you will be in retina OPD, you'll be starting off, and then in 1 to 2, after you learn the basics of the OPD, you can manage and identify some amount of retinal diseases. You'll be starting off with your OP procedures, your B scans, your lasers, other things. And then in 3 months, you'll be posted in the after 3 months, once you have basic training in the OPD, you'll be access to the retina operation theater. And then you'll be giving injections. And after the 1 or 2 weeks, that's already, by the time it's already 6 months, and you'll be starting your cases, silicone oil removal or clearly fixated IOL. These are the initial cases where you can judge the fellows on how they are doing their anterior segment, how they're doing well with their globe management. And then down the line, slowly, 6 to 8 months, almost towards the end, like, 3 months before or even 6 months before your fellowship, depending on the capability, you'll be given retinal detachment cases or, vitreous hemorrhage cases, and you'll be confident in handling them single-handedly. So in when you are doing your fellowship, you have to set some goals. It's easy to get lost because OPD is quite busy. It's easy to get lost. So you have to have your own personal expectation, as well as you have to manage the institute's expectations too. So, and you also have to manage different personalities and gain a collective experience. Not everybody is bad, not everybody is good, but learn all the good points from everybody. That's what, sets you apart from the others. So you have to have a good clinical education and a self-directed learning. It's like I said, go back and read something, and then you'll get to manage the next time in a different way. So at the end of fellowship, you should have a clear plan or an action or an algorithm for managing common retinal diseases. So next,
you have 1 minute remaining, sir.
Yeah, coming to maximizing VR surgery. So earlier, before you should do a simulated training, learn your machine, your microscope, the foot pedal, read on retinal, go back and read regarding surgery, assist and question the seniors. So simulators, not all institutes will be having. Sit with a mentor and learn and see how they do surgeries in a different way. Then once you are an intermediate, do a step properly, then do a case properly. And numbers don't matter. It all matters how you manage the patient. And next day, the post-operatively, the patient should be good. You should do a good job on a single patient. Don't go for numbers. Watch a lot of videos. Okay. And then, so sit, once you're performing surgery, a mentor will sit with you and assess how you're doing. Learn to put ports properly. Okay. And then once you're advanced in your end of fellowship, record your videos, discuss these videos with your seniors, log your cases, follow up your patients, and also teach others, teach more juniors on how you perform. So once towards the end of your fellowship, you can sit single-handedly and manage simple cases. So initially, you'll be given silicone oil removals like this. You should know how to do a proper exam, depress the fundus, see the periphery, see the aura. Then you'll be, and if you're complacent, you'll have problems like this, retinal touch, that too with a light pipe when you go inside. Then you'll be managing oil removals along with sclerally fixated intraocular lenses. So all this will decide in the initial phases how you manage well the globe, your anterior segment management and all those things. Then you'll be moving on to simple RDs like this, where the PVD is already there. And once you are confident in your simple RDs, more complex cases where the PVD is not there. So here's a video of a fellow trying to induce a PVD. And then you can sit and assist, obviously, scleral buckles. And also you will be given chance to put sutures and putting the bands. So go back and read, look at a lot of videos, VR surgical procedures, a lot of material is available, YouTube, Facebook, iTube, and even on Instagram, Retina Tips is there. You can go back and look at those videos. Try to squeeze in some amount of research. Personally, I did only I got only one or two papers out during my fellowship. It was mostly after that where I started doing research. But if you have time, you can, that's also a part of learning. So always multitasking, you have to learn how to start to learn multitasking. You'll feel that there are not many hours in a day. So time management is very important. Work-life balance may be difficult. So you have to fully immerse in the field to gain the most, especially when you are in retina. So after you are finished, you feel like you have had a well-rounded fellowship. You can discuss your options with your mentors and colleagues and see, you can do a self-assessment. Am I good or do I need to continue? So you can continue in the same institute or you can join elsewhere, but under guidance. You feel if you can manage on your own, yes, go ahead, but be wary. And also you have an option of further continuing in pediatric retina or in uveitis. So to conclude, clarity before you enter and during while you're doing, you should have a clarity of the clear goal of what you want to do. When you are in retina fellowship, you should learn and maximize that opportunity. Enhance your clinical skill. That's the most important. Watch, discuss, and learn surgery.
Your time is up, sir.
Yeah, whatever the path, enjoy the journey, and it should be committed to lifelong learning. So thank you. And if you are in retina, it is fun and time flies when you're having fun. Thank you.
Thank you so much, Dr. Varghese. May I request the next speaker to start sharing the slide? Meanwhile, we can discuss a few points. So very comprehensive presentation, Dr. Shishir, and you have almost covered all the points that I wanted to discuss. So one thing that I wanted to ask you was, what is your take on a solo retina practice? I mean, do you think it is feasible in the present scenario?
Yeah, a solo retina practice is feasible, but as you need to have a dedicated team, a dedicated team of sisters. And even if you have like a mentor who's guiding you through the practice, it will be easier, at least for the initial period of time, after which then you can be kind of independent. So if you're asking me whether you should go for a solo practice immediately after fellowship, no, I would not recommend it, because the whole idea is that you should know how to handle not a case, but how to handle a retina OT. So when you are outside in a practice, when you're doing your own solo practice, you should know how to handle a retina OT, by which what I mean is that you should know how to handle your complication, as well as if you're training somebody, you should know how to handle their complications. So managing a retina OT is different from managing a retina case. So even after your fellowship, you should be confident in how to manage a retina OT. So once you're confident in that, then I guess you can go ahead with the solo retina practice.
Right. Thank you so much, Dr. Shishir. And Dr. Aman, if you are there, your take on life after fellowship in the real world, in the private setup, your take on that.
You see, I very well agree with what Dr. Shishir said, that immediately after your fellowship, because during your fellowship, I don't think you get your hands on to the complicated cases like a grade C PVR or a diabetic vitrectomy with TRD. So during your fellowship, I guess your goal should be to learn the basics of the surgery. And after that, gradually, see, retina has a very long curve. It is not like you will learn everything very quickly. So it has a very long curve. So before going to a private practice, you should learn all the aspects of retina surgery. Like handling a retina OT is a completely different thing as compared to just doing a case that was what was said by Dr. Shisher. So because there are a lot of aspects attached with it, you have to keep all the equipment ready, because during your fellowship you don't learn all these things. During your fellowship you learn how to operate, and in the retina OT you have to learn about the machine, you have to see the microscope, you have to see all the instruments which you have to use. So there are a lot of aspects. Before going to a private practice, I think one should focus on these aspects, and then only you can think about starting into a private practice. Hello.
Perfect. Dr. Khanna, let's move ahead with the next talk.
Sure, we can actually take up. Is Dr. Siddharth there?
Yeah, I'm there. Yes.
Would you
Morning,
give some comments on the things? Siddharth is also a VR surgeon.
Yeah, actually, I was listening to talk by Dr. Varghese, and it would be my talk would be an extension of what Dr. Varghese has said, that how the pediatric ROP is going to be as a fellowship. So what I would understand from his talk is that after 2 years of fellowship, the residents are not really much confident, because initially they would be going in through screening programs, OPDs, then they would be acknowledged with lasers. As we were discussing, they would be just inducing PVDs. So full-blown surgeries, they may not be really confident at the end of 2 years. They need more time. And going into, as he mentioned, pediatric oncology is a separate field being offered by Arvind. So that is their choice later on. So point being that they have to be more dedicated to taking up a certain specialty individually. So if they are totally into ocular oncology, then they cannot mix it up with ROP. That is what I would say. So a long-term fellowship is a must, and their specialty, subspecialties after retina can be decided after 2 years. That is what I think, that 2 years are not just enough for them to build up their confidence. That is what I've understood. Maybe my talk can incite more questions, and maybe we can discuss. Thank you.
Sure. Let's move on to Dr. Rashmi Deshmukh, who will be speaking of international fellowships in the United Kingdom. Over to you, Rashmi.
Thanks, Karan. I would like to thank YOSI for inviting me for this talk. So today I'm going to talk about international fellowship in the UK. Most of the questions that come regarding an international fellowship in the UK start from how to shortlist the course up to how to actually reach there. So that is what I'm going to give you an overview about. So first, you shortlist the course, and then how you reach the final destination that you have in mind, that you want to do a fellowship in this particular place. So the different types of fellowships that are available for us as Indians to do in the UK would be a clinical fellowship, a clinical and research fellowship, a research fellowship which will not have any clinical work or surgical exposure, or a proper PhD, which is anywhere between 3 to 5 years. When we say clinical fellowship, then you don't have any research sessions in that. You just have clinical slots, and you have some admin slots where you have to do a little bit of admin work for the department. When it is a clinical and research fellowship, then you have a balance of both. So you might have 2 to 3 days of clinical work and 2 to 3 days of research work. A research fellowship is full-time in the lab and clinical research only. And PhD, again, depends on the topic that you are pursuing. Then how would you want to shortlist a course is, first you've decided what kind of fellowship you want. Then this is one of the websites, idocs.uk, which I used to visit quite frequently to see what all opportunities are there. It gives you details about the fellowship which is available, including the mentor who would be supervising you and the duration of the course. And the Royal College of Ophthalmologists also has this particular list, which also gives you very similar information like the iDocs UK, where it gives you, again, which supervisor will be there, what is the university, and how do you contact them, and what is the duration of your course. Once you have shortlisted, then how do you apply for the course? So for applying, there is this website called jobs.nhs.uk, which advertises all the available fellowship slots. So it comes under jobs category for them. So it will show you whether you have a cornea fellowship, a cataract fellowship, whether it is 12 months or 18 months or 6 months. And the good thing is it always gives in description of what kind of work you should expect and what kind of work they are expecting from you, including the salary and working hours and everything else. So then you could look at these this website and then shortlist your jobs and then start applying. Now on this website, you will see usually two kinds of fellowship. One is a post CCT fellowship, and the other one is just a clinical fellow in ophthalmology kind of a thing. And this one is the one that you are looking for, because wherever they mention that it is a post CCT fellowship, that is the one where we are not eligible. CCT is completion of training, certificate of completion of training. So that is not equivalent to MS ophthalmology. CCT is a training which is done there. So if you have done your residency there, then you are eligible for this kind of fellowship. If you have done your residency in India, then you need to go for other fellowships which do not mention that they want a post CCT person. But then they can write something like they want somebody who is FRC of part 2 or equivalent, and we are eligible for that equivalent portion. So MS Opthal is considered equivalent to FRC of. And the second criteria that usually these fellowships will have is that you need a full registration and a license to practice from the General Medical Council. So similar to how we have Indian Medical Association, they have the General Medical Council, and you need a license before you start seeing their patients and start operating there. And of course, GMC license would be important if you're looking for a clinical fellowship or a clinical research fellowship, not for the other two. So then next step is how you go about applying for your GMC license. So there are different routes which are available for applying for a GMC license. First is the PLAB test, which is the Professional and Linguistic Assessment Board exam. It is in 2 steps. I'll talk about it. Second is the sponsorship program that the UK has, through which I had gone. And third is approved postgraduate qualifications. So before you apply for a GMC license through any of these routes, there is an English exam called the IELTS test, which we are expected to appear and clear. Usually it is the academic IELTS that we have to give. There are different kinds of IELTS exams which are available, of which the academic IELTS is the one which we are expected to clear as clinicians just to get the license. It has four parts of the exam, usually done on the same day. One is the reading part, in which they just give you a paragraph and you're supposed to answer all the questions. They will assess how you interpret English language. Then there is a writing part where they give you a graph or a picture and you're supposed to describe it in limited number of words. Most of it is doable. The listening part is where you listen to a conversation. Here you might require a little bit of practice because you need to get used to the accent that those people use, and then you need to answer those questions. And then there's a speaking test where somebody just sits in front of you and they talk to you and they assess how your communication skills are. So your overall score is expected to be more than 7.5, and individually you should score a more than 7, and then you are eligible to apply for a GMC. Then deciding on the route that you want to take. Like I mentioned, there are 3 different routes which are available for you to apply for the GMC. So once you have applied and cleared your IELTS, then first thing is the PLAB test, which is the first route, which is very common. People appear for this exam most often. So there are 2 parts. First is PLAB part 1, which has MCQ questions. So they'll give you a short scenario and they'll ask you MCQs on it and you have to answer. It's a 3-hour test. Once you clear first part, then is the second part, which is a structured clinical exam where they are going to assess the clinical skills that you have. And you are expected to have clinical skills equivalent to a second-year resident in UK. So UK has a 7-year residency program, of which the first 2 years are called as the foundation year. So you're expected to have that kind of clinical equivalence. So there they give you 18 short scenarios, clinical scenarios, and then you have a mock consultation. It can include an emergency sometime. There are different stations that are created and you go in and you perform your consultation and they observe how you are doing. Once you have cleared PLAB exam, it is necessary for you to apply for your GMC application within 2 years. After that, you have to appear for the exam again. That is important. It's the same thing for the IELTS as well. So if you clear an IELTS exam, your score is valid only for 2 years. The next route is the dual sponsorship scheme. So when they say dual sponsorship, means there are two sponsors that you have. When we talk about sponsors, that means there's a person who has trained you and who are ready to vouch for your clinical skills and your ethics. So in a dual sponsorship scheme, there is a UK sponsor which is involved, and there is an Indian sponsor. The criteria for your Indian sponsor is they should be involved in your training of ophthalmology. So ideally, it should be your thesis guide or HOD or somebody from your department who has actively seen you in your residency and was involved in your training and is ready to give you a certificate saying you are okay with your clinical skills. Your UK sponsor usually is the person who is recruiting you there or is your fellowship supervisor there. Now, why there are two routes is because not all UK sponsors can directly sponsor you. There is a list on the GMC website where there is a list of sponsors. So some universities or some individuals also can act as UK sponsors directly. But route B is for people if you have a fellowship in a place which is not a UK sponsor. So they act as your primary UK sponsors, and your secondary UK sponsor is the Royal College of Ophthalmology, which coordinates with them and gives you a certificate. And your Indian sponsor again will be the same. And the third route is if you have an approved postgraduate qualification. For example, you just decide to go and do your residency there for 7 years. It's your choice. So you'll have a CCT or you appear for those exams like FRCS and FRC-OPT. So the approved qualifications are FRCS Ophthalmology, Edinburgh and Glasgow, and MRCS Glasgow and MRCS Edinburgh. And the Royal College in these cases sponsors your GMC license. But even after your GMC license, you still need to have a FRC-OPT if you directly want to go for a fellowship there. And then they work towards your visa. Once you have a GMC license, usually the university helps you get your visa. It's the HR department that goes through it. So if you are going through a dual sponsorship scheme, then you get a certificate of sponsorship from them saying, okay, all the sponsorship things are fulfilled, and you get a tier 5 visa. And if you are going through PLAB or the Royal College of Ophthalmology, then they sponsor the entire thing. So they sponsor your visa via the letter of appointment, and then you are working for a tier 2 visa, which is a worker's visa.
1 minute remaining, ma'am.
Yeah, I am done. And yeah, so this is the summary. So first you shortlist the course, then you apply for your job. Once your interviews are done and you know that they are ready to offer you a job, you can give your IELTS exam, decide on the route of your GMC licensing, acquire your license, and then they arrange for your visa, and then you can reach there. So the conclusion is that training can be either at a senior level or junior level. You can obtain whichever position you want if you apply at the right places. Most of the people think it is only research programs that are available there, which is not true. You can go in for clinical opportunities as well. Most of the programs have 1 to 2 openings a year. So some will be once a year, some will be 6 monthly. And then each type of fellowship will have its own rules and timelines and requirements, which will be very clearly told to you. And accordingly, you can make your choice. Thank you very much. I'm happy to take if anybody has any questions.
Excellent talk, Rashmi. There's a question in the chat box by Dr. Megha. Says, do PLAB tests have any questions only in ophthalmology or medicine in general?
No, it is medicine in general.
Okay.
So even when it is emergency also, so emergency situation is not an ophthalmic emergency, it will be a systemic emergency, and they'll see how you respond to it.
You had also mentioned that the MS is equivalent to that.
Yes, where they write FRC-OPT or equivalent. So there, if you have an MS ophthalmology, then there is a process they have which is called as verification of your degree. So you just send your degree certificate to them and they verify. And if your university, most of the universities of India are approved in that. So like, for example, my MS degree was from JIPMER. So I just had to send it for approval. And if that university is listed with them, then they consider you for the fellowship.
What about DNBs and DOs?
DOs, I am not personally aware of if they actually look at DOs or not, but DNBs they look at because National Board of Examination is included in that. Okay. But even if you have like a DO, I'm sure it comes from a university and it is an approved thing. So because the thing that they actually look at is the university from which you are trained and the college at which you are trained. And most of the colleges and hospitals in India, I saw on that list.
So I don't know if everybody knows this. Your fellowship in the UK was under Dr. Harminder Dua, and that is it is to do a fellowship under somebody like somebody who's under whose name is one of the layers of the cornea would have been a fantastic experience. What was your experience under him?
So when I went there, like I told you, I went for a dual through the dual sponsorship scheme where he was my UK sponsor and my Indian sponsor was from JIPMER. I had opted for the clinical and research fellowship so that I get equal surgical opportunities as well with him. And so we had like 3 days of clinical work and 2 days of research work. Like we know it's a 5-day week for them. And I think it was a good experience in the sense overall also in the UK, apart from just being at the University of Nottingham, there are some good points. There are some points which are negative as well. But if you are doing just one particular case, then you actually get a lot of understanding. So there is I mean, most of the people know that the numbers are low in the UK, which is very true. I think that affects how you want to look at it from long-term perspective. But if you're looking for a short-term fellowship, then even if you're going just for a single theater, you do come out learning a lot more, is what I thought. And again, because it was a clinical and research fellowship, my research experience also in terms of ideas and the academic perspectives I got from there was, I think it was, it helped me quite a bit.
So thank you, Rashmi. Aditi is also, she's a cornea surgeon as well. Would you like to, give some comparison point, about the advantages of a cornea fellowship in India? And, then Rashmi can again counter it, because she has done some fellowship both in India and abroad as to what are the advantages and disadvantages of it. First Aditi, then Rashmi.
Definitely. Thanks, Karan. Excellent presentation, Rashmi, as usual, and so informative. We all
Aditi.
learned so much. And yeah, definitely. And Rashmi has also done fellowship in India. So in India, I think we get a lot of numbers depending on the institution that we are doing our fellowship from. We get to learn the basics and, definitely there are the easiness of, being in your own country that is there. I think that was difficult for Rashmi. I remember that. Yeah. No matter from where you're doing your fellowship, you have to, maximize that time. Do as much as research as possible. Learn from the surgery. As she rightly said, numbers might vary, but as long as you know the right steps, how to do it, how to, handle your own complication when you are teaching someone, if you're teaching your junior, how to handle their complication. So that is very important, no matter wherever you're doing your fellowship from. Once you have learned the basics, I think it is very easy to, implement it no matter where you go, whether it's a government job in India, a private practice, but your concept should be clear, your ethics should be clear, and definitely your research, you should have a good research exposure, and the relationship with your mentor, the teachers, that should be very good because they guide you a lot, and I know Rashmi will agree to that as well. So that in that way, you can utilize your fellowship to the maximum extent, no matter which place you are. Then I think sky is the horizon. Over to you, Karan.
Yes, any comments from Dr. Aparna as well? She's also a cornea surgeon here.
I definitely agree that fellowship in UK is like icing on the cake. Like if you actually do a fellowship in India and then you have exposure to abroad, exposure to something more better facilities and all. So it's definitely like an addition to what you have done. So yeah, that would be my.
So from all, before we move on to the next talk by Dr. Rolikash, I would just wrap it up, the cornea and the refractive part, and what would your, as the 3 cornea surgeons, in the program today, what would be your take on or guidance on a cornea and a refractive fellowship, both of them?
Can I say something on this first?
Yes, please. Yes, please.
So when it comes to cornea and refractive in UK, one of the very important things that I would like to point out is that refractive is not done everywhere in the NHS because it's a cosmetic surgery. So you have to be very mindful of that part, that you might not get as much refractive exposure as you would get in India. first thing. Second thing is, when it comes to cornea fellowships where you are expecting like so many keratoplasties, I think like Dr. Aparna said, it should just be an icing on the cake where you just want to refine your skills, but your basic skills, if you have acquired in India, that always helps, because the amount of surgeries, the number of surgeries that we do here every day is very different from what you would get there. There, like I said, it should just be a refinement of your skill. If you're doing one dalk, you should just know how best you can do it, but you can't be doing your practicing there that you get in India. So it is, I think I would advise that you should first have a primary fellowship from here, and then you go there and fill up your lacunae and your deficiencies.
Thank you, Rashmi. And Aparna and Aditi, any comments on the fellowship programs in India regarding cornea and refractive?
So is Aparna taking it this first?
I think Dr. Aditi can go ahead first.
Okay. See, for refractive, definitely there are small term programs as well later on which you can do. I'll just tell about my personal experience. In my fellowship, I got a lot of cornea and ocular surface, but my main interest was ocular surface. So I chose an institution where I got the best exposure regarding that. And then refractive is something which you can definitely learn even after that. There are many short-term centers. NN is giving a very good course. I personally got trained from Dr. Parthu Biswas, sir. So there are many. If you do not get refractive in your fellowship of cornea, then later on you can definitely learn about it. Anyways, the academics and the theory, the patient selection, the complication all are dealt. Maybe hands-on exposure is less during the fellowship in some of the institutions, but it can be easily learned later on as well.
Yeah, I totally agree with that, because even when we plan for a fellowship, not all centers give you refractive exposure as well. It is either going to be only cornea, or like refractive workups will be there, but then hands-on will be very less, or probably in the end. So if you want exposure of both, I think you'll have to inquire and then go ahead with that fellowship. And as you told, refractive, you can go ahead with a lot of paid fellowships, and like the one with the Narayan Netralaya, and the other one, I think Dr. Fogla is coming up with the new course. So they can definitely go for a short term, because skills in refractive are not much. It's all about the planning and the workup. That's more important. So yeah, this would be my take.
So thank you, Rashmi, thank you, Aditi, and thank you, Aparna, for your wonderful pointers. Over to you, Rolika, for your talk on the mentor-mentee synergy.
Thank you so much, Karan sir. Thank you, Yosi, for giving this opportunity to talk. And my screen is visible. I'm audible.
Yes, please go ahead.
All right. So I'm Rolika Bansal, currently pursuing my fellowship under Dr. Santosh Unave sir in ophthalmic and facial plastic surgery and ocular oncology at Center for Sight, Hyderabad. And I'll be talking on the mentor-mentee synergy. So we've all had mentors right from the beginning, from our parents onwards, in school, in college, and every mentor has played a very important role in our lives and shaped us up into who we are today. However, fellowship is a phase where the mentor-mentee synergy is the most important, because it's a one-on-one interaction, and it's very important for you to understand what a mentor means. So these are the questions that are often asked by the residents: when to apply for a fellowship, which institute to apply to, and which specialty to choose, and which city to go to. I feel that a very golden and important question goes unanswered, and in fact not asked itself, and that is, which mentor? Yes, that is the most important question, and that question answers every other question that has been popped up. So how do you choose the mentor, and who do you think makes the first choice? The choice is made by the mentor, of course, but the first choice is by the mentee. So yes, the ball is in your court, because you have to first make the choice. You have to apply. So you have to make sure that you have chosen the right mentor. If you have not put everything together, and if you don't think that this sync is going to work, then no, the mentor-mentee sync is not going to work. And how do you make this choice? So the pointers that I kept in mind were: attend conferences and webinars, be active and overcome your inertia, be out there, go and interact with people,
check out surgical videos. You might not get the the exposure in your college, so it's important for you to go ahead and check out surgical videos of different specialties, different mentors, and see what goes for you. Discuss with your professors. My professors have played a very important role and have taught me, and have encouraged me to go ahead and apply for my fellowship, and express your interest to your mentor. And this is a very difficult thing to do. And I remember when I expressed my interest to Dr. Santosh Nagar sir, and he said, "You're applying too soon. It's just 3 years more to go for before you really have to apply." And I had it from the day one of my residency of where I want to apply and whom I want to apply to. So what Santosh Nagar sir told me once was that, write to me on the December before you have to apply. So I sat down and I opened my inbox to write an email to him on the 1st of December 2019. And this is what popped up in my email. Believe it or not, this is exactly what happened. And this is an article written by Sir where he has mentioned mentoring is a serious business. Call it coincidence, but I'm thankful to that. In this article, Sir has enlisted what a mentor means. A mentor is the one who motivates, who empowers and encourages, who nurtures self-confidence, who teaches by example, who offers wise counsel, and who always raises the performance bar. He's absolutely right in saying these, but I have an answer to him now, and that is what a mentee should stand for. A mentee is somebody who masters the art taught by the mentor, somebody who embraces the efforts of the mentor and has faith in his or her belief, and somebody who never fails to observe. It is very important to observe each and every clinical or surgical skill by your mentor. And you should be thankful and loyal. It's an often forgotten thing, but you have to understand that this is your mentor for life. And you should be eager to learn and evolve. And always remember, efficiency is always rewarded. You might not know it, you might not understand it, your mentor might not even express it, but it is true. So you must remember while you are in your fellowship, these are the pointers which nobody tells you, but you should understand that this fellowship is based on your mentor's pattern, your mentor's comfort zone, his or her work, your mentor's patience, staff, rules, principles, skills. Everything is about your mentor. And you have to understand that you're a part of their program. And you have to understand that if the best of it is going to come when you blend well in their pattern. So the one thing that you should remember and understand, which is very difficult in this COVID era, is to understand the phases of the mentor or the faces of the mentor. I hope my mentor is not watching this, but I'm sure that he's always watching me. So this is the face of your mentor. Mostly this is when he's giving me tasks, when he's giving me difficult tasks each and every day. This is the phase of mentor which he's always trying to perfect my skills or trying to teach me. Often seen phase by Dr. Santosh Nagar where he's amazed as why am I doing, what am I doing? And I would call it a little disappointed. This is the more disappointed phase. And this is when he's rolling his eyes at me when I am not working as per his expectation. This is the phase which we see very often, and that is after he is done with the wonderful surgery. And I think this is the phase we all go in after the amazing surgery that he puts up. And this is mostly in OPD. I think this is the better one in the OPD. But this is a phase which I have still not understood, or, this is when he wants to be calm and meditating in his zone. And I'm very bad at it because I disturb him most in this zone. This is a phase which my seniors have not seen, but I have seen that he has for them. And that is the phase of achievement that he has. And when they finish a fellowship and they go thank you for, understanding what all I had to teach. And this is the phase which I have seen him having for my seniors, and that is inner peace achieved when he sees their achievements. So things to remember about your mentor are that the mentor has chosen you for a reason. The mentor maintains your focus, polishes you effortlessly, teaches and hones you selflessly, and is afraid of you not recognizing your potential. Often my mentor asks me that, you don't know what you are supposed to do. You don't know why am I pushing you? And he's right. And because they bring out the best in you and they always want you to excel. The things that you should remember as a mentee: trust your mentor's instincts and be loyal. They have seen more than 80 or 100 fellows, maybe. They know, the moment they see a fellow, they know what are they looking at, what kind of fellow you're going to be, what kind of person you have to be carved into. Observe them very carefully, be dedicated and disciplined, never get discouraged. Often you're going to have your mentor be disappointed and not agree with you, but that's okay. You have to compete with yourself only. You don't have to compete with your co-fellows. You don't have to compete with your mentor. You have to only compete and be better every single day. Don't judge your mentor. It's not your place. And be creative and speak up. And remember the lessons always. And it is important for you to hand over these lessons in future, one day, to the next group of mentees. And the synergy that I've been talking about is that your contribution, your mentor's contribution together, that synergy is when your efforts and your output gets multiplied. And this is something Nasser et al. Had mentioned in their article very successfully, that is, a successful mentor is the one who celebrates the mentee's success, listens to them, assesses their progress, and at the same time, a successful mentee has to be productive, identify the right mentor, set your expectations, and have clear career goals. The extended world of mentors that I have had, and I'm thankful for Sir to be introducing them to me, and they have taught me a lot. And Sir has probably understood of what all we need in our lives, and we learn from everybody, including our co-mentees. I'm actually thankful to all of these people, my juniors or seniors, who have taught me one or the other element. We do not understand what they're trying to do when till we come in their position. So you have to step into their shoes, and then only you'll be understand what they were going through. And thank you for introducing me to this world. And you have to make sure that you get the right flavor of your M&M. Thank you.
Thank you so much. Truly, it's such a very wonderful presentation and some very important points that you have shown to us and all our listeners. What the takeaway from her talk would be that at the heart, at the core of your training program is always the mentor. The institute, of course, has a lot of importance, but the mentor, I also believe, is the most important pivot around which your training revolves around. Dr. Karan, your take, and then we can have some input from the panelists as well.
Absolutely, a mentor. Actually, I have had the privilege of having many mentors in my life, from my PG days to my fellowship, and for now also, for the even the simplest of doubts or silliest of procedures, and I'm a couple of years into my practice, that I still do call them up and, sir, I'm समझ नहीं आ रहा है मुझे इसमें क्या करना है. And just not this, and also in life expectations. Now I'm entering private practice now. So then I had called up, KP sir, Krishna Prasad sir, and sir, what should I do? And he's like, and then he guided me on some things. And then there are multiple, mentors in which who have been contacting on which machines to buy. And just not the academic thing. The mentor is going to stay for your entire life, from academics to your clinical and surgical thing, to your practice, and to whatever you do in the future. So big thank you to them. And the reason what I am today is because of my mentors. Agreed, Rolika?
Absolutely, sir. They are mentors for life, and actually, more than we can recognize our potential, they know what they are looking for. I mean, as I've said, that they've seen more than 80 fellows. So, in their life, they have, and Dr. Aksha Rao had once commented in one of her presentations that you get your experience out of their experience, which is already of past 25 years. So they know what they're looking for. And that is why you should just let it be in their hands and let them hone you and let them carve you. I think Dr. Harika is here and she'll absolutely.
I was going to take comments from Harika only. She's been your senior there and done a fellowship under Santosh sir only. What are your comments? And you already mentioned that there are a lot of memories that have been refreshed by the pictures there. So Harika.
Yes, thank you so much, Rolika. I really could just glance through all my fellowship days. That is too refreshing to have. And she's actually absolutely right. And what mentor we choose is really, really important. And once we choose the right mentor, and we can just relax, the things go on their part. They'll automatically go. Maybe you have few good days, maybe you have few bad days. You might end up crying someday, but definitely trust me, at the end, that is really, really gratifying, and there won't be any day you won't recall your fellowship, maybe during some surgery or when you see some patient. That is really, really gratifying, and mentor is really very important. And thank you, Rolika, once again. Excellent presentation.
Thank you to you also for being a part of it, ma'am.
My pleasure. Thank you.
We can now, Devakant.
Yeah, yes, let's move. Any
Yeah.
more comments before we move on to the next small, we have few small talks left. Okay, Dr. Khanna, let's invite the next speaker.
Yeah, Dr. Siddharth Madan. Are you there?
Yeah, I'm there. I'm just sharing my screen.
Yeah. So he will be speaking about the ROP training program. Over to you, Dr. Siddharth.
Yeah, just a second. My slides are visible. Am I audible?
Yes.
Yeah, please go ahead. Yeah.
Yeah, thank you. So, good morning, all. I am Dr. Siddharth Madan. I am currently working as an assistant professor in GTB Hospital, which I joined last year only. And I'm giving a few comments on surgical ROP fellowship, because ROP I feel is a little neglected topic. And mostly the primary VR fellowships mostly cater to around the adult retina, unless it is a part of a special pediatric VR fellowship is a ongoing topic with that. So slides. Okay, so I have no financial disclosures. We all know that WHO has estimated that there are 15 million preterm births in a year. With the increasing number of ICUs and poor neonatal care, there is increased number of severe ROP cases. And to add to that, stage 5 is a presentation which we mostly come across in our centers, because these children have never been screened. So this was a study conducted by RP Center in 2016, where 32.4% of outbound babies were referred to them with ROP, and 89% were never screened. 74% were picked up by the parents when they noted leukocoria. Ophthalmologist only referred 25% cases, and pediatricians never referred any child. So there comes the importance of screening these children. International guidelines are different, we are all well aware, but in the Indian scenario, the guidelines are different. So we have to screen more number of babies. And unless we come across with a leukocoria at the end, and then we are not left with much. So to apprise everybody of the screening guidelines, the management guidelines are also well formulated. It based on the ETROP cooperative group. So we are all well aware of the management guideline. So how to treat these ROP babies? We have anti-VEGFs, laser, and surgery. Laser is a gold standard treatment. Level 1 evidence exists from the ETB ROP study, and it is a definitive treatment unless the child comes with a loss to follow up, and they may present with a late recurrence. Anti-VEGFs, have given a totally new dimension to ROP management. So all drugs ranging from bevacizumab, ranibizumab, and even few centers are injecting Eylea in these eyes. But anti-VEGFs have a double-edged sword. Not everyone can inject these ROP babies. Babies with the eyes are different. So it's not that the fellows who have never had exposure to anti-VEGF injections. The evidence for anti-VEGF injections exist. Reactivations can happen, and complications are well known. There can be endophthalmitis, lens touch. So ideally, such injections should always be administered as we do in our OT setting, and it should be done to eyes separately with separate instruments. Having said that, children may progress. We can come across with stage 4A, but I'm regularly hearing to talks by Dr. Parijat, who I look upon to, and he has also emphasized that early surgery is important in such babies, unless we wait for full funnel to close, and then the visual potential is minuscule. So early surgery is a key intervention. and it has various advantages. And that is the outcome we look for in babies who present with eyes like this. So for perspective of surgical ROP fellowship, if we come across, as per this latest classification, if we come across a stage 5 where the optic disc is visible, we will err on the side of early surgery. Unlike in 5B, when the funnel is totally closed, we may not want to operate. And in 5C stages, some centers and some surgeons, it's the choice of the surgeon, but it is usually said that although the results are poor, there's a risk of phthisis bulbi to happen, but you may give a trial of navigable vision to these children by surgery. So various surgical approaches have been mentioned. We have 25 gauge, 27 gauge lens bearing vitrectomy, clear corneal surgery, and a hybrid technique is known. So who is going to operate these babies? So vitreoretinal fellowships are being delivered at various centers across India. However, pediatric VR as a specialty is mostly a part of long-term VR fellowship. Having said this, eyes of a child are different from that of adults, and lifetime of follow-up is indispensable. So I went across and researched the various fellowship programs mentioned on the AIOS portal. I shortlisted the centers which were offering pediatric VR fellowship. However, specifically ROP fellowship was only mentioned in 1 or 2 of the centers. So I had to go back. I saw the contact IDs. I mailed the contact person of these centers. I had a feedback from the fellows and my colleagues. And this is a table which I formed. So to mention how is the ROP training program at RP Center? It is now at present short postings with only 2 or more senior residents who are posted at a rotational basis, and to a maximum of 3 years, which was in the last few years when my colleagues were also part of the ROP screening program. So there is no separate ROP fellowship program at present in RPCs. And the residents who are posted in their short postings, they are given around 100 lasers or to around 30 anti-VEGF injections. And the ones who have an entire tenure of 3 years, they are doing around 300 laser and more than 50 laser, 300 laser and more than 50 anti-VEGFs, I would correct here. And the surgeries are mostly based on observation. Hardly any residents operate, but the ones who are considered surgically confident, so they may be given 2 or 3 surgeries at the end of their tenure. As far as PGI Chandigarh is concerned, a duration of 3 years where the senior residents are posted, they do about 200 eyes in total for lasers and anti-VEGF injections. The surgery offered to such senior residents is almost nil, to about 2 to 3 if the level of the confidence of the operating surgeon is good enough. At the Arvind Eye Care System, as we were hearing to the talk by Dr. Varghese, there is a 12-month surgical pediatric retina fellowship program, which is after the 3 years of post-graduation or once the student has completed 2 years of long-term fellowship in VR. But this is mostly for, as per their website, it mentions pediatric retinal diseases, including retinoblastoma. So I had contacted the Dr. Shah for this input, and he mentioned that mostly adult surgical and surgical pediatric retina cases are given to the residents, and these pediatric retina cases are mostly ROPs. So surgery, number of cases given for surgical exposure are dependent on the surgical expertise of the candidate. Looking at the website of Arvind Eye Care Hospital, there I could find that VR fellowships are usually for 2 years. And after that, it is a 1-year fellowship program where the expertise is offered in ROP, mostly in the form of anti-VEGFs and lasers. Having reviewed the LVPI, I got a reference from one of these fellows who underwent 1-month training for ROP. He was given expertise in lasers. However, surgical exposure was nil. At Shankara Eye Foundation, they have a comprehensive VR training program. There is no specific ROP fellowship which is being offered, and this is a part of comprehensive VR training program. The surgical exposure here is also not much. However, the fellows assist the chief operating surgeon. At the Netralayam in Kolkata, they also offer the comprehensive VR fellowship, which includes pediatric retina, includes lasers and surgery. Surgeries are offered, as I was told. At the MGM Eye Institute, Raipur, they have a 3-month fellowship program. This was mailed to me by the director of MGI Eye Institute. Number of ROP screening sessions in 3 months include 30. Number of babies screened are 200 hands-on. ROP lasers hands-on are given to the extent of 4 to 5. Number of intravitreal injections are mostly observation, as the senior faculty are giving. So are the number of surgeries, which are 5 to 7, and they are mostly observation. So number of fellows trained at MGMEI are 7. So that is the expertise offered. IQ hospitals, the duration of surgery is the duration of fellowship is 2 years. They have currently 1 VR fellow, and that too, this fellow has done 1 laser independently and assisted around 10 lasers. Center for Sight has short-term medical retina and long-term VR fellowship. However, there is a no specific ROP fellowship. At Lady Hardinge Medical College, where I spent around 3 years of my senior residency and further 2 years, so I had done almost 50 lasers and more than 30 anti-VEGF injections. I am currently working at UCMS. The senior residents there are posted with us for 3 years in one team. So since last 1 year when I've joined, we have initiated lasers and anti-VEGFs, and SRs are under training. Surgeries are yet to start, as the equipment is yet to be procured for these small babies. So I would conclude by saying that ROP is an emerging and evolving challenge. There are limited number of centers who are dedicated to ROP screening and management. In the era of anti-VEGFs, the risk for its non-judicious use and over-treatment is likely to be administered by the untrained. So one must not hurry to laser. Early surgery in selective cases may be given for better outcome. So I still feel that ROP fellowship should be a separate program in dedicated centers, and this should be after the candidate or a fellow has gained sufficient experience, say around 2 years of a long-term VR fellowship, and may take ROP as a subspecialty, because the management for these babies is mostly different. Thank you.
Thank you, Dr. Madan, for such a well-researched talk. And I personally believe that all of us, all retina surgeons and even general ophthalmologists, should be well-trained in at least screening for ROP. And all retina surgeons should be well-versed with lasers and injections. And yes, surgery is a very challenging aspect of ROP management, and a lot of people prefer to do it in a better and a larger setup. What challenges do you think if you are also practicing ROP? So in terms of screening and the medical and surgical medical management in terms of laser, what challenges do you feel are there, and what somebody who wants to pursue ROP maybe as a career or as a part of his or her career, so what things he should keep in mind?
Yeah, so what I would want to add that in my experience over last 5 years, what I've seen, most of these babies who are referred to us, firstly, the residents are not much exposed. The junior residents or the postgraduates at various medical colleges, they're not exposed to ROP that much, because that is not being catered to specifically. So a scleral examination with scleral indentation is hardly performed. At times, we have also observed our fellows just having a look at the posterior pole, thinking everything is normal, and the disease is progressing in the periphery. So unless the residents are well trained, they have seen how the examination is basically to be performed, they would never know. So that is first thing, that the correct technique is important. Secondly, a good neonatology backup is very important, because if you want to laser or you want to give injections to these babies, you may not always get anesthesia fitness, because there will be a lot of issues, hemoglobin to be built up. If you want to give them blood transfusion, the disease would worsen. So you would want to have a neonatology team who are more confident in managing these babies. And it's a topical anesthesia where you want to give these procedures. So best to have a good neonatology backup. And if not, then you request the pediatrician to assist, because at times you have seen 4-month, 5-month-old baby being referred for a first ROP screen. So that is not the right thing. So screening guidelines should be clear. Neonatologists should be dedicated, and they should be approachable, and they are usually, because in our setup, what I have seen in Kalavati Hospital, Lady Hardinge, hardly we had any problem. Even the outbound babies were promptly admitted. and we used to give them injections free of cost. So screening guidelines are important. Neonatology backup is very important. Surgery is indicated in selective cases, but that can only be performed in a tertiary level center where you have a good neonatology anesthesia facility available. So I would still feel that for the trainees, they should first know how to screen. Lasers they can observe under supervision, then they can do a few lasers, because if they do laser, nothing much, if they can't give injection, they do at least a laser in the periphery, that will still give a reasonably good outcome in these babies. So I feel a training program is very important. Unless they do it, they won't know it, I think.
Perfect points. And one horrifying experience that I would like to tell everyone here. So I had recently a baby gone blind because of ROP. They came to me almost at 7 or 8 months, and I was very frustrated why an examination was not performed. But the pediatricians had advised ROP screening. He had gone to some ophthalmologist who had examined the patient through a torchlight. So, I mean, these things are something that we should all avoid, and this is at the level of criminal negligence. So, all of us should train ourselves and help these ROP babies. Dr. Karan, over to you, and let's wrap up the session.
Yeah, next we have Dr. Harika Regni. Dr. Harika, are you there? Yeah, so Dr. Harika has actually done a long-term fellowship in oculoplasty, and then she did a facial aesthetics course under Dr. Kasturi ma'am at Sri Shankara Deva Netralaya, Guwahati. So, what I would ask you on what is your take on a long-term versus a short-term oculoplasty course and additional courses such as facial aesthetics? What would be your guidance for the young ophthalmologists? Over to you, Harika.
Yeah, thank you so much, sir. I won't be taking much time. So I was asked to comment on this facial aesthetic fellowship. So basically what I say is this periocular and facial aesthetics is an ophthalmologist domain. So as per an International Society of Aesthetic Plastic survey, so what they have noticed is there is a growth in the surgical and non-surgical cosmetic procedures every year. And to our surprise, India is among the top 10 countries where these procedures are being done. And the most common surgical procedure done is blepharoplasty, and the non-surgical procedures are this Botox injections and the fillers. And unfortunate part is 80% of these blepharoplasties and 90% of this Botox and 70% of these fillers, they are all done by the plastic surgeons or the cosmetic surgeons, and our ophthalmologists play a very minor role in that. So one more unfortunate part is all these patients might have visited an ophthalmologist for any concern, be it refraction or cataract, and ourselves, if we ignore or be ignorant on any wrinkles or their lax skin or any other aesthetic thing. So it is a lack of opportunity both for the patient to get it corrected and for ourselves to enhance our aesthetic practice. So coming to the training part, if given an option, long-term training is the best. There is no replacement for that. But if someone is keen on this short-term basic approaches, then what I say is there should be a lot of dedication and there should be a lot of planning before even we go and start our short-term fellowship. What I suggest is we should be thorough with our theoretical knowledge before even going for our short-term fellowships. So any workshops or hands-on training programs will be very useful to really grab it and improve on our surgical skills. So usually this Botox and these fillers, these are the courses are like promotional courses are being organized by the manufacturers itself, and our All India Ophthalmic Society and Oculoplastic Association of India, they have dedicated facial aesthetic sessions in their conferences, and definitely hands-on training sessions in their physical sessions. So these are very important platforms for our ophthalmologists to grab the opportunity to enhance our skills if we are really strong with our theoretical knowledge. So what I say is this facial aesthetics really has a good scope, and for someone who wants to practice solely oculoplasty, this facial aesthetics also serves as a to increase our revenue in our practice. So I urge all the young ophthalmologists to please be aware of all these things and to pick up, to counsel, create awareness among the patients, and to choose this oculoplasty and facial aesthetics as a subspecialty fellowship. Thank you so much.
Thank you, Dr. Harika. I think we can now conclude the session. I would like to thank all the panelists and the speakers for giving their valuable time. It was really an excellent session and would have definitely been beneficial for all the young ophthalmologists and other ophthalmologists of India and the world. Over to you, Avanish, for the next session. We can take a screenshot if everybody can turn on their cameras. We can just take a screenshot, of the session. Okay, everybody, please turn on your cameras. Okay.
Hello, Harika. How are you?
Okay, 1, 2, 3. Say cheese. 1 second.
Nobody has said cheese.
Okay, cheese.
Okay, over to you, Avanish.
Thank you so much for the session. Wonderful session, Dr. Karan.
Excellent
Dr.
session.
Divakant.
Thanks.
Yeah.
Thanks a lot.
Bye. Hi,
Bye-bye.
Aditi. Yeah,
Hi,
bye.
Krishna. Bye-bye. Bye.
Lovely session, guys.
Thank you, everyone, and great session, Dr. Devakant and Dr. Karan. I think the speakers were very good, and there were a lot of insights about your fellowship programs. Now, moving further with our session, what we can see here is post fellowships, what exactly to be done, and that is where our session comes into picture, where we are actually talking about the post fellowship conundrums, where we get the gyans from our experience use. So we have our panelists here. We have Dr. Rohan here. We have Dr. Rohan is presently the medical director at CKI Institute, Saharanpur. He is also a consultant at Vision Eye Center, Mumbai, and he has done his fellowship in phaco and refractive surgery from Narayan Nethralaya, Bangalore. We have Dr. Chintan Shah here. He is presently a consultant at Dr. Chintan is, So Dr. Chintan is actually a consultant in pediatric ophthalmology and strabismus at Sadguru Nethralaya Chikitsalaya at Sadguru Netra Chikitsalaya at Chitrakoot, and he has operated more than 10,000 adult and pediatric cases, and he has more than 30 publications to his name. We have Dr. Sahil Bhandari. He's a VR surgeon. He's presently working at Guru Hasti Chikitsalaya, Paper City in Rajasthan. He has completed his long-term fellowship and DNB from Arvind Eye Hospital, Pondi. And he was also a senior resident at AIMS, Jodhpur before this. We have Dr. Gunjan Budhiraja as our next panelist. She's presently working in IQ super specialty hospitals, and she has completed a long-term fellowship in cornea and refractive and ocular surface at Shroff Eye Charity Hospitals. So first, we'll move on to the session. We have Dr. Rolika Bansal. She'll be speaking upon the metamorphosis from a resident to a consultant. Dr. Rolika is presently a fellow working under Dr. Santosh Nawar sir at Center for Sight, Hyderabad. So Dr. Rolika, are you there? Can you just, So Dr. Rolika, over to you. Thank you.
Hi, sir. Thank you so much for the opportunity. I'll be talking on the metamorphosis. My screen is visible, right? Yeah, okay. So I'll be talking on the metamorphosis from a resident to a consultant. And I know that I have put a very dark and dingy wallpaper out there, but that is exactly how a resident feels when they enter from MBBS to MS or DOMS for that sake. So talking about what is metamorphosis, it's a process in which someone or something changes completely into something different. And as Franz Kafka has put it across, that I cannot make anyone understand what is happening inside me. I cannot even explain it to myself. So it's a change that you will not even understand or realize, but you will go throughout the phase from your residency to your fellowship and to being a consultant and thereafter. So if I put across the evolution, it would be like from MBBS coming down to residency, which includes MS, DOMS, DNB, secondary DNB, and then moving on to a fellowship or SR-ship, assistant professor, associate professor, professor, and even beyond that. So throughout all this, you won't even realize the changes that you are going through. Often you come across a path multiple times in your career, you will come across a path where there will be different ways to choose. You will not know where to go to, but this is exactly how you evolve into a new person. Now, this evolution could either be subtle, like from a caterpillar slowly growing into a butterfly, or a major transformation that people go through. And it's okay. Either way, it is okay to be whoever you are and to understand how would you like to evolve. Talking about from MBBS to residency. So during residency, what do you face and what do you feel? This program has been crafted pretty well because repeatedly several speakers have pointed out these pointers, which I'm going to enlist. But it's for your, it's for your benefit that I'll be repeating the same. And that is, entering the world of ophthalmology can be appalling because it can be a little scary. It's not like how it's going to be like, people think that it's going to be an easy world. No, it's not. It is pretty complicated, and I'm glad that there are so many subspecialties in ophthalmology, and you need to plan ahead of time. I would say that the first day of your residency is when you should plan. You should have a 3-year or 2-year or 4-year plan. What are you going to do next? Which fellowship you're going to take up? Where are you going to go? Everything should be sorted in your head. You have to explore all the specialities. Many institutes do not have the opportunities of providing you with all subspecialties. So it is it's your responsibility to go through videos, attend conferences, and explore the subspecialties which are available for you. Watch videos in live surgeries and understand what gives you a rush. It's important for you to understand your surgical rush. Attend conferences, as I said, and divide your day in read duty. Yes, residency should be a fun zone, but you should still be able to divide and read. I did not do so, but I'm thankful to the COVID times that I got a very good, break time after my residency where I could study. So stay humble throughout your residency, because with humility, you will be able to learn more. It's not possible sometimes to be humble in whatever you are doing, but try to do that. Try to put it as a part of you and participate actively in each and everything that is possible. So if nothing ever changed, there would be no such things as butterfly. So you have to change. You are going to change. And you have to understand that learning the basics and avoiding distractions is quite important. Our professors and our mentors were very lucky that they did not have so many distractions. We do. So it is important for us to cut down the screen time and get to work. Follow instructions of your professors and seniors. My professors, my mentors in my residency have played a very important role in guiding me and being there for me. Write parallel exams. You don't know when you will need what. So be it ICO, FICO, or FRCO, or even USMLE for that sake, just write the exams. It doesn't matter. You're just going to read a little more. Compete with yourself only. Even if the world around you feels that you're competing with them, it is really not so, because your whole competition is about you. Tomorrow, you have to be a better person than what you were today. And trust an advisor and follow their advice. Paperwork is quite important. I used to tell my juniors that paperwork is like, you have to understand how to get beside, how to overcome the law work. And so everything should be precise and perfect, because you don't know which paper is going to be used against your, it can be used as a litigation. Phase-wise development is important. As a junior, there were certain roles that you had to play. I might not have played extremely good role as a junior, but you learn that throughout your phase. I might not have been a perfect senior, but I have learned what it is to put in the elements together. And even now we are learning it. So every single person plays an important role in your life, and please try to participate in research. It might not be the thing that you would like to do, but you don't know how it will be. And you have to want to learn to fly so much that you're willing to give up being a caterpillar. So you have to put in your efforts. Coming to the phase of fellowship, that is, you have to be calm and patient in this phase, and you have to read extensively. It was not about MS. You have to read beyond. You have to read through articles. You have to read through books which are specific to your specialty. You should have a virtual 1-year plan or 2-year plan. It is very important, because there is a timeline that you're following here. And as my consultant says, that whatever you learn in MS, if in your residency, if it was X amount, in 3 years, you will now be learning 10X in 1 year. So it's very important for you to rush up. Keep it easy and yet be in charge, and pay attention to small details and learn the elements of a complete setup, because next you're going to evolve into a consultant. So it is important for you to know and observe what every person is doing, what every staff member is doing, and be open to learning from everyone. Have a subtle way around it and observe the surgical skills. Each and every movement should be observed. Now, this is the time where you have to pay extreme attention to your details, because when you forget what you remake yourself. For a caterpillar to become a butterfly, it must forget it was a caterpillar at all, right? But then it will be as if the caterpillar never was and there was only ever a butterfly. You have to evolve. So try to multitask. It's very important. You're not going to be in, it's so easy in MS. Plan your day ahead. Consider an international fellowship. It's always important. Many speakers have mentioned today that it's important for you to go and learn from the experiences that people have in countries abroad. Learn to balance your life. This is going to be a problem for many people, because related to age, you have to balance between family and your work. It's fine. And learn to have teamwork. Every single person plays an important role, and every day has to be better. There is no room for error. Be perfect. Whatever you do, try to look at it twice. You're still going to find errors in your work. When I look at my work, which I had done 3 months back, I wonder what was I thinking that time. That means that I had made mistakes too. So today I have to learn from my mistakes made yesterday. And
You
please
have 1 minute remaining.
make sure that you publish as much as you can. Then comes the phase which I do not have the experience to talk about, is to turn into a consultant. So remember, to conclude, that I will say that in this phase, you have to learn that you have to grow, you have to become more mature. You have to take on your clinical and surgical experience. Remember to self-analyze and self-criticize. It's okay to do so. Be determined and stay confident, and try to become a multitasker. Balance out and be an innovative researcher. Go beyond your comfort zone. Till you're comfortable, you cannot grow. Take charge and make decisions and form a team. These are the elements required for your metamorphosis. So a little darkness is all right. Don't worry, because it won't last forever. And it is important and you need it, because that's how you grow, and a little caterpillar needs it. It is in the darkness that you will realize your wings. So it's important for you to grow throughout this darkness. Thank you.
Excellent talk, Dr. Rolika. I think you have actually put in how actually that metamorphosis actually happens, and that transit, where you start actually being under the umbrella, and you start taking independent decisions about it. At this moment, I think let me introduce our other speakers also, so that we can have a good discussion about these topics, where we can actually move ahead as to how things happen. We have Dr. Rohit Moti here. He's presently working he's a VR surgeon, and he's working in Centra Clinic and hospitals in Mumbai. We have Dr. Bhavik Panchal. He's the head of LVPI Vizag, and we have Dr. Akshay Nair here. Dr. Akshay Nair needs no introduction. He is a practicing oculoplasty and ocular oncology surgeon at Aditya Jyot Eye Hospitals. And we have Dr. Samiksha Agrawal. She's a VR surgeon presently working at Krishna Eye Foundation Eye Clinic, Prayagraj. She has done a long-term fellowship and in VR surgery and ROP at Narayan Nethralaya. So let's start with Dr. Chintan Shah. Dr. Chintan, can you give us some practical tips when you actually feel like you are actually getting into the groove of a consultant? So when do you actually feel that okay, you are ready, or maybe you are in that position of actually taking decision making techniques, and what are the practical tips you would want to give us to our team and for the sessions? Dr. Chintan, you're there?
Yeah. So as discussed, it is very important to learn at each and every phase during our training, be it MBBS or the post-graduation or the fellowship. So the learning never ends. That is the first thing. So you cannot expect that, yes, I learn everything in my fellowship and that's all. So it is very important to understand that we have to keep learning at each and every day. We need to read at each and every day, read new articles, read new techniques, read new surgeries, watch surgeries, and learn everything as much as we can. So it's a very difficult thing to say that when one is ready. So it is up to the individual that how much training he or she needs in a particular field, what else we can do, the international fellowships and all. And then if at the end of fellowship, or if after some years of consultancy in your institutes, if you think that yes, now you can take independent decisions, yes, now you can manage your patients very well, then it's time, maybe you can move on, you can explore further things, and then you can start your own practice. But the most important thing for me is to keep learning and keep knowing new things at all the stage of your life.
Thank you, Dr. Chintan. I would like to ask Dr. Gunjan here about her specialty and what practical tips she can actually give it to the people. Gunjan, are you there?
Yeah. So, good morning, everyone. Of course, I'm practicing cornea, and before joining consultancy, I was doing cornea in an institutional setup. So definitely, the things were more systematic, and the procurement of tissues and everything was so well aligned. But once I've started my practice as a cornea surgeon, I have understood what are the practical problems. I wanted to see everything. I have to know from where, a lot of manufacturers are supplying all the materials that are required for my surgeries. So before my surgery, I need to sometimes plan a lot, because before that, I was under the umbrella of the institute, definitely, because all the things were available, and I just wanted to tell everyone that's very important when you're doing fellowship. Please, when you're finishing, you at least know some suppliers or something, instruments, surgical instruments, etc., from where you can procure when you are going out for practice.
Thank you, Dr. Gunjan. I think we can move on to the next topic. We have Dr. Rohit Modi here. Dr. Modi would be speaking about freelancing, deciding your own attachments to hospitals. Rohit, if you please upload your presentation, please. Dr. Rohit?
Yeah, sure. I'll do that. Just give me a second. Is my slide visible?
Yes, Doctor.
Yeah. So thanks to YOSI, my alma mater LBPI, and all my referring surgeons.
Dr. Rohit, your voice is slightly not audible. If you can increase the, yeah.
Is it audible enough now?
Not much, but if you can come a bit closer.
Yeah. Is it better now?
Yes.
Yeah. Thank you. So the first and the foremost important thing which I've learned over a period of 7 to 8 years of practice is defining the area of practice. I'm a big fan of going hyper local. First of all, it saves a lot of time. Now, for example, I'm working in a city like Mumbai, and this city, I believe, is like 5 to 6 cities put together. So if I think that I can cover the whole city of Mumbai, that would be wrong. So if I just focus on a small area, my availability increases. I save a lot of time by not traveling a lot, and it increases my patient time. Whereas if somebody is practicing in smaller towns, one can think of covering the whole town or probably the adjoining town also. But we need to realize that it takes some time, to build up a practice in a particular area or in a particular hospital, especially if you're starting with a new subspecialty practice. And as your practice grows, the traveling time eats away your practice. So you may, have to give up certain hospitals where you have practiced earlier, because at some other hospitals, the practice has picked up better. And that's where your hard work, doesn't reap that benefits. So you have sown the seed, but the fruits are eaten up by the other person who comes in after you. That's why going hyper local makes sense. Now, what does the attachment does for you? That is something you need to define, especially if you're immediately fresh post fellowship pass out, whether it is giving academics. Now, if you're attached to a medical college as a visiting surgeon, you can teach postgraduates. you can publish papers, whether it is giving you the additional surgical exposure which you haven't got during your fellowship or post-graduation days, or it creates a name in the community. Now, if you're attached to the local community charitable hospitals, it creates a good name in the community, which ultimately translates into good practice in your private practice. And last, obviously, money part comes into consideration. Now, the most important thing which I've learned in practice is time. The time is the most precious commodity. I remember early on in my practice, one of my contemporary retina, colleague had left from one of the hospitals I had recently joined, and to my surprise, that hospital was really giving good amount of remuneration. And I happened to meet him in a conference, and I asked him, "What made you leave that attachment?" And he told me, "Rohit, it was not valuing my time, because the traveling time I was spending to reach that hospital was huge." And he told me, a few years down the line, you will also be, deciding, whether to value a particular attachment or not. So it's important to understand the value of time. That's why restrict your visiting days. Learn to say no to the attachments which may not be for long term. And I would recommend no attachment should be twice a week if you're freelancing, probably once a week. And give time to develop your own practice, and you will get other opportunities as your experience grows. So if you have some time in hand, additional time in hand, it is easier to pick up more fancier attachments later. And on the topic of remuneration, when we are young, freshly passed out, we are looking out for work, and we are ready to work at a lower cost also. But can you put a value to your time? And these are the few things which I have learned over a period of few years. One is a notional value, and other is wage per hour calculation. Now, notional value is, if I target, let's say I value my per day earnings at 1 lakh rupees, and I am working for 10 hours a day. So per hour, my value is 10,000 rupees. So if I join an attachment, are they giving me enough patience and work to generate 10,000 rupees as a surgeon fees? That's the notional value I put it on my time. Now, wage per hour calculation is going to come in the subsequent slides. And always take traveling time into consideration. So hospital or an attachment may be paying you fabulously well, but if it takes half a day to reach that hospital, trust me, it is not worth joining that. And be frank in the beginning about remuneration. So initially, when we are juniors, when we speak to senior directors, we may be taken for a ride. So if you're clear, speak to your senior colleagues about how the remuneration works in a particular city, because it can change from place to place, and be frank with your expectations. Now, this is an example how your wage per hour calculation works. So you can calculate your monthly average salary divided by the number of days, let's say 25 days are the working days in a month. And then you can calculate the per daily salary and divide it by the number of hours you put in every day. So this will help you understand which attachment is paying you more than the average, which attachment is paying you less than the average. And it's okay to continue with the attachments which are paying you less than the average, because they may be giving you something more, like academics or name in the community, which in the long run may make a big impact. And another thing, especially in big cities, is the choice to do subspecialty practices with solo practitioners or join corporate multi-specialty hospitals. Now, corporate hospital, I mean not corporate ophthalmology setups. I mean corporate hospitals where you have cardiology, orthopedics, nephrology all into one. So they look, these big hospitals attachments look fancier on visiting cards, but they may not have huge subspecialty load. They may be okay for a comprehensive ophthalmology practice. But in my experience, solo practitioners provide more high quality specialty cases, and also surgical conversions are more, because there's a touch of that person who's practicing over there, who's convincing the patient that you are the best person to operate for that particular condition. And corporate hospitals most of the times don't pay well. They have a lot of hidden charges like bed charges, visit charges, admission charges, which are not there when you're practicing, doing it in a smaller setup. So the ultimate surgeon remuneration out of that fat fee the patient pays is very less. There are certain advantages, obviously, with freelancing is that there are multiple sources of income, and you know the patient flow is from multiple places. So if one of the hospitals is not doing at a particular time well, the other hospital's income compensate for the overall net monthly flow, and it increases the outreach. You're able to meet different people from different strata of the society. A lot of people start knowing you. You know, you get to interact with other doctors. Your referral base increases. But my two paisa aka, my 2 cents on this is own practice is most rewarding. I have transitioned from just doing freelancing retina and uvea practice to slowly starting up my own practice, and I am able to provide a much more better quality of care. There are standardized protocols which I am following, and I can see a drastic difference in the surgical outcomes as well. And ultimate goal of for most of us is to have our own patient base, because the referral surgeons preferences may change over time. Some of the centers which are well paying,
1 minute remaining, sir.
yeah, their kids may join back, so the things may change in a few years. So if you have a own patient base, it makes a whole lot of difference in practice, and this gives us the maximum returns in the long run. Thank you for the opportunity.
Thank you, Dr. Rohit. It was an excellent presentation, and what I understand is like you've given the nuances of actually how to go about with freelancing. I would like to ask Dr. Rohan Mehra, what is his take on this? Since he is actually based in Saharanpur and he goes for visiting in Mumbai, so how much that is worth? And as you have said in your talk, Dr. Rohit, where you have actually talked about like having your own practice is better than actually going in for corporates or anything. And if is Dr. Rohan here, can you talk?
Yes, I am here. So excellent presentation, Dr. Rohit. And what I would like to say is that he spoke about time. I feel that time is actually the currency. We always sort of go after the money, but the ultimate goal should really not be money, and it should really be how you are spending your day, because we are overworked, we are overburdened, especially in when we get attached to some other attachment, which in my opinion, as sir said, is paying you less and taking more out of you. So the ultimate goal has to be able to strike that balance between, of course, learning, getting the money, and spending time with your loved ones and your family. So what's important is that if you are going to multiple centers for freelancing, you have to make sure that you don't spend half a day, as sir said, in traveling. You've got to make sure that you plan your travels in a way that you travel at night and you get the entire day of work over there. As sir spoke about that algorithm that he gave, I always talk about revenue per minute. Revenue per minute has to be taken into account. How much time you're putting in, how much money you're getting out of it. So time is the currency, money is not, according to me.
Yeah, thanks. We have Dr. Devakant. He wants to ask something here.
Yeah, Dr. Rohit, very nice presentation. So there's another aspect to it that I believe, as you said, that it's important to say no to certain practices when you realize that probably you're not doing well there in terms of revenue or long-term prospects. But I want to have your input on mending things. I mean, if you visit a practice and it's not doing that well, what can you do as a visiting surgeon to develop that practice in terms of your specific specialty? Any specific pointers or any experiences that you have on that?
Yeah, so what I have realized is that having a frank discussion with the director or the hospital owner. Now, if you, so I would say that when you need to have patience with a particular attachment. So for example, I had joined a nearby charitable hospital where I didn't get any surgical work for the first 4-5 months. And now in a year, I am able to operate like 70 to 80 retinal surgeries a year. So over a period of time, we could develop the retinal surgical load by having frank discussions with the trustees, understanding what kind of socio-economic crowd comes over there and what kind of surgical fees and center fees we can keep, and what kind of training can be given to the nurses and all. The other aspect is when you have these kind of discussions, you realize how open is the owner of the place or the trustee of the place is to the whole thing. Now, some of the directors I've found are very open. They in fact want to develop retina as a specialty, and they are not looking at to make out money out of specialty, because most of the times, even in my hospital, when an oculoplasty surgeon comes and operates, honestly, I'm not making any money. But at least that specialty is growing, and that is giving a good name to my hospital. So if the owner of the hospital where you're visiting has that kind of a goal to grow the specialty, a frank discussion can go definitely a long way in building up the practice in that center.
And have you ever considered investing your own money in terms of advertisements or anything else for the development of that specific practice?
So in Mumbai, what I have done is I have invested in certain equipments at couple of hospitals. So I carry the biome or certain equipments which the other person has not invested. So the other person has invested in a high-end operating microscope so that I can operate retinal surgeries. Probably invested in a vitrectomy machine. Then probably the laser investment has been basically in a partnership. And the reason behind is that I also stay invested in terms of time over there. So, but in terms of advertisement, no, I haven't spent on the advertisement part. But in the improvement parts, yeah, there have been a couple of places where I've partially invested.
Thank you so much, Dr.
Thank you.
Yep. Thank you, Dr. Rohit. I want to ask Dr. Sahil here. He's here. He's actually practicing. I think he's doing cataracts plus VR. So when you're actually doing some freelancing, do you actually go in to look in for general patients, or do you actually go in for your specialty, and what hiccups do you actually feel, or maybe do you tell your respective places if you want to go that this is what I want to see? Because sometimes you travel and they tend to show you some general patients which are actually not worth your time. So how do you actually manage that thing?
Thank you, Avnish, and sorry for joining late. Got stuck up in some work. See, technically, the freelancing practice over here in this part of Rajasthan is pretty on a lower side. Most of in this western part of the Rajasthan, like the Jodhpur city and the surrounding area, here more of the things are based on solo practice or join as a working in a particular, when you work under a senior or something. When we do a little bit of freelancing, most of the people are concerned about mostly here are NTA segment surgeons. So they technically concentrate on cataract or kind of pterygium or squint or something like that. So NTA segment. So they have their own set of interests, but most of the thing in freelancing is concentrated on cataract. For myself per se, I limit myself to technically only VR. It's for a freelancing system. I don't go for any NTA segment, even though I am located in a trust hospital which is in periphery, so I do have to take care of the NTA segment. But then my freelancing system is only limited to my subspecialty like ROP and retina and medical or surgical retina related only. So I limit that thing. I clearly tell the NTA segment or whoever surgeon, whoever brings into the freelancing system that, okay, the thing will be limited to the retina only. So I don't take, I don't give an opportunity only to go into that general aspect, because that obviously is going to take up a lot of time also. And as Rohit sir said, time is your money. So when you calculate that thing, is even sometimes I feel that when you go for a freelancing retina also, that is also sometimes not worthy, because the patient do not technically turn up to you. Because if you go for freelancing, the patient may not be referred back to you, or may not be followed up in that same particular hospital also many times. So I limit myself only to the retina practice and specifically to the ROP practice also. So these are the two things, and I technically exclude everything. I don't project myself as a general practitioner when I go for any kind of freelancing. Other than my practice part of freelancing is only, I would say, less than 10%. Technically, because when I'm working in this trust hospital, so 90%, more than 90% of the time, my goes into the practice over here in the trust hospital, where I handle both the anterior and posterior segment surgeon as a surgeon over here.
Okay. Dr. Akshay, your take on this topic of freelancing. Dr. Akshay Nair, if you can give us some comments about it with respect to your specialty and your pointers.
Yeah, I think
thankfully, oculoplasty being, having fewer specialists, the scope for freelancing is more. And unlike other specialties where everybody is able to do a little bit, in terms of a general ophthalmologist being able to do some amount of cornea refractive work, or medical retina work, injections, assessing, seeing patients on getting OCTs done and investigations, and medically managing or even intravitreal injections. Oculoplasty almost is sequestered completely differently, so that nobody else wants to do anything. It's all the dirty work that is left to us. So that way, oculoplasty has, is relatively immune to having people put their fingers into it. But I think what Dr. Modi said was very valid. At the end of the day, while you do freelancing it cannot be sustainable in the long term. Eventually, you need your own patient base, and not just for yourself, not just for a source of income, but in terms of the eventual outcome for patients. Having your own practice, whether it is in an institute, in a private setup, or your own clinic, allows you to standardize procedures, standardize protocols, and SOPs for every patient. When you freelance, your schedule and your availability are the biggest constraints in which everything has to fit in, including the patient's availability. Whereas when you're at a center, the patient comes first when you're at your own center, and you can mold everything around it. So while freelancing is good, it cannot be a long-term sustainable idea. But yes, for us, especially for ophthalmologists who do not have a family background in ophthalmology, it is something that can always, in the short term, be used. In oculoplasty, with time, the more you do, the more, like any surgical branch, the more you do, the better you get. And that's it. I actually talk a little more about this in my talk, which is coming up after some time.
Absolutely, Dr. Akshay. I would want to ask just last question to Dr. Digvijay, sir. What is his take, since he has an hospital and he actually has people who come for freelancing at his place? So how does he manage, and what is his take on the other side where he's actually inviting people to join him? And how does he break even, or can he give us some tips about it? Dr. Digvijay, are you here? I think he's not here. I think we can move on to the next talk, and if Dr. Digvijay comes around, we'll ask him again. So we have the next.
I have a question for Dr. Akshay, sir. If
Please.
Akshay, sir, how often do you think that oculoplasty gets divided? Because it's a part of plastic surgery comes in, and a part of cosmetic surgery, like from the dental aspect, comes in. How often do you think that gets divided, and how do you think it affects the work of a facial plastic surgeon in general?
I think it is unfair, it is ridiculous, and it is absolutely unacceptable that oculoplastic surgeons call themselves facial plastic surgeons. We are not facial plastic surgeons. We are ophthalmic plastic surgeons.
Right, sir.
So I think we need to get that straight. We are trained only in the periocular area. We can do a little bit of non-invasive injectables around the face, but just by doing that, can we call ourselves facial plastic surgeons? No. There are certain programs where you are specifically trained in that, none of which exist in India. So if you are trained in that, by all means, you should do what you do. But we should restrict ourselves to the eye alone. And addressing what you said earlier, at the end of the day, it's results that will drive which way a patient would go. If you are able to deliver good results, document them, and market yourself, whether it be on social media, on your website, post videos about your surgical technique, speak on forums like this, automatically people will start referring work to you. Patients will be able to see tangible benefits and improved results, before and afters on your website, on your social media handles, and that itself will drive patients to you. Believe me, the best advertisement is a satisfied patient. So as long as you're doing your job good and you're able to deliver results, which way this patient is going, which way that patient is going, why is the plastic surgeon doing a fracture, why is the dentist doing a blepharoplasty, all of that is noise. You can focus on the signal, which is your work, and deliver results. Automatically work will start coming. There are enough patients. We are a country of 1.4 billion people. If we are going to split hairs about why is a plastic surgeon doing an orbital floor fracture, that means there are serious issues with ourselves. We just need to focus on our job. There are enough patients for every specialist of every city for us to do that. And I'm sorry, I'm being a little blunt, but this is what it is.
No, but that's quite important, sir.
Yeah.
You're absolutely right that it doesn't matter who does what. It's about what we do and what we have to do right. If as far as our results are good, nothing else matters.
Absolutely. And just to add, sorry, Avnish, I'm taking a minute longer. Over the past 10 years that I've been in practice, I've realized that every year I end up dropping one surgery from my repertoire. Like for the past 3 years, I haven't done a single pan-facial complex trauma, which means, zygoma, Lafort 1, 2, mandible. Earlier, we used to do all of them with the max fac surgeons. But in private practice, these cases get far few in between. And over time, you realize that there is a maxillofacial surgeon who is trained in this, who does this 5-6 times a month, as compared to 1 or 2 times a year that I am doing. Why would my results be better than his? And so therefore, when I get called for these cases, you just decide that, what, this is not my cup of tea. I know someone who can do it better. You need to go there. And, with time, as your hair grays, you realize that focusing on what you do better is good. And eventually you hope that everybody else also figures out what is their niche area and sends work that you do better to you.
That's absolutely right, sir. I agree.
Okay, thank you, Dr. Akshay, for those things. Moving on, we'll go to Dr. Bhavik Panchal here. Dr. Bhavik, his talk is on soft skills, really listening and talking to your patients. Dr. Bhavik, over to you.
Yeah, thank you, Avnish, and thank you, everyone, those who are present here. And no, I'm just listening to the conversation between Akshay and Rolika. So Rolika, in her talk, when she spoke about mentor and mentee, it's a very apt way to actually go ahead and what she presented, she's doing that now. She's reaching out to a mentor in Akshay Nair. And Rolika, I have one comment for you. Do not forget your cataract surgeries. You'll never get into all these things. That can be a bread and butter for life. Yeah, see that is what is written on Akshay Nair t-shirt, right? Okay, and part of what you'll communicated is what I'm going to share in my talk as well, which is soft skills, communicating with your patient. What you mentioned about why you want to worry for that one patient. Okay, and if someone has experience in doing that surgery, might as well refer to that individual. So without wasting further time, let's proceed with the talk. Okay. Yeah, so time and again in the past few years, we are seeing and reading a lot of this, that the litigation cases against doctors are increasing, especially in India. We know in the West, it is quite common. The doctors are rude and the patients are complaining about it. And the media also picks up on one small thing and highlights it further. So which again demeans the reputation of the doctors. So what is the root cause of this? So the root cause of all of this is one important attributing factor, or a bigger factor, is poor communication between the doctors and patients. So what you see the picture there, I still believe this is the picture in most other government setups. May not be in a private practice as of now, but this is what it is. This is what we have gone through as interns in a medical college as well. So the talk here, which I'm sharing right now, is on how we build upon this, how we improve upon this good communication. So before that, let us look at, sorry. Yeah. What are the benefits we get out of good communication? The most important is managing difficult clinical encounters in a better way. I'll come to this in detail in the subsequent part of the talk. The patients, yeah, there's some error there, sorry. So good communication skills are integral for the development of meaningful and trustworthy relationship between the doctor and the patient and the attendant as well. If the trust is not there, no patient is going to allow you to touch their eyes, or for that matter, I'm restricting my talk to mostly ophthalmology. And say, for example, you want to go and intervene and give an interventional injection inside the eye. How does a patient trust you? Okay, so it is first thing which starts is a communication between you and the patient and the family. So when you listen to the patient in a better way, your diagnostic capability also improves because you get those hidden clues from the patient. This decreases your work stress eventually. The patient satisfaction is better, and this increases your own job satisfaction. And all of this finally relates to improvement in your in a better handling of clinical encounters which are difficult in nature. So you handle them in a better way. So as a result, patient's level of satisfaction is improved, which directly implies to better compliance with the treatment. And this impacts positively on the patient's psychology, mental health, tolerance, power, and the quality of care what you provide to the patient. So let's quickly look at what are the components of communication. The three major components of communication are verbal, non-verbal, and paraverbal. Okay, so why verbal skills are extremely important? Say 90% of what we do is around verbal communication, but apart from that, we have the non-verbal and the paraverbal communication as well. Important is the selection of words. A simple statement like "Ande ka putra andha," what is such a big, we have been learning Mahabharata and watching it as well. It's supposedly said that this is the line which started Mahabharata, which is actually not the correct reason, but people do add in for the spice content, like what a media does right now. Okay, important is the selection of your words, what you utter. Once the words are spoken, it's like a bow and arrow. The arrow which is released cannot be taken back. So what you speak matters, especially for the patient, because sometimes the patient do consider us as gods. It still exists, and they may get hurt with that. So non-verbal component includes the posture, gesture, facial expressions, the spatial distancing, how you relate to them, your eye contact. Whereas the paraverbal communication part of it is the tone, pitch, the pacing, and the volume of your voice. Every time you cannot be speaking in the same sense to those patients. You have to alter your voice to an extent when you are breaking a bad news to them, or sometimes you are happy the treatment outcome is better. That should be dealt with. So this is about the benefits. Now, when you look at the barriers of good communication skills, the most important barrier here is lack of knowledge about the disease or the treatment. So if you are not skilled enough, if you have not attained the maturity of the disease to speak in front of the patient, you'd never be able to communicate in the better way. So lack of insight. So inadequate knowledge adds to the lack of insight. So you cannot empathize with the patient. The other important factor here, since in a country like India, is a language barrier. People from the West, North try to come and learn in the states of Southern India, and language becomes a very important factor there. So that can be overcome by putting extra effort in learning the language. Apart from that, stress, tiredness, and lack of time in an overburdened setting, be it private or a government, we have enough number of patients and we are overworked, as Dr. Rohit Modi also said in his speech. So learning is an art, and it's an active process through which all the information is imbibed, expressed verbally or non-verbally by the patient. This is where the cases of litigations can be reduced if you listen properly. And listening is a part of verbal, non-verbal, and paraverbal communication. So the next question is, how do I become an artist? So make the patient and the attendant comfortable. Show interest in what the patient is saying with your mannerisms, body language. So different ways of mannerisms exist, like patting the shoulder, shaking hands with the patient, holding hands, nodding when the patient is speaking, eye contact. Only in India, especially, holding hands are something which you need to be careful, because again, that can be taken in a different way. Avoid interrupting the patient when the patient is speaking. Let them complete the statement, then you can reach out to them. Also, while concluding, ask the patient if he or she would like to add something more to the conversation. Start the conversation, introduce yourself. Do not wait for the patient to come and speak to you. This will break the barrier. One other important point, what I have seen with a lot of younger doctors or new residence fellows, is that they do not know the patient's name or the age when the patient is sitting in front of them, and they ask them, so what is your name? And they are checking in their records or the electronic medical records. So that is, patient feels little dishonored, disrespectful. So ensure that before the patient comes in, you know the data of the patient, his name or her name, and so and so. Maintain privacy. Do not allow other patients or your staff as well to come inside when you're examining the patient and speaking to the patient. Involve the patient and attendant in the decision making, and explain the details in simple language. This takes time to understand, explain in simple language. We are all trained with medical jargons, but when it comes to patients do not understand. Okay, then what is happening to me? You have retinitis pigmentosa. Patient is not going to understand. You have to explain them you have night blindness which cannot be cured. You have to use light during your entire work in the evening, and so on and so forth. The communication can go on. Next part of this talk is communication with the attendants and the colleagues and our colleagues. So be formal with the attendants, do not be informal with them. That may backfire. Appreciate their efforts towards the care they have taken towards their loved ones. Involve them in the discussion and resolve the doubts. It is most of the times, it is these attendants who are the ones who come with queries from Google, because the patient is busy in their own treatment, but the attendants are free and they come with a lot of questions. You may have to take time to resolve the doubts. Explain about seeking second opinion if you feel the patient is inquiring a lot and may cause problems in the future. Always give them an option of taking a second opinion for the same condition. Though you may be an expert in that, nothing wrong in getting your ego down and asking them, go take a second opinion. This will give you a peace of mind. One more point I would like to add here is that what happens is sometimes you explain in detail, say a case of trauma comes in, you explain in detail about the condition and the prognosis to the patient and the attendant. Next time a new attendant comes in, you have to spend the same amount of time in explaining them. Second time another attendant comes in, and then you also lose your mind. So when you're angry, do not talk much and ensure that the same attendant follows the patient and comes with the patient rather than a new attendant every time. With your colleagues, very important, avoid loose talk, saying that this faculty is not doing a good job, this fellow is not doing a good job, or this staff nurse is not good. Okay, respect them. Avoid shouting at them in front of the patients, because they are the same kind of individuals who are going to treat the patients in your absence. Lead by setting examples. Last two slides about managing difficult encounters. It is a combination of factors related to doctors, patient, and the circumstances. And the doctor has both ethical and professional obligations to treat the patient irrespective of the ailments and the circumstances. So this is where things are not taught to us. And this is where over a period of time, we need to build our acumen in such a way that we understand how to manage difficult encounters and how to even break bad news. Say a patient, you post endophthalmitis, you cannot save the eye. You cannot tell the patient you're going to go blind. That patient and the attendant may actually have a vasovagal syncopal attack and may fall down as well, which has happened in the experience in a lot of individuals if you look at the stories. So important is we need to learn the art of how to break bad news to an individual. It is a complex communication art, and majority of the doctors lack the competence as well as the confidence to divulge such bad news. So there are ways to tackle this. Prime up for the situation, rehearse, practice that what if the patient comes in such a way, how am I going to tell them? Say a couple comes with a child who has lost one eye. It is such a devastation for them, and you cannot tell on their face that, sorry, your child has lost vision, we cannot do anything for it. But there are different ways to say it. You can take them outside, not in front of the child, explain them that we have tried our best, but certain situations go out of hand. Okay, and we are, let us see what can happen, and give them time to assimilate the information, adjust to the situation, and they'll turn around and they'll be very good patients and understand that you have given your best. This will all reduce the chance of litigation against you. Assess the patient's knowledge and attitude. Assess the patient's desire to get the level of details of information required. And then is the act of actual breaking of bad news, and eventually address the patient's emotions. You have to connect emotionally and empathize with the patient. So in short, to conclude, good communication is important to gain the trust of the patient, improve your own knowledge, and give the best care available to the patient, and avoid any kind of futuristic litigation cases. That's all from my side, Amish.
Awesome, Dr. Bhavik. That was a very insightful talk, and thank you for that. Let's get back to Dr. Chintan Shah here. I think, Dr. Chintan, you're here?
Yeah.
Dr. Chintan, how would you have these communication skills? Because your patients are usually children, and you have to actually communicate with the parents, where they have to be having that trustworthy being, having faith in you so that, you can go about with your surgeries, or maybe some practical tips which you want to share about.
Yeah. So communication is very important in all the branches, but it's even more important, and I would say even more difficult in my subspecialty, because I'm not just dealing with the patient. I need to gain trust of small children so that they can give us useful information regarding their disease. It's often people feel that why should we take so much time in history taking with the children, because the children, they don't know much, they won't be able to give proper history. But that's incorrect. If you spend more time with the children, with the family, actually you can gain a lot of information, and not only the information, you gain a lot of trust from the parents, from the children, and that goes a long way in the entire diagnostic and the therapeutic process. So once we spend more time with the patient, and here what we do is we don't wear aprons around the children, because the children, when they think that they are seeing doctors, then they get afraid, and they have certain fear regarding the doctors. So basically we try to be friendly. We have lots of toys around us, the chocolates and everything. So we don't directly jump to the diagnostic process and everything. We first try to know the patient, we interact, we chat a little bit, and then we try to find what's wrong with the patient. And that's really good. That builds the rapport with the patient. And it might be difficult for people to believe, but here we do operate even 8-10-year-old children under local anesthesia with a little bit help of mild sedation. So that is possible only if you have a good rapport with the patient, with the children, with the family, when they believe in yourself, when the children, they don't treat you as a doctor, but rather they see a friend in you. So I think the communication is extremely important, and that was very excellent presentation by Dr. Pavik, and there were a lot of good pointers that is very important in our practice.
Yep. Thank you, Dr. Chintan. Dr. Gunjan, are you there? I would want to ask you what, Dr. Gunjan, are you there? I think so. Okay. So what we can do is I can ask Dr. Rohan here, what difference is there when you are actually, like, you are working in an institutional practice where you are a fellow, and even now as you are a director of a place? So what skill sets have changed? And since your refractive patients are more demanding, what sort of practical tips you want to share with us? Dr. Rohan?
Dr. Avnish?
Yeah.
Hello.
Dr. Gunjan, can you answer this? What is the change in skill sets, from practicing in an institutional when you were a fellow, and now since you are working in a corporate setup? So what change of things are there? And also about refractive patients. Yeah. I just wanted to ask, what sort of skill sets, can you hear me? Hello?
Yeah, I can hear you.
Yeah. So what is the change of your skill sets? Yeah, yes. So can you tell us what sort of changes, or what are the skill sets you use, or what are the differences when you were a fellow and when you were doing your private practice? And some insights about your refractive patients as they are more demanding in terms of vision and their visual outcomes.
Yeah, definitely the refractive patient that everybody knows, they are very demanding, and some of them, they definitely are rejected from a lot of places because maybe they are, they have borderline pachymetries, or maybe they have abnormal posterior floats, etc. So a lot of times they come for second opinions as well, and some tell the patient very honest, because these patients are taking opinions from a lot of places and sometimes are doing doctor shopping as well, and they know a lot of things by Google, etc., that these things are available. So it's not always necessary that all the patients have a very good visual outcome, because sometimes they are amblyopics as well. So before the surgery, definitely I need to be more cautious now. During fellowship, definitely I had a cover of the consultants who were actually dealing with refractive patients along with us. So definitely I feel more pressure when I see refractive patients before surgery as well. And it's very important to counsel the parents as well, because sometimes the parents are sometimes very fussy, and especially the post-surgery results are very important for them, because even if you have some kind of blurring or some adaptation problems, they don't understand. So I take a lot of time, lot of chair time before my refractive surgery. It's very important, I feel now. So I just think that definitely we should always give a lot of chair time and should understand the psychology of the patient. And a very nice talk by Dr. Bhavik. I definitely had a lot of learnings today in how to develop my soft skills. Sometimes these patients may be irritating, and when you tell them that it's not a normal thing, they keep on getting people and they keep on visiting again and again with some other person of the family. So a lot of times we are not very patient in the clinic. Sometimes a very busy clinic, or sometimes we are going rushing to OT, etc. But yes, definitely I think soft skills are, I feel. Thank you.
Okay, moving on with Dr. Akshay Nair for his next talk. Dr. Akshay, over to you. Starting from scratch, what worked for me? Dr. Akshay, if you can start your presentation, please. Thank you.
Right. So thank you, Avnish and Yosi, for this opportunity to present on this topic. So basically, this is in a sense a continuation of the previous session, what was discussed about how different options of freelancing, working at your own center. I'm going to put all of that together. A little bit of my background is that I do only oculoplastic surgery. I do not do, being a specialist, my practice is now in such a way that I do not get patients, or I don't see patients who require cataract refractive surgery or general ophthalmology and refraction. I am attached to now 3 hospitals which are under a corporate chain of hospitals, as well as some amount of freelancing. I have a once a week attachment to a government medical college. I don't have a standalone solo private practice of my own. So at the end of the day, what decides what you end up doing? There are multiple things. You need to sit back and figure out what is it that you want to do in life, whether it is an academic name in the academic circles, whether it is good monetary returns, whether it is a bit of both, or whether it's only good family time with fixed hours. All of these will decide what type of practice you do, which is also dependent on the specialty that you practice. Other things that you need to look out for is whether you're fixed about going back to your hometown, your willingness to relocate to a different city and start all over again, your spouse, their careers, the age of your children or children, if you don't have any, what needs to happen. And also eventually, if you are shifting from one to the other, like for some time you want to do freelancing, then be a part of a large hospital, and then eventually set up your private practice, you need to figure out how long can you wait before you really start earning, because different phases or different practice patterns, like freelancing versus having your own setup, you earn differently on each of these. So what are your different options? One option is for you to stay back in the hospital which you finished your training, if that is available. The other is to join just as a fresh graduate, you join a hospital or a chain of hospital as an associate. You can start away, take the plunge and start your own practice. You can do freelancing as discussed by Dr. Modi. You could go and become be a part of a government or a trust or an NGO organization, or what is called a charitable hospital. or you become a full-timer in a large institute or a corporate hospital. And I'll just quickly go over the pros and cons of each of these. So when you stay back in your training hospital, you need to first figure out whether is this for a short-term process or a long-term. Because when you're thinking of the long-term 10, 15 years, then you're going to be a part of the hospital's growth. And then you add a lot of value to it. If you're going to be there just for getting the name tag of being an ex-faculty at so-and-so, so be it. But at least you should be clear of what you want. Now, while you're at it, try to specialize further in something. If you, like, say, for example, oculoplastic surgery, if you've done fellowship from an hospital and now you're a faculty there, try to make the most of that time. Maybe say, specialize in endoscopic surgery or aesthetic surgery. In a way, this is buying time before you actually figure out what you want to do or what you don't want to do. The advantage is you're in a familiar environment, you finish your training, you're immediately back in the game, and you have some steady source of income. What about joining a hospital or a chain as an associate ophthalmologist? See, the thing with this is that you end up joining an established practice or an established surgeon, and you become a full-time associate. So the onus of building the practice is not on you. You directly have adequate volumes and some amount of freedom. The good part is that you start working without having to put in any investment from your side, and you get paid reasonably well. But it also comes with a flip side, the downside also, which is that you're working for someone else, you're working for another organization. At the end of the day, you will be given targets. You have to conform to certain working hours, and you may be one amongst many. So your identity may be lost. And as a junior associate, there's always a ceiling to earning, how much you can earn. So this can be a stepping stone to moving on ahead. So this is also something that one could explore. How about building your own solo practice? When I say a solo practice, I'm referring to a clinic or a standalone practice of your own, with or without an operating room, where the patient is referred to you and you're their primary ophthalmologist. If you need to, you could have other consultants of different specialty coming in for some time. The biggest advantage is that you have complete freedom to choose. You set out the SOP for every patient, surgical patient, or treatment practice patterns for every patient that comes in. Where you practice, what you do, you are essentially your own boss. As was discussed earlier, by being the boss of what you do, your earnings are significantly high, but also it is the most challenging type. It is investment heavy, and you need everybody on your team to be aligned with what you're doing, on the same page. There are going to be overhead costs, and you have to be prepared for an incubation period. You don't start your practice and start doing 10 cases a day the next day. Also, when you have a solo practice not in larger cities, but in slightly smaller cities, it may be difficult to have a specialty practice like only retina or only oculoplastics. Visiting conferences or other places means your practice is shut and your income goes for a toss for those periods. And here there is no one that you can refer a case to. You will end up learning from your own mistakes, and you are your own backup. Each upgrade of technology is going to be expensive, so it has its own share of disadvantages as well. So in solo practice, you need to figure out what is the right timing for you to start solo practice after training. And once you go in, it's a long-term decision. You can't think of starting private practice for 5 years and then come back and say, no, I don't want to do it. You've invested so much time and equipment into it. It's not for everybody. It doesn't mean that private practice is the ultimate holy grail and the end of practice, the end of the journey for everyone. Some people are just not cut out for private practice, and you need to figure out whether you're one of them or not. How about freelancing? Freelancing is basically where you offer your services as a specialist to different centers, whether it can be in the same city, it could be different centers in the same city, it could be different parts of the city, or even different parts of the country. You could visit a different city in a different state once a week, once a month, depending on the need for you to go there. This, of course, should be in addition to what you are already doing primarily as your hospital attachment. How does it work? You get to decide along with the center that you're visiting. You could either have a fixed schedule, or which means once a week or once in 10 days, once a month, and pre-decide this date, or it could be an SOS where they just call you, hey, I got a macula on RD today, can you come in? At the end of the day, don't undersell yourself just because there's not enough work happening. Never end up doing surgeries for costs that are lesser than what the market rate is. It has advantages because practice building there is not your responsibility. You're offering a service to for a need that is already there. Because there is a need, volume is going to be good from your first day. It's freelancing, you have that flexibility, and it can be rewarding initially. But disadvantages is that everybody wants flexibility, and you don't want to be freelancing at too many places, spreading yourself too thin. Sometimes as a freelancer, you don't always end up seeing what you're trained for. I, as an oculoplastic surgeon, have sometimes been called in to see patients for squint, and I've had a tough time explaining that oculoplastics and strabismus are different specialties, and this is to ophthalmologists. At the end of the day, you're offering your service to someone at their practice, and it's likely that you're replacing someone else. So you are also replaceable. It is not a practice of your own. So that is a disadvantage that is there. And of course, carrying your equipment and consumables everywhere can take a toll over time. How do you break into the scene? I talk about ABC, which is availability, behavior, and competence. All of these things have been discussed previously, so I won't take too much time on it. Freelancing is good in the short term, but because you go visit more places, meet more people, your visibility improves, but it's not sustainable everywhere, every time in the long run. At the end of the day, like I said in the discussion with Dr. Rolika, good results are the basis for good relationships with ophthalmologists and with patients. How about joining a government hospital or an NGO or what is called a charitable hospital? These are good things where you can be an honorary or be in an academic position in a teaching hospital, especially that allows you to treat a lot of unaffording patients. But this, I strongly suggest, should be in addition to what you're already doing. This should not be your primary center of practice, unless you want to stay in a hospital, or as they say, haath safai karna, where you feel you've not had enough surgical practice and you want to go to a place where you learn from a mentor who's already there. And finally, so you finish your training, you're back. Now what? First thing is take a break. The next thing is to work on visibility. Get a business card printed. You may not have a place that you're already working. Just put your name, your specialty, what you did, where you did, your name, your phone number, and email address. Get some brochures made, build a website. Having an online presence is important. To be on groups of ophthalmologists, on online fora, on Facebook, if not for anything, just for seeing what is happening. You may not want to post every day, but seeing what is happening, because visibility is important. Visibility is important, not just online, but also in person. So when you're back in your city, meet the local ophthalmologists. They're the people who are going to refer patients to you. Meet local specialists of allied. Like if you're a pediatric ophthalmologist, you may want to meet local pediatricians. Seek out help. Always if you've trained from a large institute, when you go back to any large city, there are going to be people who also trained from your same institute. So meet your alumnus. They are usually the most helpful. Once you've done all of this, go and meet the local ophthalmologist again, because persistence is important, and do not be dissuaded by all the things that they'll say. 10 years ago, people were telling me that nobody can be an oculoplastic surgeon alone without doing cataract. But work has been good. So that's not always, if you have a decision, you should stick by it and keep meeting them again and again and again, because like I said, persistence is important. You should go to local meetings. Now, of course, things are coming back on track in terms of physical meetings. Go to your local city meeting, state meeting, volunteer to present something, so that the guys whom you met 3 times earlier will see you present and make a connection that, okay, this guy's actually a retina specialist, he's presenting something, he's talking sense. Even if you're not presenting something, go and attend, because networking is important over there. And something that they don't teach us in medical college or fellowship is fees. You need to be honest, clear, and transparent about it. Like I said earlier, don't undersell yourself. Affiliations with ophthalmologists where they call you as a freelancer or as an attachment. These are long-term associations, so they should be built on honesty. The foundation has to be good. If you don't know charges, seek out, meet colleagues and ask them. There's no harm in asking. Be honest. Don't operate when you do not want to. Just because someone wants and they feel that there's an indication to operate in whatever specialty, unless you're convinced, don't do that. Don't compromise on your clinical and ethical foundations. Like I said earlier, your best advertisement is a happy patient, but an unsatisfied patient is your worst nightmare. Ghost surgeons are a reality of our practice. I leave it up to each of y'all to personally decide whether you want to be a part of it or not. I, from my side, never have been a ghost surgeon, and I don't, I'm not approving of the practice of it, but I realize that a lot of surgeons are able to, get by operating for someone else, and if that works for you, so be it. In the beginning of our career, once you start working, you realize that you're working a lot, and burnout is a real thing. So you need to pace yourself. Don't spread yourself too thin, attending every Saturday meeting, every Sunday conference. Give personal time to yourself and some family time. From my side, I have no ophthalmological background. So when I came back 10 years ago, I kept meeting colleagues. I met alumni, and that for me worked the best. These three hospitals, when I'm affiliated to, all are, the hospitals are owned and set up by alumnus of people where I trained at. And that's how I got in, and that's where I've been for the past 10 years. I'm also attached to a medical college, like I said, which allows an outlet for my academic pursuits. I used to freelance a lot, but nowadays I have only 4 places that I visit once in 2 weeks or so. And my website is something that I've worked on, which I feel every ophthalmologist should do that. There has to be a way. In 10 years down the line, patients are not going to be referred through specialists or other referring doctors. Patients are going to refer themselves to you, and that will happen only online. So to summarize, whenever you figure out what you want to do after your training, think, discuss, and decide with your family members and all stakeholders, because it's not only your decision that's going to matter. Everyone's input should matter as well. At the end of the day, you decide what you do, not others. It's like Dr. Bhavik said, never forget your cataracts. So if you feel you want to do cataracts, regardless of being a retina specialist or a screen specialist, you stand by that decision and do it. If you feel that, no, I'm an oculoplastic surgeon, I should not be doing cataracts because my referrals will get hurt, you do that. Don't let people's thoughts and ideas influence what you do. Be persistent. Align your long-term and short-term plans such that they work synergistically towards the goal. And at the end of the day, don't forget to have fun. Not enjoying what you do is the worst thing to do. I repeat myself, we are a country of 1.4 billion people. There are enough people with a lot of issues, and most of it, ophthalmology, thankfully, is blessed to have so many aging issues that come with it. So as people grow old, there are going to be enough patients for everybody. The concept of an unsuccessful ophthalmologist doesn't exist in India. So enjoy what you do, and eventually you'll have fun. This is one of my favorite quotes. The best way to predict the future is to create it yourself.
Awesome, Dr. Akshay. It was a very comprehensive talk on what we've done. I think any comments from the panel, or we'll move on to the next talk. All right, then we have Dr. Samiksha Agrawal here. She'll be speaking about her experience in a 2-tier setup, smaller cities, bigger dreams. Dr. Samiksha, over to you.
Actually, sir, I would just like to add that you're absolutely correct, especially in like a subspecialty like ours, wherein ophthalmic plastic surgery and ocular oncology, we have a very small spectrum. So the most rewarding part is when the patient recovers, when the patient gets better for a long time. It's not really, the focus is really not about earning for a very long time. Maybe that happens after 10 years, as you have quoted. Right. Thank you, sir.
Am I audible?
Yes, Dr. Samiksha, please.
Yeah, so I will be telling about the ophthalmology practice in a tier 2 city. I work in Allahabad, Prayagraj in Uttar Pradesh. One second, my slides are not moving actually.
Samiksha, you can stop the share and try to reshare it.
Yeah, is it seen now?
Perfect.
So after we finish our fellowship, once we come to a tier 2 city, and if you have done your fellowship from a tier 1 city or a bigger city, you get a culture shock, like how you talk to the patients, what are the patient's expectations, and all those things. So what we see here is like the paying capacity of the patient is less, and they tend to pay lesser for the same facilities in a smaller city. And they have this mall versus general store mentality. Like what for the same things, you tend to pay higher in a mall versus in a general store. If you buy, it's like you pay lesser there. So yeah, and the patients are little less educated. They are less aware about their diseases. So here what I saw was like you get very chronic RDs, chronic ulcers, like non-treatable cases, pre-thyscal eyes. All those things are very common here. And then again, the quack culture, obviously mistreated, and all those eyes, you will see that chronic steroids and very bad eyes. So what difficulties we see in smaller cities, like there is difficulty in getting good paramedical staff, then immediate availability of drugs or injections for that, say, like if you want it the same day, it won't be available. Then if there is instrument breakdown, then obviously immediately it won't get repaired. It will take at least 2 to 3 days for that. Emergency facilities are not that easily available. And if you want to send culture reports, lab reports, they are not immediately available. For again, if you want any PCRs or higher technologies like ICG and all those things are also not available. Again, if when the patient comes to you, they think that if you tell them they have retinal detachment or something which needs higher cost than guarded prognosis, obviously they think that they should go to a bigger city and they'll get better treatments. Again, in terms of conferences and CMEs, we don't have those regular CMEs as you see in bigger cities. Then all those bigger machines, genetic testing, electrophysiology services are not available. Then there's set of patients who are very poor. Then they go to something like very charitable or a very government setup, obviously. So there's this middle group of patients. And so we have to look for the pros and cons. Like the pros of the smaller cities, that doctor versus patient ratio is good. Like there are more number of patients as compared to doctors and subspecialists. Obviously less competition for specialist doctors. Then if you are starting new, or if you are starting solo, then the cost of living and all those things, the investments are lesser. And obviously for starting a practice in a smaller city, you don't need cutting edge technology. The patient's expectations are not so much. Then you can start in a smaller setup. You get staffs at a comparatively cheaper rate. And like bigger cities, it's not that much saturated. Also, you get fair enough patients if you're starting new. So those are the pros of tier 2 city. Thank you. I think Dr. Avnish will be telling more about tier 1 cities. And
Thank you, Dr. Samiksha, for this brief discussion, or you can say the commentary about two-tier city experiences. We have Dr. Devakant here. Dr. Devakant, can you suggest or maybe give us some pros about how you have developed when you have gone back to Lucknow, and what actually went in your favor about it? Dr. Devakant?
Yeah. Thank you, Dr. Avnish. Before that, I think Samiksha has pointed out some really good points, what challenges people face in a tier 2 or a tier 3 city. Another challenge I feel that you guys face would be doctors or subspecialists visiting from other cities. So whenever I go to some other town, they might not know me, but they are very happy to come and see a Lucknow wala doctor or a Delhi, Mumbai wala doctor. So they always, I may be not as good trained as you are, but still they'll keep a doctor from a outstation doctor at a higher pedestal. So that is another challenge. Coming to what Dr. Avnish asked, I practice in Lucknow, and I very soon realized that I do exclusive retina practice. So I realized that this will only work if you have a good referral channels. So that was the thing that I worked on, and it is all about as Dr. Akshay had pointed out, you need other doctors to have confidence in you, and they need to trust you and believe in your work. So that is something that you should work on whenever you start a subspecialty practice in whatever city, whatever area you are in. You need, because developing confidence amongst the general population, general public it comes slowly. It comes at until unless you invest heavily into advertisements. But if you're practicing a specialty, you can reach out to doctors. That is the number one thing that needs to be done. For that, I think Dr. Akshay has talked about it. You need to be visible. You need to present your work. They should be aware that what kind of work do you do and what is your specialty area within your specialty as well. So reach out to people, reach out to IMA, reach out to your local bodies, local doctors, go and meet them personally, and there's a lot of the financial aspect of it as well, probably that can be discussed on a more closed group. And yeah, that is it, Dr. Avnish.
Thank you, Dr. Devakant. I would want to ask Dr. Gunjan about her take on working in a place like Delhi NCR and what hurdles she actually faces when it comes to her specialty, and how well you can establish yourself in this sort of a setup. Dr. Gunjan?
Can I talk in a minute?
Yeah. So I'll ask the same thing to Dr. Rohit. Is Dr. Rohit here?
Yeah.
Yeah. So, sir, can you tell us about your take about this? How do you go about in a one-tier place, and what hiccups do you actually see, and how do you overcome it?
So I feel there is huge amount of scope. Many a times we feel that in tier 1 cities, especially metros, there is oversaturation. And there is a famous joke in Mumbai that there are only more than 100 retina specialists working in the city. But still, when I speak to my colleagues who have just come in Mumbai, they are also doing decent number of cases. So there is enough work for all of us. Just we need to be positive about it. Second thing is that in some of the cities there is a kickback culture, and many a times a few of us are reluctant to speak about it. I feel if we as a new generation say no to it, we can move away from it. What some of the people from the previous generation have done about the kickback culture in the specialty work. And the third aspect is I believe that instead of going to doctors for referrals, I now my approach has changed that I directly want to get in touch with my community to get the direct patient connect, so that I get referrals from them rather than from doctors. That is something which I've started doing recently.
Okay, sir. Is Dr. Gunjan there? Okay, we'll come back to Dr. Gunjan. What we can do is
Dr. Avnish, yeah. One question from Dr. Rohit. So he said something about reaching out to the community. How exactly do you go about doing that? Any tips on that?
Yeah, Divyakan. So one is that you can join the local Rotary Club or the Lions Club. Then also from the community itself, many times they do refer patients who are not able to afford care at other hospitals. So you can do part charity work also, that at your own setup, which will you can take care of the cost part, in the sense your disposables are taken care. You can probably waive off your surgical expenses initially for the patients who are truly not affording, and that also creates a good of word of mouth, and slowly that name spreads in the community. And my setup started only 2.5 years back, but I can see a significant support from my own community, and we are hardly doing any kind of marketing, and we don't even have a hospital PRO. So that when attending every community function, even if you meet somebody on the road, just going saying hi to that person makes them feel that you are approachable. You are and if they feel as a as a patient you are approachable, they are more comfortable with you.
Right. Thank you so much.
Okay. Dr. Sahil, can you tell us about how do you go about with your locality actually establishing your practice?
See, regarding establishing, as Dr. Akshana said, that you should meet the local ophthalmologist. So that is one thing. You should understand what actually is the practice over there. Because obviously every city has its own rural background or its own periphery. So has its own culture, as everybody has already spoken about. So that is the main thing that you need to understand, that where are you going to place yourself and what that area demands in all the terms, like as Dr. Bhavik said about communication, obviously, and as everybody has spoken about different things. So we need to look into that part first. And then you need to look into it, that what you are willing to do in future, your solo practice, or you want to work at a hospital, you want to work in multi-specialty trust, whatever it may be. But the base thing is to understand that what is actually going on, and try to understand the local ophthalmologists, like seniors and juniors and the colleagues over there. Because obviously you will have a lot of competition, you will have bad mouthing also, you will have good mouthing also, you will have word of mouth spreading also everywhere. So you need to have a good terms and condition with everyone, because you may not, if you start a solo practice or you work at a trust hospital, you may not have all the backups. So you may need other people as a backup. So a kind of coordination with everyone is also required, and very important is to understand that particular area. Plus, then you need to understand the paying capacity of your patients over there, the population, the demographics of the population. Because even when I'm working over this particular area, this Jodhpur district belt and all, so if we have 4 places of this particular district, so each quarter of that district has a different paying capacity. So even the not every quarter will work as the same way. So I cannot have the chargeable rate as the other quarters have. So I need to keep a lower, because paying capacity of this thing will be lower. People are more dependent on free camps and all these things. They are mostly requesting kind of their poor background, so they may need more of a low cost treatment. So there are 2 things to balance always. One is less number of patients with a good buying capacity, so you spend more time with each patient and get a good outcome on per patient. Second thing is, you understand that if you have to deliver a low cost services, then you always need a bulk over there. So you have to work on that thing. You need the bulk of the patients coming to you, so that even if you maintain a low cost for the each patient, then technically when the bulk of the patient comes to you, then the outcome will be a better one. So this thing needs to be balanced as per the local practice over there. And obviously it all depends that where you are finally going to place yourself, in a private practice, charitable practice, in a charitable organization also now always doesn't have like a bulk of doctors over there. You can have a charitable organization, you can join a charitable organization where you are technically you are the clinical boss over there, because you are the only single person. So you get to see the patient. It's like a more of a private practice only. The only thing is you are working in a charitable organization, but since you are the single doctor, if you give your 100%, probably you can make a very good name out of it in the future. And obviously that will be more of a private practice of your own only. Because slowly the patients will come with your name, on your name, for you, specifically to get tested by you. And the rest of the things like good communication skills are very much important to establish yourself. So I suppose that thing is just
Thank you, Dr. Sahil. Dr. Gunjan, your quick comment, and then I think we'll be closing the session. Dr. Gunjan?
Yeah, yes.
So your take on working in Delhi NCR?
Okay, so yes, definitely there are so many eye centers in Delhi NCR as a hub of ophthalmology, and a lot of referrals come from nearby places, Haryana, Rajasthan, and UP as well, and some of them from far places, because in few times COVID was picking up, and all the government setups were not functioning for full capacity, so a lot of referrals were coming from far-flung places. So it's not that that the patient is coming for a lot of patients are not coming for the first time for consultations. They are showing to a lot of doctors. The treatments are ongoing in different parts of India and different centers, and all are very good. So it's very important to remain very ethical, and it's very important to tell the patient also that whatever thing the treatment the other practitioner had done was good, and it's very important not to speak bad about any of the practitioner, whichever way they have treated. Might be that time we don't know what was the status of the patient, but we should never badmouth about anybody. That's very important because ultimately we all are, in the same boat, and it's very important to support each other as a community. So yes, I think it's very important at all the places, even, but in Delhi NCR, because there's a lot of centers that are working nearby at, all in different parts of cities as well. And a lot of our friends are also nearby. So it's very, easy at some times when you're stuck up somewhere, that you can take help from your friends who are, or the seniors who are practicing in your specialty, or not even your specialty, they are in the field since long time. So it definitely helps when we are as a community where we are working. So the competition definitely is there, but it should be a very healthy competition for everyone to function properly, what I feel.
Thank you, Dr. Gunjan. That was a good way of actually saying that we all are in the same boat and not to badmouth. Just a quick comment from the panel as well as the speakers about the commentary which we actually had was filling the gaps in COVID-affected fellowships. So since last 2 years was a problematic for everyone where there was COVID and the patient load was less. I would want to ask Dr. Akshay how to actually go about doing your specialty in post, like you have done your fellowship and after that you had issues with COVID and all. Dr. Akshay, can you give us some insights?
Yeah, I think this is something that even medical program directors and academic directors are grappling with. Thankfully now, of course, things have opened up, but yeah, there has been a big lacunae in terms of at least 4 to 6 months during the early phase, where elective surgeries were significantly affected, and especially those in short term or towards the end of their fellowship, where your learning with surgical volumes is higher, that was affected. I think one way to do that is, to go back to your institute and probably have a short-term observership again, or just you could speak to your own program director if you could continue for a while, or try to visit another surgeon in a different city to observe a little more, or maybe as a part of your career plan, like I said, one of those options of either being a part of a charitable hospital or an academic hospital, a medical college for some time, such that you're able to refine your surgical skills. These are different options that we have, but at the end of the day, we are just shooting in the dark. That surgeons who've lost surgical training period to the pandemic is a very real thing. In fact, not just fellowship. There have been people who joined their residency in 2019, 2020, and 2021, and they're finished with their residency virtually having been in the middle of the pandemic, with which later on will have significant implications.
So, yeah, Dr. Akshay, I think even it's more of like, you have to either go back to your institution, or you should actually go to places where they have good surgical hands-on. And it doesn't matter whether you are actually going to a 2-tier or 3-tier place. It's more about getting experience and then going back to where you actually want to go. Whether you want to work in a 1-tier, 2-tier place, or do your practice, like your specialty with your whether to do cataracts along with that. So with that, I think thank you so much everyone in the panel as well as the speakers for this session. And over to you, Dr. Karan and Dr. Devakant, for the next session. Thank you. Thank you, everyone. Dr. Devakant, you there?
Yeah, I'm here.
Yeah.
Devakant, you there? Yeah. So thank you, Avanish, for ending the session early. We still have a lot of people joining in. And, it's a very important session that we have. Next up, it is the do-it-yourself private practice setup, all you need to know. Now, this is a very important session as to, there are a lot of young ophthalmologists such as myself who are entering private practice. And I'm sure the speakers and the panelists right now will give their insights because they have done this. And it will really help guide fellow YOs and others in, better management. So before I, go ahead, I'd like to introduce the panel over here. So we have Dr. Shraddha Surekha, Dr. Rohit Modi, Dr. Swapnesh Sawant, Dr. Tanveer Ahmed, Dr. Digvijay Singh, who is the president of YOSI, Dr. Madan Gopalan, Dr. Biswajit De, Dr. Ankit Agarwal, Dr. Piyush Chandak, and Dr. Aarti Heda. The session will be moderated by Dr. Divakant, who is the secretary of YOSI, and myself, who is the joint secretary of YOSI. Before I go ahead with the first talk, now we have a slight order change. We'll have Dr. Akshay Nair's talk first. But before we go ahead with that, I would like to open a discussion to the panel first, and everybody's open because we want this session to be a very, very interactive session. And what I would like to ask the panelists, anybody can come in, is when is one ready to enter private practice?
Hi, Doctor. Hi, sir. Dr. Shraddha here. So I would like to start off by saying that one is ready for private practice as soon as one is done training. We don't need to wait, to go and join an institute first in the place where we are going to practice and then jump into private practice. There's absolutely no need for that. You are ready for private practice as soon as you are done with training. If you have that mindset in your head, then what happens is even during your training, you focus on that patient, thinking that what if this patient will is come to me in my own private practice and I don't have the umbrella of my mentors and my institute over my head to manage this patient. So I think we take a lot of good from the training also during residency and fellowship if we have that mindset.
Excellent points. Would anybody else want to comment? Anything else?
I think I'll just chip in, Karan. What Dr. Shraddha said makes a lot of sense, but I think we have been fortunate enough to be trained from institutes where which not just taught us to be practice ready, but also taught us to be training ready. We were good enough. We were luckily trained well enough to start training others, but that's not the case for others. We also see a lot of training institutes in a metro like Mumbai, where people complete their residency and have done less than a handful of surgeries. So I think it's also important to figure out whether you are in a position to offer the basic standard of care for most conditions in terms of medical and surgical. And if you think you're sound enough, technically to do that, anytime is good time to start practice. Also, just a continuation of what I said in my previous talk. Over years, being a freelancer, initially we've met a lot of different private practitioners. Private practice is not the be-all and end-all of ophthalmology. A lot of people get a lot of pleasure working in charitable hospitals, working for the underserved. People who don't have enough resources. Some people are built for academics and research, and they'd rather be in an institute. So I think you need to also figure out whether you're cut out for private practice, and only if you feel you are, should you do that. It's not be all and end of. Sure, monetarily, it's the most probably the highest rewarding. It's also the most challenging, but it's not necessary that everybody any ophthalmologist has to be in private practice of their own.
Hi, sir. Good afternoon.
Good afternoon. Good afternoon.
Hi, sir. This is Tanveer from Assam. So I would like to say that private practices, what our teachers told us while we came out of our after completing the MS, they said that you only do independently to which you are confident enough. It's not like you jump into cataract surgeries, SICS on day one if you're not confident enough. Or rather, I would like to say that, we can go for the private practices once we get our registration, first of all. That makes us legally sound. Number two is that we should start seeing OPD patients more and more. And once we put our cases on the OT table, definitely we should take help from our seniors, so that on the very first phase of our OT practices, we shouldn't mess it around and lose our confidence level. So right now also I'm sitting in my own setup, doing little bit of private practices on a Sunday afternoon. So I think once we complete our course, we are ready for the private practices, and every single day we learn. So we gradually learn and we increase the level of practices and the services that we provide. And right now we are also having this bond is another issue. We cannot just leave that bond and go for a fellowship. We feel kind of stuck in. So till that time, let's not sit idle. And I think we should continue our practices, basic practices, SICS and all, DCR, Teresium kind of surgeries.
Very important. Yes, Dr. Swapnish.
First of all, a very good afternoon and very nice to see Akshay, Rohit, Shraddha and everybody from all over India. To see a very short answer from my side. When your skill set is ready and you are mature to handle your economics, I think you are ready for private practice.
Absolutely wonderful points put by all the panelists. Yes, Dr. Martin, sir.
Last word on that, when you know your limitations.
Extremely important point. So now let's move on to our first talk. As I said, there's a slight order change. We'll have, the first talk by Dr. Akshay Nair on social media and the ophthalmologist. Before that, I would like to ask him, what is written on his T-shirt, and they explain the meaning of it.
So this is from a cult movie that all of us grew up watching. Andaz Apna Apna. That's Crime Master Gogo. His favorite line is "Aankhein nikal ke goti khelta hu." Only thing is that as an ophthalmologist and an oculoplastic surgeon, this is literally what I do. So, I mean, I wouldn't put this on if I were a cataract surgeon, but yeah. All right. So I'll just share my screen if you can see it. Yeah, my screen is visible, right?
Yes, please go ahead.
All right. All right. So basically, why do we need to have an online presence? Like we said earlier, in 10 years' time or even 5 years' time, everything that we do is going to be online, whether as it is for flights, hotels, everything we look for recommendations and reservations online. It's the old school technique of a doctor referring it to a specialist who refers to a specialist is dwindling down. Patients are going to directly look up doctors, look up their credentials, look up their reviews, and come to them directly. So it's important, it's imperative that we start having an online presence and an accessible portal at the earliest. Now, it goes hand in hand with private practice. And it's not just for patients, it's also for peers. So that when someone looks up, if someone needs to refer a patient to you, not everybody can pick up the phone and call you. So they can also be able to look it up online. Also, if you're online and on social media, you're posting things about yourself, it helps because you're creating awareness about a new excimer lens or a new femtolastic, an unusual case that you saw, a conference that you participated or got an achievement or an award in. Let people know about it. Although you need to, do it measured so that you don't overdo it, but you should definitely do it. Also, in terms of building a practice, being online on social media is also a good way to connect with peers, but that doesn't necessarily build your practice, but it's important. So once you've established and understood why you need to have an online presence, the next is to start off. The first thing and the most important thing is to have your own website, because this is one place where no one is going to post a review. No one is going to decide what photo goes on, what are the details that will be put up. It's your story in the way you want it, in your words, with no restrictions, no limits. And it's not for other doctors. It's I mean, maybe for referrals, but it's the most important way patients can connect to you. So you have to start off on your website. Luckily, oculoplastics for me is a very, very visual branch, so that works well. How do you do that? The first thing is to register your domain, whether that's your name or your center's name. Go to a hosting site like GoDaddy, Wix, MailChimp, buy the domain, and then slowly you can build content and build the site. You don't even need to have a professional web designer. Website designing now is like making a PowerPoint presentation. You drag and drop, change the font, add a picture, and you can, keep modifying it on the go. Roadblocks that I initially felt was an inertia. I bought my domain in 2014, but I eventually ended up making my website in 2017 or 18. So it's a technological block that we have in our mind. And if we think we cannot overcome it, then it's even worth hiring a web designer to make it. Because at the end of the day, having your own website and making patients reach to you through a website is going to pay for itself. What about Facebook? It's the necessary evil in our lives. I absolutely detest it, but I spend at least half an hour on each day on it. If you look at the average age of the Facebook user, it's about 40 years. So you can use it to your advantage. Remember that Facebook is not just amongst your friends who are already there. You can actually harness the use of Facebook to reach out to people who don't know you or don't know about you. So create a professional page apart from your personal page and don't mix them. You also want to stay away of constantly being on Facebook and self-promoting, or look, I went here, look, I went there, I got this award, that award. Don't make it an echo chamber that people just get, after some time they get bored of it and they don't want to see posts from you. Interact with people. Also, be a little cautious, because if you're posting a photograph of a patient or something, consent is important. If you're using to make Facebook into a professional, harness it professionally, then I would strongly recommend that don't talk about politics, don't talk about cricket or any other thing which could be controversial on Facebook, because unknown to us, a lot of patients or people whom we don't intend to look, whom we don't want to, read what we're posting, actually end up reading that. There are also guidelines about what you can post and what you can't post on Facebook. What about Instagram? Now, Instagram is obviously, we know what it is. It's the photo-based app. But the key things here is hashtags, how you tag things to it. Now, if you look up LASIK, you would see that half the posts on LASIK, which are tagged LASIK, have nothing to do about LASIK. And yet, these are the ones that are the most popular. These are the most topmost posts. Similarly, when you look at cataract, sure, half of them are of cataract, but a lot of them are not cataract. Because these doctors and these specialists have now realized that you need to up your social media game. It's not just about posting academic things and surgical things. You should also, this is a portal for patients to have a look into your practice, your personal life. What you did, what you ate for breakfast, where you went for a vacation. People like to see the human side of you, so you can also use that to post these things. It's a personal connect that patients have with you. Remember, compared to Facebook, the average age of the active Instagram user is 23. So you can be really popular as well. These are ophthalmologists, and like one is a triathlon, an Ironman athlete. The other used to be a model and now is a cornea specialist. 45,000 followers. So all of these things can, and it's you need to, if you use it well, patient generation can be very high. Also, thanks to Zuckerberg, now all platforms are integrated, because you can have a post on Facebook that also goes on to Instagram, and you can also have a post on Instagram that goes on to Facebook and Twitter at the same time. So you can merge platforms such that you amplify the reach of a post. What about YouTube? YouTube is surprisingly very useful. Now, what do you post on YouTube? You can post surgical videos, you can post examination videos, informational talks, talking to patients about, say, different types of lenses, what do you expect in a cataract surgery, how is your recovery of a cataract surgery. You can also have patients to give feedback about how their experience was during the treatment with you, so that they can, you can click a small video and put it on that, so patients who look for you may also stumble upon that and realize that, okay, there are patients who had a good time. The YouTube search algorithm is something that I've never understood, but keywords are important, just like hashtags are important for Instagram. As is the case with Instagram, and it is with YouTube. Posting one thing in 1 month will not help. It has to be high quality, it has to be relevant, and it has to be frequent. You have to be consistent in your efforts, Only then in the long term will these things show results. So when you post a surgical video, you've seen Dr. Pradeep Mohanta, who's a rock star in cataract surgery. It's not just for peers, it's for residents, it's for fellows, patients. The higher the quality of your video, the more views it gets, the more people see it, and the higher it will rank up in your search when people look for it. In your videos that you post, you may want to again integrate everything, link it back to your Facebook, to your website, to your Instagram, and it's also seen as validation. And it's the ultimate external audit, putting your surgical video out there, letting the world know, hey, this is how I operate, this is my before and after. Obviously, your results are there for everyone to see, and only a confident surgeon would be able to do that. So patients see it in that way, and can also, that can serve also. It can serve as a route for you to generate patients. Also, if your videos do well, you could also monetize it if you have enough subscribers and public hours of watching. But what would a patient think about seeing a YouTube video? It's important because that's the way they connect with the doctor. If you can do a hospital tour of your a video of your hospital tour, so that way the patient already knows the hospital before coming to you. You'll be surprised, patients are very tech savvy and they're not afraid of blood. A lot of my patients actually end up seeing surgical results, videos, and come back. This is a video that a message that a patient sent me. They saw a dermal filler video and said, I need to get a filler done. You're charging too much. I found this. I'm going to buy the filler and come. It's only 5,000 rupees. Just tell me the cost, how much it'll cost for you to fill it. It's like that patient telling the doctor, plastic surgery aapko nahi karna, main plastic lata hu, aap sirf surgery ka kaam bataiye. So you can have something unusual and weird here, but that's how patients are, and it can definitely help generating patient footfalls. My experience was, like I said, there was a lot of inertia from 4 years. I wrestled with the idea personally that I'm a doctor. Why should I market myself? But that is the reality of today. You can easily build it and do it yourself. For the past 5 years, 4 years, 5 years now, I've been on YouTube. I have almost 6,000 subscribers, and that for me serves to be my biggest referral base for patients. Your website should not just, thankfully, like I said, oculoplasty allows you to post before and after, and visually tangible results are seen. It should be customized to phones also. 80% of all people visiting a website do it on their smart devices. So your website should be customized to how it looks and feels on a mobile phone or an iPad also. Have accessibility so patients can write to you, seek appointments, or even get online consultations from you. I end up getting 20 to 30 queries a week that result in about 3 to 4 procedures a month. Instagram has shown a lot of promise because here it is you who is responding immediately, and it's a direct connect that you respond quickly with them. Patients have come, they send you videos, they can come and get operated. These are patients who had seen. So this is a patient who got in touch with me on Instagram after seeing a YouTube video and eventually got operated. So all of these platforms end up pushing at least 3-4 patients a month towards surgery. And these are organic searches that have come up themselves without having a PR officer or someone going out and reaching or paying for advertisements. YouTube videos, I have almost 40 videos and now 6,000 subscribers. It helps because this is the widest reach. In Facebook, whatever you post usually reaches within your friend circle. But in YouTube, you just post it, then it goes out there. Anybody who wants to search for what they are looking for will find it if you have it. So it is important to put the right keywords on YouTube. Of course, you get a lot of patients who frivolously come in and keep asking for appointments and things like that, but things may not materialize initially. But you have to fight through that period, and be regular in posting what you do for it to get traction. So to summarize, start early. If you're starting private practice, like we were discussing, when is the right time? Whenever you feel you're ready to start private practice, you need to have a social media presence, a website. It has to be a strong approach. You have to be consistent in posting what you do. And there will be an incubation period. You will see 5-6 months, maybe a year or two, where you're posting things, there is not enough interaction, not people seeing it, but your digital footprint in the internet is your place that eventually has to be there. The longer you're there, the more dividends it will play eventually later on. Three things that I always tell doctors not to talk about unless you're very clear on your website, unless you are doing it deliberately, is never discuss pricing on phone or on your website. Never give out prescriptions on the phone or email, and don't post pictures without consent. Paid promotion, I do not haven't yet done it, but whether it's ethical or not is something that each of us needs to decide and take a call on it. So I think that is it from me in terms of how to optimize social media presence online and how to market yourself in ophthalmology.
Thank you so much, Dr. Akshay, and excellent as always. One thing that I want to ask you, that you do not have a Google profile, right? You haven't listed yourself on Google. Am I correct?
I haven't. Yes, you're right.
So any specific reason for that?
Yeah, actually, like I said, I don't have a private practice of my own. I'm affiliated to 3 hospitals where I have fixed clinic days and fixed OT days. And when you look for me online, it eventually shows up the 3 hospitals where I'm affiliated, and each of those sites have their own Google page, which also is a very good talking point, because if you're starting your own private practice, your own center, it's extremely important to have a Google page, because that's the first thing that shows up when you search for someone. The stars, the number of reviews, the phone number, the website, everything is listed there. So you can do that. And for me, the second result that shows up when you look for me is my website. So I think that for me was the reason why I didn't put a Google page. But I think I should start one. What do you think?
But I got a question.
You should definitely do it, because
how do you manage, reviews, for example? Sometimes you end up with a lot of frivolous reviews, and that becomes a problem with a Google page. And there have been, doctors who've reached out in the past because they had problem with people putting either fake reviews or, PR agencies doing the damage on that. So that's one kind of side of the social media one has to be very careful of.
Yeah, actually, Swapnish is very tech savvy, and I think I would like to hear about him. How do you deal with possibility of negative reviews being posted?
I think he's not here.
Oh, okay.
Can I take that question?
Please.
Yes, please go ahead.
Yeah. So we had a patient in the clinic who had to wait for a little longer time than usual, and he immediately posted a bad review. So we acknowledge that by replying that we are sorry for the service, and we will make sure that our systems are in order. So, but it was a genuine patient who had a trouble, and who came back. Yeah, so he's still with us, and he brings his family also. So that was a little experience we had with Google bad reviews, but most of them have been good reviews.
So, I want to comment on that. I have a Google profile, and it actually generates a lot of traffic to your clinic. And what Digvay sir pointed out, yes, it is a double-edged sword, as sir has told. But these reviews are always editable, so you can reach out to the patient. I've seen people, talking to the patient and asking them to change their reviews, and it also helps in keeping your staff and yourself on your toes. Because when you are worried about these reviews, everybody is at their best behavior. And Dr. Akshay, your point, like if anybody is specifically searching for you, then of course your website will come on the top. But if somebody is searching for the best oculoplasty surgeon in Mumbai, then probably it won't. So that is where it helps. And if you have good, genuine reviews, your profile develops, and it slowly lands up in the top 3 or 4. And a lot of people do pay for these services. So anybody has experience for these Google AdSense and paid.
So that was my question actually. How would you go about doing, search engine optimization, or would you do it or not?
Search engine optimization would be different, I feel. I think Dr. Akshay can tell us about that. My question was more about paying for these Google ads, having a Google AdSense account and paying. Then automatically your name comes at the top whenever those keywords are looked for.
Yeah, especially for investment heavy procedures that have a good a payout. Like say the most of course the most common is refractive surgery. So you look for one word, say contura or something, and there are only a fixed few results that show up. So one way is to make sure that every time someone in a particular, so when you do SEO, you can do it keyword, you can do it geography wise, wherein you basically buy an ad slot that links to a keyword. Now, if someone looks for LASIK in Bombay, my result should show up as the first one, and it will show up as a genuine search result, except that there'll be written a word written on top saying ad sponsor. So if it works for you, it works for you. At the end of the day, if you're putting ourselves out as a service, and if we are allowing patients to review ourselves as if we're offering a service, then I think it's only fair that we also use that same place, same marketplace to advertise ourselves as a service. If it works for you, by all means do it. Like I said, ethics are something personally you need to be comfortable with doing. And if it works for you, you can do that. The only thing is that, it can skew a lot. When you do Google's word search, you also end up, a lot of unintended, like say, for example, if I search Google, you need to be very specific about which search result should show up your name. You don't want traffic from Delhi or Guwahati coming your way if you're based in Bombay. So you need to optimize it geographically, very important.
See, also from the ethical standpoint, as far as the medical council and our regulations are concerned, a doctor is not allowed to advertise officially. I mean, legally, except you can advertise a new service, a new center, a new technology. So therefore, to have an advert which says best oculoplasty surgeon in Mumbai, that advert is a wrong advert to have. But if you want to have an advert which is saying Contura LASIK available at this place, is an advert you can use. So, you also need to see what is the word that you want to use. So you cannot market yourself, but you can market a technology, you can market your center, or you can market a new opening or some kind of so there is a limit, there is a kind of a limitation on that.
Taking that forward, so suppose my question would be to Dr. Nair and the panelists, all of them, like if you would want to have a YouTube page. So suppose you're having a YouTube page, would you rather have it in one surgeon's name, or would you have it in the hospital's name? Now you just started a hospital, for example. So what would be the preferred way, and what would in that scenario?
So I think, see, like I said, when you put up a YouTube channel, you need to be sure of what is it that you're doing. Are you going to put educational videos? Are you putting surgical videos? Whom is it targeted at? Is it targeted as at residents, at trainees, or colleagues, or patients? And accordingly, if you're going to tune it to put surgical videos out there for people for patients to see what happens, and if you're going to put educational things on it such that you create awareness, like I mentioned, about small talks on types of IOS or how your recovery is after surgery, I would think that projecting yourself is more important. So you can definitely put yourself, but I think that's splitting hairs. Whether if it's your own hospital, whether you project yourself or the hospital, it's the same thing, because eventually the goal is the same, to direct traffic and footfalls towards your practice. So I'm not so sure about that, but a lot of institutes have a clear policy on what you can and cannot post on social media. So if you're in a large hospital or an institute, you need to tread carefully, get permission, and then do it.
So, taking the last,
I think the smart thing would be to do both of them. Have your hospital account and a personal account. You will see a lot of YouTubers having multiple channels, and it will not affect. A lot of us think that the views on one specific channel will go down, but it doesn't. I think it doesn't affect that much. So you can have both a hospital account and your own personal account. So hospital will be more focused on infrastructure and all those things, and you can concentrate more on your surgeries. And
so taking this last question now on this, and then before we move on to the next talk, is would this social media accounts be the same for tier 1 versus tier 2 versus tier 3 cities, or would you change your approach?
Yeah, I would like to answer that.
Just go ahead, Ankit.
I'm working right now in a tier 2 city and Allahabad, UP. So what I have noticed that social media reach is almost same everywhere. Even almost every person has a mobile. Every person using Facebook and YouTube and Google and all. So what we try to when we put something on Facebook or YouTube here, what we try to tell them that the facilities which we are offering are almost exactly the same as what you would get in a tier 1 city like Delhi or Mumbai, and we are in no way inferior to them in terms of service or the results which we give. While when giving in when the social media accounts I see in Mumbai and Delhi, what the doctors there put on the Facebook and YouTube, they are giving then the options of uh, world class services, better machines, and the infrastructure is more focused upon, like we are providing a sober infrastructure. Here in tier 2, we are more focused upon the outcome and the cost based advertising.
Thank you.
Dr. Karan, irrespective of the geographic scenario, I think the top two resources would be Google and YouTube. So most of my patients who come from interiors, they also who come through the internet or through Google, they have either looked up on me on YouTube or Google. So recently I was operating on a 12-year-old child, and I just asked him, how did you land up? He was from almost 200, 300 kilometers away. So that 12-year-old child told me that I Googled strong retina doctor and your name came up. That's why I've come to you. So, it's the penetration of these things are really, very extensive, and people are searching a lot and they trust these things. So concentrate on those two things.
Okay, thank you for the comments. Let's move on to the next talk. So I would request Dr. Madan. Sir will be talking about being the boss, starting your practice with.
Slides visible.
And if we have time, we can discuss about these aggregator apps, Practor and all these, if we have time at the end.
Yes, definitely. Yes, sir, your slides are visible.
Right. Good afternoon, everyone, and thanks, Karan. Thanks, Dr. Devakant, for having me here. Thanks to YOSI. So I'll be talking about how you equip yourself to be your boss. So at the outset, let me just state that I'm in no way trying to say that owning your practice is the best way to do it. There are other avenues we've been seeing from the morning. Each one has its own benefits. So this is not aimed at influencing people to make a career choice, but rather to provide an outlook for someone who's already made a career choice. So why own your practice, or in other words, why your own practice? Now, there are certain obvious advantages, as has been discussed, but beyond the obvious, one can recognize and nurture productivity, creativity, and innovation in many people around ourselves. You can provide someone with an opportunity, and that's one of the best things that we can do for our fellow men. We can push the economy, develop the local community. We can serve as an agent for social change, integrating marginalized people, and contributing to regional progress. These are all things that we can help with. And the earlier we start to equip ourselves, the better it is. So we need to see things from a different perspective. We cannot see what we're not looking for. So I would say one needs to start very early, actually from our residency days itself. Think you're the boss of the place. As someone has just pointed out, take responsibility, take ownership. In your mind, think that you're in your own clinic or hospital and you have a patient walking in. What all will be needed? Every object and person in the premises in your institute that you're currently studying in is there to serve a particular purpose. So where are they placed in your institute? What are their roles? Could they be placed or oriented a little better to serve the same purpose? So keep thinking where, why, when, how of every event, however small it may be, is very, very important. Next, after your training in an institute, try to visit, or better still, work in a few places that match the scale of practice that you envision for yourself. This will give you real world experience. How do they go about doing the same things that you were used to in your large institute? How do they manage their costs? How do people multitask? There's a lot to learn from these places. Replicating something directly from an institute into a nascent practice is really difficult. Now, if you're used to only the top end equipment at your Apex Institute, you will have to get the same to be comfortable in your practice, and that costs a lot. So in your training, try different machines and instruments. Seek out the most average machines and be comfortable with them. Be it a slit lamp, a microscope, a phaco machine, whatever. Operate or handle those machines, know them inside out. Understand the value that something offers for its price. Try operating or working without a skilled assistant. I tell this to all my fellows. Try getting the OT ready, laying out the table, operating on your own. I say this as a VR surgeon. Trust me, many a times outside you'll be doing this only in your own practice. Now, besides the science, ophthalmology involves a lot of machines. So learn the technicals. And for that, spend time with all your technicians and staff, network with them. They know much more than we do. Not about what drug to prescribe or what surgery to do. They know how to get a job done. Which machines are workhorses? Which machines are going to keep giving you trouble a lot? How to quickly fix something? Or whom should be your first contact when something goes wrong? Even today, if I want to buy the smallest equipment for my OP or OT, I call the technicians from the institutes that I worked, and they give me the best possible advice into longevity and running costs. You need to know everything that keeps the show running. For example, what happens if you're operating and the power goes off? You have a case on the table. First, the UPS comes on, and what's the capacity of the UPS? Is that in a 5 amp or a 10 amp socket? How many sockets are there in your OT? How high are they from the ground? Next, the genset. Again, who switches that on? Is that person around when you're operating? If he's not around, can somebody else do it? If that somebody else is also not there, can you do it yourself? The point is, you should enjoy all this. It should not be a chore. Now, about 20 years ago, before my dad taught me how to ride a bike, he taught me how I should remove and fix a tire. That's very important. Now, in planning and running your own center, I wouldn't be wrong if I say that science comes second. Man management skills come first. Identify your team for their aptitude and then train them for skill. Allow people to take decisions and find solutions by themselves. Do not micromanage everything. In this process, be prepared to lose a few. Be prepared to unlearn and relearn. Be prepared to adapt and change. That is what will help in growth. Now, if you expect to work lesser and have more free time, then honestly, this is not how it works when you're the boss. In business terms, you actually work more. The drive is that you're owning something, and the difference is that you're creating something. You are the last in the comfort chain. You're the first to step in case there's an adversity. In the pecking order, the organization always comes first. The needs and values of the organization are paramount and can't be compromised at all. The employee comes next. Take care of your employees, they'll take care of your patients. Individual preferences of the owner comes last. Now, learn the language of money, very important. As physicians, we are not aware of the direct and indirect economic impact of our actions. And that is why now you see a whole lot of other people coming in and dictating terms to us doctors. Take it upon yourself to do a cost analysis. X is the amount charged for a particular procedure or surgery. Y is the expense to the organization. X minus Y is what remains. Often X is predetermined by the market. Y has many variables that you can work around with, and you will have to optimize Y to provide your running capital. Now, get to know interest rates, types of loans. Are you eligible? Do you need collateral? How do you keep your CIBIL score decent? Now, what are your other sources if you're going to start out? Speak to your family about finances and options that you have. Have an open talk. Often you'll be surprised to know what you have or what you don't have. And all this has to be done a good year or two before you even think about starting out on your own. Now, what sets a leader apart is the ability to anticipate. Always stay 2 steps ahead of the current situation, be it clinical or non-clinical. Now, suppose I have a surgical case, I anticipate this problem, so I have all these instruments ready. So similarly, you anticipate and prepare yourself for many things in the management aspect as well, so that you're not caught surprised when something, an ordinary day spins out of the ordinary. When starting a practice, patients don't walk in simply because I finished my MS, I've got so many fancy degrees, I have 20 papers, I speak in conferences, I'm sitting in my own property. All this doesn't matter. The ball game is completely different, and I'd like to think that these are very important: accessibility, availability, affordability, and finally appropriate care, in that particular order. So we tend to assume that what we do is very exclusive and that I have a unique skill. In all honesty, just sit back and think what treatment I can offer, anyone can offer. No one is doing anything that is drastically different, save a few people. It's not like 2-3 decades ago where doing phaco was a unique thing and people used to travel long distance for that. So how do I make myself relevant? Accessibility and availability are most crucial, more so for a startup. That brings us to the next point, market analysis. I can't stress this enough. Geographical location. We saw that from the patient's perspective, not from our perspective. Where do I have the chance of being available and most easily accessible to people who need me? Where does my skill set and expertise match the needs of the community? Now, this is called product market fit. I have something to sell. Where is it not available? It's not about my interests. As I said, that comes last. It's less about what I like. It's more about what value I bring to the table. When we look around now, we see that doctors are moving to smaller towns because that's where the need is. That's where we can create a difference. A common mistake that we make at the beginning is to start at a location simply because we own a plot of land there and we can save on the rentals. I know many doctors who have not done great in their initial private practice. They studied the market, moved to a new location, and then were able to provide value. In the end, we are in the business of dealing with people. People don't buy our science or degrees. The patient is not interested. He's least bothered about what I know. He's interested in what I can do for him. So people buy from people. Can I alleviate his suffering? Now that's a world of a difference. How genuine am I? Does the person sitting across the table from me feel that I'm genuinely interested in helping him? That's all that matters. The best way to do that is to listen. The needs and perspectives, the language of population in your locality will be unique. One needs to be aware of that and be always in sync with that. Know the pulse of your clientele. Have a ear to the ground always. Think global, act local. We have to understand people. Now, from what they say, it's easy to deduce what they want. And from what they want, I know their circumstances and beliefs. I can relate better and provide relevant solutions. It has to be holistic. That's all most of our patients want. Now, when we're able to do that, we connect with people around us. Slowly but surely, word gets around. And when your basic needs are fulfilled, one can get back to science in academia. Now, that's the icing on a well-baked cake as far as private practice is concerned. Time is the real currency, friends, not money. So being your boss allows you to control your most valuable asset. Being a boss teaches you many things and gives you the confidence. So that can be carried forward and you can diversify into other fields as well. Management principles are almost always the same in any field that requires person-to-person interaction. I can give you the example. My wife, she's an ophthalmologist. She's taken her passion to the next level. She owns her own entrepreneurial venture. She runs her own skincare products. I'm sure most of you would know doctors who are following other passions, and they've diversified into other fields. They have time to do it. Most importantly, they also have the confidence that was born out of the struggle and learning and running and owning your own setup. Now, I like to conclude. I like this one sentence from these masters of Tamil music. What it says is, Pudu Ragam Padaipadale Nanum Irevane. A loose translation would be, if someone who creates is God, then I'm God. Well, that's extreme. But I would say when you create something, you have the ability to provide livelihood. As I mentioned at the beginning of my talk, you have the ability to be known for the values you inculcated and the values you stood for. You have the ability to create an impact. It may be on a small scale, but then you have the power to change and make an actual difference. The most reliable way to predict the future is to create it. Welcome to the world of entrepreneurship. Thank you all for patient audience.
Excellent talk, sir. It was really mesmerizing. Any comments by the panel?
I think it's a wonderful talk, and it's always a scary prospect for somebody to move from an employee to an employer situation. But if you are if you are due diligent with your homework, if you've looked at things and parameters, I suppose it's something that all of us can actually achieve. It's not just about somebody who has the finances to do it or to go getting, but I think that is something that's probably is something that you can easily arrange as long as you have the other parameters in place, I think. So that's what this talk is so nicely shown, that do your homework before you get into it, and once you're into it, you'll be successful if your homework was done well.
So can I chip in, Dr. Bhatia? Yeah. So I think a lot of residents and fellows would be watching this, and a lot of them would be students who do not have a ophthalmology background in their family. Now, it's for people who have an ophthalmology background, it kind of becomes, like a logical thing to get into it. But for those who don't, there would be a certain thought process into why you should take up ophthalmology, and in ophthalmology, why take up private practice. So one of the important things to consider is that ophthalmology does not as in a general off-thal setup, does not require you to admit patients at night. So you can actually run a daycare center, and that's little easier to do than, you know, actually having a 24-hour setup, because the cost of staff and the other things reduces drastically. The other thing is that in some places, because it's a daycare center, a nursing home, registration again may not be required, or you can get away with it. So again, you know, from the investment aspect, the paperwork that you have to do may reduce. Also, it will be an investment heavy branch, because you will have to start off with a phaco machine or operating microscope. But something like, say, pediatrics, you can just start with a table, a chair, and a stethoscope and do your pediatric practice. So in that way, you need to figure out whether you can put in that much investment into starting your private practice. But at the end of the day, considering other branches, say cardiology or other branches, you can be your own boss. You can set up your private practice. You know, your small setup, maybe a single practitioner setup, but especially for people who don't have an ophthal background, it is not something which is not doable. It is doable for you if you're scared about getting into it. Just figure out the finances for, you know, the staff and the equipment and all those things, and you can get into it. And the rewards are very good. And I don't want to shy away from saying that the rewards are good. At the end of the day, you need to run your family, you need to earn. So the rewards are good.
Sir, can I say a few words on this note? There is always one aspect that comes to the beginners when we think about starting maybe a daycare setup or maybe an OT setup later on, about the loans. The bank, you know, just come and just, you know, attack you from all the sides that I'll provide you loan, I'll provide you that loan. So any enlightenment on this, that whether we should go for the loans at an early stage, or we should think that whether we have a stable you know, income or not. So when actually to take the loans, or if at all, is it necessary to take the bank loans, or we should grow on our own selves? So can you please enlighten us on this?
So if you have some kind of you know, support from your family, that's very good. And if they can spare a few lakhs, that would be a good place to start. But of course, we understand that most of us don't have that luxury. So there's no harm in taking a loan, as I'm sure Dr. Rohit Modi will enlighten us later on. There are refurbished machines also available, and they also do a very good job. You can get loans, and it's important. Usually what I do is I pit the bank agents against each other. I ask them to come on the same day. I ask them to sit down. I ask them, what is your offer and what's your offer? So in all honesty, I've taken a loan recently on 8.5% interest. And I think that's a good deal. Don't go for personal loans, go for doctor's loans, and you do get good deals if you pit them against each other.
Thank you, sir. Thank you, sir.
Devakant, are you there? There are a lot of questions that we have. We move on to the next talk first, and we'll wrap up all the talks, and then we'll take up all. Yeah.
Yeah, I was saying that we should finish the talks and then
yes. That's exactly what I was
sequential manner, all the points.
Yes. So the next talk is by Dr. Swapnesh Sawant. I would request you to please share your screen. He's talking on maintaining ophthalmic assets.
Can you hear me?
Yes, we can hear you. We can see your screen, but you'll have to enter into slideshow mode. Yeah, perfect. Please go ahead.
So thank you, Devakant and Karan, for inviting me, and all the YOSI coordinators, and a lot of these questions which have been asked by, again, Dr. Tanveer also. I would be happy to answer them through my presentation. First of all, it's a big task to follow the presentation after Madan Gopal, because he was so brilliant at doing it. So this is my bit. Again, as I always stress, skill set is very, very important. You need to be sure when to start, and you need to be sure of your skill set. The second area that you need to be very sure is how much investment you have and what is your risk taking capacity, how much is your family backup, and what is your realistic plan of going forward. Area of practice again depends on which city you are starting off. Like something like in a Bombay, you need to start with a bank probably if your skill set and investment can afford that, or you need to go to the suburbs of the Bombay and then slowly build up your practice and probably open newer centers. So that where you want to start off depends on your affordability also and the skill set also. Type of practice, you may start singly on your own, or you may have like-minded young ophthalmologists coming together for a private practice, but in a group. Like you may be there with your wife, and there might be 2-3 people of different subspecialties coming together and then starting, but a private sector. Again, then it is an issue whether you are able to do multiple things. Like I am a VR surgeon, but I also do my anterior segment surgeries fully. But for LASIK and pediatric, there are people who are coming on appointment basis and they are seeing my patients. So do you want to venture into a multi-speciality as a center, or you want to stick to only VR or cataract? So that you need to figure out. So the answer to Tanvir's question that when to take the loan is actually you should prepare a project report. And how to prepare a project report, any CA friend or your whoever is your chartered accountant will be able to tell you that, and share it with the investors. It could be your parents, it could be your in-laws, it could be the bankers, your seniors, and then see the feasibility of that. Because you will not be very perfect in charting out your financial plan, but at least preparing a project report will help you to think about various aspects, which I'll put forward in the next few slides. So the main decision is whether to have a ownership or to go in for a rental. Pros and cons of both. Rental will not be a lifetime asset, and the person who is renting you out may just throw a fit like in COVID times and continue to ask for rents even when you are not practicing. So my choice would be always to go in for ownership, even if it is a smaller place. But in that, you need to know what EMI you are comfortable with and what are the maintenance costs for that property. And in a city like Bombay, how much property tax annually are you going to draw on that? If it is a family inherited property, then it makes easier sense in that case that you already have it pre-owned. Then you just need to see the maintenance and the property tax about it. Then the main investment, according to me, though I am a VR surgeon, would be that anterior segment is a bread and butter. So you need to have in the priority list your expenses on the phaco or the anterior segment, then the VR segment if you are skilled or whichever is your subspecialty, the rest of the OT equipment and the diagnostic equipment, because we are good clinicians and we should be good clinicians, that we should not depend upon a OCT to diagnose a macular hole. So that we can probably plan out a better OCT in the 3rd or the 4th year. But OT setup has to be top-notch to the best that you can afford, because that is going to give you results. Also, you need to look at the expenses in the CSSD, the OT complex, whether you want to go for a modular OT or you're happy with a split AC, anesthesia trolley and the anesthesia setup, especially if you are looking at doing ROP cases or pediatric squint cases or GA cases in oculoplasty. Small things like dehumidifiers, emergency tray, emergency trolley. And if you're really going into a refractive setup, whether you want to go in for a first-hand machine or a second-hand machine, along with whether you want the imaging techniques, which is the best, like Pentacam, or you are happy with just a simple anterior float giving topography. So that you need to figure out, and you need to make a short list of all these things. Taking a loan with your degree and having a decent family backup should not be a problem, but you need to ask for the payout structure before you enter into a loan. That what is your payout like? And not many of us know about the taxation systems. So just in brief, when you are taking a loan, suppose you have taken a 1 crore loan, and it is over a period of 10 years. The first 5 years, you are going to pay the interest to the bank, and your principal amount which is deducted will be much lesser. And so because the interest is counted, or you can take benefit in the income tax, in the first 5 years, that interest is going to help you in reducing your taxation. But after 5 years or 6 years, once your more and more principal amount starts going and the interest ratio starts coming down, you will find that though you are, and after 5 years you are doing good in your practice, though you're earning more, but you're not saving much, because what you pay as a principal is not counted as an expense. It is counted as an asset development fees. So that is taxable, and the interest portion is less, so you get lesser and lesser benefit on the taxation. So though you are earning more, you are saving lesser in proportion. So the framework of the loan has to be understood by the doctor who is taking it. Again, our local things like IOL bundling, you should be beware of the target, because it sounds like very promising that I'm committed to Apaswami, or I am committed to AM or Alcon or Zeiss or whoever. But are you realistically going to have that many patients? Because their bundling is going to be 6 times the amount. So if you're buying, say, Autoref from a company, which is worth 3 lakh, they are going to expect almost 15 to 18 lakhs of business through IOLs in that particular year. They may extend it to 2 years, but you need to be clear about that target. Also, you can ask the companies to have a deferred payment option. Do an R&D of the equipment performance, and also beforehand, before committing to buying the instrument, take the CMC and the AMC rates from them. Also, you need to know what is the exact expense of the air handling unit of the OT systems that are going to be in place. The elevator system, if you have 1 or 2 floored hospital that you're planning, or the maintenance of the elevator in your premises, the DG set, the RO plant, the water cooler, and the medical gas piping, because as a VR surgeon, I need the nitrogen coming to my Constellation machine, and obviously I need the O2 piping also. So whether it is wise, if I am practicing on the 3rd floor, to do the piping, or to have smaller chambers coming to the OT through a robust elevator and getting it closer so that the piping is lesser. So all these things you need to work out. UPS is one very important thing. Only tip I can give is keep separate UPS for the OT complex, separate UPS for your LASIK machine, and separate for your diagnostic, and a separate UPS for the rest of the hospital. So don't combine all the KVs together and just have one unit or one DG set, because at least in Bombay we don't have power cuts, but most of other tier 2 cities would be having that. So having a good UPS will help in maintaining those machines. Fire is an important issue, so you need to invest now only in a fire extinguisher system with a hose pipe and an electrical panel alarm system, the sprinkler system if it allows, and the wood work which is there, especially of the main doors, has to be fire resistant, because at least in all the major cities, having the fire NOC is very important, without which you can't get the nursing home registration. So, and the law is going to now spread to even the tier 2 and the tier 3 cities. As Akshay mentioned, having a social media presence is very important, and that starts from having a digital backup of all that you do, which starts with the EMR system. So number of PCs, the server that you want, the intercom system, because if you're going for an NABH accreditation, you would need a central speaker system which needs to be installed. Also, many hospitals like to play a silent music which soothes the atmosphere in the hospital. A TV display system for the patient information and promotional videos, and the website expenses have to be taken into care. These are the annual expenses which usually we don't think about, like pest control has to be done 4 times a year, water tank cleaning at least twice a year, staff salary, beware of the overstaffing. And in COVID, we have seen even bigger institutes shed off their staff. Diwali bonus, like in Mumbai, it is almost the entire 1 month salary is given as a Diwali bonus. Staff insurance, if you have a larger staff. corpus for property maintenance has to be developed from year one, because down the line 10 years you are going to paint it again, you are going to have some amount of rain damage and wear and tear of your property as such. The signages, if you're living in a main city, then if you're putting up a large LED, there would be some tax which the local municipal corporation would be coming and asking you to pay. Stationery, housekeeping, security guards, and laundry also have to be taken into account. And as you grow, these expenses are also going to grow with your sale. Networking within the eye surgeons and within the doctor community is important, because what you do has to be shown to the public and your peers. Online forums, there is a cost which is associated with that. Having a brand building is very important via your digital presence, but that too has a time as well as an expense attached to it. A PR staff, again, that it's a personal choice whether to put up the advertorials in the newspapers, but if it is ethical, if you have done some rare case, and you can promote it, as far as it's not very in the face. And many of our hospital chains under the brand of a private limited company are doing the marketing, and there would be opinions on this, whether MCI should just not lay down rules for individual practitioners and not for a private limited company to market the medical fraternity, to advertise about the medical fraternity and their work. The licenses are important licenses like Form B. Just to take this license, even if you have fire safety norms in place, it costs about 60,000 per 6 months, at least in Bombay. So these things are small, but then they slowly build up almost to about 2.5 lakh per month of a maintenance cost if you divide everything as an annual fee versus a monthly fee. A pollution board control certificate is very mandatory now in Mumbai, so look out whether it is mandatory to maintain it. And though it attracts about a 2,000 to 5,000 fee per month to give your wastage to a proper assigned agency, that's still an expense, and you need to chalk it out in your plan. Nursing home registration, again, very important. If you're choosing a new place, have a separate entry into it, and decide about the number of beds that you're going to show, because though it's a daycare center, yes, agreed, but a lot of CGHS or ONGC or MTNL or BSNL affiliations are still harping about how many beds you have. They don't understand that we are a daycare center, and there is no separate norm as of now for ophthal, that even if you don't have beds, it's okay. So at least you should have some space, so that when they come for inspections, you show that these are our beds and wards, and it could be your waiting area, which is converted to beds in the afternoon time when the patients come in. So you need to take that into account, because those are, suppose you want to have an affiliation with Air India, you want to have an affiliation with ONGC, or whichever is your local government body, those people are still stuck into having an inspection, and they would find that if there are no beds and no admission facilities, they would not rate you very highly. OC certificate, now this is medical legally also very important, that wherever you're buying the premise, you have a proper OC certificate and a change of username to that. License for the working of the lift. Your lift should be ideally a stretcher lift if you're planning your own place. And if you find a stretcher lift in your place where you're hiring a floor or buying a floor, it is very good for the future licenses. If you're owning a B-scan, then you need to have a PCPNDT registration, and you need to give a report every month. Weird as it may sound that we are not doing sonographies for pregnant ladies, but still this paperwork has to be there. And indemnity certificate is best bought through the local medical council, Association of Medical Council, because they will help you with the best rates. Also, they have their panel lawyers with them in case of any problem that arises. So indemnity separately for individuals, separately for the hospital, not a combined indemnity is what is recommended. The person who is doing your electrical fittings, you need to take the installation report on day one and do electrical audits every year. That is a very important thing. Have an MOU with the ambulance, with the lab, with the blood bank, with the catering, with the laundry, that you are going to hire facility if in future you are looking at expanding and also getting the JCI and the NABH accreditation. Have the numbers for the water supply and the medical gases emergency in the emergency situations. And it's good to have a pharmacy shop or an optical shop, either pre-owned or outsourced, because that adds to a bit of revenue. And also you need to have MOUs with the LASIK center that you are going to take your patients. So these are all important from the accreditation point of view also, but in general also it helps to smoothen the processes, and your staff is more well aware about where to refer and where to call up in case of emergency, and you will not be bothered about these small emergency if there is a need. So about the NABH, it's a whole task in itself. My center was the first among the first top 5 centers in Maharashtra to be fully accredited with NABH. But myself am not renewing it because of the cost that is associated with it. And in Bombay, if you know, BOA is not doing any cashless treatment. So that benefit is not really passed on to us, because the cost difference between the NABH and the non-NABH centers is about 15%. And unless you have a turnover of about above a crore or a crore and a half, it doesn't justify, even if you are doing cashless, and we are not doing cashless. So you need to weigh the volume of your practice and then go in for these accreditations, because they will come with a cost. And not that it is not useful, it definitely helps to put in a staff discipline and a good atmosphere to work in, and all the checklists are maintained. But whether to continue with it, with the newer and newer agencies coming and charging for each and everything, asking you to buy an AMC and CMC for practically each and every equipment, and asking you to do infrastructural changes, it's a personal call whether to take it or not. Other expenses, we are humans also, not just ophthalmologists. So there would be personal expenses, education expenses, home, car loans. You have a dependent family of your own, your in-laws, and you would also like to invest in something other than ophthalmology. So you need to make space for all this and think about it, not just go on investing blindly in ophthalmology, because success is not final, neither the failure is. It is the courage to continue that counts. So don't be afraid to jump into it, but calculate your risks as we do in all our surgeries. I would end up by saying that you are also very important than your profession. We tend to overvalue ourselves and rate ourselves too high, that we are gods or we are doing some great surgeries. I am doing an island feeling, I can conquer the world. But the neighbor is also doing an equally good job. So don't undervalue your skills, undersell your skills. At the same time, don't overvalue your own profession. Your family is also there, and live a life beyond ophthalmology. Be thankful that somebody is ready to get operated from a 30-year-old, 38-year-old, or a 40-year-old. Like, suppose you have a fracture, you would definitely try and go to somebody who is more experienced. That would be the knee reaction. And be ethical in charging your patient, but not so dumb as to undersell your skills. Be kind to the needy also. It's a great journey. So venture into it, and it's a very, very fruitful experience. And as Shraddha said, it's definitely rewarding. Private practice is definitely rewarding if you plan it out and you stick your guns out. The skill set is very, very important for your private practice. Thank you so much.
Excellent talk, Dr. Swapnesh. We'll move ahead to the next talk for now and then take up the discussion later. The next talk is by Dr. Rohit Modi, who will be speaking on refurbished equipments.
Am I audible, Dr. Karan?
Yes, you are, and your screen is visible as well.
Yeah, thanks, Dr. Karan. Thanks, Dr. Divyakant and the whole YOSI team for this opportunity. So we are going to discuss about refurbished equipments, whether to invest in that or not. And after the first three talks, what we have understood, heard, we realize the importance of financial planning before starting our practice. And that's where these refurbished equipments come into picture. So, why to think about refurbish? It's about, money. A rupee saved is a rupee earned. That's very, very important concept, which I have learned over a period of few years. Now, most of the stuff we get refurbished is at least at 50% discount. Many a times it can be at even 70% discount. And the return on investment concept is something which is very important to understand. And this is one of my uncles who told me this, that any equipment you buy, the thumb rule needs to be at least be 4 years. Within the 4 years, the machine needs to earn on its own. Like if you're buying a OCT, the number of scans needs to return the investment on OCT. And that's where the return on investment concept comes. The thumb rule is of 4 years, or you can apply the Marwadi Funda, that there is 1% depreciation of any machine you buy, and 1% is the interest on the capital you have invested. So let's say a machine is worth 20 lakh rupees. So 1% depreciation would mean 20,000 per month, plus additional 1% interest is what you pay, on the capital you have invested. That will be 2% a month. And hence, at least 2% investment per month should be taken as return on investment, which means in 4 years, the return would be 96%, which is as good as rule of thumb. So, if you do a basic calculation, if a OCT machine is costing you 20 lakhs, the return on investment needs to be 40K. And per patient scan cost is 2K. So the first 20 patients scan is only for the return on investment. And mind you, I'm not taking into consideration the AMC you pay for the machine. That's additional. So that way you will be able to understand whether to invest in a machine or to collaborate with someone who has already the machine. Now, if you buy a refurbished equipment, this calculation comes down to half. And the amount saved would mean less amount of loan required, less interest and EMI, and less amount of stress. I read, in one of the bestsellers, do investments which make you sleep peacefully at night. And this is what refurbished equipments can do for you. And you get more money for investment. And if you start investing early, it could mean a huge difference when you're retiring. The net worth can be twice if you're even 10 years late. Now, which are the equipments which you can think of easily getting the refurbished ones? I believe the OPD setup, which is there, and the microscope, because these equipments require least amount of care. And the total equipment cost for OPD and plus the microscope could be, if you buy a new one, could be 23 to 24 lakhs, which can cut down by at least 40 to 50%. And OPD chair and slit lamp again wouldn't require much maintenance. Autoref K, they run for years well, and microscope well maintained. And independent service engineers are at least available easily in the metros, which can actually assess the status of that refurbished equipment which is available. Obviously, you can compare the features with the latest version, and you can plan a few months in advance, because sometimes that particular machine may not be available immediately. And if you plan in advance, you can get better offers. And sometimes good deals can be available at odd times. So one of the things we need to check is if any major parts have been replaced, number of years of usage, and will the original company give service if it is bought from a third party? Because sometimes the current dealers may not be interested in giving service even if you pay for a refurbished equipment. And some of the machines can be outdated in the sense, like Alcon has stopped giving service for certain machines. So for certain machines, it may give service only for next 3 to 4 years. So you know that if you're buying a machine at a particular cost, you may not be able to use it after a X number of years. Obviously, the tricky decision comes when you're looking at your operative setup in terms of phaco or vitrectomy machine or an excimer laser. And in these things, well, we have to, basically balance out with the kind of investment we have and what is the cost of a new brand machine. Basic knowledge of machine functioning is absolutely necessary before buying a refurbished one, and what kind of warranty is available. Sometimes the same companies do sell their own refurbished machines with good amount of warranty, and there is some risk taking required in this. So a little bit of courage is required. Now, this was one of the offers which was circulated in one of the refractive groups, where they were, giving a excimer laser for as less as 75 lakhs, and they were giving some warranty with it also. In fact, they have multiple offers where you could actually deposit some interest-free deposit, and then you can pay per patient basis also to them. Now, I believe the green laser as a retina practitioner needs to buy a new one, especially if you're buying the Indian one. They are quite cost effective because the laser cavity depletion and the fiber optic cable status cannot be ascertained. Servicing can be expensive, and refurbs are sometimes more expensive than the locally made. So the imported refurbs are more expensive. Again, OCT, one of the companies I had just contacted for the sake of presentation, they said for OCT, we only give 3 months of warranty, and that is too short a period. And replacement, even for OCT, if you are saving something like 5 to 10 lakhs, one replacement of part can, be as expensive as 3 to 4 lakhs. So your whole purpose is not achieved. And companies can in fact give a 3 or 4 year warranty, and if you have a good running institute, you can even think of IL bundling. Obviously take it carefully, and don't be penny wise and pound foolish. Sometimes the decisions can backfire, hence a background knowledge about machine functioning is absolutely required. Maintenance issues sometimes can be faced, hence take in confidence the local service provider. And sometimes some of the people who are dealing with these machines, they ask cash, hence taxation benefits cannot be availed. This is one of the companies which deals in refurb equipments. I do not have any financial interest in it. Thank you.
Excellent talk, Dr. Rohit. This really puts some insight into, particularly regarding the refurbished equipments. We have been joined by Dr. Namrata, ma'am. Would you like to give any comments, ma'am?
I think it was a very nice presentation. I could almost identify, with the people who started private practice during our times, and I went into academics, but the people, my friends who started, I think started like this only, by taking refurbished machines, by taking refurbished items, etc. So I could, kind of correlate with that. So I think very useful talk for all the people who are wanting to start practice.
Thank you, ma'am. Digvijay sir, any comments?
So welcome, Dr. Namrata, ma'am. So we've been having a great session since morning, and I think you've come from a cricket match. So I'm sure you've had a good time too at the RPC day. But thanks for joining in.
Just 1 second, ma'am. I think your camera is a little bit smudged. You'll have to wipe it up with a cloth or something.
Okay, I'll do that.
Yes, sir.
Yeah, so I think this is a very prudent presentation. So, I mean, I also have started practice not too long ago, a few years ago, and I too have used one refurbished equipment in my practice right in the beginning. And fortunately, it's been serving me all right. One of the things I took was that, so I took the AMC from the company for the equipment along with the equipment, because the first 1 or 2 years, when you're using it is when, when it's new for you, is the time when you can end up with some troubleshooting. So that did help, because in the beginning, there was some teething issues here and there, but that was sorted out because of that initial AMC. But there onwards, then you can be on your own, because you know your own machine and you know how to operate it. It also helps to know, the background from where it is coming, whether it is, coming from a single-use clinic, or is it coming from a place where it has been under multi-use, and that is something you may not always get to know, but you must always inquire for it. And if possible, get a demo before you take it up. So these are some of the points that I would like to add to this. And I think even in the previous talks, the idea about the finances and how to plan it is very, very important. I think it's something that we as ophthalmologists often don't think of, whether it is in our private setups or even, when I'm sure in the public setups. Now, I think, Dr. Namrata, even for the newer faculty, I suppose pensions and all would not be the way it is for you.
Oh,
So
I know, I
also
know.
think-
Yeah, for us, pensions have been abolished now for the more younger faculty, and it's a different kind of a scheme. So they're not going to get all their money at the end when they, retire.
Right. So that is, I think, one aspect that we could look at. And I don't know, ma'am, if as AIOS or as you see, we could have a body where we have some, financial planners, etc., on board that people could utilize services of, or or have group indemnity insurances for all the members. That's something you could look at.
I think that is something we really need to work on, and that is something which is required. Like you said, I mean, it's really required, and we need to work on it. That is something which it's an uncharted territory completely as far as AIOS is concerned, and nobody's ever thought about it. And I'm surprised that people have not thought about it, and I think this is the need of the day.
Dr. Rohit, what could be the possible sources for procuring such refurbished equipments? And Namrata ma'am, again, can AIOS be of some help?
So, I usually, I have only bought a couple of equipments which is refurb, and so most of the times, it's the WhatsApp groups which are there, which people post they are selling something which I have seen in my BOA groups or the WhatsApp groups, and then there are certain people who just deal with, like one of them is refurb, who deal with second-hand equipments. So you can probably go through them. In AIOC only, I have seen 2 or 3 stalls for this. So you can get in touch with them at that time. And what Dr. Digvijay Singh said was very relevant to know from where it is coming, how many years of usage. So that background is very important.
I think that's a very good idea, Rohit. What we can have is that we can separately advertise in AIOS itself. The companies, they do come with their equipment, and they do come with their new equipment. I don't know whether they come with their old. I don't think they come with their old. But all those who want to sell or are wanting to sell can showcase their equipment, in the conference itself. So people can do the negotiations, etc., and can also have the look at the instrument. I think that's a good idea, and I think we will try to implement it this year only. I think it is going to be in Mumbai only, so we will do it from this year. That's a good idea. We will take it forwards, I think.
And also there is a Facebook page about Ophthalmology Equipments Forum. So a lot of people just posted, and it has a good strength of more than 5,000 members.
Yeah.
So that is also one area where if anybody is looking out for a refurbish, they can just pick it up from there, and direct contact numbers are shared. About the indemnity, in Mumbai, there is Association of Medical Consultants, which if you are just a part of that, then a very good group insurance schemes, private indemnity as well as the hospital indemnity. In fact, they have now extended it to car loans and home loans also. And you just need to be a part of AMC, and you just keep getting the flyers regarding these newer and newer indemnity proposals. Also, they have a team of lawyers which are there, and they would have handled a lot of medical cases. So it's a win-win situation for the more the number of people who are taking the indemnity, the next year's whatever is the paycheck starts reducing. So it's like our the one which Dr. Maskati has started, and Dr. Ranjit Sinha is also a part of it. The life insurance policy of AIOS, similar to that, like more and more people taking indemnity from that body, the next year's premium fees starts reducing. So I think that would be a great idea.
Something like family benefit scheme.
Yes, yes.
So taking this forward, I would like to ask the entire panel and the speakers, Namrata ma'am also, if somebody is starting off and he is a specialist surgeon, should you start off basically with the basic setup or go into a specific specialties as well? Retina would definitely require it because he's a retina surgeon, barring retina I'm talking about.
I think current most models are that people start with a basic setup first, and then as they become more confident and they earn more, or they have more finances, they branch into other fields where they have specialized in, like you said, except for retina, because without the machine you can't do anything. But I think that has been the model from my experience. Whosoever has gone, if they don't have support from the family, or don't have support of investment from any other major source, or any if they're not joining a corporate, I think that is what most people would do. And then, as and when they buy the machines, etc., then they keep upgrading it. Like, nothing against it, but just to give example, they would buy possibly microscope first, and then upgrade to a better one or an imported one at a later date. So that is the way I have seen people have been doing. But I think Digvijay can also give his own experience, who shifted from a corporate to his own practice. And I think Digvijay doesn't need any finance. He's a very financially accomplished person. So
No, it's always difficult to start off in the beginning. But I think, as I also said, that I did start with some refurbished equipment, but you have to take it with care and then build upon it. But the first year the clinic's smaller, the next year you add something. So every year, if you're adding one or two equipments, over the next 4 or 5 years, you'll start to get more and more comprehensive. Fortunately, for my practice of squint neuro-ophthalmology and glaucoma, I never really needed too much of equipment. If you have one surgical instrument tray and one prism bar, your squint is done. So I mean, it is somewhat that simple. And so I think, Tarun, you're right. The idea, I think, is to build it up slowly. There's no point of over investing in the beginning, because you need to. There's a lot of other expenses that come your way, as was already discussed.
So just to jot that down, in about 30 seconds, basic equipments in the OPD that you would like to put. This is absolutely must. Somebody can just jot down from 1 to 10 or more or less?
Yeah, I think, like I just started off, so probably you definitely, you have to have a visual acuity chart, you have to have an auto refractor, you have to have a tonometer. You can go for a non-contact or a contact, that depending on your cost. You have to have a slit lamp, biomicroscope, a surgeon chair, an ophthalmic chair unit is helpful, so it helps compact everything in one place, or you'll have to have motorized tables. Apart from that, in terms of the I think it's probably very important to have an EMR these days. So you should try and invest in that right in the beginning, because later on to shift all paper into an electronic takes a lot of effort. So in the beginning, I think that's something you definitely want to have. Apart from that, if you're thinking of an OT, then a good an operating table, a microscope, which is probably a step above the basic. It's helpful to take the zoom and XY in one form or the other, whether it's your table moving or the microscope moving. A basic, phacoemulsification machine, a crash cart, that is a very must if you're doing OT practices. And, in terms of lasers, a lot of things in the bigger cities, you have people who can get laser machines to you, or you can tie up with a colleague or a hospital nearby. As far as the good to have equipments would then be the OCT based on your practice, if you're a retina or a glaucoma specialist, or a perimetry. But these would be the good to have. They're not mandatory right in the beginning.
So regarding this, I saw a lot of videos also. There was one video by Dr. Piyush Chandak, who couldn't join us today. He had compared the various low to moderate cost OCTs. So in your, the panel's entire opinion, which would be the OCTs that you would recommend? There are a couple that are available in the market, and the previous speakers had said it's always better to go for a newer OCT in comparison to in refurbished one, particularly considering the fact that the guarantee won't be there much.
The OCTs should always be bought, which is actually newer in the market, since the technology of OCT is changing, just like the technology of computers. The 5 years back, for the OCT which were coming, the usefulness of them has reduced a lot in today's time. What we have just bought, I have no financial interest in saying this, but we have just bought a Hewitts OCT, and we are finding its results are quite good and comparable to the similar and even a little bit higher costing OCTs of other companies. And that's what actually Dr. Piyush Chandak and I did this once before, and he also has one OCT, and he has compared the OCTs in between the companies. And what we found that in the newer companies and the smaller companies, like Hewitts is a smaller Korean company, so they are incorporating more deals into the OCTs just to entice us, so that we are able to buy their OCTs and not prefer the ones which are established companies like Topcon or Zeiss. So that's a good option.
I would look at buying an OCT, which would give me a function of fundus photo also. Because if you're starting off, you want one machine to do something extra. So I don't have it, but if I were to start today, I would invest in a Topcon Maestro, because that gives me the anterior and the posterior segment OCT. Plus, it gives me an additional advantage of the fundus photo. See, going with a newer company has its risks and benefits. Definitely, they'll give you better deals. But if you are a super specialist, but if you are going to do cataract surgery also, then you are going to use the IOLs anyways. So if you're going with a established company like Zeiss or any other company, even if you're using 10 IOLs per month, they can be bundled and it can reduce your EMI for that particular machine. So that is one thing that depends on purely whether you are actually doing cataracts or you are sticking to your own super specialty. But I would definitely look out for a fundus camera, good decent fundus photo acquisition capacity of the OCT also, if it is my first OCT.
Any other views from anybody else? I think those are very good points. That's exactly what I'm looking at personally right now. I think the Hewitts has a fundus photo, is it, as along with it, right?
Fundus photo, OCT angiography, and topography and optical biometry.
So I was speaking to one of my senior retina persons, and what he told me was also that Hewitts OCT angiography is actually not great. So for somebody like me, probably who's not a retina surgeon, it would not be a good option. But for the others, it might be. So there are a lot of retina people over here. Dr. Madan is also a retina surgeon. What is your take on it?
Practically, sorry. Yeah, please continue.
I'm sorry, Dr. Siddharth Madan, you can chip in and then I'll probably give my name.
Yeah, actually, I got confused with because my surname. I have been into government setup only. I was in Lady Harding, then I shifted to UCMS. So I've had the experience with Zeiss, and currently we are using NIDEC. So I don't really have a personal experience with the Hewitts model per se. So what I would see as a practitioner in a government setup, as a faculty, I still feel that if somebody wants to go in for a machine, he should take a machine which is upgradable. Maybe if not initial investment at first time, that at least the OCT should be upgradable to OCTA. I think that should be a good option. That's what I think. Please continue. Thank you.
Yeah, I might have a slightly different opinion when compared to most of the other people, because I think, given the context, we're sitting here talking about how you start your own practice. So every lakh matters. And for somebody who's starting out, I would say, go for whatever you get. And when it comes to retina, my personal opinion is that a single line scan, if it's good enough to have a decision to treat or not to treat. So if your machine can give you that properly and you're getting it at a better rate, always go for that. And most of the other changes and the other extra details that a higher end machine, probably 10-20 lakhs extra, that can give you, I think is a little cosmetic. And for 100 patients that walk into your OP, 90-95 of them are not going to need that. And if one or two need that, you can probably get it from your next center or something like that. So if you can save 20 to 30 lakhs on that, I think that makes more sense, at least for a beginner.
I have another question. Now, Dr. Prasanna is over here. He's probably waiting for the question. Yes.
One thing before we come to that, I think since Dr. Namrata ma'am is also here, we did want to just sensitize everybody once on infection and endophthalmitis and what AIOS has been doing. So ma'am, if you could just give a quick 2-minute comment on the cluster endophthalmitis that have happened and what how AIOS has looked at infection control.
I think this year, meaning in the last 6 months, we've had 2 cluster endophthalmitis in the country. One was in UP and the other one was in Bihar. And both of them, what happens is that it is our duty to protect our own members, and it is our duty to see that our own doctors don't get caught. But the only thing is that it is also the responsibility of our doctors and ophthalmologists that they are observing all that is required to be observed to prevent an endophthalmitis. So we've come up with the guidelines on the endophthalmitis, and the guidelines have been made in such a way that they are not very stringent. They are the basic minimum that everybody should follow so that it doesn't occur. We don't want to write anything in the guidelines which is going to get tomorrow, for instance, if there's a litigation, are going to get our own members into trouble. Like, something very stringent, which probably not all of us follow or not all of us do, like something like intracameral moxifloxacin is a must. So we don't want to write anything like that, and we've not written like that. They are made very general guidelines. Second thing that we are really trying to understand and to do is that whenever there is a endophthalmitis anywhere, and it occurs after a CAM surgery or otherwise, the first thing that the relatives do, or the FIR is lodged, or the complaint is made is against the doctor. But it is not the ophthalmologist who has to be blamed every time, because the fault can lie with the irrigating fluids, the fault can lie with the viscoelastics, the fault can lie with the IOLs themselves. So we are in communication with the lawyer, and very soon we are going to file a PIL against this, in the sense that we will not get a complete relief because we are responsible for the surgeries that we do, but we'll get a partial relief. So that whenever an endophthalmitis occurs, it is not the surgeon, who is the first line of attack, but there are so many other things which are also involved. So our industry partner is equally responsible if the manufacturing is not okay, and our other staff are also responsible, like the nursing staff, etc., etc. So that is what we are trying to get, and hopefully when we are successful, I will let you know. But this is what we are working on with our lawyers.
Thank you, ma'am. I think that will be very useful, because that's kind of a fear always, and now with probably more camps and all starting out again, it will become a hassle. So thank you for that.
Thank you, ma'am. So we are out of time, but I would request Apurva to give us just 5 more minutes to discuss, a couple of questions. So 30 seconds, Dr. Prasanna, you have been using the visual fields, the virtual platform. What is your comment on it? 30 seconds, please.
Visual fields, pardon me, Karan, on virtual platform. I didn't get your question.
The 3D visual fields, the ones that you're using. LSR, the one.
Yeah. See, the thing is, in the pandemic era, especially the LSR VR headset visual fields, it saves a lot of time in the sterilization part of it. Because in the bowl type perimeter, if the patient doesn't wear the mask properly, then you would have to take your time to clean the bowl type perimeter once in every 2 patients. But with the enclosed chamber, the nose is always outside the chamber of testing. So in that case, it really works well. And the second point is, for moderate and advanced glaucomas, it is good. But for picking up early glaucoma defects, it is still not really that reliable, but still it serves a very good job, is my comment for that. Yeah.
Thank you, Prasanna. So next question that I would like to ask our panelists, it was already touched on EMR, but I would, Dr. Madan uses a free-based EMR, and it was recommended, that you should start off with the EMR, particularly in early practice. So which EMRs is everybody in the panel using? And just quick 10 seconds or 20 seconds and advantages about it and disadvantages.
Yeah, Karan, as I was mentioning to you, I'd like to have something that's with me. The data is with me, and I can, in a single click, I should take out everything to the Excel. And that was the priority when I was looking for an EMR, because all these are fly-by-night operators. They have 2-3 computers. They can disappear any day. I mean, at least the lower level people. So you'd like to have your data with you, not on the cloud.
Yeah, I use the Yarago EMR, which I got customized for my practice somewhat, and it's been doing a good job for me.
I'm using a Crystal EMR, which is designed by a Gujarat ophthalmologist, and a lot of retina people from Maharashtra is using it. It's a Symbian-based software, and again, I prefer not to use anything which is cloud-based.
I'm using a Netra Clinics EMR, made by an ophthalmologist from Gujarat, and it's also the data is stored on site, and I prefer it because the patient data is proprietary and should not get leaked in case of a hacking or something of the company. So that's why it is very important to have the data on site.
So Devakant, are you there? Digvijay sir and Namata ma'am, with your permission, we would like to conclude the session. There is a lot of matter to be discussed, and this is always a never-ending topic. And I'm sure we can, take this forward in our YOSI members group, and I'm sure the AIOS and our seniors will be always available to us juniors for help and guidance, because we are still in a very nascent stage of our practice. So with your permission, Digvijay sir and Namrata ma'am, I would like to conclude the session.
I think it was a very nice session, Karan. You can take it up as a standalone session, maybe for a longer period of time at the AIOS itself also. And it will be really useful and involve a lot more, many more other people, especially the EMR part, because I think EMR is going to be the future of tomorrow. And even at AIOS, we should be, offering at least some EMR to our members.
And I would like to also just say that Dr. Namrata has been very kind to tell us that our Yoga Pavilion is waiting for us at the physical AIOS later this year, and she's already planned some events for YOSI from the AIOS side. So thank you for that support, ma'am, and we're all looking forward to be there physically.
So thank you Namrata ma'am, Digvijay sir. Thank you Apurva and Devakant for crafting out an excellent session and being always there for us. Thank you to all the speakers and the panelists who laid down really important points. Over to you, Apurva, for the next session.
Thank you, Karan. That was a seamless conducting of this session, and thank you so much for making it so interactive. So we are ready for our next session. We have our innovators and trailblazers who are here. Dr. Hirika Gosalia wants to talk after 2 to 3 talks. I hope the others will be accommodating of this. Dr. Prasanna is here. Dr. Prasanna, may I ask you to begin, please? Is that all right with you?
Yeah, sure. No issues.
Yes. So just a second. Yeah. Right. So Dr. Prasanna is one of our leaders in virtual reality and augmented reality. He is currently the research director and glaucoma head at Mahatma Eye Hospital Private Limited. He is published in numerous articles and a lot of them in IJO as well. He's the section editor for the regional journal in Tamil Nadu. He's given various talks at the national and international level. He is basically very interested in moving images in ophthalmology, augmented reality, extended reality, 3D printing, app developing, and academic filmmaking. We discovered him in the last Yoga Pavilion, and he's just amazing. I think we are looking forward to your talk. Over to you, Dr. Prasanna.
Yes,
Thank you for going
Thank
first.
you. Yeah, no issues, ma'am. Thank you for the warm welcome and kind invitation. I'm just sharing my screen. Yes, ma'am. Is my screen visible? Am I audible, ma'am?
Yes.
Yeah. Thank you, AIOS and Yoga Pavilion, for this wonderful opportunity and a beautiful topic, deep dive. Welcome to augmented reality. So, welcome to the world of 3D ophthalmic metaverse. This is something that we have been creating for the past 2-3 years or so. And I would like to share with you my journey as well as the thought process that led into this. Usually, as a college person, as a postgraduate, or as a fellow, for teaching, we started creating the 2D and 3D animations. And by creating these animations, we wanted to convey certain concepts to neophytes so that the learning can be made more gamified and fun. For example, the common encountered practical difficulties like the iris process and peripheral anterior synechiae. I used to make these animations and then take them into real-time scenarios so that we can show them what these really are in real-time practice. But then I started wondering, why not we have unanimated modules? So these are something that are animations, which is not really real. So let us go into creation of the unanimated 3D models is what led to this pondering of using the patient's own image and creating a model. And it can be used for patient counseling as well as it can be used for student training as well. So what we did was we used real confocal unanimated fundus images, which are white field 110 degree true color, And they were confocal, not only the color images, we can use an atlas of autofluorescence and infrared for the posterior segment construction. And you can also use the anterior segment slit lamp and gonioscopic pictures as a photoreal visuals. So the atlas we started collecting. So this is a color fundus atlas. Then we had a patient of flecked retina. You just need to take a wide field autofluorescence and an infrared. We had our own confocal fundus image. EDON, I should say. It's no financial disclosure again. And we started collecting our atlas in a diabetic retinopathy patient, a retinitis pigmentosa. You can see all the beautiful images. The retinal nerve fiber layer defect for glaucoma. It goes on. The list just keeps on going. A myelinated nerve fiber, a splinter hemorrhage. So yeah, now we have collected our 3D models. So now what we need to do is, we thought of presenting the models in the best way possible, such as a 3D atlas and augmented reality. That's when we started making our own augmented reality holograms in a cost-effective manner. So what we did was, we took our 3D eye models, our real-time true color images, and we put it into Unreal Engine software, as you can see here. And then we made the 3D eye models, and then we coded them in the Android phones for a good AR display. So this is the 3D eye model. And we also made sure we used complex structures, not only eye, but structures pertaining to ophthalmology, such as the cavernous sinuses and the circle of Willis. So all these models were coded. So this is the blueprint that you're seeing on your screen. So by coding these 3D models in the Unreal Engine software, and we anchored them to this white ball called the root. So by anchoring them in the white ball called the root, so many of you will be familiar with the Pokemon games that came in augmented reality, or even the filters that we use, especially the kids or someone. We used to play with a lot of coolers. Once you have the phone in you, it will automatically read you. So this is what is called the root, the white root. So this is very important for the model to get span into the mod for augmented reality usage. So we started using the eyeball model, the circle of Willis, and once all were created, we had this root, and this is the AR template that is mandatory. And now it's all set. You just need to install the application that we have created. It's free of cost. I'll just be showing the application next. You just need to install the app in your phone. Make sure you fit the phone's camera onto that AR template. So this is the paper that I'm again showing once again. It is also available to download in the App Store. And once you do that, so this is the QR code to download this particular app, which is currently available in the Android platform. We are soon launching it in the iOS as well. So once you download this app, all you need to do is, let us see a real-time scenario, what you need to do. So print the AR template and place it on your table. And now open the app and click it and focus your phone on that particular paper. You can see that on the left-hand side is a real-time scenario, and on the right-hand side of your screen, you can see this is the display of the mobile camera view. So the model will be spawned as a hologram. Now by moving your phone accordingly, you can access different views of this hologram. So you can move up, you can move down. By moving up, you get a much smaller view of the eye. By going down, you can go and see the optic nerve, the retinal vessels. All these are not animated models. These are our own patients, real-time models. So with this, the learning can be made more fun, more interacting, fundus learning, angle structures learning. All these can be made very interesting. And this is again another model, cavernous sinus. Once we create the model in the Maya software, import it into Unreal Engine, and then we code it for augmented reality. So again, you can see on the left-hand side, the user is demonstrating with a piece of paper and a phone. It is cost effective. We have provided it free of cost. And by just moving your phone front and back, finding your sweet spot is very important. You can see that on your right-hand side of the screen. By rotating the model, you can get the different sections of the cavernous sinus, which is actually not possible by textbook reading, because in textbook you always have a single slice or 2-3 slices maximum. The creative cognitive learning is always impaired because they have to, especially the neophytes, have to imagine a lot. But with augmented reality, every 360-degree can be accessed. And then this is again another model. This is a recording in my phone taken where not only the cavernous sinus, even the angle structures, as I was saying, you just need to move your phone back and then just go in and visualize the angle as well. So normal angle, abnormal angle anatomy, everything can be fed and learning can be made more fun. Once this is done, we can go into real-time scenarios, and even for simulations also, it works wonders. So we are, the USP of our particular app is we have used real-time images, not animations, real-time angle structures, real-time fundus images. So it's really important that we use real-time images, and we have also published the same in this year's January 2022 innovation section in the Indian Journal of Ophthalmology. And obviously the cover picture also is ours. That is where the flecked retina I was just showing you. And then these are some of the references. We have also published a chapter on how to do it. We have provided it open access for viewers who are seeing this. It's always available for you for download. And not only we stopped with augmented reality, we also went one step further and did the extended reality. This is a true holograms with HoloLens Microsoft. You can see this again with HoloLens. We have incorporated all our models into the HoloLens as well, where you can see the pedagogue here is actually moving on the right hand side, but it's actually a museum of holograms that he is actually seeing. On the left hand side, you can see the display of what he is actually seeing through his eyes. So that is very, very important, because for 360-degree learning, all these models from cranial nerves, starting from their anatomy, where they are origining, where they are inserting the extraocular muscles, all these models we have created, and we have provided it in the Microsoft platform as well. And the advantage of this is not only you get a visual aura or a photo immersive feeling, you can also use the tactile learning. You can see here the user is actually holding the hologram. He's actually pulling it off. By pulling it, you can actually enlarge the hologram. You can rotate the hologram. You have access to the eyeball as a whole. And by this simulative learning can be made more gamified, and also the skill sets can be improved. And not only for anatomical learning, we are even trying to incorporate it for smaller procedures like gonioscopy, foreign body removal. And here you can see the beautiful visualization of the angle. So all these are, we have also provided a multimodal atlas, color fundus photograph, and autofluorescence and infrared for all the eyeball models. We have also provided the cavernous sinus, the circle of Willis in the eyeball models. So all these are available as true holograms by us. So we are a more of a 3D ophthalmic metaverse is what we are creating. And we are the team Mahatma Center of Moving Images. We are not only ophthalmologists, we have a group of technicians as well. You can all feel free to visit our website. We are a growing team, research and development, moving images, AR, app development, and even 3D printing as well. And these are some of the applications that we have created apart from the holograms. We have our own 3D atlas called the IMG 3D. We have our own Windows version application as well. All these are open access. We have printed our own 3D models as well as a puzzle for a cognitive learning. For want of time, I'm just skipping through certain slides. And this is the last slide that I'm closing with. We have done totally 6 innovations, which are all available in our website. I think the users here, whenever you're free, you can go look at it. Not only augmented reality, we are there for extended reality, 3D printing as well. And we also publish our work, IGO videos. Recently, we published our animation deck, and we keep learning. And the future is going to be augmented reality and extended reality. This is my daughter who's playing with the VR headset that we have actually innovated. So I think in 10 years now, or 5 to 10 years, every home will have their own VR headsets, and we can actually go into everyone's home with this particular application. And this is going to be the future of e-ophthalmology. I thank Yo Pavilion once again for giving me this opportunity to share the innovations that we have made. Thank you, team AIOS and team YOSI, for this wonderful invitation. Thanks a lot.
Excellent talk, Dr. Prasanna. I had the pleasure of reading your article, even which you have submitted actually. So, right. So, right. So now a quick question, Nilesh, are you there?
Yes, ma'am. And excellent talk, Prasanna sir, as always. I am following sir since he started flash-based animation. For last 2 years, I am following him and learning from him. So excellent. This thing is there, sir. It is mostly right now centered on residents. So, but I feel there is a large chunk that can be used for patient education also, sir. So, are you working on that front so that at least for the complex thing like glaucoma and complex retina surgery, and even like the cornea surgery where the layers are being used? So
yes, Nilesh, actually to start off, yeah, we just started slowly. We wanted to go slow and steady. As you know, for the past 3 years, 3 years back, I was only making animations. You would be knowing that. So now we are slowly moved on to simple procedures, because there is something called rigging. It is quite difficult, and the rendering process also takes a lot of time. So now we have started making the simple gonioscopic insertion and removal. Sometimes when we use the visco, that itself for residents, it makes a lot of pain to the eye for the patients especially. if they don't handle it right, the vacuum suction creates a lot of pain to the patients, a simple foreign body removal. So now we have started with that also, simulations. So then slowly we are planning to upgrade ourselves to cataract surgery and then maybe to cornea and retinal surgery. I think it will take our time, but I think we'll be positively be able to get there. That is for the student's point of view. For the patient's point of view, we have thought of a 3D K-sheet module where now we are all talking about the patient's K-sheet, what we can give to the patients. Maybe we are there where we can, so we have done our 3D models. So it is just about removing the fundus and the anterior segment. In the code, you just need to feed the patient's fundus and the anterior segment. So by this, maybe with an EMR, we can attach the patient's own 3D K-sheet. Maybe that is very near where it will be somewhat innovative, as well as the patient can get to access the 3D K-sheet. So if the patient loses follow-up and then maybe he's traveling and he's going to another doctor, the 3D K-sheet will always work wonder for the patient, because sometimes the fundus, we would always want to see what is in the equator or maybe what is in the periphery, and for the angles as well. So I think it has a role to play, and soon we will be able to reach there is what I am optimistic about.
Looking forward to that. So Namrata ma'am, a quick word from you on this.
This was completely mind-blowing, absolutely. I know that we always get innovations from him, but this was just, or maybe I saw it for the first time. So for me, I mean, it was completely spectacular. And I'm looking forward to the cornea part of it.
Thank you. Thank you.
Thank you so much, ma'am.
It was quite a recent one.
I'm just wondering, you should have had a prize here for second, third prize in this session. But anyway, each of the innovations, I'm sure, is going to be great.
Thank you. Thank you.
Thank you so much, ma'am. So, Dr. Apurva, shall we move ahead?
So moving on from that wonderful talk, we have the special privilege of hosting Dr. Wong Chi Wai. Is he here?
Hi,
yes, ma'am.
Yeah, yes.
Hi. Dr. Wong Chi Wai is an ophthalmologist at the Glen Eagles Hospital, Singapore. He was a big part of SNEC prior to this. He's set up the myopia clinic there, and he's also done his post-graduation from there. He has an immense number of publications in the field of myopia and ocular drug delivery, and he's got several awards for his research work. He's got travel grants, and he has served as the deputy director of SNEC's undergraduate education, and he was the program director of the Duke NUS Medical School's ophthalmology program. He's a committee member, obviously, of the Singapore Young Ophthalmologists Society, and he is a reviewer in the big journals in ophthalmology like IOVS and Ophthalmology. He is the recipient of the Singh Health Healthcare Heroes Award, the Young Eye Ambassador Award, and the Singh Health Quality Service Award. We are really honored to have you here, Wong Chi, and I really look forward to hearing your talk on ocular drug delivery. Is nanotechnology the way forward in ophthalmology? Thanks for being here. All yours.
Thank you. Thank you so much for your kind invitation and also introduction. I'm very impressed with Dr. Prasanna's ophthalmic metaverse, and hopefully I can share something that is equally exciting. I'm going to share my slides now. So today I'll be talking about nanomedicine, which I believe will be the next frontier for ophthalmology. And this is based on the work that we did at the Singapore Eye Research Institute on liposomal drug delivery. So first of all, what is nanomedicine? If you look at the diagram here, you see that on the nanoscale, this is essentially a subcellular scale. So nanomedicine is the application of nanotechnology, which includes biomaterials at the subcellular level. And the advantage of this is that we are able to then influence cellular activities and processes directly. So nanomedicine has found application across a wide spectrum of modalities in medicine, which includes imaging, diagnostics, regenerative medicine, as well as nanotherapeutics. So I believe that nanomedicine could be the next step in the evolution for ocular therapeutics and diagnostics. And today I'll talk on how it can revolutionize ocular drug delivery. So nanomedicines, one of the first utility for nanomedicine is used as a drug delivery platform. It can be broadly classified as lipid-based nanocarriers, which includes liposomes, polymeric nanocarriers, which includes hydrogels that most of us would be familiar with, included, and also dendrimers and micelles, as well as non-polymeric nanocarriers, gold nanoparticles being one of the most commonly used nanoparticles. So today I'm focusing on liposomes. What are liposomes? They are essentially naturally occurring membranes in the human body, which means they are perfectly biocompatible as well as biodegradable. And advantages of using liposomes is that you can encapsulate drugs either in the aqueous core or in the lipophilic bilayer. So a wide variety of drugs can be included and encapsulated by the liposome. And by encapsulating the drug compound, you can slow down degradation. And liposomes are selectively targeted by macrophages. So essentially, it selectively targets inflamed sites. And at the same time, it avoids undesired drug effects at non-inflamed sites. Liposomes are very versatile drug delivery system. So there are many, many ways you can alter the physical chemical properties of liposomes, which includes its charge, its size. Typically around, the size of it is typically around the 50 to 100 nanometers. And you can also modify the cell surface receptors to give you a variety of functions. For example, you can make them, you can add polyethylene glycol onto the cell surface to make them stealth liposomes. These avoid detection by the circulating macrophages, which allows them to circulate in the systemic circulation for a longer time. You can also add cell surface receptors to make them target specific cells in immune liposomes. You can alter charges to protect the payload. You can also create stimuli responsive liposomes that release the payload on stimuli such as heat and light. So what we did with liposomes at the Singapore Eye Research Institute was that we're trying to solve the HO problems of eye drops. So eye drops have been in use for ophthalmology purposes since 150 years ago, but yet there's not been a lot of innovation, and we are still faced with some of the limitations of eye drops, which include low bioavailability, difficulty in instilling, and also reliance on patient compliance, which often, as you know, will be difficult. This was one of the first studies that we did. It was a preclinical study where we looked at the use of subconjunctival liposomal steroid to treat experimental uveitis. So the aim of the study was to demonstrate efficacy of subconjunctival liposomal steroid. We had two types, liposomal triamcinolone acetonide and liposomal prednisolone phosphate. And this was the study design. We pre-immunized the rabbits with TB antigen, and then on day 0 induced uveitis. On day 3, we injected the rabbits based on their treatment groups. So there was a control group and there was an eye drop group. We had two separate subconjunctival liposomal steroid groups, a single injection of that on day 3, as well as a subconjunctival free prednisolone phosphate group. On day 8, we simulated a relapse by injecting antigen into the anterior chamber. So looking at the performance of the liposomal steroids against eye drops, we saw that the initial suppression of inflammation was much better than eye drops. And also it was able to prevent a rebound inflammation after a repeat simulation of inflammation on day 9. And compared to daily eye drops, a single subconjunctival dose of liposomal steroid was able to achieve the same sustained anti-inflammatory effect. When we looked at the liposomal steroids compared with the free steroid, we saw that the initial suppression of inflammation was similar between the two groups, but the free steroid was not able to attenuate the rebound inflammation on day 9 compared to the liposomal steroids. And free steroid was also not able to sustain the anti-inflammatory effect at 2 weeks compared to the liposomal steroids. Histology confirmed the clinical findings with more inflammatory cells seen in the eye drop groups as well as the free steroid groups compared to the liposomal steroid groups. And also confocal microscopy showed that the macrophages as well as the liposomes were co-localized. So this provides evidence of the selective targeting of macrophages to the inflamed sites in the ciliary body as well as the iris, and specifically inside the macrophages. There were no side effects which included raised intraocular pressure or cataract formation from the use of these subconjunctival liposomal steroids. So we can see from these preclinical studies the promise that is liposomal steroids can be promising agents for anti-inflammatory treatment in cases of anterior segment inflammation, and that liposomes also demonstrated selective targeting to inflamed sites with little side effects. So we went on to perform a clinical trial. This was a phase 1/2 clinical trial using liposomal steroids. And we wanted to look at cataract surgery because cataract surgery, post-cataract surgery inflammation is the most common cause of anterior segment inflammation. And as we mentioned, there's lots of limitations with the use of steroid eye drops, particularly in certain groups of patients like the elderly, children, the non-compliant, and patients with concomitant medical conditions that may make it more difficult to use eye drops after surgery. So in these patients, these were patients that were scheduled to go for cataract surgery. At the end of cataract surgery, we gave a single subconjunctival dose of prednisolone phosphate and then monitored them for ocular inflammatory scores as well as safety outcomes. This was a small pilot study of 5 patients, but we found that all the patients tolerated the procedure injection very well. None of them had any side effects, including raised intraocular pressure or cystoid macular edema up to 3 months after the surgery. And all of the patients had complete resolution of inflammation. Laser flare photometry also showed that there was a complete resolution of inflammation in all patients. So in conclusion, I think nanomedicine is particularly relevant for ophthalmology because the eye itself is a very special organ with multiple barriers for drug penetration. So nanomedicine with its selective targeting, with its reduced degradation of the payload can certainly be of a huge benefit to ocular drug delivery. So in particular, liposomes are very effective because they are targeted towards macrophages, and also they encapsulate the payload, which then effectively enhances their therapeutic efficacy without the off-target side effects. So there are many future applications of nanomedicine, which includes delivering gene therapy, in vivo imaging, and perhaps in the far future, nanorobots that can allow surgery at the cellular level without any invasive procedures. So thank you very much.
Great talk, Wangchi. I think Nilesh has a couple of questions and we have some audience questions also.
Thank you so much, Dr. Wangchi. It was really thought-provoking, and I actually have not 1 but 3 questions for you. The first thing is, I wanted to know what was the dosing in the clinical phase 1 and 2 trial. Like, is it a single injection and you do it and forget it, or you need to repeat them at like 2 weeks or 3 weeks, something?
Yes, that's a great question. So it's a single dose of subconjunctival steroid, 0.1 mils. We use 5 milligrams per mil concentration. And none of the patients actually required any rescue topical steroid eye drops after the surgery. So a single dose was essentially able to replace the use of 184 drops of steroid eye drops over 1 month.
Okay, sir. And we have an audience question. How is subconjunctival liposomal prednisolone used here? Better or efficacious over the conventional subconjunctival dexamethasone? and the cost issue, because I think the cost issue is really early we have to discuss here right now because it is in clinical trial, but at least what is the benefit over other subconjunctival implants or depot injections?
Yeah, so the main benefits of using a nano carrier basically is because we want to have targeted delivery. So obviously free steroids would not be targeted towards inflamed sites. It can go into the trabecular meshwork and everywhere else that you don't want it to go and cause side effects like raised intraocular pressure. And also you have to deliver a much higher dose if it's not targeted. So the greatest benefit I'll say for nanocarriers is really the targeted delivery and also protecting the drug from degradation before it reaches the sites of inflammation. So that allows you to deliver a much smaller dose with much greater efficacy. So overall, what it does is that you don't need such a great big dose. You have less side effects as well to have the same effect.
And this liposomal membrane that you are using, are they synthetically made or are they derived from a living organism? So is it a biologic or is it a completely synthetic molecule?
So these are basically synthetic lipids. So the lipids are synthesized and then rearranged into the phospholipid bilayers.
Yeah. So once we go for gene therapy, then it won't be considered as a biologic. It will be considered as a synthetic drug.
Yes, correct.
So the use will be different.
Yes.
Okay. So great talk, sir. We are really enlightened, and all the best for you getting this drug into the community, getting the approval, and hope to see you in physical conference at the All India conference.
Yes, hope to see you in person too. Thank you.
Sure. Okay. Thank you so much. Thank you so much.
Thank you.
So.
Nilesh, you can introduce the next speaker.
Yeah. So next we have Dr. Amar Pujari, sir. I don't think he needs any introduction, at least in India. He is a leading innovator from RP Center AIMS. He is currently working as associate professor, and he has multiple innovations, both as new devices as well as improving on the limiting the recent available resources. So sir is going to talk about AIOS-YOSI and strabismus resurgeries. Over to you, sir.
Thank you, Dr. Nilesh. Am I audible?
Yes, sir. Audible and screen is visible.
Okay, thank you, Dr. Nilesh, and thank you everyone at the UC. So today I will be telling what we have done on AIOS-YOSI and strabismus resurgeries. So why AIOS-YOSI studies are necessary in strabismus? Because basically, as you can see, the retina and the cornea people are much more oriented about the OCC, and they want to see something in the cross-sectional imaging so that they can get some information and they can operate or they can treat the patient. But as far as the strabismus is concerned, you are going to only dissect the muscle, either you are going to recess it or you are going to resect or placket it. So why do you need OCT here? So OCT can tell something about the muscle location or its thickness or what kind of surgery has been done. So it can basically tell the anterior portion, so up to 6 mm of the medial rectus, up to 9 mm of the lateral rectus, and up to 5 mm of the superior and inferior rectus muscles can be visualized on OCT. In fact, practically we operate on these portion of the muscle, so hence it has some value. So that we want to show that like what are the utility or where it can use this one. So what experts have explored across the globe. So basically, if you get around, if you search the literature, you are going to get around 25 to 30 publications. So out of around 80% have said that they are able to visualize all 4 recti, and they have identified or correlated the normal insertion on OCT as well as intraoperative measurements. But we can do more justice, or we can use AIOS-YOSI for more practical reasons in strabismus surgeries. And that is the point when you want to use OCT as a tool based on which you can plan the strabismus surgery. That is going to be key, and that can actually define, or that can do a justice for a strabismus surgeon to buy an AIOS-YOSI machine. So previously, normal identification of the muscle has been described. In addition, how we can use AIOS-YOSI and what is the stark difference between AIOS-YOSI and UBM, sorry, that has been said. So as I said, we can do more justice if we are able to define the role of AIOS-YOSI in strabismus resurgeries. But one thing is, as we have a referral center, so often we are going to get at least 2 or 3 patients per month where like strabismus surgery has been done, but there is no available or documented details. So patient has lost this one and the clinic has lost the details because it could be 10 years, 15 years, 20 years previous surgery. So in those conditions, you can see congenital scarring, you can say some of the surgery might have been done, but you don't know exactly where the rectus muscle lies on the sclera. So you need to identify where the rectus muscle is. If you have some insight, so you can either re-recess or re-resect, or you can adjust in the same eye. Sometimes patients are going to have more than 100 prisms deviation. In those cases, all 4 horizontal recta has been operated. So now you'll be in a very dilemma, like which muscle I need to operate. So that is a tricky situation where you can use OCT to gain some insight. So I wanted to explore the AIOS-YOSI role in strabismus resurgeries with lost surgical details or where previous surgical details are completely not available. So it was a prospective interventional study. So preoperatively, I did OCT, and intraoperatively, there are 4 surgeons who correlated what are the distances I gave to them. So I took ethical clearance, institution ethical clearance, and patient attending to our strabismus surgery clinic. So for the surgery were evaluated, and those specifically who have lost the surgical details were included. The sample size over a period of 1 year was 10. Till now, I have completed 30, but initial 10 included for assessment and publication. And the number of surgeons were 4, and I was the only AIOS-YOSI evaluator. So here you can see that the picture A, component A, shows that the medial rectus cross-sectional imaging in case of extreme abduction. You can see this is a thin tendon, which is becoming more of a belly here. After 4 to 5 millimeters of the tendon, you can see this is a medial rectus belly. And similarly, you can see on the B component, you can see this is inferior rectus. Again, this is a small portion is tendon, which is becoming more thicker or more black. That is your muscle belly. Similarly, in extreme adduction, you can see lateral rectus. Again, the tendon is very thin, and you can see dark belly. And here you can see superior rectus, and superior rectus, of course, it has more of belly, so it is very clearly visible. So this is how the superior, inferior, medial, and lateral rectus appears. So you can just focus here that like the contour, overall contour of the globe is very convex. It's very crystal clear. You cannot see any bumps here. So it is very well defined. It's like 1/4 of an arc, right? So for just practical understandings, what I said is the scleral or the ocular coat between the insertion and the limbus, let us consider it as an enterocular coat. And from insertion onwards or towards the posterior, let us consider this a posterior ocular coat, right? So here, this is one example where you can see the larger red arrow shows that there is a slight bump, right? As we know that the sclera is going to be thinnest just behind the rectus insertion. So you can see the thinnest sclera that is depicted by subsequent small arrows, red arrows. And the largest red arrow indicate that probably here was the medial rectus muscle. And you can measure from the angle. So distance was 4 to 5 millimeters. That's what the normal distance is going to be, right? So we are looking for the hypointense area along the scleral coat. It is going to be at the 50% depth, but here I am not able to see anything. So I'm able to see some kind of hypoechoic intensity at 10.8 millimeter from the angle. So in addition, I can see that there's a congenital scarring. So this appearance of the original muscle stump bump and the thin sclera and the congenital scarring, all 3 indicate that yes, probably this eye has undergone some sort of surgery. And where the muscle lies, so probably the hypointense layer lies at 10.8 millimeter from the angle. So I need to compare with the other eye medial rectus muscle. If I'm able to get at 4 millimeter or 5 millimeter, I can subtract 10.8 minus 4 or 5, and that is the amount of recession I'm going to get. Similarly, you can see here, this is another example where medial rectus has been dissected. You can see this is the initial hump. You can see congenital scarring, and there is a thickening of the ocular coat because the muscle has moved anteriorly. And in comparison to the previous examples of normal medial rectus, you can see the medial rectus here, it is quite thick. So it has to be the belly portion rather than the thin tendon region. So again, the distance is 8.4 millimeter. Intraoperative showed that there is a stretch scar. So this is how we need to identify the resected muscle. This is for lateral sclera. You can see the ocular contour has completely lost. It has become more of undulating. So this is how when you expose the sclera, it's going to lose its rigidity. It will become more of undulating. And you can see this is the initial bump, the large red arrow. And subsequently, you can see that the ocular coat has lost its contour. And I cannot see a hypointense layer, consistently visible hypointense layer till up to 15 millimeter from the angle. So I need to relocate the LR in the other eye, and I need to correlate where exactly the LR in the other eye, and here I need to subtract that one. So it indicates that probably more than 9 millimeter of lateral rectus has been recessed. And this is for lateral rectus. You can see that the belly, you can note this is not a normal rectus, it is a muscle belly instead of tendon. So it is a resected lateral rectus. So again, I need to correlate to the other eye LR. So if it is a 7 mm and this is a 7.5 mm, yes, probably this is a resected muscle. And with respect to tendon thickness, I can say that this is a belly. So it's a resected lateral rectus muscle. So I evaluated 10 subjects, right? So the mean age of 10 subjects was 23 years, and the mean preoperative AIOS-YOSI measured distances was 8.9 millimeter, and the intraoperative distance was 9.12 millimeter. So you can measure within 0.5 difference, right? So you can get a quite agreeable measurements on AIOS-YOSI. So to conclude, in strabismus resurgeries with lost surgical details, we can use the AIOS-YOSI as a reliable tool where muscle details can be assessed with respect to type of surgery as well as amount of surgery, right? So, but the limitations where it is an evolving tool. I got another publication where they are able to image the muscle cross-sectionally. I mean to say, I was able to image cross-sectionally, but they were able to image in phase. So they were able to see the muscle. They adopted new software. Probably in future that is going to be more common, right? And subjective variations are high because of all the scarring and this thing. Subjects needs to learn how to image the muscle, how to identify normal subjects. Then we can extrapolate and we can understand unusual circumstances. Then we can use it as a tool with more accuracy, right? So this I have published, and thank you.
Thank you so much, sir. This was, I think you have extracted most out of anti-segment OCT from using it for posterior polar cataract evaluation and right now to strabismus resurgery. So really excellent innovation, sir. I would like to ask a question, sir. Is there any utility of it to identify lost muscle also? Because that is a real problem that squint surgeon face.
Exactly. So you can compare in the other eye, and if you are not able to, the best part of the sweat source OCT is we can visualize up to 15 millimeter of the overall ocular code. So from angle, if you are not able to see muscle up to 15 millimeter, so because the medial rectus normal distance is around 4.5, inferior rectus around 5.9, lateral rectus around 6.9, and superior rectus around 7.1. So it can give beyond that one, right? So if you are not able to see within that one, so obviously the clinical findings and the Bayes sclera, everything can correlate and you can conclude that yes, probably there is a split muscle, lost muscle, anything can confirm.
And sir, going beyond this strabismus, because it is giving such a nice view, so can it be utilized in two areas specifically? If there is a resurgery in buckling and all, where a lot of tissue destruction has happened, so it can give areas where we need to focus. And second, what came into my mind in my area of interest is in repeat traps or placing, finding the area where we can do the drainage implants. So do you think it will be implied in that?
Yes, AIOS-YOSI using soft source OCT, you can explore which is a much potential site. And recently there was one paper from ophthalmology science where they have identified the lymphatic drainage in trabeculectomy patients. So in that manner, they described very subconjunctival, very good subconjunctival space or the lymphatic flow. So in that manner, what I learned from that publication also, you can identify the conjunctiva, tenons, and the episcleral tissue, scleral health also. So if you want to do a trab or the AGV, if you want to put, so you can just screen the superior temporal in between the muscle area on the superior nasal and superior temporal part. If you feel that this is not scarred, it is quite easily dissectable. So you can use in that manner also.
Yeah. And Namrata ma'am is here from Namrata ma'am. I'd like to ask ma'am and you also, sir, how is it going with the use of anti-segment OCT for the posterior polar cataract? What are the recent development in that? Going beyond your topic right now.
Okay, so I'm doing that one. So initially I did 101 eyes and I published that report, and routinely we are using that one. So any of sort of, even Namrata ma'am sends me patients, so I must just do OCT and tell me whether PC is deficient or intact. So I do that when I give information. So it is around 10% of the patients they are going to have deficient capsule. So you can use actually that one. So should be it's going to become more common in future. So it will be available with the manufacturing in India. So we hope that one. And in addition, I'm going to do, I am right now doing some kind of histopathological studies just to understand how it, like whether the posterior opacity lyses the capsule, or it's a pre-existing deficient in the capsule because of which vitreous has hydrated the posterior part of the lens. I just want to identify, or I want to correlate histopathology. I want to understand more. So that is my second part, which I'm doing.
Thank you, sir. Thank you so much. All the best for your future endeavors, and we would look forward to listening to you always. Thank you so much, sir. So I would next like to invite Dr. Purna Chandra B. He is an accomplished ophthalmologist. He has completed his PG from AFMC, and after that he has done his fellowship from VR in Narayana Nethralaya. And his area of interest is inherited retinal diseases, retinal vascular disease, and gene therapy, for which he has done his fellowship from Moorfields, London. So welcome, sir. Looking forward to your talk.
Thank you, Nilesh, and I would like to thank all the core members of YOSI for giving me this opportunity, and also thank you for accommodating my talk little early. So I'll be talking about the basics of gene therapy. I know there are a lot of postgraduates and residents who will be listening to this talk. So I thought I'll cover very basic aspects of gene therapy. So before going to the gene therapy, you need to understand what is gene. It is the study of heredity in general and of genes in particular, and it forms one of the central pillars of biology and overlaps with other areas like agriculture, medicine, biotechnology, etc. And we all know field of genetics is evolving at a very high pace, and it's very surprising to know that eye is the second only to the brain as an individual organ in its frequency of involvement with genetic disorders. And almost 50% of pediatric blindness will have some genetic etiology. And clinical picture also can be overlapping sometimes, which may not be enough for proper and full diagnosis. So before going to the gene therapy, I'll just show this example to reiterate the fact that gene therapy is the need of the hour for some group of patients. So this was a 16-year-old female who presented to us in 2017. If you can see the autofluorescence, there is some definitely atrophic changes in the foveolar area, which progressed over next 2 years. Atrophy became even more prominent by 2021. So there was a total foveal atrophy. So now she's 20 years. On presentation, she had a vision of around 612. Now it's 660. So this was her OCT and presentation in 2017. Over 4 years, this complete atrophy. So basically, this is a very mild variant of Stargardt's, which is usually Stargardt's happen because of a defect in a gene called BCA4. If at all, if you want to progress this disease from an initial stage to an advanced atrophic stage, as we saw in our case, what we need to do is we need to fix this gene called ABCA4, which is defective. So that's where the role of gene therapy comes. Basically, gene therapy, it is a technique of correcting effects of a defective gene that are responsible for the disease development. There are different approaches by which it can be done, where a normal gene is inserted into the cell to compensate for a non-functional gene, or abnormal gene can be traded with a normal gene, or we can also do an abnormal gene can be repaired without replacing. We can just repair that gene by a technique called selective reverse mutation or gene editing. And sometimes we can introduce a stop codon. There are some exons which are usually the coding sequence. By introducing stop, so we can do some kind of a gene editing. And sometimes what we can do is we can also intervene at the regulatory sites of a gene. We need not directly interact with the gene. By changing the regulatory sites also, we can, to some extent, we can give some functional recovery. So for this gene therapy, we use something called adeno-associated vectors. So these viral vectors are most preferred compared to other vectors. The reason being, these have got a very efficient delivery system, and they have got a very high level of gene expression, and they don't have unwanted this viral genomes which can cause undesirable immune response, toxic reactions in the host. All these are relatively almost none. Okay, and also most important thing is it has got an excellent stability, which allows it to be manufactured, stored, and handled so that it can be safely transferred to the delivery site. So that's a prerequisite for any new drug what to develop. From the manufacturing site to delivery, it should be stable without losing its efficacy. These are the different gene therapy trials which are currently underway. I will not go into the details of each and every trial. So these are our main focus for gene therapy, because these are quite common in everywhere. Of course, in Indian setup also we keep seeing these cases quite often, like retinitis pigmentosa. LCA starts very early, Stargardt's, some of the corneal abnormalities. So, and we ophthalmologists are lucky because there are several factors which makes eye an ideal organ for gene replacement therapy as compared to the other organs in the body. The reason being, eye is easily accessible, and we all know it's immunologically privileged. And because of the small size, whatever we inject, either intravitreally or subretinal, it kind of get compartmentalized. So the systemic absorption is little less, so no undesired immune effects. And the very good thing is we have the possibility of using a contralateral eye as the control. Okay, and monitoring is also easy. We have many non-invasive monitoring like OCT, autofluorescence, ERG, where it becomes very easy. The effects can be seen and monitored easily. I'll just show a short video which I made as a kind of a cartoon which I made last maybe 2-3 years back, which basically shows the how a gene. Basically, it's a form of treatment that is offered to people with single gene defect. This is very important. For multiple gene mutation, if it's causing a particular phenotype, then it becomes quite complex to correct it. So preferably we prefer patient with single gene defects. So where a virus is made, what you call virus DNA is taken out and replaced with the one that treats the patient. And this virus is mixed with the normal human cells and they are cultivated. Then they are injected into the, for the patient for the treatment purpose. Okay, I'll just mute this. So then they are injected into the retina. Okay. So this is the video which I took when I was in the Moore fields. So before doing the gene therapy, we do a complete thorough vitrectomy to remove all the residual vitreous. Then we select the site, and most preferred site is subretinal. This is the subretinal injection which is being done in a case of choroidemia. Okay, so once this is done, these viral vectors will go and bind to the plasma membrane. They get internalized and travel all the way. The virion particle uncoats itself, it releases the material, and this will travel all the way to the nucleus. Once it is inside the nucleus, it will get incorporated into the host genome. So where it is, this is the animation showing the incorporation. So once this is done, it is expected to function normally at the way we have edited that gene. Okay, so that is in brief or in simple. It's not that simple a process, it's quite complex. This is the thing, this is how it is done. This was the team in which I worked. Team about initial when I was getting trained for gene therapy in more fields. So, and mentioned like, see, these AAV vectors, they have many advantages, but there are some limitations also. For example, if you take our case example, which happened because of the ABCA4 gene, this is quite a large gene, but the cargo capacity of AAV vectors is quite limited. So because of which we have come up with a novel technique called dual vector technology, where we split the gene, they are loaded into the separate variants, and they are co-infected together. Once they reach the host cell, function normally. So this is these are the scientists like Professor Arkand, Shomi Bhattacharya, who are the main. This is their brainchild. This is the dual vector strategy. This is an ongoing research in Narayan Nethralaya. So why there is an unmet need for gene therapy in India? Because we know the patient, there are many patients of retinal dystrophy. We are fed up of telling there is no treatment and all that. And most of the disease, they occur in early childhood. And when we diagnose a retinal dystrophy and when we diagnose patient, but also for the parents and the family. And we all know, like a couple of years back, FDA approved only one gene therapy product called Luxturna, which costs around 6.5 crores. Obviously, Novartis is trying to bring it to India, reduce the cost, but still, I mean, 99.9% of Indians can't afford this kind of a therapy. But that's the reason the treatment needs to be developed indigenously to limit the cost to the patient. So once we develop the viral vector, first we need to do an animal trial. This is what I'm doing here. This is the injected some few viral vectors subretinally, and we also used some fluorescent bead tracking technique to make sure that the viral vectors are in the correct place. So we have a dedicated gene therapy production platform laboratory with an expanding team of scientists. I was telling vectors form the vital role in gene therapy, but how to produce these vectors? So these vectors are produced in an area called, this requires class 100 clean room facility. So the class 100 clean room facility means basically it's what is what we routinely use for cataract and retina surgeries are class 100. So these vector production facility are there are 10 times more sterile than our routine OTs. So after crossing several barriers, finally you enter the vector production facility. That's where the clinical grade vectors are produced. So we have built the first in India gene therapy production, vector production facility at Narayan Nethralaya. And also the national guidelines for gene therapy development and clinical trials is out in the ICMR website. Whoever is interested, they can go to the ICMR website, download these guidelines. In case if some of you are interested in starting these trials and all that, you need to go through these guidelines, get an approval from there is one committee in ICMR called Gene Therapy Approval and Accreditation Committee. You need to get an approval from them before you start any trial, either animals or humans. So if any of you are interested in knowing more and want to collaborate with, you're free to do so. So thank you so much.
Thank you so much, sir. I think that was an eye-opener talk on gene therapy and a very good primer. Narayan Netralaya actually has been leading these cutting-edge technology in India. So really happy to see that, sir. Regarding the cost that you have really well pointed out that it is very unaffordable, but in India there is a concept called as orphan drug. So do you think these gene therapy will come under orphan drug and get subsidized from government because it is such less population?
If that happens, nothing like it, Nilesh. That will be very good. But I mean, of course, obviously, like just to start this vector production facility only, we have to fight a lot with ICMR. But finally, they've given some grants and all that, because the cost involved is huge in this vector production facility. Just to build that gene therapy production facility, we have taken some 6 years. We have to collaborate, correct experts and all that. But as you rightly mentioned, if they can give that orphan drug and if we can get aid from this thing, which eventually is going to happen, because before government does that, it's our responsibility as a clinician to show the data to them. We have done this, it works. Yeah. So then maybe they'll be motivated to extend that support.
Yes. And sir, regarding the practicality, what do you think will be a more better option of drug injection? Will it be intravitreal or subretinal, which will be more, which will have more uptake?
At this point, if you ask me, subretinal. So the thing is, the defect lies either in the RPE or the photoreceptors in the retinal dystrophies. You better introduce the vectors as close to the site where you want to act them. So that is the thing. Intravitreal, everything you have been trained, but I am a fan of subretinal one. So even my guide whom I worked, they all prefer intravitreal injection. There are suprachoroidal methods also have been tried intravitreal.
Yes, that's what I was coming to. So, one method which I read about in my area of interest, that is the anti-VEGF. They are trying to inject into the iris so that it keeps producing aflibercept, and then we don't need a repeated injection. So that can be something also, like not going to treat the genetic disease, but also for ongoing retinal pathologies.
Yeah, eventually we never know. We may come up with a depot like that where it can be vectors can be loaded into that implant in the iris somewhere. Yeah. That is possible.
So exciting things are coming up, sir. So thank you so much for your time, and looking forward for more talks, sir. Thank you so much. So next, now we are moving to moving on to a young innovator, Dr. Hirika. She is a second-year DNB resident from Arvind, Coimbatore, and she has developed a recent, a very marvelous innovation. I just came to know about it like 2 months back, and I am excited for her talk. So welcome, Dr. Hirika.
Good evening, everybody. Thank you so much. Thank you to YOSI and AIOS for this opportunity.
So, can you share your screen? We are not able to see the screen.
Magnifix and iVerter, a do-it-yourself innovative tools for easier and safer ocular examination. Yes, sir.
You need to minimize the panel where you are seeing the speakers.
Yeah. Sorry.
Yeah. Okay. Yeah.
As a first-year resident, it was just few months into the residency program of my prestigious institute. I carefully observed my mentor as he did the ophthalmic examination of the patients. I realized few problems which were quite unnoticed for any other ophthalmologist because they adapted to the routine system of the ocular examination. The two main problems that I'm talking about here is, first, target fixation, and the second is lid eversion. So first, talking about target fixation. It is important to acquire fixation of patient's eye during slit lamp examination for a careful and proper ocular examination. Routinely, we tell patients to fixate their eyes on our ears, but due to inability of few patients to comply with instructions, it is often difficult and time-consuming. The COVID pandemic led to the introduction of the Safe Slit Lamp Shield, which prevents aerosol transmission between the doctor and the patient. I used the Safe Slit Lamp Shield as a base to attach two magnets on either sides of the shield and came up with the innovation called Magnifix, formed by three important words: magnet, eye and fixation. Materials used were block magnet, coin magnet and a red reflector. of law of attraction between the two magnets, we acquired a freely mobile target fixator. In this video, we can see how we use this to obtain a target fixator. I then came up with the idea of fridge magnets for pediatric patients. Look at how well these work on pediatric patients. Magnifix is now used by other Arvind centers with the help of the Arvind Center for Eye Care Innovation. This can be used by all other centers, and it also makes the slit lamp look more pediatric and attractive. Hence, it is a do-it-yourself, cost-effective, easily accessible, quick solution which can be used to obtain target fixation for corneal foreign body removal, uncooperative hard of hearing patients, pediatric patients, and also for fundus examination. We have published an article regarding the same in the Indian Journal of Ophthalmology. Coming to my second problem of lid eversion. Eversion of eyelid is a skill-based technique performed routinely by ophthalmologists by using their hands or sometimes cotton buds. It becomes difficult to perform this procedure with patients with no eyelashes or madarosis, patients with deep sockets, or uncooperative or anxious patients, especially children. It has also become a concern in the COVID pandemic, wherein there is a risk of transmission of viral infection due to exposure of ocular fluids such as tears and conjunctival secretions following direct contact of the examiner's fingers and the patient's bare ocular surface. Eversion of eyelids using fingers occurs with a combination of two forces: pulling force by the fingers on the eyelashes and a pushing force by the fingers on the upper tarsus. In Hackathon 2021, an innovation forum organized by ACEI, we came up with the idea of a tool for lid eversion with no direct contact to the ocular surface. A simple tool called iVerter was made initially with an ice cream stick with the given measurements. The following video demonstrates the use of iVerter. The iVerter can be used in routine ophthalmic clinic in adults, children. It can be manipulated to observe the area of interest. Its uses include examination of the upper tarsal conjunctiva and superior fornix, removal of the foreign body, saline wash in chemical injury, and in lid pathologies. It can also be used by an assisting nurse while the doctor is examining the patient on a slit lamp. A refined version was made with the use of coffee stirrer sticks, scalpel, and double-sided tapes. A double-sided tape was attached to the edge of the coffee stirrer stick, and you can see here how it is really easy and less cumbersome to make. The following video is a demonstration of the same. Hence, iVerter is a do-it-yourself, a tool for corneal foreign body removal, also for madarosis patients. It is cost-effective and really safe in the COVID times, easily accessible, and quick method of lid eversion. The method is also published in the Indian Journal of Ophthalmology. As a young resident, I could find solution for two important problems of target fixation and lid eversion. Hence, in the same way, many other residents can find solution to many other problems by just thinking out of the box. Thank you.
Thank you so much, Dr. Hirika. And it was really, I think we have in chat box, it is being appreciated by everyone. It is very, very innovative. The only question I want to ask you is like, are you going to make it commercial? Because many people won't be doing it themselves, despite how easy it is.
Yeah, so actually, MRV sir and the team in Pondicherry, they are already 3D printing the iVerter. So it was done with a team there. So we are looking forward to that. And Magnifix is what we have already applied to all the slit lamps in our hospital and also many other centers of Arvind. So it's a very easy thing, and I hope like everybody else can also follow.
Yeah, so Magnifix also, if because it is very easy to manufacture and you can just manufacture it and start selling it.
Yes.
Do you believe in that, or do you want to take it forward like that?
Yeah, I've not really thought about it that way. I'm very young right now, but yeah, definitely with the right guidance and with some advice from the seniors, maybe I'll look forward to that too soon.
Yeah, I think everybody in Arvind is right now into innovation.
Yeah.
Venkatesh sir can help you, and even Dr. Prithvi is there to help you. So I think you can take it forward with and hope to see it in market very soon. Thank you so much for this innovative talk. So moving on, because we have slightly running behind, I would like to invite Dr. John Davis Akara. He is an innovator par excellence, and he is one perpetual innovator, I think, because every day if he doesn't innovate something, he can't sleep. So I would welcome him. He is working right now as a glaucoma consultant in SRHC, I think. So I am. SRMC and West End Eye Hospital, Cochin, and I don't think anybody needs sir needs any introduction to anybody. So sir, stage is all yours. Looking forward to your three.
Thank you, Nilesh. Thank you so much for the kind introduction. I would like to thank AIOS and YOSI for organizing such events. This is a very useful platform for all the youngsters who never knew what all are the possibilities in ophthalmology. So very, very much thankful that we are having such a platform. Is my screen visible?
Yes, sir.
Okay. So I'm going to talk about my first 3D print. I'm Dr. John Davis Akara, and I'm working as a glaucoma consultant in Sri Ramachandra Medical College, Chennai, and also Western Eye Hospital, Cochin. I think many of you must be familiar with 3D printing by now. There has been a lot of innovation in 3D printing in the past few years. They are 3D printing even houses. So making a three-dimensional solid object from a digital file is the simplest definition of a 3D print. So if you see on the right here, this is a filament-based 3D printer, which is printing a model of a hand. And it is made by laying down layer after layer of the material. So this is the basic principle. This can be done in plastic, resin, metal, concrete, even ice cream or chocolate, all these things. These are the two most common, easily accessible 3D printers. This is a filament-based printer, also known as an FDM printer, fused deposit modeling. And this is the one which I'm going to be talking about. This is the one which most people are familiar with. Also, I recently used resin printers, which is also not difficult to find, and it is available very easily in Amazon and everywhere. It costs around 30,000. This one, this is more expensive, but cheaper ones are also available around 20,000. You can get the low-end models. So if you want to get started with 3D printing, what you need to do is the fastest way is to just download and print. So if you go to MakerBot Thingiverse, this is where I started from, or if you go to National Institute of Health 3D Print Exchange, you get medical related 3D models, or so many websites, Free 3D, NASA has a 3D page. All these places allow you to download and print your own 3D models designed by other people and shared. You can also design your own 3D models by using these softwares. Many of them are free. FreeCAD, Fusion 360, Tinkercad, SketchUp, all these are free softwares. So you can just go to this website, search for what you want. If you find something interesting, download and print. As simple as that. This is one of the ophthalmic designs. This is from ODocs. This is from an ophthalmologist in New Zealand. He designed it and uploaded it on Thingiverse back in 2015. So this is something which anybody can download and print. If you want to design, you can go to tinkercad.com, do it online, or you can download Fusion 360. If you want a free version, just provide them with an .edu email address. Or you could use FreeCAD, which is what I used. So this is FreeCAD. And recently I designed a glaucoma valve. I had made a design for a 3D printed glaucoma valve, and it was done using FreeCAD. And this is a design for a forceps. So if you have any idea for any instrument or anything like that, just think it, draw it, and just draw it in 3D. You can prototype it. This is the workflow of 3D printing. First, you design in CAD or you can download, export as STL or step files, and use a slicer software. All these are free software, and it generates the supports. So if you see this, the empty spaces have to be filled in with something which can be broken away, that is support. Generate the G code, send it to the printer, and the printer will print it like this, layer by layer. It might take between 30 minutes to 30 hours, depending on the size of the print and the fineness at which you are printing. So once you print it, you can remove it, break off the supports. That is the base. You break it off from the base, and then you remove the supports. Okay, you might have to break off the supports with some force if it is such a print, but then you are ready. This is what I printed first in Arvind Eye Hospital, Pondicherry, because of Dr. Rangaraj Venkatesh sir. We got a 3D printer just before I finished my fellowship. So the first thing which we printed there was this smartphone fundus camera. The very next day was the hospital day, so we printed it and presented it to the chief guest on the hospital day. This is how we could take fundus photos with the device. This is another thing which I printed while I was in Ramchandra. I was working on a device, a head-mounted device. So this is a case into which we put all the electronics of the Raspberry Pi and ultrasonic sensors. So this case I designed and printed here. This is the glaucoma drainage device which I had designed and printed. And this is a slit lamp adapter Dr. Ahmed Ataya had designed. This is an Egyptian ophthalmologist. So the basic thing is you measure, draw it in 3D, print it, and this becomes a slit lamp adapter, smartphone slit lamp adapter. There are several other things which we printed. So this is a spectacle. This is a eye drop helper by Dr. Annamalai and Dr. Shivagami, and so many other adapters. I have put all this together in an article in Kerala Journal of Ophthalmology. And if you look, there are so many other things which you can do in ophthalmology with 3D printing. This is just some of the things: spectacles, lenses, even moisture chambers. So all these personalized things are ideal things that can be done with 3D printing because they can be customized. So eye model for fundus viewing. This is one model. Dr. Rajesh Vedachalam here, he has also designed some 3D printed models of eyeball for practicing examination and even vitreoretinal surgeries. This is also available for orbital dissections. And these things which are being sold in retail by this company, Bionico, they are also supposed to be 3D printed models. And there are surgeons who say they have designed forceps and other instruments with the help of 3D printing for prototyping. You can even 3D print in metal if the need arises. This is a transconjunctival vitrectomy trocar, which was initially designed with 3D printing. This is Dr. Sergio Canabrava. He said he designed the Canabrava ring using 3D printing initially. This is a glide, a smart storage glide for DSEC. This is another 3D print artificial anterior chamber. Dr. Rajesh Vedachalam has made this. And for anterior segment imaging, an attachment was made this is the same doctor who made the Odox fundus. And this is the one which we printed from Xiongchang. And this is another one. This was designed by Dr. Ahmed Ataya. And all these things have been designed by people who had not much experience in engineering. So this is a 16-year-old girl who designed this smartphone fundus camera. So everything is simple. All these things you can simply draw. If you have an artistic eye, you can do it. 3D printed prosthetic eyes are also available. You can, take a CT scan and use that to make the appropriate size and shape devices. So all these orbital implants for children, 3D printing has a big role to play. And not last but not least, bioprinting is going to come up in a big way because then you can 3D print the cornea. There have been multiple researchers working on this. And so that is going to be the very close future. Thank you to all the institutions where I have studied and where I have been given the opportunity to practice all these extracurricular activities in ophthalmology as well. Thank you.
Thank you so much, sir. I think, again, a bunch of innovations and a bunch of new ideas that you have given to all the innovators. I think 3D printed renal implant has already happened, or 3D printed skin grafting, something like that has already
3D printed skin grafting has happened. So that is basically bioprinting a layer onto the skin. So that's also very useful.
So cornea is not much behind. We might have artificial cornea and get over.
They have done prototypes, but still working on the transparency. It's difficult to print transparent things.
So I just wanted to ask, all these prototypes that are at least coming from you and your associate institutes, are they available? Can somebody access them if they want to print it at their own setup?
So I have started uploading them to the website. So Thingiverse, I have uploaded on Thingiverse as Dr. Jonda. So you can go to thingiverse.com and find it on the website.
Okay, sir. So it would be great if you can share it on the YOSI groups also. So
Yes, absolutely. So I've just started uploading. This is the glaucoma drainage device. I will upload the other designs also here. So I'll send the link as well.
Yes, sir.
Dr. John.
Thank you so much, sir. Thank you so much. So we will move ahead due to scarcity of time. The next speaker will be Dr. Sagnik Sen. Dr. Sagnik is a research fellow right now in. So just a minute, I lost the intro. Dr. Sagnik has completed his specialist training in ophthalmology from AIMS, RPC, and now is working as clinical research fellow in VR at Arvind Madurai. And he is an avid surgeon and actively interested in clinical and translational research. So he has a strong advocate for diabetic retinopathy and myopia awareness, and we are looking forward to his talk on the non-capillary perfusion areas and the reclassification of diabetic retinopathy. So over to you, Dr. Sagnik. Looking forward to your talk.
Hi, sir. Thank you for the introduction. Can you hear me?
Yeah, we can hear you. We can't see the screen.
Yeah, I'll just share it. Yeah, can you see the screen?
Yeah.
Okay, so I thought I'll bring an interesting topic today for discussion. So today is about reclassification of diabetic retinopathy with a focus on capillary non-perfusion. So as you all know, that the International Clinical Diabetic Retinopathy Disease Severity Scale has divided diabetic retinopathy in these 5 stages, which are no apparent retinopathy, mild, moderate, severe, NPDR, and proliferative diabetic retinopathy. This is like every resident which is passing out of a medical school, they know this classification. So this classification was based on the diabetic retinopathy severity score, which was decided in the Airlie House meeting in Virginia in 1968. So that was 54 years old. And the classification was based on 7-field stereoscopic film-based fundus photographs. However, later on it was realized that the 7-field photograph was almost equivalent to a 4 wide-field digital photographs that we use today. So this is just an overview of the classification. Mild to moderate NPDR was levels 35-43 on ATDRS DRSS score, which included intraretinal microvascular abnormalities, hemorrhages, microaneurysms. Levels 47-53 were moderately severe to severe NPDR. Again, patients would have intraretinal hemorrhages which were more severe and including all the quadrants, then venous bleeding, intraretinal microvascular abnormalities, lipid exudates. And 60-75 would be moderately severe to severe PDR, where we'll have neovascularization. This is again another infographic. So the DRSS score would range from 10 to 12 up to 85. So below 47, the previous scores would be subclinical DR. And 47 to 85 onwards, we'll have moderately severe to severe NPDR, then mild moderate PDR, and high risk PDR. So as you know that the conventional treatment strategies for PDR is panretinal photocoagulation. And for diabetic macular edema, it has been anti-VEGF. But nowadays, we are getting a lot of studies which have started evaluating anti-VEGFs for DR itself. So these are some of the later studies from Beetham Eye Center, Jocelyn. So they started evaluating more peripheral retinal lesions on ultra-wide field color fundus photographs like optos. And they said that peripheral retinal lesions could better predict the risk of DR than conventional ETDRS photographs. So this ETDR is 7 standard fields you can see in the center, and these are the peripheral fields. So they divided lesions into predominantly central lesions and predominantly peripheral lesions. And Later on, they also measured the capillary non-perfusion on ultra-wide field fluorescein angiography, and they found that DR peripheral lesions were associated with the severity of diabetic retinopathy. So in this chart, you can see that as we progress from no DR to PDR, the diabetic non-perfusion index is correlating quite well with the severity of DR. Here you can see wide field angiography photographs, which are showing peripheral neovascularizations quite well. And here you can see in the right side photograph, you can see comparison of fluorescein angiography and non-dye-based OCTA, wide field OCTA. You can see in both the photographs that the OCTA picture is showing us the capillary layer a little bit better than fluorescein angiography. Then the DAVE trial came, which evaluated total retinal non-perfusion, and they found that non-perfusion was greatest in the mid-peripheral retina. And they also evaluated that capillary non-perfusion was correlated well with vascular leakage in all three retinal zones. So coming to the role of OCT angiography in all of this. OCT angiography is able to image retinal vasculature with different retinal layers at resolutions which are not possible with fluorescein angiography. And as we all know that OCTA cannot demonstrate leakage, but it's a benefit for us because it allows the imaging of capillary non-perfusion better, which may be masked by leakage. And OCTA also is more reliable for correlations between DME and biomarkers of interest, including non-perfusion. So this is one paper which we did. This was an exploratory review article on diabetic macular ischemia and diabetic macular edema development. So we can see that diabetic macular edema develops as diabetic macular ischemia first. So non-perfusion appears first, leading to breakdown of blood retinal barrier, leading to superficial capillary loss, deep capillary plexus loss, and finally, what we see is diabetic macular edema. Coming to role of anti-VEGFs, as we all know that anti-VEGF blockade has been used to reduce retinal edema. So VEGF blockade is also being proposed to help reverse the progressive capillary non-perfusion development which happens in DR. Coming to RISE-RIGHT studies, their post-hoc analysis, all of them showed that capillary non-perfusion can be prevented with VEGF blockade. These are some of the studies which have shown that use of anti-VEGF can prevent development of non-perfusion. So these are some prospective clinical trials in PDR, like DRCR protocol S, Clarity trial, which have been done in PDR, and prospective clinical trials also have been done in NPDR, which are protocol W and Panorama trial. So these are all evaluating clinical outcomes of anti-VEGFs in DR, and a lot of them have evaluated capillary non-perfusion. So a patient of high risk PDR, you can see, has undergone 9 injections of anti-VEGF. Patient has progressed to mild NPDR, regressed to mild NPDR, and has stayed stable over year 2. Similarly, this patient also had high risk PDR and has regressed to mild NPDR. This patient had moderately severe NPDR, level 47, which has reduced to level 20 after 2 years. And another patient who was at severe NPDR stage had reduced to mild NPDR. Again, repeated anti-VEGF injections have been shown. So they have evaluated ranibizumab in this graph. And we can see that with ranibizumab, the DR progression, the levels of DR progression is also stabilized. So DR has not progressed compared to sham. And there are a lot of new therapies which are coming, which are specifically targeting non-perfusion, like semaphorins. So semaphorins, they are neuronal guidance proteins, which are involved in a wide variety of signaling pathways, and they increase the vascular permeability in the retina. So the way ahead is to develop an integrated DR classification with clinically detectable peripheral lesions, angiographic features, and also including the macular status. So in this infographic, you can see that so we can use clinical photograph for detecting microaneurysms, hard exudates, irmas, which are included in the conventional classification. Then on this arm, we can have diabetic macular edema and diabetic macular ischemia, the severity. And with that, we have to correlate capillary non-perfusion, probably with either ultrawide field fundus fluorescein angiography, or we can include ultrawide OCTA, which is coming up. DR classification needs to somehow take into account the treatment effects of patients receiving repeated anti-VEGFs. For example, if a patient has received anti-VEGF and has regressed to mild NPDR, this mild NPDR is not similar to an untreated mild NPDR patient. So we need to include that as well in the classification. So we need to differentiate between treated DR grade and non-treated DR grade. Again, in this endeavor, artificial intelligence and machine learning based platforms can help in the integration. And we need to finally incorporate newer biomarkers which can be used in next generation clinical trials, because we are having newer drugs which are coming up every day apart from anti-VEGFs, which can help in reducing non-perfusion, for example. Thank you so much.
Thank you so much, Dr. Sagnik. And I really thank you to finish within time because we are running short. So I just have a quick question for you. What do you think is the real practicality of using OCT angiography for peripheral, the far periphery, mid periphery and far periphery?
So that will be very difficult to say because wide field OCT has not come into practice as of now. Just the papers have started coming from Joslin Eye Center, Cleveland Clinic, and MEI. So they have started evaluating how peripheral leakage index and peripheral neovascularization, they can be imaged well with wide field OCT, and how that correlates well with visual acuity and progression of DR. So we don't have the studies yet. Probably the next 5 to 10 years, we are going to have wide field OCT open in the market. As of now, we are still evaluating macular status.
So currently, it will be better if we do a wide field FFA and then evaluate.
Yeah, exactly. So we have UWFA. Now wide field FA we have. So FA can be done.
Okay.
Like Optos, the higher versions of Optos has FA.
Okay.
And I think it's still in the research level. I mean, practical, in the clinic, wide field FA, it's not really done to evaluate peripheral CNP areas and then correlate it with the patient progression. But yeah, it is definitely used for titrating panretinal photocoagulation if a patient has adequately got PRP done or not, and targeted non-perfusion areas can be lasered. For example, in CR views and BR views also that is done. That is being used.
Thank you. Thank you so much, Dr. Sagnik, for this wonderful talk. Looking forward for more. Now I'd like to invite Dr. Sumit Grover, sir. Sir is an ophthalmologist academician and a public health professional with credentials that are highly admirable. He is a DNB Opthal MBA and then MPH from London and then FICO, and he is currently working as a PhD scholar in community ophthalmology at AIMS. And now we are going to hear from Sir. Sir also has an NGO non-for-profit organization for community eye, that is Mantra Healthcare Foundation. So looking forward to your talk, sir. Sir, we are not able to hear you.
Sorry, I think I was on mute.
Yeah.
Yeah, now it's now I'm audible.
Yes, sir. Audible and slides are visible.
To you? Yeah. Yeah. Thank you so much. Thank you. Before not wasting too much time, from my talk will not be so much innovative, but definitely I had a very trailblazer journey in the field of community eye care, full of risk and perks, challenges and opportunities. The scope of my discussion today will be the recent advances in primary eye care and how we leverage the technology in enabling the diagnostic and data solutions for primary care. So back to the basics, primary eye care is the provision of appropriate, accessible and affordable care, which lead to a comprehensive and competent, giving a comprehensive and competent eye care needs to the patients. And also it is the first contact for eye care for the patient and also in the continuum journey of his lifetime. The primary eye care should be integrated and should be coordinated with the general healthcare services. Like, for example, our NPCB or the eye care services should be coordinated and integrated with the National Health Mission, with the primary health centers, community health centers to make it more efficient. And we should be very competent, and there should be a managerial skill and a decision-making skill for these are all critical things for promoting the quality and efficiency in primary eye care. If we see the concept of primary eye care, the left-hand side, leftmost side showing the eye disease, the in between is activity, which consists of the primary, secondary and tertiary prevention. And these all types of service deliveries are possible in primary eye care, not only the preventive and promotion. And we can see the stakeholders on the right-hand side. I'm always amazed to see the stakeholders right from the community leaders, school teachers, nurses, primary healthcare workers, optometrists, ophthalmic technicians in the field of community eye care, and not only the ophthalmologists and optometrists. There are various models of primary eye care. The heart is the vision centers, which are defined as the permanent fixed facility, first point of contact with the community, and equipped with all the equipments which are needed for the primary evaluation, especially the refraction for the patients. They can be fixed facilities, mobile units, integrated, standalone, or mobile with or without teleophthalmology. So this is the talk for intended for the all the young ophthalmologists who wanted to, who want to come into the arena of community outreach and reach-in program, and those who want to, live a life of a, both. They want to, balance their self-serving goals, professional goals, and the altruistic goals, in a way that how they can start the community outreach, how can they do the reach-in programs in their group practice, solo practice, or if they are part of any eye care hospital, etc. So I'll start with the quote of Helen Keller, who said that the only thing worse than being blind is having sight but no vision. The other worst thing is having a good number of tertiary centers but no vision centers in our country. This is the state of affairs in which we can see the central obesity of the pyramid. Central obesity is always not good. So we have to see the by 2020 we should have more than 20,000, around 20,000 vision centers, but now we are lagging. We have just 4,000. And this slide is more of a theoretical slide, which the data has been, extrapolated from the various surveys and prevalences of various eye disease to come up to the need. We always say that vision center caters to a population of 50,000, and these are the estimates of eye care needs of these 50,000 population, and we see almost 25% of them need any form of eye care services. So this is the main, I think, the slide of this whole presentation, which shows the hub and spoke model, in which the hub is us, we, young ophthalmologists. Any base hospital, it could be RP Center, it could be Guru Nanak Eye Center, it could be your private practice hospital, something, a base hospital with all facilities of surgical and medical intervention. And spokes are the vision centers. Vision center, as discussed earlier, can be fixed, mobile van, health and wellness school. You had tie-up with schools, you have tie-up with primary health centers. And the human resources we need is the optometrist, ophthalmic assistant, trained nurse, your optometrist, and ASHA workers, trained ASHA workers, or even a school trained school teacher who has been trained in taking the vision and referring the students. This model has been a very cost-effective model, and has been, it has been used in various parts of our country as well as around the globe. Our strategy of Vision Center has been guided by the National Program for Control of Blindness, and these are some list has been given by NPCB, that these are some essential equipment which has to be there in a vision center, and there are some desirable which are may or may not be, but are desirable. So the two things always, have been a barrier for starting community outreach. First, how to take the equipments of your fixed facility center to the field in the community, and second is the data. So for the first barrier, we can see that now there are many portable slit lamps, portable fundus auto refractometer, and we have just seen the presentation of Dr. John Davis, that he can make everything. I mean, out of 3D printing. Mobile, he makes use of mobile to, take the fundus photo and anything. So we have to be very innovative, and all these auto refractometers, tono pen, portable visual field analyzer, these are all real pictures, real-time pictures taken in our department, and the NGO I'm associated with uses all these portable devices. Previously, we used to, take a mobile van, or we have to, think about the transport logistic, but now everything, packs up in a small briefcase. This is the community eye care initiative, which was started by RP Center in association with Stride Savers. And we all use all these portable slit lamp, portable handheld auto refractometers. And right now, currently, there are more than 20 vision centers, which are spokes with the hub of RP Center. Another thing which I personally have suffered in my journey of community eye care was the data management. I suffered a lot in this because since 2013 I was involved in many outreach camps, but the like in the name of data, what I had were the newspaper cuttings, were some registers having the name and demographic details of the patients, and some pictures or videos, but nobody cares about that. We cannot generate any evidence, you cannot publish that. So the main lacuna I had in my own practice was the data. And now there are innovations in this data collection also. It's very feasible because we are the busy clinician. You guys are the busy in your tertiary care centers. You don't have time to feed the data in the data app or something. So here is an open data kit. It's an open Android based source Android app, which is designed to work without network connectivity, which is the main advantage of this. You can use it in fields where there is no network available, and it collects supports of location, audio, images, video, barcodes, anything, free text, multiple choice. You can make a custom made form and upload and link that form to their server, and then start collecting the data. We are using all these entry forms in RP Center as well as the various NGOs I'm associated with. This is the example of a daily report. With daily PEC report, you can see that it can show us how many old cases were there, how many new cases were there, how many spectacles were prescribed, booked, and how many were referred. This was the custom-made list of diagnosis which we have fed in the form and linked that form to the server. And it just takes 5 minutes for an optometrist to fill in all these details, or even a data entry operator, which is not much technically qualified, can in liaison with the ophthalmic assistant, can fill the form. Second, this is a form of diabetic retinopathy screening, which is being also done in the vision centers associated with RP Center. We can see the NSC classification. This form has been designed, and operators who see with the funds form in 5 minutes. And when this data is retrieved from the server, it can be downloaded in the form of Excel, and you can make beautiful graphs and all things in just you make an enter, and all these data comes up beautifully in the form of graphs and diagrams. Health education talks which have been done, topic, number of participants. Now this data app is also used for the reach-in program, that how many patients reported to your base center, the hub, and how many got cataract, and how many were admitted for the cataract, and what were the reasons for not getting admitted for the surgery. So all these details can be, you can frame the forms like that, and these data can be retrieved very easily. In fact, the cataract surgery outcomes for the monitoring and evaluation in the form of outcomes in the form of visual acuity can also be done. You can, if in this you can see that this column shows the presenting visual acuity, surgery date, and which I was operated in, post-operative visual acuity. And in the previous slide, we can see that even the cause of the post-operative visual acuity, poor visual outcome, were stated by the staff which was present in the post-op follow-up. And due data follow-up also can be fed in the forms, and even the reminders messages are also given to the patients. I'll not go in depth into the artificial intelligence. In this elite gathering, there are many stalwarts, but I just want to reinforce the importance of diabetic AI in field of diabetic retinopathy. Remedio has come up with many softwares which has an inbuilt AI, and which differentiate that this is DR, not DR, and same with the plus disease in ROP, ARMD, and glaucoma diagnostics as well. And another thing, just one slide about the teleophthalmology. We all know teleophthalmology, but just one slide, the success story of the Tripura Vision Center project. I think this project all inspires us all, that the small northeastern state, and if we see the statistics in year 2007-8, only 3,000 patients were referred to the but the toll of the patient, while it becomes around 90,000 in 2015-16, and the cataract referrals, we can see they all shooted up after the uses of this teleophthalmology practice. So we all can start our own community outreach, community reach-in program by using these portable equipment, by using these freely available open data kits which are available, and we can make a custom-made form according to our needs and this thing. Another thing, this is not something philosophical. All these which I have told or discussed, this is all evidence-based, that the use of technology enable us, for the delivery of low cost and quality eye care at the community level in 3 ways. First is the remote screening and diagnosis. Second, the real-time delivery of the treatment on the spot. And third is the monitoring of continued care. Thank you so much. I would like to acknowledge Dr. Praveen Vashisht, our in charge of community ophthalmology, in making of this presentation. Thank you so much.
Thank you so much, sir. I think it was a really wonderful talk, and due to lack of time, we can't discuss actually too much. But I think it requires a separate session in itself to train everybody, young ophthalmologists in community outreach program. It can't be done in a discussion over 2 to 3 minutes. So I urge YOSI to provide us a bigger time segment for community ophthalmology. Over to Apurva ma'am for wrapping up the session.
Thank you, Nilesh, for moderating it so well. Thank you, Dr. Sumit. I think you're one of the foremost young ophthalmologists who's doing this work, and one of the few who's actually done a master's in public health. So Dr. Namrata has been with us for the entire session. Ma'am, would you like to give some final comments?
I think ma'am just logged out. She's away, I think. Ma'am, you are, Apurva, you are on mute.
So without further ado, let me begin with the next session. Thanks a lot to the speakers of Innovators and Trailblazers session. So our next session is how to avoid a premature midlife crisis. So it's basically pertinent because most of us, although are less than 40 years, are I feel aging faster than our predecessors. So I think we are at the crossroads of either falling into the trap of being digitally addicted to screens, to social media, and not being in the moment. So all this has added to a lot of stress, anxiety, a lot of premature thinking about what life is, and some personal crisis that is happening, which is a lot more than our previous generations. And this session is also about how to go beyond just ophthalmology. So in this session, we have talks ranging from thinking beyond ophthalmology in terms of administrative jobs, in terms of de-stressing, in terms of nurturing hobbies, in terms of managing time and productivity, and lastly, having an influence in the social media sphere in the form of being influencers or even entrepreneurship. So let me call upon the first speaker, Dr. Sayantan Ghosh. Is he here?
Yes, I am here.
Yes. So Dr. Sayantan Ghosh, it's my pleasure to introduce him. He is MS Ophthalmology, Diploma in Ophthalmology. He's got a Master's in Political Science and International Relations. He's got a Diploma in International Law. He's the awardee of the Build Grant. He has stood 7th in the State Civil Service. He's cracked the UPSC, and was able to get into IPS, but then he's chosen our stream and he's at present the medical officer cum tutor at the Calcutta National Medical College. So it's our pleasure to have you here, Doctor, and we are really looking forward to your talk on administrative jobs.
Is my screen visible?
Yes.
A very good afternoon, or rather good evening to everybody here. So my talk is on administrative job, dream big. So I wanted to have an interactive session. So may I have an interactive session? It won't take long.
Absolutely.
Then
Absolutely. Absolutely.
Thank you. So would anybody volunteer? What is the idea about administrative job in 2-3 lines? What is an administrative job? What do we understand by that? Okay, come
Maybe
to the definition.
taking on some administrative capability in your.
So what is administration? Administration is nothing like being the superintendent of an hospital or being the superintendent of an office, be the supervisor. This is administration, isn't that? So first, coming to the definitions, what is administrative job? This administration include both public and private sphere. So in administration, in the public sphere, we can tell that this is the Indian civil service. I know this is a very famous picture in many forms. This ambassador, this red board, and this man signifies the Indian administrative service. And this is another administration, right? In the backdrop of North Block, this is the convoy of a political leader. So what is this? This is again administrative job, but this is from politics, the point of view of a politics. So if we summarize what is the administrative job, in public sector, it has two parts. One is Indian civil service or any kind of civil servants. Another is politics. One is legislature, one is politics. So this is legislature and this is politics. Both comes under the administrative job. So are we going to the 40s? Why should we be interested in administrative job? What are the prospects are we having in this kind of job? And are they cover the insecurities we are going to have after the 40s? Coming to the civil service. This man, probably you have seen this man. This is Roman Saini. He is from AIOS. He has done. He has the job rank of 13 in UPSC 2014 or 15. This is Arjun Goda. He has the rank of, if I'm not wrong, 213 in UPSC civil service. He is IS in Manipur. He's a doctor. He's a doctor from Chennai. So what are the pros in the civil service, a kind of administration job? We roughly know about civil service, right? It's DM, IPS or IRS or Indian Corporate Administration Service, Indian Revenue Service, Railway Service. All these services comes under civil service. What are the pros? Pros about the civil service. It gives you recognition. Even after 60, you will be recognized as an important person. The car will every day come to you to pick you up. This will respect. The people will respect in your office, probably in your district. Or if you can reach the higher ranks than in a state, have even more higher ranks in country, we will respect. Shoshikanto Das, if you can really remember, he is now put into the finance ministry, right? So he is a revered figure in all around the world. Why can't we dream being like them? Even being a doctor, we can go to the Arjun Goda can one day he can be the speaker. He can be the finance secretary. So there is a career progression which is assured, time bound, and the power comes with these pros. What are the cons? There is uncertainty. There is definitely uncertainty in any kind of job, but the civil service is not without uncertainty. So we will see some people have progressed regularly with time, and some people have failed to do that. It's time taking. Definitely, it's time taking. The basic ranks of civil service takes around 5 to 10 years. So after only 10 years, so 7 to 10 years, you can be district magistrate, the basic rank of any civil service. Then there will be political obligations vis-a-vis a freelancer surgeon. If I'm a freelancer surgeon, I can go to any hospital. I can do surgery. I can, if I want, I can skip surgeries. I can just stay at home. And the income, yes, there will be limits. There will be limits in income if you are a civil servant. Coming back to this Roman Saini, what did he do? He had a fine rank and he left the job. He left the job after he's a surgeon. He's the MBBS from AIOS. He left the job after 2 years. He started his own academy, an academy, You must have heard about An Academy. That's his entrepreneurship. That's a different topic altogether. Coming to the politics, Mr. Harshvardhan, he's our health minister, right? So he's a doctor as well as he is a politician. He started his career in 1960s as an ENT surgeon. Then he went into philanthropic job and finally joined politics. So our health minister is a politician. Can't we dream like that? Can't we dream the ranks of being there, doing something good for the people? What are the pros of being in politics? The power, every time this administration gives you the test of power, is the easy ride, and is the experience with the human handling. We do have the experience with human handling, be it at the private sector, be it the public sector. We definitely deal with people. So we know how to deal with people. That comes handy, quite handy in politics. And specialized skill set. We have two kinds of skill set, physical as well as mental. What is mental skill set? We know that before the MBBS or before the MS final exam, we have to study, otherwise we will fail. So we can take the pressure out. And what is the physical skill set we have? We can do surgeries. So even after being a surgeon, even after being a politician, you can go to the hospital and you can do surgeries to show that this skill is still available with you. What is the ultimate definition of power and money? Is definitely this man. I mean, this man symbolizes the situation of power and money. Now, this money is, yes, a little bit debatabilities, but whatever, it comes with money. There are chances to work. Although this is just a small point at the end, but theoretically speaking, this is the thing that should attract you. If you don't have this thing in your mind, then please don't go to the administrative job or politics. What are the cons? There are huge competition. Dynastic politics is going on everywhere, and huge competition is going on. Not so clean image. You will lose the clean image of being a doctor. And public perception is very short-lived. One day they will put in the king's position, and the next day they will put in the bottom. It's swinging in the nature. That's the biggest problem. In politics, one day the party will carry you in the higher ranks. The next day it will throw you off. So it may be the situation of a king of a one day, and slow rise to the top. So there are many studies like median age of Indian policymakers at the top would be more than 45. So this is a slow rise to the top. But we are altogether, this talk is about after 40, right? Then comparison with the conventional career of eye surgeon. What is the conventional career of a MSDO, DNB or fellowship, an eye surgeon, right? So in a private sector, he or she will start with a junior consultant post. In a government sector, he or she will start with a resident. Then assistant professor, associate professor or professor, head of the department, principal, director of medical education, head of the institution, start of an institution or chain, and in between senior consultant or segmental head. The last point is head of the institution or head of the department. Yes, they are kind of principal or DME. This comes with a kind of an administrative job, but it's intermixed with being a doctor. It's not purely administrative job. Although this principal or director of medical education has the rank of a secretary to a government. So it's kind of a administrative job. The problem with this is that very few people reach the top of this pyramid. Mostly retire at this phase, in the middle phase. So money, the basic thing that counts is the money. It's the foundation of everything. We have to accept the money is the foundation of everything. So start at the base. My figures are just indicative. Please don't get provoked by them or angry with that. So in the government, we start at the lower situation. In a private, a little bit higher situation, and the top of the private is quite high compared to the government. So in the basic junior consultancy, it is around 70K to 1,40,000, where it is 1,50,000. And in the mid-career zone, so 45 to 50 or above 50, it will be around more than 6 lakhs per month. This is all in per month basis. More than 6 lakhs you can expect after 45, but that would be hardly more than 2 lakhs in the government sector. And finally, you settle down at 3 lakhs, and whereas more than 10 lakhs in private sector. So what the public sector gives you? It gives you respect in the public sphere. If you are appointed in a medical college, it comes with a respect clause, right? Next, teaching. If you love teaching as a passion, it definitely comes with the government sector, especially being this professor, associate professor, whatever you want. Next, the public service. So if you're in the public sector, actually you are doing the public service. So ethics is over-talked. I think it's the overhyped thing for all of us professionals. But public service is kind of a thing that should be the basic string of our all encouraging, all inspirations. And that should be the underflow. And that is there in the public sphere. And income increases with the private practice, although this is a debatable topic, because to handle both the official job as a government servant as well as keeping up with the practice is not so easy, and it's difficult to handle. What is in the private sector? There is no upper limit for the income. Money is, there is no upper limit. We all know that. The independence, that is huge a factor. That's a very huge factor. You have the independence of doing your whatever you want to. That is not there in the public sector. Then again, the subspecialty service is more developed in the public sector. So is it dreaming big? If you talk about the normal conventional career services, is it dreaming big? All this private sector job or public sector job, junior consultancy, HOD kind of a thing, principal. Can you tell me what is this? Anybody of you? What is the relevance of this term? Anybody, please? Okay, it is Niti Aayog.
The Planning Commission, National Planning Commission.
Yeah, NPC has been replaced by Niti Aayog. Can you ever imagine that you can have a job at Niti Aayog if you are in the administration? MCI, it has been replaced by right now NMC. Can you have a job at NMC after being an eye surgeon? This is our administrative job block at New Delhi. This is the north block in the right and south block in the left. Can we have a job at that building? And this man, I think everybody knows, right? Please, anybody?
Yeah, our foreign minister.
Jai Shankar. So can we have a job like him as Jai Shankar? Politics or civil service are the best baby steps to have the jobs like here. Coming to them one by one. This Niti Aayog, it has a post of assistant director. It has a post of members. So what are these members taken for? These members are taken from the persons of having kind of a educational qualification just like us, but with an added feather, with an experience in the administration. It can be administration of public service. It can be an administration of a corporate service, but has to have an administrative experience to get an appointment at Niti Aayog. So in Niti Aayog, you will decide the basic framework of planning of Indian government's future 5 or 10 years. So you can have an impact over India in progress. This NMC, there are so many controversies are going on with MCI to NMC conversion. There are so many controversies with NEET PG, the exit exam, the next exam coming, right? Can't you think of a position of yourself where you can be at that seat, where you decide what is right, what is wrong? We are all, critics of the system, but can't we be in the system and criticize the system from inside outwards? We can be there, but for that, we need to join this administrative service in any kind, join politics. Or if you have the still age limit under your career, then go for Indian civil service, go for state civil service, why not? And this North Block and South Block, both this politics and civil service leads you to here, this North Block and South Block. And this foreign affairs, it's a huge payment, hugely paying job. If you are coming from the civil service, the parks of the compensation around it's 12 lakhs, 10 to 12 lakhs at least for any country. You will get the compensation because you are working in the foreign countries. So 10 to 12 lakhs for at least one.
You need to wrap up fast, please.
And this service gives you immense amount of respect. So dream bigger. Can we dream bigger? So this is a WHO headquarters. This is World Economic Forum, and this is the World Parliament at WHO. Can't we reach there through administrative job? Yes. All three actually gives appointment to doctors, but they need to have a background of an administration or community ophthalmology. So what is the comparison between income, effort, and time? The civil service gives you around maximum income of 2.24 lakhs plus parks. IFS and ISS get more parks. And effort is absolute exclusion. It's absolute exclusion, just like NEET PG. And median is 3.9 years. It's a survey data. In politics, there is no limit as long as Office of Profit Laws is not violated. It's a full-time job. requires learning by experience. Don't take politics as a side-time job. It's not a side-arm, right? And there is no limit and no such study is there. How long do you require? Then the corporate administration is another term for administration, but it's a topic of a different talk, probably food for thought. So it's MBA requires after post-graduation, and individual entrepreneurship can be started. There are so many schemes available, so many fundings available. Administration in hospital administration in other fields. Even I know a few doctors who are actually working in Goldman and Sachs. Why is this image? To conclude, whatever we be in administration or be in public service, be in private service, let's not forget our roots. This is what we come from, right? This is the Bharat. This is not India. This is Bharat. And we all are Bharatvasi. So let's keep it in mind. Wherever we go, whatever we do, we shouldn't forget this image, right? There is another India living with us. And we have some responsibility to do that. And probably coming into administration will help them better to progress. Thank you. Thank you so much.
Thank you, Dr. Ghosh. Any questions from anyone? I think it was slightly longer talk, so we'll have the questions at the end. Next speaker is Dr. Arnav Saroya. He is a third-year postgraduate resident at Ambala, and he's got a few publications in international journals, and he's given faculty talks at various conferences. So Arnav could not be here, so I'll be playing his talk. He sent us his video. So I'll just share his video here. Yeah.
A very warm good evening, everyone. At the outset, I would like to thank the entire team of the All India Ophthalmic Society and the Young Ophthalmic Society of India to give me this opportunity to talk at the AIOS-YOSI Forum 2022. My topic for today's talk is laying stress on de-stressing. According to a survey published in the Indian Journal of Psychiatry, as many as 30% of doctors in India are suffering from depression, while 17% of them have even thought of committing suicide. This is not a very great start to the talk, but this is the bitter truth. Reasons for the meltdown among doctors could be many. Before they graduate to become registered doctors, doctors undergo an
Apurva, we can't hear anything because you have gone on mute. Apurva, you need to unmute yourself.
Yeah.
And seeing trauma from close quarters is not an easy job. This predisposes the healthcare professionals to the condition of being diseased. Among medical students, which eventually deteriorates their academic performance, and at the same time predisposes these individuals to the risk of substance abuse. This causes attrition from the profession, inability to maintain an effective doctor-patient relationship, failure to establish healthy interpersonal relationships, suicidal thoughts, despondency, feeling of worthlessness, and even guilt, which may cause further complications that eventually creep up over the years. In the long run, they end up contributing to the failure of the entire healthcare system in the country. In a country like India, where we have such a competitive atmosphere, and I, coming from a city called Kota, which is called the education hub, students are subjected to a lot of competition, pressure, which causes a lot of stress. According to a recent study, which is published by the National Institute of Mental Health and Neurosciences, 1 in every 5 teenagers in India faces some sort of mental illness. Other factors which contribute to this include the parental pressure, the peer pressure, fear of failure, and irregular sleeping patterns because of the rigorous study curriculum. Growing competition and performance pressure is turning these Indian students the victims of stress, which is truer for those appearing for multiple competitive exams. Starting from undergraduation to post-graduation, the disparity in the seats and the number of students appearing for these examinations is huge, huge, huge. The government has, however, increased the number of seats in undergraduate as well as postgraduate level over the years. But still, there's a huge, huge shortage. In 2014, there were around 23,000 PG seats in both the government and the private medical colleges, which has been raised to around 44,000, which includes the MDMS as well as the DNB seats. However, more than 1.5 lakh students apply each year for these seats, both fresh and the dropper candidates. Even those who might actually make it to the cutoff list might not get their stream of choice or the college of choice, and would take a drop and appear for the examination next year as well. MBBS doctors usually attempt 2 or even 3 times for PG admissions, thus adding to the burden each year. Even when the resident has gotten into his choice of college or his choice of residency, it is followed by more competitive exams like the super specialization exam or fellowship examinations. Getting a fellowship of choice at the desired institute is another Herculean task with variable amount of exposure at respective places, followed by stepping into the actual real world, which includes tougher challenges like finding jobs, settling family, or starting their own practice. A study done by Khanna et al. Evaluated the psychological impact of COVID-19 crisis on ophthalmologists in training and practicing ophthalmologists during lockdown in India. They concluded that out of 2,355 ophthalmologists who responded, 765, that is around 32.6%, had some degree of depression, which was mild, moderate, or even severe in strength, they had a lot of mental issues. There can be many recommendations to create awareness among the medical postgraduates regarding the health hazards of excess stress. Periodic counseling sessions should be taken. These should be organized by the institutions as well as other bodies. Medical college authorities must organize some screening programs in the colleges to identify and treat early cases of stress and mental breakdown to prevent its late complications that we have discussed so far. Distribution of the workload among the residents and optimizing the duty hours in order to provide appropriate relaxation time should be made mandatory at all levels of work. If work is causing you stress, you're not alone. Nearly 44% doctors are burned out. Why we need to think about stress among young doctors? Because these can cause public health crisis. De-stressing and solution. In order to serve the society, doctors invariably suffer, and most of the times, like ironically, they have no one to turn to. Mental illness still remains a social stigma, and as surprising as it may sound, many doctors find it equally hard to defy the social norms for reasons such as doctors being incapable of treating others who are suffering from mental health conditions. They themselves are suffering. Now, so far we discussed about all the stressing factors. Now let's enter the stress-free zone. How can we actually manage the stress? Stress management involves the use of coping strategies in response to stressful situations and adopting what's the source behind your stress, talking to the loved ones, simplifying our life by shortening our to-do list and learning to say no when we don't want to work. Quiet our mind through yoga and other relaxing exercises, or find time to do something that you enjoy or following your activities. There's this simple algorithm that I try to follow in my daily life, and it has been said by a lot of wellness speakers. It says, do you have a problem in life? Yes. Can you do something about it? No. Then why worry? If you can do something about it, then why worry? Do you have a problem in life? If the answer is no, then exactly why worry? There can be various strategies of coping with stress, like awareness. The initial step is managing the stress to become aware of the stressing factors that we have. Getting organized. Coping with stress involves a lot about the planning. Organized time for work, family, hobbies, spiritual time, time with friends, alone time, exercise, and time for relaxation. We should visualize what do we actually want and working along to visualize the outcome. We should not try to postpone the action that we're taking. Coping with stress becomes more difficult when you defer the situation. Do your least favorite choices first, followed by the later ones, and you should award yourself with some rewards. We should be realistic and set realistic goals, emphasize quality over quantity, and work at a leisurely pace, taking breaks often that helps to avoid stress. Sleep, eat, exercise. Coping with stress is all about treating your body properly. Eat food that nourishes you and get plenty of sleep, taking frequent breaks again. This will help you boost your energy, enhance your mood, control your weight, strengthen your bones, and even improves the memory, which is very important for doctors. We can consider going for a walk, meeting with friends. Reading is a wonderful hobby, which is a favorite of many. Listening to music is my favorite, and even singing as well, or just take a bath. Begin by practice relaxation techniques like meditation, deep breathing exercises, or muscle relaxation exercises. This will lighten the entire body. Talking about all of this, we should make sure that dealing with unhealthy ways of coping, unhealthy ways of coping with stress should be avoided, like smoking, drinking too much, overeating, undereating, using pills or drugs to relax, zoning out, should be avoided. We should seek help if we are facing any of these problems. The solution, however, lies in the basics. If we wish to deliver an effective universal healthcare in the long run, we need to bring an academic plan and the working plan, which will help to lessen the stress among the doctors and healthcare professionals in total. So in the end, I would just like to say that you can reach out to anyone, a psychologist or even any other doctor, to eliminate your personal stress, and we can work together to eliminate the stress of the entire community as a whole. Thank you.
Thank you so much for sharing Dr. Arnav's excellent talk. Now, I can see that Namrata ma'am has joined. Would we like to have some comments from ma'am, if possible?
I think it was a great talk. I think this is the need, again, what we need to do together. And the way we work, I think there is a lot of stress. There is no doubt about it. And if you have a hobby, extracurricular, it always helps to, just distract yourself for some time.
Yeah, thank you, ma'am. So I would like to now invite our next speaker, Dr. Nupur Goel, who is currently working as consultant interior segment and oculoplastics at Eye Care Hospital and PG Institute, Noida. She has completed her long-term fellowship in oculoplastics and also in comprehensive one at prestigious LVPI. She's also my batchmate from SMS Medical College, Jaipur, and a dear friend. All the best to you for your presentation.
Thank you, Sonal, and thank you, Apurva. Hello, Namrata ma'am. So before we've heard about de-stressing, etc. Let's move on to a talk. I hope will help you de-stress further. So before we move on, I would like to ask the audience. When you hear the word dance, so what is the first memory or the first thing that comes to your mind? Sonal, would you like to share something on this?
Yeah, I think my first memories of dance are the Kathak classes in school. So we had to, wear those nice, lovely dresses and sashay our arms gracefully on the stage on annual function days. So those are my memories, and I think I didn't totally love it. So I left it after class 8th and took up French and all. So I was not really the dancing kind. So those are my memories, and now it's maybe limited to parties and I should say marriages.
Yeah. Namrata ma'am, if you're around, what would be your, the first thing that probably comes to your mind when you hear the word dance? If you're there, ma'am.
You're asking me?
Yes, ma'am. Yes, ma'am.
I wish I really could answer this, because I'm that way a very, what do you say? A very, this thing, I mean, I really hardly have any hobbies, except for maybe watching movies. I can't dance, I can't sing, so, and I can't paint. So, this thing, dancing doesn't come naturally to me, but I'm sure Nupur does a great dance, and so all the others also who are over here. And like I said, you should develop it. At this stage, I realized that I should have worked. If you say what is a regret, then regret would be this only, that I never worked on any, hobby or anything that I was more passionate about other than ophthalmology. Because you can't keep doing ophthalmology for 24/7 into 365.
True. And Apurva, the first thing that you associate with dance, which comes to your mind, and we can just ask the audience also to probably type in the chat box, and let's have a best response judgment. Maybe Namrata ma'am can take a call at the end of the session. We have any live audience right now. They can also start typing, what is their first memory or the first thing that comes to their mind with respect to dance. Yes, Apurva, please go ahead. Yes.
So first thing that comes to my mind is that I've been told I'm good at it. So throughout school and college, every year I've never missed a chance to dance. And some of my recent performances has been in my own Sangeet a couple of years ago and in my friends' Sangeets. So I just love dancing, and I dance like nobody's watching.
That's the spirit. I think that's the thing. Yes. So great. So with this prelude, hello everyone. I'm Dr. Nupur Goyal, and thank you very much, the YOSI team, Dr. Sonal, Dr. Apurva, Namrata ma'am, for giving me this opportunity to speak on this wonderful topic of dancing your worries away. I'm not here to give much gyan. Rather, I would just share, what I have experienced and how dancing helps me. So I don't know if it helps you too. So I just took a small survey at my own institute, people, what do dance mean to them, and got some really wonderful responses from everyone, a divine way. Dr. Prashant, he feels that it's an art, and I'm not that artist for sure. And a couple of wonderful responses. These are the other ophthalmologists who are good dancers, my very good friends. It's for them also, they have the expression of dance is different. For some, it's fitness. For some, it's just expressing yourself. It's just about dancing, like not getting from one place to another, but just enjoying every step. For some, it's just letting your head down and have fun. And of course, Dr. Priya, who's a very good friend, she says it's an SSRI for her. Then also some people feel it makes our bond stronger. So going further, dance, the literal dictionary meaning is moving rhythmically to music, typically following a set of sequence of steps. For me, dancing is the closest thing to magic. Fine. So dance for me is a de-stressor. It's athletic. It is about having non-stop musty and fun. It has helped me make a lot of connections and new friends, and it has enhanced me professionally. So my whole talk, I would be elaborating this acronym dance aspect. Before that, I'll just tell you a little about myself, my journey as a dance. I started dancing at a very early age, at the age of 5 years. It just happened, So I am a trained Kathak dancer. I have given 3 exams. Although not completed the course, completing that is surely on my bucket list. Participated throughout MBBS, MS fellowship, and now also I keep performing as and when. So as you can see, I started dancing at an early age, dressing up. This is my first year MBBS, second year MBBS. This was one of the Marathi festivals we used to have in our college. I've done my MBBS from Mumbai. Then we had gone for a youth fair in Stuttgart, Germany. Represented India at an international level. So this was our team. I was during my internship at Nair Hospital, Mumbai. So during my MS as well, whenever I got a chance, I performed. We would go out for Dandiya night. Then post my fellowship, after this is dancing with my daughter at one of the Ganpati festivals with my friends. These are the other moms. at a Teach Festival. This was the AIOT Cultural Dance, then one of the events. So coming to the elaborating aspect, de-stressor, I don't have to stress on the de-stressing aspect of dance. Everybody, I'm sure, can associate with it. It has a lot of scientific things to support it as well. So this very good book, Dr. Sonal has actually shared with me, Burnout, and this actually says that, you know, whenever you're stressed out, rather than just following and just relax, utilize that energy, and the best way to have it is some form of physical activity. For me, it's dance. It definitely helps you de-stress yourself. So nothing can clear a mental cobweb faster than a good dance. As Apurva said, dance as no one is watching you. Don't dance for anyone else, just dance for yourself, because it makes you happy. Dance is the joy of movement and the heart of life. Athletic, coming to the fitness aspect. So this is my fellowship photo. So you can see the difference. Post fellowship, I have pursued dance fitness in various forms, watching YouTube videos, Zumba videos, more pursuing dance, and you can see the difference. So yes, it is a very, very important, has a very important fitness aspect to it. So non-stop musty and fun. This is my PG time photo. We would just, you know, go to a place, just in our hostel rooms, we would play music and just dance our heart out, you know. So this is about having non-stop musty and fun. Connections, it has, especially during the lockdown period, it has helped me to make so many new friends. We connected virtually, we had a lot of collaborations, dance videos, and we now actually have a group, you know, where all of us have connected to dance, but now we are the best of friends. Some of us haven't even met, but that's how. So dance has helped me develop so many connections and so many new friends. It has enhanced me professionally. It has built up my confidence. People know me more. So there have been a couple of virtual cultural programs where I have participated. It helps me surgically too. It helps me keep me more focused, disciplined. It gives me a more positive frame of mind. So, so great dancers, I would say, are not because of their technique. They are because of their passion. And I'm really, really passionate about dancing. I hope that you all also find this passion. It's not about being a good dancer or a bad dancer. It's just about getting up, just put on your shoes and just play the music, or just hum a song and just start dancing and de-stress yourself. So thank you so much, and just dance it out. Apurva, if I have time, is it okay if I play a video of mine?
Yeah, go ahead.
Yeah, thank you. So I'll just share the dance video if it's playing. 1 second. You all can hear the music?
Yeah, we can, but we can't see the dance.
Oh.
Nupur, may I suggest, can we have it in the end? That will be like
sure.
Most amazing wrap up to this entire conference.
Sure. Yes.
Yeah, great. Yeah. So.
Yeah.
Thanks, Nupur, for that amazing talk. Over to Dr. Sonal. I think she'll have more to say about her best friend.
Yeah, so she did not put up any of my pictures because I was never on the dance stage with her. I need to learn some moves and I need to de-stress according to her. So now our next speaker is the talented Apurva, who's a consultant at MM Joshi Eye Institute. She specializes in vitreoretina. She has done her PG from Maulana Azad Medical College, New Delhi, and she's the assistant editor of IG, along with being assistant editor and academic in charge at YOSI. She's the brain behind a lot of the program that we've been seeing today. Over to you, Apurva, to elaborate on productivity today. And being a new mom, I think she would be the best person to guide all the female listeners, especially.
Yeah. So thanks for the kind introduction. So I am not any authority on this. I just want to put that disclaimer out. If you see my topic, it says the theory of productivity. It doesn't mean I am any productivity nerd or productivity guru here. It's the theory of productivity, because who am I anyway? I'm no authority. And my number one excuse out of the 100 excuses for not being productive is that I'm mom to a toddler. She's 2 years old. She occupies vast expanses of my time, and whatever time I have left, I want to switch off my brain and mindlessly scroll through Instagram reels for, I don't know, several minutes. So I'm the master mindless scroller and the procrastinator in chief. So why I'm giving this talk is because I'm fascinated with productivity. I'm in awe of hyper productive people. I'm constantly bugging them to share tips. I'm constantly looking at productivity videos on YouTube and productivity hacks. So I'm basically a student. I'm not a teacher. So with that disclaimer, I want to begin this talk by asking ourselves one major question. Why do you want to be productive? What is it that you want to put out? What work is it that you want to show? So it could be work related, career related. So in our field, it could be that we want to read more, research more, plan our classes more, teach better, create content maybe for a YouTube channel, create content in terms of videos of your surgeries. You want to prepare for conferences. All these are work related productivity. Next is personal growth. Do you want to be productive because you want to enhance your personal growth? It could be because you want to be fitter, you want to work out, or you want to nurture hobbies like Nupur does. It could be because you want to spend more quality time with your family, or you want to keep house better, like you want to be more organized, you want to focus on your kids, or cleaning, cooking, organizing. That's a very important priority for a lot of people. Do you want to be more productive in the social sphere? Like you want to have a more vibrant social life? Do you want to catch up more often with friends? Is that important to you? Or you have other avenues in your life? Do you have an alternate career? Like we heard Dr. Ghosh speak about administration. Maybe there is somebody who is monetizing a YouTube channel about something entirely different, or having an Instagram page like Neha will speak about in a couple of minutes, or they have a leadership role in their local communities. Like I know one of my mentors is a leader in the youth of India, YI. So that's something completely different from what he does as an ophthalmologist. So I want to tell everyone that we make a list of all our priorities. So you make a list of 20 priorities in your life. Just think about it and put it down on paper. The next step is to do only the top 3. 4 to 20 you need to cancel out, because that's not going to happen. It's not going to happen right now. Perhaps you may want to postpone it. You may want to delegate it. Maybe it will get done, but not by you, but by somebody else who's willing to do it for you. Or you make peace with the fact that you may not be able to do them. So the top 3 things you want to do, how to do them. So the main thing is time management. Here comes the role of routine. How to create a routine to go about doing the things that you have prioritized in order to be more productive about the 3 things that you have prioritized. So these are some things. I'm a stationery lover. It's like jewelry for me. Like I don't know, I have the biggest collection of notebooks, diaries, pens, fancy planning stickers and color pens and highlighters, and I make a big deal of planning and everything. I don't execute a lot of it, is a different thing, but yeah. So this is one of my journals where it gives me the ability to have a daily plan. Here you can see time blocks. This is what I mean by time blocks. This is what Elon Musk also does. Elon Musk apparently blocks time. So there is something called the Parkinson's law, wherein work expands to fill the time you have allocated to it. So suppose you say you have a class, like you have a seminar to prepare for, and you say, okay, I have 15 days left for the seminar. So in 15 days, I must do the preparation for the seminar. So the work will expand to fill the 15 days. Like all 15 days will be devoted to thinking about doing the class because you've allocated 15 days to it. Instead, you allocate time. You make a time block that on Thursday and Friday from 4 to 6, I will prepare for this seminar. So the work will expand to fill only 4 hours instead of 15 days. So maybe you will not be able to finish in 4 hours, but setting deadlines for yourself is going to make you more productive. So you can make time blocks, like say, this is just an example, like you want to go to gym from 8 to 9, don't miss it. This is your work timing. This, do some random thing. Sleep is also important. Make a to-do list. Okay, so now what about the other things of daily plan? So there's this book called Make Time, which says that do only one thing in a day. One highlight of the day has to be done, has to be written down, and you do only that. If you, maybe you will say, okay, what about the other things? There are so many things to do. If you just do one thing, is it enough? But think about it this way, that if you do one thing every day, you get it done in entirety, you'll have done 365 things in a year, and you'll have a lot of stuff to show at the end of 1 year. Maybe you'll write just the materials and methods part of a manuscript that you're preparing on one day. That's the highlight of the day. I'm going to write this. You've done that. Tomorrow you'll write the results. Day after tomorrow you'll write the discussion. Your paper is ready by the end of the week. So basically, when you give yourself one task to do every day, you'll actually get a lot more done than, having a to-do list that is so cluttered with 10-20 things to do. So that is about daily plan. Now, weekly plan is something I have found to be pretty useful, where you make a physical habit tracker and say you want exercise is your top priority or research is your priority. You actually mark the days that you did those things, and you say you don't mark the days you didn't do those things. So having a proper habit tracker of your priorities will be a good visual reminder of the fact that you're actually doing your priorities right. So bullet journal is something I did dabble in for a couple of months. I have some bullet journals filled. You can have an index for the bullet journal. That bullet journal is a talk for 1 hour. You can look up bullet journals on YouTube. So yeah. So now we've got our priorities in place. We've got our daily plan and weekly plan and monthly plan in place. So what are your goals in life? So you've got your priorities. Now let's look at goals. So suppose somebody wants to say, my goal is to have 50 publications this year, or my goal is to lose 20 kgs this year, or my goal is to read 20 books in this year. So this can be very overwhelming. 50 is a big number. So instead of that, I found this incredible gem of a book called Atomic Habits by James Clear, who talks about how 0.1 is greater than 0. So instead of trying to have 50 publications a year, in which you might end up having 0, by the way, knowing most of us, or at least knowing me. So instead of 50 publications a year, focus on writing 50 words a day. That's it. 50 words a day. Don't, in fact, if you want to write more, it's fine. If you don't want to write more, just stop. That equals to almost 20 publications a year. If you think about it, every week you get in about 350 words, 700 words is 2 weeks. That's like a case report, and you have like 20 publications in a year. So 50 is greater than 0. So make sure you get in 10 words or something. Anything greater than 0 you do. So instead of saying I'll lose 20 kgs in a year, you lose 1 kg and do it 20 times. So, or you lose 0.5 kg and do that 40 times. That is the power of habit. Instead of saying I'll read 25 books this year, read 1 book a month or read 1 page a day. That's going to be greater than 0. So how to focus? Now we've got our goals in place. Now how do we actually do the thing? Like, this is doing the thing right now. How do I get myself to focus? So now if I say that today I have 4 hours, and that 4 hours I'm going to write a manuscript. It's not going to happen. You're not going to get 4 hours dedicated time being a full-time professional, having a family, and having to do 100 things in the day. You're not going to get 4 hours to write that manuscript. Instead, you're going to get small, you've got to snatch like intervals of time. So here, the Pomodoro technique comes into play, where Pomodoro technique is basically 25 minutes timer. So you set a timer for 25 minutes and you do deep work. Don't get out of that work for 25 minutes. After 25 minutes, take a 5-minute break or take a longer break. It's all right. And then do another Pomodoro for 25 minutes. Do the deep work, just 25 minutes. So in our generation of very reduced attention spans, I think 25 minutes is reasonable. So if you do just 2 Pomodoro techniques or 2 Pomodoro sessions in a day, you worked for 1 hour. So that 1 hour you'll get in a lot of manuscript material. So that's the idea of snatching Pomodoros from the air and just sitting tight for 25 minutes. So I find this pretty useful, where there are these study with me videos on YouTube where you see all these highly efficient people just switching on their 25-minute timer, and you also plug in your earphones and you sit with them and do work with them. So that's one way. So a lot of us, like I said in the beginning of the talk, we work for some time and then we tend to take long breaks. So in those long breaks, it usually becomes long because we are so much into social media. Like if you notice, when you're on Facebook or Instagram or whatever it is, you don't know how several minutes have passed. You don't know, like you've spent 45 minutes, 1 hour on some social media app. So you need to set time limits for apps. Look, I have this time limit for, like, if you take up the entire usage of Facebook in a day, it probably runs into easily 1 hour or more. So instead of social media, you can either read a book or you can call up somebody and talk. That will cause much more relaxation. So one of my last slides, I think, so you need to be flexible. So although I talked about time blocks, you may not be free from 8 to 9 because maybe somebody needs you in the family, your kid needs you. You've allocated 8 to 9, but you couldn't do it. So don't stress. Maybe be more flexible. You'll probably get 9:15 to 10 or 10:45 to 11 or something. Just try to snatch those small intervals. And one more thing is to make a routine. If you have a deadline to meet, make sure you've done it much before the deadline to avoid any last minute crisis. In fact, if you finish before those deadlines, you will have more spontaneous plans and you can actually live life better if you have a routine. So I know most of us will say, you know what, I want to relax in life. I don't want to do all this. Why should I, publish? Why should I teach students? Or why should I do this or that? Why should I go work out? But then these are the things that give us the long-term results. So actually speaking, if you love yourself and you want to say, no, I don't want to do all this. I love myself too much. I'd rather relax. No, in fact, if you do love yourself, you will know that discipline is the strongest form of self-love because you're prioritizing your long-term results over your short-term gratification. So some of my sources are Atomic Habits. I cannot, stress this enough. Atomic Habits is something we should all read. This Make Time and Deep Work are 2 other books, and these 3 are like the original gangsters of productivity: Ali Abdaal and Matt Diavella and Thomas Frank. I urge you to watch their YouTube channels for most of the stuff I've discussed. Thanks.
Excellent presentation and really very pertinent points, Apurva. There's so much of time being snatched away from us through all these screens. I've kept my WhatsApp notifications on off. People have to really call me and say check your WhatsApp. So this is something that I do personally to try to have some productivity in. So maybe Apurva, would you like to introduce our next speaker, who's been your senior at your alma mater, perhaps?
Purva, you're muted. I think it was an excellent talk, Sonal.
Yes,
So
ma'am.
much to learn at such a young age, Apurva. You gave
Ma'am,
such an inspiring talk. Huh?
ma'am, you are my inspiration. I've told you so many
Yeah,
times.
but such wonderful things. You know just crystallized it, and I think we are going to again hear a very interesting talk from Neha. Yes, Apurva.
Yes, yes, ma'am. Yes, ma'am. Thank you. So, Dr. Neha, it's my distinct pleasure to introduce her. She is my senior from Maulana Azad Medical College. She's done her undergrad, postgrad, and SRship from there. She is one bright star in our fraternity. She is also has her own setup now. She's the director of her own super specialty eye center, TetraView, at New Delhi. And interestingly, she's started an Instagram page about how she single-handedly raises her twins who are really young. And she does so much. I think I'm waiting to hear from her. She has got thousands of followers on Instagram now. So let's hear it from Dr. Neha.
Thank you, Apurva, for that kind introduction. Regards to Namrata ma'am. Nice to see you, ma'am, even though virtually. And thank you, Sonal, and the entire YOSI for, first of all, congratulations. It's been a wonderful 2 days of sessions, and I particularly enjoyed this session a lot. So before I start my talk, I just want to correct you, Apurva, because we don't want a world war. I'm not single-handedly raising anything or anybody. I strongly believe in equal parenting, and that is what.
No, you know what I mean.
No. I can vouch for it. Vinod is also helping her.
Thank you. And to be honest, when Apurva sent me this topic, for a moment, I was like, oh no, it's something, which I have not made before, or it's not something which I can dig up into my hard drives of photos and videos of retina and make. But then I gave it about 4-5 days, and it's been very interesting for me also to put down so many of my thoughts. So let me start by the term used for this session, which is premature midlife crisis. So basically, what is a midlife crisis? And as Apurva rightly said, I feel that our generation, especially with so many overachievers, tend to reach it much earlier. I myself have spoken to many ophthalmologists, my colleagues, my juniors, and even friends in other professions, in high productivity professions, so as to say MBAs, scientists, graduates, wherein they reach a point where they feel that they've already done their best. It's a transition of your identity, feeling your best years are behind you. I've learned all the surgeries, I've published so much, I have my dream job, what now? So you kind of get a monotony of your work or your job. Am I just going to keep operating my whole life? Am I just going to keep publishing and seeing patients? Or even, am I just going to keep earning my whole life? This is what the crisis actually is. Another thing which I feel, talking to all my peers and colleagues and juniors, is a feeling of restriction that they get, or we get, due to family obligations. On the other hand, once you start a family, or once you settle down, or you move to a new city, you might feel that you are not able to do what you want to do the way you want to do. Maybe you're not able to devote that much time to work, or you are not able to publish the way you want, etc. So in my mind, these are the two common issues that I see talking to people of my generation. So it's basically, a lot of uncertainty, questioning, and part of dissatisfaction and frustration. But what I would like to say is that it is not actually a crisis when you enter the stage. It's an opportunity. It's an opportunity to do more, to do things differently. And here, though I'm not strictly an influencer per se, but this is something I'll take you through my journey also. This is something which struck me, and I went into it. So what exactly is a social media influencer? Basically, it is a person who is an expert in his or her field, with some amount of credibility and following, with the ability to influence people's decisions. It may be their personal decisions, it may be their their buying decisions, it may be a sort of marketing, or it may be a sort of publicity. And in this is a subset, which are the bloggers, as in who literally live their life on social media for people to see, watch, and learn.
So further adding to this is the term the mom influencer. So the mom influencers are ones who, like I said, use visual storytelling. So there's a lot of photography, a lot of videos to share their own experiences of parenting, their interests, and most importantly, their recommendations and products. And what sets them apart is that if you would look at them, literally you would feel this is the mom who can do it all, which may or may not be true. So how do you become an influencer? Basically, you select your niche, which is what I did, 2 or 3 points which you feel are your strengths or which you can inspire people to do. Then you optimize your profile accordingly. So for instance, if let's say I have a hobby of photography and I want to highlight that, then I would not suddenly put in a video of me cooking one day or start sharing recipes one day, because then I would be targeting people who are interested in photography to follow me. And if they see me cooking or see me sharing more content on cooking, they are likely to unfollow me. So at the same time, you have to understand your audience. You have to engage with them. You can't just be one-sided on social media, and you have to solve their problems. So it is, I would say, I find a lot of analogy to the medical field where, actually you are engaging and solving problems of your patients as well. You have to create and post relevant content, like I said, and there has to be a wow factor in it to stand out. And from the beginning, I feel you should be clear about your collaboration policy. You are definitely going to be contacted by brands, you're going to be contacted by, other influencers, etc., for collaborations, and you should be clear what you are here for, what are your expectations, and what lengths you will go to. So why I started? So basically, we've talked a lot about hobbies and all. So for me, the primary purpose was to nurture my creative side. I am a trained classical dancer as well. And in fact, Nupur's talk was also very interesting. I could have talked on that for hours. But also your creativity in art, in expression of what you feel life is being. So this was the primary reason I started, to nurture my creative side. And secondly, to give back to the community. I see so many young parents. I will not use the word mothers here because a large part of my following is also dads. So it is a lot of giving back to the community. What I have learned as a parent, if I can present that information in a nutshell, in an easier way, I will be educating a lot of parents. Thirdly, the networking potential is immense. So, sometimes a part of the crisis is because all you're talking to is ophthalmologists, all you're meeting is ophthalmologists. You may even be married to an ophthalmologist, and then at work, ophthalmologist again. Meeting people from different spheres of life is very interesting, and it rejuvenates you. And finally, of course, the recognition, the fame or the recognition it gives you. And I'm still a micro influencer, I would say, but then when people recognize me in the park, that we follow you, or they see your kids and say, oh, these are Dr. Momni has kids, it does give you a kind of kick. And that is something what we are looking for, whether it's in our career or in our hobbies or in our passions. So this was the reason why I became a momfluencer from a mom. And my mantra has been to inspire rather than to influence. So what I do is I simply document my parenting journey. I give out honest recommendations. I share what worked for us and also what didn't work for us. I share information on day-to-day topics, which every parent needs, every person needs, on events, on things that are happening, where you can travel, how you can travel, etc. And being a doctor, I also offer support, not medical advice, but other support. I bust myths. I do lives with people from professional fields. And of course, I encourage other mompreneurs in this community. So man and women are ultimately selfish animals. How it helps me, and this is what I got down to thinking when I was making this presentation. So 3 aspects. First is learning new things. Now, like Apurva said, that mindlessly, navigating social media. If you have a strategy, you can actually learn a lot of new things in a very short period of time. Not all of us have the time to read books, read entire books, or listen to podcasts. But social media, if you are selective and if you are smart, you can learn a lot. I learned a lot about lactation support, gentle baby sleep, baby-led weaning, Montessori, right brain education, phonics, gentle parenting, diet, nutrition, toy, and book recommendations, which I could never have just reading about it. So, the key is to be selective and to be smart. A lot of non-monetary gains, some things I have talked about. First of all, it helped me to document what all I am doing, a one-stop place for my recipes, for my activities, which even I refer to. Social media, it acts like a, kind of a push. It urges you to perform and innovate. I have to keep giving content. So for that, I have to do stuff. And it urges you to get up and show up. Even if you are feeling a bit down in the dumps on one day, that, there are hundreds of people waiting for a story or waiting for a picture. And that does make you get up and dress up and, go out, even if you don't feel like. It tells you are not alone. You connect with like-minded people. And as I said earlier, it gives you a kick, a sense of achievement, and very quick route to fame and recognition. So just to give you an example, this is what 4,000 people look like. And when you have 4,000 people following you or looking at your stories or commenting, that's a whole lot of people. It's a lot of people that you can reach, which you couldn't have otherwise. And finally, since we're talking about midlife crisis, it helps you to learn new skills, new lingo, be young and stay young. You remain social media savvy. I, for one, am a person who has multiple passions and is always ready to learn something new. And this has been a new learning experience for me. Now, finally, you can always monetize your account, your page, your brand. You can do giveaways, you can do barter collabs, which I do sometimes do because, just to encourage other mompreneurs. They will send you, companies will send you products and ask you to do an unboxing video or just to share in your story so that they get some more orders. You can do paid collabs or brand partnerships. You can also have your own storefront with affiliate links, which you get paid for every time anybody buys from there. And now Instagram also pays you to make reels and TV, their IGTV videos. Like all good things, this has a downside too. In my opinion, the most important is to set and to adhere to a boundary. There are things which I will not put or not share on social media. There is a certain time that I will devote to it, not more than that. I think if you stick to that, there is a very less tendency of it getting addicted to the point of being harmful to you. The other downside is comparing yourself and your family or your way to others and feeling guilty. I get a lot of DMs with moms that, how do you manage to do so much? You have a hospital, you have this, you have that. So the key is not to compare yourself, because obviously I don't show the entire picture. I may not show the days when I'm very stressed or, very overworked, and that holds true for everybody. So these are the two things, to remain happy on social media: boundaries and don't ever compare. And then it's all up game, I feel. Mindless browsing, naturally you have to be strict with yourself. As a creator, sometimes you can get a creator's block where you don't have content. And this is another thing which I learned, is you cannot always strive for perfection. You have to put it out there, and for people who are perfectionists like me, it's a learning experience. And then sometimes when you don't do well, your posts don't do that well, or etc., you might feel a bit disappointed as well. But to conclude, momfluencers are a league of their own, and I am honored to be one of them, because this has been a great learning experience for them, for myself. They are relatable, funny, and it's both a very glamorized version of motherhood as well as a very real version of motherhood. And the aura of moms know best is actually very lucrative for marketing, and a lot. I think it's a lot of the marketing industry is now focusing on influencers and momfluencers. So finally, a word about mompreneur, because that's in my topic as well, but I feel that's a whole separate topic altogether. So what is a mompreneur? Basically, a creative, multitasking woman who bravely manages the demands of running a business as an entrepreneur and the blessings of motherhood at the same time. So the key words here, I feel, is A, being creative, B, multitasking, and C, being brave. That is, I think, the most important. And Apurva's talk was, of course, very interesting, and Atomic Habits has been a favorite for me. But there's always this debate whether you should focus on one task at a time or multitask. And me myself have always been an advocate of multitasking. In fact, people who do a single task only somewhat irritate me. So just to give an example, while I was attending this session, I have responded to one reviewer for an original article. I have done a survey for a senior. I have collated a post for Instagram, and I've also picked out a recipe that I need to make. So there's no limit to what all you can do. You are the only one who has to set your limit. So the key is having clarity of thought, what you want to do, having not just a work-life balance, but a work-life-home balance. And you have to prioritize and strategize. You have to decide, this is what I have to do, and this is what I can or cannot do, or may not do. Make a routine or a to-do list and stick to it. Look at small goals before big goals. Like Apurva was saying, you can't target 50 publications. You have to start with 1 or 2 or 5. Ask for help. This, I would say, is the most important, or rather demand help from people around you. You know, sometimes we tend to take on so much ourselves that we feel guilty in asking others for help. And use the power of delegation. Someone once told me that if you do everything, you can't ever be promoted. So the work which you can delegate to others, always do that in order to enhance your own productivity and your own creativity. And of course, take care of your mental and physical health. So thank you for your patient hearing. I'd just like to end by saying there's a difference in just being alive and in living, and you should never settle for the first.
Thank you so much, Dr. Neha. That was amazing. And I am an ardent follower of yours, like I've told you so many times. You know that. And I think one thing I want to tell everyone is not to be intimidated by this hyperproductive woman. You don't have to do so much. Yeah. So yeah, I think, yeah, like she said, don't compare. So I think we've come to the end of this session, and we've got a very interesting financial planning session. The moderators of which are Dr. Shraddha Surekha, Dr. Nilesh, and Dr. Sonal and me also will be here. So I think the Google form that we circulated had very interesting submissions about how financial planning is so essential for ophthalmologists, and Dr. Shraddha has been also talking about, you know, doing, I mean, financial planning essentials for women ophthalmologists especially, and she's been playing a key role in you know, organizing DIY practice setups and the setting up of so many assets, ophthalmic assets. She's a mompreneur herself, I should say, and looking forward to a great question and answer session on financial management by Dr. Shraddha and Dr. Nilesh.
First of all, thank you, YOSI and AIOS. Thank you, Namrata ma'am, for gracing your presence. It's an honor to, you know, do this in front of you. So thank you, Apurva. So we'll start off with this interesting session. First of all, let's start off with residents and fellows. And Dr. Sonal, I think, has a few pointers to tell us how and why residents and fellows should be thinking about money. And then we'll go to jump into the game. So Dr. Sonal.
Very good evening once again to all of you who are still staying on for this, you know, panel discussion time till 6:30 on a Sunday evening. So the first few things that I would want to, you know, request residents to not compromise on our, books. A lot of residents I'm seeing now, I was myself a resident till 2013, and then SRship is almost like an extended residency if you join in your own alma mater, basically. But I think a lot of residents just take online copies and soft copies, and they don't want to spend on even, you know, photocopied print versions. I'm not trying to propagate that don't buy books, but I'm just saying that don't buy real books, buy photocopied version. A print version has certain advantages to it, which is coming out in a lot of research also, and then the retention improves. You tend to read the whole perspective instead of just picked up paragraphs when you are reading something online. Also, a lot of memberships should be taken up as early as possible in the career. I feel that not just YOSI, because I am associated with it, but AIOS, DOS, your state membership and your city membership should be taken up within your first or second year of residency as soon as possible. You have to set money aside for these things, and good YO schemes are there. So FBS AIOS is also a very good sort of alternative to investing in LIC or something which maybe is not feasible at that point of time. Then spending on OT instruments, your indirect, your direct ophthalmoscope, lenses, and some of those things which are very personalized, like your choppers and rexes, forceps and all, should be done early enough in your career, because it's not necessary that you are going to immediately after your residency is done join a place where all these things are going to be tailor made to your to your preferences. So going and buying things at that time, rather have a look at what is available in your center. Do you like it? Do you want something else? You're seeing a lot of live surgeries. If you're comfortable with those instruments, buy them. If not, try to hunt for your own instruments and try to make some sort of a space in your money planning for your future. In these are investments. So books, lenses, memberships, these are investments. These are not expenditures. So whenever I urge residents to take up some membership or the other, many times they get itne kharche hai ma'am, how to do this also, how to do that also. This is not kharcha, this is an investment. So the way it is going to pay you back is in terms of your knowledge, and that knowledge is how you're going to multiply and make money in the future. Ultimately, what are we all doing as doctors? So that is my first thing. So instead of maybe watch a few movies less, or buy some less clothes, but these things should not be really compromised on. Then your personal care, meditation apps, exercise, after all this, that would make you an excellent resident and you can have something planned for the future. Then comes the question of investment, proper investment, PPF, LIC. I started all of that in my residency itself, although the pay was not too much, but then yes, I made it a point to have some amount saved up each month for putting at the end of the year in a PPF. Then I realized that it should not be end of the year, but should be as soon as possible, because there's something called as interest and compound interest and all that. So I'm quite naive on those topics. I would now request Dr. Nilesh, who is now back in the game after residency, and he's seeing business side also. So he'll tell us how personal business finances are different, perhaps.
Thank you so much, ma'am. So as you have really pointed out, we need to have a separate thinking that there is a business that we are going to take care of once we pass out. And that's why the investment starts early on. As you said, power of compounding is like the eighth wonder, they tell. Because it just keeps on doubling, and 2 to 4 to 8 and to 16 to 32, you will never know when you are going, you will accumulate so much wealth. So first thing first, ma'am, what you told, the investment, what they need to make. So whatever you are earning, you need to divide it into, like if you are earning 100, 50 has to go for your needs. So if you need to do something, you have to spend 50 rupees of the 100 that you are earning, and 30 can be on your wants. Like if you want to attend a conference, that is 30. Like you need to buy an instrument that comes from 50 rupees, and then you want to attend a conference, that comes from a 30, and 20 you have to save because you also need to grow and take care of your thing. So whatever personal finance that we are going to talk about will be from that 20, but from this the 80 that you need to spend, 50 you need to spend on what you need. You need your instruments, you need your surgical instruments, you need to invest into your property and everything. So that goes into 50, and then 30 goes into your wants. So that is one thing. Second thing is, as soon as you're going to start, you have to have a separate account for your business and a separate account for your finance. You start, even if you are starting your own practice, your own clinic, have a business account separate, and then fix yourself a salary, like say 1 lakh, 2 lakh, whatever you think that it is feasible to take out for yourself, you take out that. So make personal finance separate for your house needs or anything you want to spend. But for business account, that you are going to keep it separate. This is the first thing that I think Dr. Debashish Bhattacharya sir in one of his LDP session told, that you should not take money out of your clinic and then spend in the evening, and whatever is left then you take it to home. It should not happen like that. So you have to have that separate, and then we will move ahead with personal finance, the 20 that you are saving, how to go ahead with that. So ma'am, Sonal ma'am.
Thank you so much for really hitting the nail on the head, I should say, by saying that first of all the two bank accounts should be separated. I am really wondering, after this, once the accounts are settled, once some sort of a saving scheme has started, what are the basic, insurance policies which we should take? I remember having invested in one health insurance and one professional indemnity as soon as my PG was over. I think maybe Dr. Shraddha would be able to answer that question.
Right. So Dr. Sonal, taking it forward from what Dr. Nilesh said, one of the famous books on personal finance tells you that your income minus your savings should be your expenses. Okay. So people take it income minus expenses equal to saving, but that should not be the case. You should have discipline in the fact that your income minus your savings, you have to allot that out of whatever my income is, this much will be my saving. Then you take it on to your expenses, which would be your wants and your needs. So coming back to the topic that you asked me about, Dr. Sonal, about the insurance aspect. Now, there are many insurance, and there'll be, enough advertisements about insurances all over the place. So let's start with life insurance. Now, in life insurance, basically you would take life insurance. Why would you take it? You will not take it to earn money out of it. It's not an investment strategy. It is basically something that if something happens to you, your dependents will continue to lead the same lifestyle. So you basically calculate all the assets that you have, all the savings, all your investments. And if you feel that that much is going to be good enough for if something happens to you, for your dependents to carry on, then you don't need life insurance. Then you don't need to spend into that. But if you feel that is not going to be enough, then you need to go and buy a life insurance. And basically you should go for something known as term insurance. And term insurance, you should buy it as soon as possible, because lesser the age, the premiums are lesser. And then the premiums are said that, over the course of years, this is going to be the premium. So that is something you should focus on. Don't go into fancy schemes, just simple term insurance. Then the other insurance you should get is a health insurance. So health insurance for you, your spouse, your dependents, and again, go for the simple policy. Just to add up, because we don't have too much time, you should read up about the super top-up policy. Okay, so if you have taken a health insurance of say 5 lakhs, you take a super top-up policy of say 7 lakhs with 5 lakh deductible, you get a total coverage of about 12 lakhs. That would be cheaper than going for a total policy of 12 lakhs at the basic as a basic health policy. So just read up about super top-up policy and go for it. Third thing is, as a professional, you should go for a professional indemnity insurance. So in Mumbai, we have something known as Association of Medical Consultants, which has a fantastic policy. And in other places, also there would be similar organizations, but that is something you should go for. And for your clinic, you should go for error and omission policy and fire or any accident policy for your clinic setup if you have a clinic. So these would be the major things you focus on. And the bottom line is, your insurance is not your investment. It is a spending that you have to do. So from this, we will go on to Dr. Nilesh, who had something to add about emergency fund planning.
So very well put for the insurance policy, ma'am. COVID has told us that we two things. That first, we have to take insurance because anything can happen anytime and you need to be prepared. And second, your job is not fixed, because suddenly a pandemic can come and shut down everything, and then you don't have any money to spend. It was a sad situation, but a sad reality that we all saw on everywhere. So what is emergency fund? Emergency fund is something that you keep so that if whatever you are earning, that if that earning stops, still you can maintain your lifestyle. it is not that extravagant spending that we do, that not the 30% of wants, but the 50% of needs need to be taken care of with this emergency fund. So the emergency fund can be for your business also, and should be for your personal finance also. So for personal finance, it should be at least 6 months of your total salary, or 1 year of your total needs. It is the same thing, like 50% of your salary goes for needs. So it's a 6 month of salary, or 12 months of your needs. So that even if you are unemployed for 1 year, or you can't do your work, still you can complete your needs, your pay your EMIs, pay tuition fees for your children, and anything, any dependent thing. And similarly for business also, you can't have, because business expenses are more, you can't have a cash of around 6 months lying idle. So at least 3 months of emergency funding should be there for your business also, so that if a pandemic comes and you have to shut down your hospital, still you can pay your employees and you don't have to lay them off. So these are the two things that you have to do for emergency funding. But these emergency funds should have two characteristics. One, they should not be cash, because cash, when you are keeping in your own place, there is a risk of theft first. Second, it doesn't grow. So the inflation is growing at 5% or 7% per year. So your emergency fund at least should grow at that time. So you don't need to keep adding fund into that emergency fund. Once you are done with that, you are done with that. So it has to grow at 7% at least. So a long-term bank FD or something like that, something should be looked upon. It should be safe. It should not be an equity market where share market crashes and then your fund becomes half. So it should not be that. And third thing is that whenever you want, it should be available. It should not be in a property that you have to sell a piece of land to get that emergency fund. It should be accessible. You want it today, you can have it today, or in a day or two. So those are the characteristics of emergency fund. So when you are planning your investment, first take an insurance. Second, you build up your emergency fund, and then you start your investment journey. So that is the learning that I have gained during my 4 years of the investment that I am doing.
So, Dr. Nilesh, one of the ways of having an emergency fund is basically having, FDs and, putting money in liquid fund, mutual funds like liquid funds. So, just sharing some light about that. So, basically, debt is basically funds or any place where you park in your cash, which will give you steady and low return. So, they are low risk, but they will also give you low return. So you have fixed deposits. Now, fixed deposits are something which is very common. I'm sure each of our parents must have, trained us about fixed deposits. And right now, they're very easy to make. You just click a button on your bank website and it's done. You have steady, assured returns, and it's there since years. And, they seem very safe. Now, the problem is that the FDs, the rates of the FDs are lowering with time. 10 years earlier, whatever rate you got, they are lowering. The other thing is, whatever rate is mentioned over there, you will think that is your return, but then that is taxed also. So your eventual return that you get is actually lower. So instead of that, you can also think of putting money in another kind of modality, which is debt mutual funds. So there could be overnight funds, liquid funds, cash funds. So those are also one more way of parking your extra cash. Now, the advantage over FDs in these debt mutual funds would be that you would get, say, similar rate of interest. But if the money is parked there for 3 years, then that money, they accounted for inflation. So there are calculations which are done wherein you eventually end up with more return than the FD. So that is something which is a little complex. Again, it would require some slides to, understand. But you should read about the debt mutual funds, and instead of FDs, you could think of parking your money there. Of course, there's also something known as PPF, which is Public Provident Fund, wherein your money gets locked in for 15 years and you have no liquidity. But the interest which comes out of it and the money which comes out of it is tax free. So that is something, again, a lot of people do. What you can do is, as soon as the child is born, you can make a PPF account, put minimal amount in that, so that the parking, the 15-year lock-in period is taken care of, and then later you can decide what to do with it. But at least once it's started, then those years keep on going on. So the rate of interest today is about 7.1. and it's again something that most Indians would do. Now, these would be the safe bets, low risk, low return items. Dr. Nilesh would share some details about the high risk and high gain items for.
So there is a saying in investment that if you have to gain high returns, you have to take high risk. So I'm not telling you to take high risk such as crypto that is so volatile. They give much more return, but they can suddenly crash like right now. But equity is a good option to look at because it over like a period of more than 5 years, they give you positive result. Whatever we hear about equity market that it is a satta bazaar or something, it is true actually when you daily buy share and daily sell shares. It is not true when you are going to buy and keep it with yourself and let it grow over time, 5 years, 10 years, 20 years. So the main problem with investing in equity or directly into stocks is the time. Because to pick a company, there are 5,000 companies that are today in share market, and it is growing. We are daily seeing 2 or 3 IPOs coming in, so it is constantly growing. To pick a company from that 5,000 is really a tough task, and we end up asking our relatives and which company to invest in, and then invest in that, and suddenly it crashes because you don't know anything about that company. It suddenly crashes, and then you are like, this is not for me, and then I'll go back to FD, which is giving me 4% return. The equity can give you 15 to 20% return if you are really invested for a long time. So how to invest for us, for ophthalmologists? Practically, there are only 2 solutions that are available. One is mutual fund, as Shraddha ma'am said, similar to debt fund. Even mutual fund for equity are available, where there is a manager that is sitting, and he makes the decision. These are the 10 or 20 companies that we should invest in. So you give him money, you give him 1,000, 2,000 per month, and then he will invest in those companies on your behalf and give you the returns. But as the manager is there, so he is going to charge a fees. So that is called the expense ratio for the mutual fund. So that takes about 1% of your return. So if you are getting 20% from the share market, you will get 19% from the mutual fund. So 1% doesn't it seems like very minuscule amount right now, but once you see that over long term, it can cost you around 10 to 20 lakhs over a long term. So the second option to save that 10 to 20 lakhs is to go for a small case. Small case is something like a manager is there, but it is really low fee. Like they will charge you around 3,000 for a year. There is a manager that is sitting. They will just give you, these are the 10 companies. Now these 10 companies, like for us, it is we know with the COVID that now people are going to buy more insurance. So we will just ask them, give me 10 companies from insurance. So they will tell us that these are the 10 companies that from the insurance you should invest, and then you invest directly into that and you take the gain. They are going to just charge that one-time fee. So small case is one another option that we can look at for equity. And the equity investment should only for a long-term goal. In the financial planning, you have something called a short-term, medium-term, and long-term goal. Short-term is something that you need for less than within 1 year. So you have to go for a debt fund or debt instruments. Then there is a medium-term goal, that is you want something to do in 1 to 5 years, like buying a car or something. So that for that you have to go for a mix of low risk equity and debt. A mix of that you have to go. And for long term, for more than 5 years, like buying a house or going your retirement planning or education planning for your children. So that will require after 10 to 20 years you require that. So that you can directly go and invest into equity. You will get 15 to 20% return, and then you are going to see marvelous amount of corpus that you are going to accumulate at the end of it.
Thank you so much, Nilesh, for these insightful comments about mutual funds and stocks. Now, I would like to ask Dr. Shraddha regarding investments like property and gold. Like around every Diwali time, I keep purchasing some little bit of gold or something, and then men around me in my department, they make fun of me and say that you should invest in gold bonds, not in gold. But you can't wear gold bonds, can you? But so what do you have to say to that?
Right. So, ma'am, gold per se, okay, it's considered as a strong investment option. Now, the people who are pro for that believe that, the women since ages, since centuries, have been doing a fantastic job of accumulating gold by any means, and they, because of them, the families have a very strong gold background. But then there are other people also that who believe that gold is not a good investment option, because what happens when you buy the gold jewelry, you're already losing out on some amount of the actual pricing. Then when you go to sell the gold jewelry, again you lose out some amount. Plus, during the buying and selling, there are also taxation things which happen, and of course the safety part of owning the physical gold. So it's really more like, if you go by actual financial calculations, gold is not a very good investment option except to make the women in the house happy. And if you calculate, then it will not give you too much appreciation also, but that's according to finance. Now, for sentimental value, people want to, buy gold, keep gold, that's up to them whenever they have extra cash. Instead of jewelry, what you can do is think of buying the gold coins or gold bars or biscuits, which that way you won't lose too much money in the making of the jewelry and all. Also, there are something known as sovereign gold bonds. So sovereign gold bonds are something which you go online and you can purchase it, and it's available on your bank websites. And that will, if by logic, it will, the appreciation would be there as the gold prices keep rising, and you would get that appreciation. And there are certain tax benefits also. So there's nothing to, get scared about that. Just go online, read about the sovereign gold bonds, and just you can buy it when you want to. And jewelry, just don't consider it as your investment, just consider it whatever you're doing to make you happy. The other thing is, like you said, ma'am, the other way, I'll be the devil's advocate here. Now, if you have to buy 1 kg of gold versus buying a BMW, both of these are luxury items. Okay, so if you have to convince somebody or the men, then your BMW, the cost value will reduce with time, or when you buy it or try to sell it, the gold value will not decrease so much. So for that extra cash, if you have to compare your luxury items, then yes, gold would be better than those. Now, coming to another investment opportunity, which is property. And again, people are very pro property, that you can use it, it appreciates very nicely, and you can generate income out of it, rental income, you can sell it and get a huge profit. So yes, that's again one of the options that you can look at when you have extra cash. Now, the disadvantage of property is it's not very liquid. If you go to sell it, you may not find buyers. Again, there are many taxes in buying, in registration, while selling. You will have a constant maintenance fee and a development fee. And when you go to buy property, you'll have to put in a large capital input. Wherein something, if you compare that with something, say mutual funds or something, you can start off with something as small as 1,000 or 2,000 also. So you can start small also. Well, property would be something that you kind of, have a large sum of money, and only then you can get it. Also, naysayers say that when you get the rental income out of property, it's not so much. It's just about 3 to 5% per annum, which is not a very big amount. That much amount, if you just put in your mutual funds, you can earn more out of it. So that is something that you need to consider. But property traditionally has been something that Indians like to buy. And, there would be a story of this guy buying that much, and he got so much profit out of selling that much property. To be on the other side, I would give you an example that in the past 50 years, if you had, say, X amount of money and you bought a property in Bombay, the cost became 100 times. But the same amount of money, if you would have put in BSE Sensex, that became 400 times in 40 years. So it's not like property only appreciates. Again, people who do financial calculations, a lot of them believe that it's not like it appreciates too much as compared to the Sensex. So again, mutual funds may be a better option to invest in. So I think we've touched up, a little bit about the different avenues, and I strongly urge, all of you all to read about personal finance, because that's what we are working from 9 to 5 every day, right? For gaining money and, making something out of it. The excellent books, this Finance for Doctors by Amar Pandit, and Rich Dad, Poor Dad. And these are good to inculcate some values into our children also. So with that, I would just like to end with Dr. Nilesh, kind of giving us a basic thing. Sir, you have money. How would you allocate it into the various types of investment opportunities that we have?
Thank you so much, Mama. It was really great points that you put forward for both the properties and for gold. Both were really succinct. So let's assume that we are earning 100 rupees. So as I told earlier, that 80 you can spend. It is not a very small amount that we are telling you to save. 20, we are asking you to save 20 rupees only. 80 you can spend, and if you are earning say any junior, is small amount that we are telling you to save. 20, we are, there is echo. Okay, so like you are earning if you are junior resident, you are getting a stipend of around 45 to 50 in most of the cities. So you can spend 40, and we are just telling you to spend save only 5 rupees. 10,000 rupees, that is 20%. So now I'm going to first give you an example of the power of compounding that will really motivate you. That motivated me to start investing. So like if you are investing just 5,000 rupees per month in all the assets, and you are getting 15%. 15% is a very conservative estimate. If you are really planning, you can gain up to 20, but I'm telling you 15% only. 5,000 and 15 rupees, 15%. For 5 years, you are going to get 4.5 lakh. For 5 years, 4.5 lakh. For 10 years, it becomes 14 lakh. For 15 years, it becomes 34 lakh. For 20 years, it becomes 76 lakh. For 25, it becomes 1.64 crore. And for 30 years, it becomes 3.5 crore. So at the end of 35 years, if you're investing only 5,000 rupees per year, it might, for young ophthalmologists, it might be a little harsh to start directly with 5,000. But after you enter into your business and then you start growing, 5,000 will be nothing. You are totally, at the end of 30 years, you are investing only 18 lakh, and you're getting a return of 3.3 crore extra. So on 18 lakh, you're going to get 3.3 crore. So that gives you a power. So if you want to retire at say 55, you start at 25. You have, at the end of 30 years, you have 3.5 crore. You can retire. At the end of 35 years, you will have 7.8 or 7.9 crores. So at the age of 60, you can have that 7.9 crore. You can just buy a house at Goa and you can just chill. So that is the power of compounding that will give you the freedom. So then you have got your 20%. How to invest? So as I told, there are short-term goals, the medium-term goals, and the long-term goals. So short-term goals, you have to, similarly, there are mutual fund calculators or SIP calculators. SIP is something like monthly, whatever, what investment you're going to make. So you have you use those goal calculators. Like if you want to buy a car at the end of 5 years, it is costing you around 10 lakhs. So how much you need to invest per month to get that 10 lakh at the end of 5 years? So those goal calculators are there. So for the short term and the medium term goals, go for a safer option, such as the debt mutual fund, the fixed deposit, recurring deposit, not the fixed deposit, but the recurring deposit. Every month you can keep adding on that. And for the long term goals, there is a formula that 100 minus your age will go into equity. So like if you are 30 years, 70% of your investment should go into equity for long-term goals. And rest 30, you can either buy gold, which is a very good appreciation, which appreciates very well. But we should not invest into jewelry, as ma'am told, because jewelry is something that goes from your wants. That 80% what you're spending, you can buy jewelry from that. For investment purpose, you only have to buy the gold bonds. So 30% can go into gold bond. And if you are really earning well and you have a lot of corpus lying around, you can buy some property also, like 5% or 10% of your equity of your investment can go into property. So that is the basic broad idea, and it depends on individual basis. Like you have to talk to your planner, or you have to read up more on this to plan your finance. But this is the broad idea that we follow for any investment journey. So that's all from my side. Thank you, ma'am, for this opportunity.
I would like to suggest a book called as Let's Talk Money by Monica Hallan. I think it's a very, very good book. I got a copy recently and I've just read a few chapters. So I was really looking forward to all your, tips and tricks. Dr. Shraddha and Dr. Nilesh have summed it up pretty well. What do you say, Apurva? Is everybody else also able to see that she's frozen?
Yeah, ma'am is frozen.
So, Dr. Namrata, if you're here, you want to
Yeah, very much here, trying to understand the finance part. I think for people who are in government organizations, it is really a challenge to understand it. And the way both Nilesh and Shraddha, they went off and on, that, you have to be really good at it. Because we never bother about finance, because our finance is limited, which comes, and what goes into investment, we really don't bother. I think Sonal will also agree with me, but
Yes,
still,
ma'am.
Sonal still has a lot of knowledge about finance. But I think this is something which is required, which should be discussed, because this is something which is not given in the books, which nobody teaches, and only experience teaches. So if you've had the experience, others will not have to go through it again. But I was hearing the whole thing, and it was really a pleasure to hear and to know about certain things. For me also, it was really educational, because I myself did not know so many things. So we know where to go to when you have to seek for help for finance. It's Nilesh and Shraddha.
Right. So with
Ma'am,
that,
invite everyone for a group picture in the before we close the session. Yeah.
Nupur ma'am had to share her dance video.
It's okay. I think we are running short of time. So yeah,
you can still share.
Yeah, if your video is 1 or 2 minutes, we would love to see it, Nupur.
Okay, sure. And let me. You all can see.
No, Nupur, we can just see the screen where 3 video small icons are there. We can't see the whole dance.
Okay.
Sorry, guys, my Wi-Fi just got disconnected suddenly at a crucial juncture. I'm sorry.
So we didn't finish, Apurva. We can't without you.
Ma'am, can we have a group picture? Did we have it, Dr. Sonal?
No. We were waiting for you.
No, I'm just, let's have one. If Neha is around, can she switch on her video? Dr. Digvijay?
Yeah, just switch it on.
Yeah. Yes. Right, done.
Right. Thanks, everyone. Lovely session. Thank you, Dr.
You want me to share?
Yes, Nupur. Go ahead.
Is it visible?
Yes, Nupur, it's visible.
छलकाई मधुशाला मेरा चैन रैन नैन
पग डोलूं रे डगमग सी मैं चलती हूँ जगमग लो सी जलती तेरे नैनों की कैसी मदिरा थर थर कांपूं रे तेरे तीर से झिपती चंदन पे नाग सी लिपटी मैं बेहोश तू नशा ऐसी मोह की दशा मेरा चैन रैन नैन अपने साथ ले गया नैनों वाले ने छेड़ा मन का प्याला छलकाई मधुशाला मेरा चैन रैन नैन अपने साथ ले गया
Such a graceful performance, Nupur.
Thank you.
Very nice.
Yeah.
Fantastic.
So this
Really
I started
fun.
at 6 in the morning. So that's what, dancing is like that. You want to just do it.
Thank you.
Ma'am, there's no age. You just have to just put on your dancing shoes and just start dancing. It's
Those who are born with 2 left feet cannot really relate to this.
No, there's nothing like 2 left feet, really.
Thank you so much. Very nice performance and a very fitting end to the entire session, entire forum. In fact, I would really want to extend my thanks to Namrata ma'am for being here and being our support. She's been so kind and it's so nice of her to kind of spend her Sunday evening with us. So thank you, ma'am. Thank you so much. It's such a pleasure to have you as always. And of course, thank you to all the office bearers of YOSI. It's a dream team really. Dr. Digvijay, Dr. Sonal, Dr. Divakan, Dr. Karan, Dr. Avnish. I'll miss this dream team. I think this is one of the penultimate events that we'll organize together as a team. Dr. Nilesh is like the one of the unsung heroes and like one of the office bearers unofficial of YOSI, and he's just so active and proactive in helping out, and I am looking forward to seeing him in an executive position at YOSI. Nupur has always been very at the forefront for so many things. She's hyper enthusiastic for everything. Dr. Shraddha, thank you. That yours and Dr. Nilesh's session was so informative, even for dummies like me who doesn't know like the F of finance. I'll be contacting you for any questions I might have. So I would like to thank everyone, the mentors that attended, the mentors of AIOS, Dr. Namrata, Dr. Lalit Verma, Dr. Nayak, Dr. Rajesh Sinha, Dr. Santosh Honavar, and the seniors who've always taken us under their wings and helped us grow from strength to strength. And thank you everyone. I don't have I don't have much more to say. Thank you.
No, very special thanks to you, Apurva. You put in a lot of effort to put this together. This program would not have been
mammoth task to do it.
Thank you.
You guys really are a dream team. Really, I totally agree. It's like when you say this is going to be the penultimate event, so I feel like we're going to miss you all so much. It's like, yeah, ma'am, they're also approachable. All of them, ma'am, very approachable. Like everybody has this thing that the entire YOSI core team is so approachable, and so open to new ideas. So I think that stems from you because you yourself are like that. So the mentorship has passed on. It's amazing. I'll just add one thing. So since we had this forum beyond ophthalmology, why don't we add a cultural wing to YOSI as well?
Yeah. You can head it for sure.
No, just yeah.
We'll have one performance thing, cultural evening at Yo Pavilion also.
Yeah, you should, because like I said, in American Academy of Ophthalmology, you always have a gala night separate. So maybe you can have something like this, and it is only for you. The elderly are not allowed to come inside.
Best ho gaya ye to.
So we'll also
Thank you
get
so
one
much.
more at the YOSI thing for us also,
Absolutely.
financial planning.
Mumbai, of all
Financial
places.
planning.
Should
At Mumbai, yes.
Yeah. Kamla Mills. Yeah.
Like,
Stop the live now.